able to be, I hate the visual, but the tip of the spear in this conversation. And I think in the moments of truth, if you ask the carriers, they like to watch us go in and negotiate because then they can sort of follow behind. I always thought, as a purchaser of health insurance, that the carriers, because of the size of their book of business and their own self-interest, would always negotiate best practice and would always negotiate best costs. And that is simply not the case, as evidenced by the willingness of hospitals and large provider groups to negotiate directly with us on behalf of the members of our plan. So that is a significant difference. And we can be responsive to the needs of the enrolled, and we don't have to serve multiple masters.
I appreciate that feedback, but as I was listening to you, I cannot help but think that as I talk to physicians and I talk to hospitals, I always think the insurers do a darn good job because they're not very well liked in regards to their pressure and leverage, just as you articulated that you are able to do under the partnership program. So I think it's not a lost art of negotiations that is pursued by all actors in trying to get economy and scale and cost efficiency. And I think that's part of the rationale that we have right now is the fact that our health insurers aren't always thought of in the best light. But I also understand that they have a very, very hard job to do because the true cost of healthcare is not always understood. And the management of risk and the economics of healthcare is one that I have been aware of for over 30 years from my benefits background and also from studies of it because it's important. It's always been the goal of everything that we try to do related to healthcare costs is try to contain it. But nevertheless, it continues to rise despite our best efforts to leverage and negotiate like you articulated. I want to get to the economics and dive down a little bit in regards to SB 842 and how it's dramatically different. And for you to articulate that, particularly as it relates to, let's go to section 1, where you are going to include the Taft-Hartley Coalition. But could you, for education purposes, explain to people what the Taft-Hartley Coalition means and what you are looking to do under definition to incorporate them into the partnership pooling that you're proposing?
Certainly, Senator, and I agree, it is hard work. I think I'm just going to go back to your reaction to my last comment, and that is to say it is hard work. I didn't mean to say that the carriers are not doing it. I'm saying that sometimes the different positions that we have give us an ability to negotiate in different ways. And I don't mean as a government official, I just mean based on the book of business that we're doing. And that is evidenced by sort of the efficiency of the plan that is well documented. So the Taft-Hartley plans are the union plans, and I had a bit of misinformation about them for a long time. I just assumed that the Taft-Hartley plans, because of their size or their association or because of their international or national footprint, would have the heft to negotiate better contracts for themselves in the market. And I've come to learn that that isn't always so. It is true for some, but not for others. And many operate just like small businesses in their ability to negotiate. And if you want to talk about a power differential, I mean, talk about what it must be like for a small business to try to negotiate rates for themselves. It is impossible to do. So the Taft-Hartleys have asked if they could be part of the group that would have access to the public option. And it is included in 842, and I would welcome them to be part of it. And they are part of the coalition that's supporting the bill as well.
So you asked that they have asked to participate. Is there a group coalition like we have in CBAC, or is it individual unions? Having been a student of labor relations, I understand that most of the Taft-Hartley Coalition are predominantly craft unions, and you're right, they don't have that economy of scale, but they also have a significant record of risk management, and to incorporate them into the partnership pooling with a broader pool is going to be a dramatic change and an exposure for them. So you said they have asked to join. Can you cite a couple of particular unions that have articulated and made that request to you?
I'll just say, Senator, that the Coalition of Taft-Hartley plans sits at the table in the coalition meetings, and then their membership is, I'm sure they'll be happy to answer who is in their membership, but it is made up of SEIU and 1199 and UAW and individual unions, but they have a common interest in policy setting across all of it.
So the SEIU, as you just cited, is part of the Taft-Hartley coalition?
Oh, I'm sorry. I'm sorry, Senator, I misspoke.
So SEIU is not part of the Taft-Hartley coalition?
I don't believe so, no.
Okay, thank you. Thank you. I do believe it's part of a kind of it's a federal program. It's an umbrella coverage group across employers. I found it even when my studies in the labor relations school at Cornell that it was a very interesting and a part of our history that started from the labor movement. The second question I have relates to Section 2, which I find it interesting. And I don't know if you have the bill language lines, but I'll just for a point in line 74, 73, leading to possibly line 74 to 92. It allows you as the controller. It allows you, but does not require you to address the rating factors that small group private plans must use. And you do, and I think you articulated in your testimony and in your written one, that you are able to provide a rate guarantee of no more than 3% increase or decrease. That's impressive. I must say, and knowing the numbers and cost containment, to offer that kind of a rate guarantee is quite interesting. I am hopeful that you're able to accomplish it, but private insurance companies can't offer that guarantee, can they?
I suppose they could offer whatever they would like, Senator. They do not, but can they? Sure.
Now, that guarantee, do you have to provide that guarantee to the insurance department under this bill or under the statutory creation of this partnership? Are you regulated by the insurance department of the state of Connecticut?
Senator, as the insurance committee probably knows better than anyone else, self-insured plans are not regulated by the insurance department of any state. They operate under ERISA law, which is federal. And in our case, there is a double layer. And for this population, it would obviously be subject to ERISA because they're not state employees or municipal employees. And in addition to that, the Healthcare Cost Containment Committee, which is a labor management group, also sort of oversees what we are doing with the health plan and gives us that input that's necessary. So things around state mandates that come into play. I see there was some accusation yesterday that somehow I would decide you don't get something. Well, the history does not support that. And so I think when we operate on the grounds of absolute facts and not rhetoric, it is clear that our plan right now and will continue to operate within both state and federal requirements for coverage, but is not regulated by the insurance department. It is an important distinction and one that I would caution the committee to not violate that wall between state and federally regulated, because there are many large plans in the state of Connecticut that are self-insured, that know where the regulation comes from and where it does not. The third-party administrators in Connecticut who support and help us are our partners. They know where the regulation lives, and in some cases that does live at the insurance department. And I know the committee would not suggest that the state get in the business of regulating self-insured plans.
No, I really appreciate your answer on that, and it is important. In all my experience with you, as my compliment to you earlier on, you have been a tremendous public servant, and the state of Connecticut owes you a great in debt of gratitude for your tremendous service. So no doubt, and do I ever question or impugn your challenge? But I'm simply looking at the language as it's written, and the execution of reading the language. And I just wanted to simply point out that this partnership and Control Embo, you as an individual have the greatest of integrity, but you will not be in that seat forever, nor will any of us. And it's important that what we write down in statute is fully vetted and articulated to the legislative intent, because it will impact many people's lives. So let me be clear. The partnership program is not regulated by the insurance department, and it's intentional, as you shared. And what I'm reading is that it does allow the controller to adjust the rate factors, but you really don't have to have the oversight of the insurance department to protect what you may or may not do. I just want to point that out from a point of transparency. And I think you did point to a rhetoric statement. And I'm going to go to line 67. I think it might have been referring to that through the partnership, the controller will have the power to approve or deny applicants. And I believe that's line 67. Now, I understand under the ACA, and one of the most important things that the ACA, the federal ACA, despite its many challenges, is the fact that pre-existing conditions and people at a high risk pool are guaranteed insurance and acceptance. But can you clarify what line 67 means? And I'm not saying you, but for any individual that may come after you, that the controller has the power to approve or deny applicants. Is that giving the controller the selectivity and potentially adverse selection in limiting the pool of applicants you have into the partnership program?
Senator, if I use the existing partnership now as an example, because the way we operate would continue just that way with this new group, we do not exclude based on pre-existing condition. Our underwriting criteria in this new plan would be limited to two factors, and that is geography and age, which is available across the small group market. The section that you're talking about is intentional. And frankly, without it, it would be horribly fiscally irresponsible to pass the bill without that language, because there are bad actors in our world, as we know. And when there is a plan, whether it's partnership or this new program, where someone has, for example, 150 employees, and 35 of them are warehouse workers, and are in a position to be exposed to physical risk on a regular basis. And 10 are white collar accountants and billing folks, and 5 are the C-suite people, the upper management of that company. If that company applied to this program and just wanted to cover their 35 employees who work in the warehouse and not the others, it would put the state at tremendous risk and allow them to wash bad risk through the program and therefore through the state's administration of this program, and would not be fair to the others that are participating in the program. So that is why that language is there, Senator. And if there is a way to more artfully put bumper guards around that, I know that I share your position that one monkey doesn't stop the show. And if I get hit by a CT Transit bus or decide not to do this anymore, someone else is going to have to do it. There may be some who are quietly cheering for that to occur. Don't get your hopes up, not anytime soon.
You know what? I wish you a long life and safety. And I mean it like a broken record. I really do greatly appreciate your service to our state. That being said, I think you hit the important part. Let me go back to, again, we share a common goal in being able to provide accessible and affordable insurance. And I think you said for you not to have that provision, it would be fiscally irresponsible. And I agree. But, as I said earlier as well, our current insurance companies aren't on everybody's Christmas list or holiday list because they cannot selectively reject people. They may charge them a significantly higher rate. And that is part of the challenge that they have, is the fact that they are regulated by our insurance department, one of the best in the country, if not in the world. We have actuarial risk managers and experience, being the insurance capital of the world, of having some of the best companies and actuarial management in the world. Look, I can assure you, every insurance company, if they can reduce rates, they do it in a heartbeat. It's a competitive advantage, as you have articulated in the partnership. But they have a fiscal responsibility to ensure that the policies that they sell, the insured that they're providing, meet the financial responsibilities. That's what we're getting to, is the escalating cost of healthcare is getting out of reach and unsustainable for many of our residents. We're trying to solve this problem, but one of the biggest incentives for people to gravitate toward the partnership program is the fact that they are able to get access, that they're able to provide in a cost-effective manner. But they also want to be able to know that they will be guaranteed insurance. And that provision of the ability to prove or deny applicants is counter to the idea of the ACA and counter to the philosophy that we should be providing insurance for everyone. And I just wanted to point that out, because you're right. There is always an economic cost and a fiscal responsibility aspect. And that isn't always a pleasant answer to people when they have to pay escalating premiums. But that cost of healthcare is incredibly high. I'll move on. And the other part that I have, and I want to thank the chair for the indulgence of the time, and the question is, there is a lock-in requirement for individuals or nonprofits and small businesses, the opening of the partnership to those entities. Can you elaborate a little bit more of what the 3-year lock-in for people that kind of sign into the system, and also if they have a bad experience or are not getting the service or the care or the accessibility that they anticipated just in a free market basis, they can leave. What is the 3-year lock-in? And after that 3-year lock-in, what is the cost of exiting this partnership plan? I believe that is in line. Well, it begins in a multiple section, and if I may, it's still part of section 2, but it's maybe the lock-in for unions and nonprofits applies to 123, 124. And also you're allowed to charge an administrative fee with no parameters. That would be one line 199 to 120. But rather than me articulating it, I wanted to defer to you as an architect of this and better understand it.
Thank you, Senator. So a couple of just quick points of clarification. I'm going to go back and say there's the cost of healthcare and the cost of health insurance, and those two things may or may not be the same. So I want to make sure that we're clear as we talk about these things. The second is this idea of, I'm going to call it cherry picking. You didn't use those words, but I think that was the inference, and that the limitation on some companies under state regulation to do some of the things that you articulated is not there, because the regulator makes sure that that doesn't happen. I would keep in mind the context as well, though, Senator, and that is there has been a long march of sales of self-insured health insurance to very small businesses with wraparound excess loss policies, and the primary sales pitch of those. And I don't think anybody would suggest that a company that has 15 employees should ever be self-insured. But the motivation and the drive and the sales shtick behind that is all around get out from under Connecticut's regulation, get out from under the mandates, and essentially offer what you would like. So that's already happening in the private sector. And if it's something that the committee wants to take on at some point in the future, I'd be happy to be helpful. You said that the administrative fee has no parameters around it. Yes, because it's a direct reflection of what it costs me to run a plan while not putting a burden on the taxpayer. And that could change incrementally over time. I don't know, you may have been, I have never been invited into the boardroom or the C-suite of the existing carriers when they're deciding what admin bump they need. And so, you know, of course, you know, they don't guarantee. It's this whole idea as well that you hear whenever there's a mandate requirement or a taxation question. The response is always, well, that's going to drive up premium. It never leads to, well, that's going to come out of our admin or that's going to come out of our hide. No, it's always about pushing that down to the consumer. So the 3-year lock-in, Senator, is back to that washing of bad risk. We are really focused in that section on the larger groups. And we don't want them coming in, washing risk, and then heading out the door the next year. So I would argue that with free will and as an option, if someone reads that and is uncomfortable with the 3-year lock-in, they don't want to engage in that, then they can move on. This is not an entitlement program we're talking about here. We're talking about an option in addition to the other options that exist in the market.
And so it is a 3-year lock-in, and I do agree with free choice. And for those that look to exit, are there administrative charges to exit out?
Senator, I forgot, I didn't say at the beginning that I'm joined by Josh Wojcik, who's an assistant comptroller and our policy director, as well as Miriam Miller, who's our legislative liaison and a policy associate. Fingers to keys, these are the people who are writing language. I know you understand that because you guys have your own group of people with fingers on keys.
Absolutely.
So Josh or Miriam, penalty for early leaving, how is that constructed, if at all?
So that language that Senator Wong that you're reading there is actually directly from the existing partnership program and the statute that currently exists. And so within the existing partnership program, right, there is a 3-year requirement for participation. And in our agreement with groups, there is a percentage of claims fee for leaving early, which reduces each year. So after the first year, I believe it's somewhere around 3%. I can get you the actual numbers, but it's a low percentage of claims. And then after year 2, it's about half of that. And then after year 3, it's 0, right? So there's no fee to leave after the 3rd year. So you could leave early, but there's a charge to do so.
Thank you for that explanation. Just in light of the Zoom world that we're in, if I could just make sure that you properly identify yourself, and I believe your screen said Kevin Lembo. I just wanted to make sure that we make note of the correction. So
yep, I'm Joshua Wojcik, and I'm an assistant comptroller.
Thank you, Josh, and thank you very much. I only have 2 more questions, and I think the other is to seek your expertise. Controller is it also requires on 842 for the controller to procure services, including but not limited to those that are necessary to comply with ERISA, which is the Employee Retirement Income Security Act, which is a self-insured governmental plan, and to charge an assessment against the unions, nonprofits, and small employers. I'm referring to line 157 and 152 to 161 for charging it against unions, nonprofits, and small employers. Now, I remember in my work in the legislature and our municipalities, the ERISA experience and the requirements are very daunting. and they can be very complex and costly. Can you explain the connection of what that statutory language intended as it relates to ERISA?
Senator, I think what's happening here is that we are, the language is breaking out the different pieces of what is really in that admin fee. And you're making the point for me, and that is there are pieces of this that cost money, and those need to be borne by the sponsors / participants in the plan. So the nonprofits, the small businesses, the Taft-Hartleys, they need to pay an equal share of those pieces, versus us paying for it, which I don't know that anyone would suggest or is envisioning. You are correct, filings that need to take place under ERISA, and there are expert folks who do that. We are not them. And so that adds to administrative cost. But again, we're starting with a base of 2.3% compared to 15% in the private market. I've got a little bit of room here. So, I don't know if we want to unpack the admin of the carriers versus what we're suggesting on a side-by-side analysis. I'm happy to do that at any time.
And if I may, and I really do thank you for articulating that, because that is the crux of it. I do believe that we all share, Democrats and Republicans share a common goal to be able to address the escalating cost of health insurance and providing health care. But we also want to be able to make it accessible to everyone. I believe that. I want that. I think that the approach is, do we approach it on a fiscally responsible one and a sustainable one moving forward? And the reason I am asking those questions is you articulated and demonstrated very clearly that the provisions of 842 does give the controller great latitude in your ability to manage the cost, to be able to assess cost and fees, just as insurance companies do. And again, as I said repeatedly, not always to the favor of the consumer, but they have to be accountable to regulators, the state insurance department. And my concern is right now, your integrity is not impugned at all, but there will be other controllers and other individuals in that office. And the fact is, we're giving tremendous power, tremendous authority without state insurance department oversight in regulating a significant financial endeavor. That being said, I don't want to close by a letter that Senator Kelly and I sent to your office on February 3rd and received an acknowledgement, but never received any answers. So I will take you up on your offer to articulate some of the data points that that goes into the current partnership system to really get a transparent audit of what is really the financial picture of the current program. I'm going to read out loud the letter that we sent to your office that we have not yet gotten a response on February 3rd. Dear Controller Lembo, we write to request the most recent information regarding the Partnership 2.0 plan. We are under the impression that you are seeking to expand participation in this plan through continued marketing to municipalities, and that this plan will be similar in ways to your proposal of a public option. As a result, we are looking for the following information. 1, the total premium received and total claims paid over the 2020 calendar year. 2, the total premium received and total claims paid over the 2020 calendar year per each municipal employer group. Number 3, what are the loss ratios for 2019 and 2020? Number 4, an explanation of the impact on the 2020 premiums as a result of the 2019 loss ratio and 2020. And number 5, your cost to administer the plan, both external and internal, including the fringe for 2019 and 2020. And what protection do you have in place for the general fund, e.g., stop loss insurance or reinsurance? Could you please explain to us also the shortfall in the state employee health services account and the retired state employee health services account identified in Secretary McCall's letter to you dated January 20th, 2021? As we understand, the legislature may be asked to expand the partnership program this session and consider a public option. We would greatly appreciate this information as soon as possible. Thank you. Sincerely, Senator Kevin Kelly, Senate Republican Leader, Senator Tony Hwang, Deputy Senate Republican Leader and Ranking Member of the Insurance and Real Estate Committee. If you could, Controller Lembo, be able to follow up with us and share the answers to those questions, it'd be greatly appreciated. And I want to close and again thank the indulgence of the chairs on this, is saying that as you said, you've never been invited into the C-suite of insurance companies to debate their machinations and strategies. And I wish we could, but I would also offer to you that as the ranking member on the insurance committee who is committed to finding solutions, I haven't been invited to discussions about the public option and Senate Bill A42 prior to this public hearing. So again, I hope we can all work together and find solutions that are sustainable and viable into the future, because our goals are the same. We're just looking at different solutions that may benefit the people and the taxpayer of the state and create an insurance program that is going to be able to keep jobs and provide the necessary access for many of the residents that are clamoring for it. So thank you for the indulgence, Madam Chair and Mr. Chair. And I want to thank you again, Controller Lembo, for your service to our state. And I look forward to working with you as we move forward on this. Thank you, Madam Chair.
Great, Senator, thank you. I appreciate that. I assume sort of that was a question, what was contained in the letter, and I'd like to answer it for you so that the other members of the committee have the benefit of that response. And I want to thank you as well for being a partner where we could be partners and agreeing to disagree where we couldn't be partners. But it's always been a pleasure working with you. And I agree, we all do share the same goal. I hope that's true. I know that's true in your case. And my problem, however, is that I haven't seen a reasonable alternative. I haven't seen anything come forward that would really address in a comprehensive way the problem that, in particular, our small employers, our nonprofits are facing. The other thing I want to be clear about is that I don't think it is fair or accurate to somehow equate regulated status with being under the insurance department only. There are multiple forms of regulation. ERISA is one of those, and federal plans, self-funded plans, fall under that regulation paradigm, and that is where this would fall as well. So it is regulated. It's just not regulated by the insurance department, but neither is the Pratt & Whitney plan, the EB plan, the Pick a Big Employer plan. They are all governed by ERISA as well. And as far as I can tell, doing pretty well. So I did receive your letter on the 3rd, and if you check your inbox, you'll see that the answer is already there. It came in today. We worked very quickly and hard on a response to you out of respect for the senators who sent that letter. And since you did read the questions, I think it's fair and probably appropriate for the committee for them to hear me read the answers to your questions. On partnership, and I won't reread the questions, which are articulated at the top of my response. As you can review in the attached documents, the Connecticut Partnership Plan took in more in premiums than it paid out in claims in 2020, whether measured on a fiscal or calendar year basis. The plan is also on pace to have a positive medical loss ratio again this fiscal year. A decrease in usage in the spring caused by COVID-19 pandemic has further reduced claims. However, the plan was already projected to have a positive MLR prior to the onset of the pandemic. A statutory change requested by my office and adopted in 2019 allows for regional rate adjustments in the partnership plan by county. Prior to that change, the plan was required to offer identical rates as the state employee plan, and as a result, experienced an MLR over 100% in fiscal year 2018 and 2019. As high enrollment of groups in Fairfield County, where healthcare costs are higher, proved higher than the large Hartford County-based state employee population. The premium impact on the state plan was 3.4% for the active plan and 0.8% for the pre-65 retirees. In the fiscal year 2020, those regional rate adjustments began to phase in, further stabilizing the plan and leading to an immediate improvement in the MLR. The rate adjustments are set now by county and will be fully implemented for fiscal year 2022. The partnership plan is now projected to run at an MLR under 100% for the foreseeable future, cementing its reputation as a market-leading option for municipal and non-state government groups. As for stop loss, the current partnership plan statute requires the state and partnership plans to share risk, meaning annual premium rates are set by reviewing the claims experience of both groups combined. The plan design allows other non-state public employees to enjoy the cost-saving contractual and relationships and rate predictability that are made available due to the large size and resulting negotiating power of the state employee plan. My office provides the services of reviewing claims, engaging in procurement processes, and otherwise complying with applicable federal regulations associated with administering an employer-based health plan, resulting in lower administrative costs for enrolled partnership groups. Generally, groups that have joined the partnership plan did so because it provided a savings for the employer and improved benefits for the employees. The positive impact of that relationship extends to municipal taxpayers in the form of lower property taxes. Together, the state plan and the partnership plan now have 260,000 participants. With such a large pool of participants, stop loss insurance is not recommended. The cost of stop loss policies would very likely result more in premium paid by state and partnership groups than the benefits received, rendering it wasteful. Current statute does not contemplate the purchase of stop loss, and I would strongly recommend against any requirement to purchase it in the future for these groups. As described above, the current financial state of the partnership plan is and is projected to be strong, further reducing the need to purchase stop loss on behalf of the plan. On the budgetary status of the state health plan, in the latest letter dated January 20th, 2021 from OPM Secretary McCaw, the state health plan showed deficit relative to its general fund appropriation. Because the legislature adjourned due to the pandemic without adjusting the biennial budget, updated lapse targets recommended by my office, OPM, and the governor's office were not adopted. I'm pleased to report that since Secretary McCaw's letter, the deficit for retiree health has resolved, while a $30 million deficiency remains in the active health plan and attachment is provided. It is important to note that the general fund appropriation for the state health plan is not a reflection of the cost of claims, but the cost of premiums collected from state agency budgets. Therefore, despite a current fiscal year deficit, the plan has generated large reserves that can be used to drive general fund budget savings in fiscal years 22 and 23. Additionally, since October, budget estimates projecting a significant increase in Medicare Advantage, my office was able to negotiate an extremely favorable contract renewal, $130 million, for emphasis, below what was anticipated. Combined, by applying the adjusted projections from Medicare contract and drawing down the reserves generated by premium collection, my office is forecasting in total $250 million in savings from the October estimates. To the Appropriations Committee members, you're welcome. In conclusion, the state health plan continues to be a strong force in the healthcare industry. Innovative contractual relationships such as a recent agreement with CVS that puts aggressive limits on administrative costs and secures best in the nation prices on brand and generic drugs, are resulting in lower costs and better care for members, including all of us. By partnering with private sector companies, from large insurers to healthcare startups, my office has been able to create jobs in Connecticut, create new models for reimbursement, such as the Networks of Distinction program that are being advertised by some of our local hospitals, and deliver world-class preventative care to protect the health of plan members, including municipal workers in the partnership plan. I'm incredibly proud of the work being done by my office and look forward to the opportunity to discuss this always in greater detail.
Thank you, Controller Lembo, and I must say that I appreciate you reading it, and given that my office received it at 10:53 just before the hearing, I wasn't able to review it because I was preparing for our committee public hearing. So I will read it in depth, and again, I am an open invitation and a engage and renew initiative to collaborate and find solutions. So I hope that we'll be speaking often because, as I said in the beginning, and I will end with this, we all have the same goals, and that is to provide the best and most affordable, most accessible, quality health insurance to Connecticut residents and small businesses and nonprofits. And I hope we can reach a compromise through the legislative body, through the controller, and through the executive branch to have a policy that we can all be very proud of and be sustainable into the future. And again, I really appreciate my committee members and the chairs for the indulgence for the length and question. It has been very helpful for me, and I appreciate it, Controller Lembo. And I'm sure you're going to get other questions as well. Thank you, Madam Chair.
Thank you, Senator Wong. Chairman Lesser.
Thank you, Madam Chair, and thank you to the Comptroller. Comptroller Lembo, you and I have had many opportunities to discuss this legislation, so I want to be brief because I want to give other members who have not had that opportunity the ability to get in there and have that conversation with you. But I want to address a couple of things just up front. One is your record of fiscal management. You spoke earlier about the savings you've achieved to taxpayers on prescription drugs and on healthcare costs generally. But I also want to know that in the pandemic, states and localities around the country have been dealing with massive deficits caused by the pandemic recession. And yet Connecticut is in a very different position with the largest rainy day fund in state history. And my take on it is that one of the biggest single reasons for that is because of legislation that you spearheaded that increased the size of Connecticut's rainy day fund and channeled reserves into it. So I think you deserve a huge amount of credit for Connecticut's improved fiscal position, particularly relative to just about every other state in the country. And I know that all of us looking at this proposal and other proposals want to make sure that we are safeguarding the fiscal resources of the state of Connecticut. With that in mind, there's all the discussion I think so far has been really focused on the public option portion of the bill, the part that would allow you to pool pens and offer them to small businesses, nonprofits, and labor unions. Now, I understand that everybody in the legislature wants to lower health insurance costs for small businesses in the state. If we don't do that, we won't be supporting entrepreneurship. We won't be building a recovery that works for everyone. We are losing entrepreneurs to other states, and we've got to be competitive. So with that in mind, are you aware of any other proposals in the legislature from any caucus that does anything to lower the cost of health insurance for small businesses?
No, Senator, I'm not.
Thank you. And I think that's important because I'm happy to have a conversation with members of any caucus from any political party. I think we have done an enormous amount of bipartisan work in this committee in the past and hope to do so again in the future. And I think that would be enormously beneficial for the people of Connecticut. But we got to do something for small businesses. And right now, this is the proposal. There are no other proposals. And I think that speaks loudly. two issues about the public option that I've heard, two concerns that I've heard from folks. One is the question of a level playing field. And I know many of Senator Huang's questions dove into that. And the second issue is the question of fiscal risk to the state. And so from a, I don't mean to travel over ground you've already talked about, but can you commit that health plans issued by your office would comply with similar provisions that apply elsewhere in terms of essential health benefits and the other conditions laid out by the Affordable Care Act? And can you tell us that you will take every step possible to minimize the risk to the taxpayers of Connecticut?
Yes and yes, Senator. And the language, particularly on risk, I think is pretty clear in the bill. And as you know, was not my starting point. So,
and in fact, you're directed to reduce the risk to the taxpayers and to make sure that we're protecting the general fund and state Connecticut.
That's correct, Senator.
Great. Thank you very much. I may have other questions, but I want to give time to the members of the committee. Thank you, Madam Chair.
I do have a certain shelf life, Representative Wood. I just want to say.
All right, we only have 1,000 more people asking questions, so we'll get there.
Okay, great.
No, all right. So next we have Representative Pavlak D'Amato, followed by Senator Anwar.
Thank you. And I will be brief because I have my son here and he will pretty soon start screaming or crying. So, and thank you, sir, for your testimony. And we always appreciate when you come in, Mr. Lembo. And with that, I just wanted to ask about, you had mentioned the 94% medical loss ratio. Was that for 2020?
That was fiscal year 2020.
Okay. And did that include claims incurred but not yet reported?
Included all claims filed in that year.
Okay. So will you be adjusting that when, let's say for claims that come in, since they have 30 days, come in after or had come in? I guess, well, we're in early February, so probably those have, come in recently. Will you be adjusting to reflect anything that came after December 31st?
Josh, excuse me, Representative, I just want to make sure the over under on the claim lag. I mean, what is the impact really on us?
So on the
Josh
fiscal,
also has a small one at home.
Yes, I apologize. I have the same challenge. So yes. So that the fiscal year, those are fully mature claims. So those are everything that was incurred during the fiscal year, even if it was paid out after the fiscal year closed, and we're far enough past that that everything would have flowed through on that side. For a calendar year, our claims lag at this point is a little under 30 days, and we're in February. So on the calendar year, there will be a slight update and slight adjustment, but it should not be very significant at all.
And where would I?
And that would move us from Representative, that would move us from 89.6 to potentially something in the tenths of percentage points above 89.6, correct, Josh? Yeah, we're talking about tenths of a point.
Okay. Let's see. Well, with COVID consuming a lot of 2020, I know that a lot of elective surgeries were put off for that year. For last year. So do you, have you taken that into account? Do you think that does make up the part of the number that you have, that it's due to that factor?
Representative, when I talked about how much we're saving in the budget, that was that 250 total number that I mentioned in reading the response to Senator Wong and Senator Kelly. That is not just sort of padding in a one-time lag in claims or a low point in claims because of COVID. We normalize the claims over that period based on past experience before we set our rates, because we don't want surprises. So that number includes a normalization of the claims over COVID, because it was clearly unusual, as you point out. The numbers obviously look very good in the plan now. And I'll stop there. I'm sorry.
And okay, so just to move on quickly about the cost containment, the limit, the 3% limit on premium increases. In the event where it does claims exceed premiums and it would exceed that 3%, what then, where would the difference be made up? Would it be made up in some type of fee, or how else? What are the other options in that event?
So 3% is not year over year. I just want to be clear about your question, Representative. So can you just give me a little bit more information about what you're seeking?
Just that I know there was the rate containment. Stop. There was a limit of 3%, right, for every premium increase, and maybe you just want to explain that to me a little clearer, because I wasn't sure what that is, and I'll put it on mute.
What the 3% was for? Again, Josh, I'll ask you to just talk about the 3% increase, please.
Sure. So the way the program is designed in the legislation is that the experience of the entirety of the state employee pool, the partnership pool, and whatever lives were added relative to these new groups that can now participate would establish the baseline of the premiums. And so the premium increase in any given year would be relative to the experience of all of those lives together. However, anytime that groups are entering into a risk-sharing agreement like that, each side is taking a risk that their experience may be better or worse than the group as a whole. And so by adding in that 3% rate corridor, what it allows is for these new groups who are entering, the small businesses and nonprofits and Taft-Hartleys, if their experience was significantly better, for instance, than the state employee plan, and the state employee plan had a 4% annual increase next year, because we're looking at the total group, and the total group was 4%. But that those new groups performed better, they could receive as low as only a 1% increase. On the other hand, if those groups turned out to be more expensive than the group as a whole, and their performance was worse, they could see as high as a 7% increase in the scenario that the state employee plan had a 4% increase. So it allows for risk sharing, but some reflection of the actual performance of this group. So in one way to look at it is that it, in some ways, reduces the total risk to the state relative to if we did, risk sharing without this corridor. And finally, the reason to do it that way is this is going to be a relatively small group when it enters. And so if you just looked at the experience of this group alone to set the rates, you would see a high variability in their rates from year to year. And one of the goals of the legislation is to create some predictability from year to year in terms of rate increases, particularly for small businesses who don't really have that, which makes it really difficult for them to plan from one year to the next. And the state employee plan and partnership plan combined have very consistent and reasonable rate increases on a year-over-year basis.
Okay, thank you very much. That's all. I appreciate it.
Thank you, Representative. Senator Anwar, followed by Representative Dathan.
Thank you so much, Madam Chair. Madam Chair, I think Representative Dathan had raised her hand about 15 seconds before me. So is it okay if I go after her?
That's perfectly fine. Representative Dathan, followed by Senator Anwar.
Thank you, Senator Anwar. That was kind of you. And thank you, Chairman. And thank you so much, Comptroller Lembo. You have been really fighting so hard your whole career to ensure that the residents of Connecticut can get access to healthcare and to get so affordably. So it's really so important. And I'm so happy to support you as much as I can in this initiative. I just had a few questions from your very thorough presentation. The first question really is, this is a little bit different than some of the things that we've talked about in 2019 and 2020. One of the questions I had was for, under this current bill, we are not offering this initiative to individuals. It is just really looking at groups, nonprofits, and multi-employer plans. Can you please explain why that is in this current bill?
Representative Dayton, thank you, and thank you for your partnership always on these issues. So a couple of things about that. The individual relief in the bill, as you know, comes from subsidy increases and raising the threshold on Medicaid. It does it in a couple of different ways to get at that population. As for the sort of behind the scenes reasoning behind the individual, I really can't speak to it since I wasn't in the room when it happened. But it seems to me pretty clear that there are folks either in leadership in the legislature and or in the governor's office who felt like doing both of those things together might be a little too much in one bite. And so they prioritized the small business and nonprofit piece, which makes a lot of sense, even in our own self-interest economically.
I agree. I don't know if you can remember my background. I CFO of technology companies, and every year with my different companies, I had, most of my companies were between 25 and 50 people, sometimes as many as 75. But the constant thread that we had every single year was looking for more affordable healthcare. And it was so frustrating that I would spend so much of my time having to do this for my companies, and frustrating for my employees as well. If we were plan hopping, which sometimes did happen, people perhaps maybe had to change doctors, and that was just really difficult. And so as a small business person, I know how important it is to be offering great insurance so that you can keep your employees and also attract great employees. It's such a business winner, and I really do think it's important. Just to kind of go back on the economics, you talked about that the plan covers about 93% cost of care. Can you, and I don't know if you know this or not, comparing it to some of the other major insurance players, what sort of, if you broke down their financial kind of analytics, if you will, break down everything, what is their sort of average cost per care that they're paying?
Thank you, Representative. I think it's safe to say, and I'll lean on the ACA requirements a little bit for this, we're probably talking about 85 and 15. 15 in admin and profit and, all of that. But the 85 for me has always been defined in a way that makes me a little bit nervous. And an example of that would be, the consolidation of a PBM, a pharmacy benefit manager, with an insurer. And when the insurer looks at the pharmacy claims, what piece of that is actual claims, or is the admin buried in the PBM, hidden as healthcare costs? So that makes a ton of sense from their planning perspective to try to sort of get that all set up. So my confidence in those numbers has always been questionable because of the definition. So 85, I would say, Representative, and 80 in the individual market.
Okay, so that makes a lot of sense. So this, 13% delta would assumably be somewhere around the profit margins for these entities. Would you be able, do you know offhand, in other states like Massachusetts that offers a public option, what sort of percentage costs do they have for their cost of care on average. And also if you have anything comparable for their administration fees and the compliance things that you spoke about in your testimony.
I don't off the top of my head, but we're happy to dig on that a little bit. As you know, the examples, when you're up here on the cutting edge, which is where we all are today, there's not a lot of precedent to lean on.
But yeah, I just thought that might be one data point that we could do. Okay, that's really cool. One last question. Well, one thing I did want to point out is, you know, the state of Connecticut has been, this isn't I would say a totally new thing. We have been under our Medicaid structure. We have been, and I'm trying to remember the name of the term here, you know, looking at, I'm just looking at my notes here. We have a system where we have been managing our state Medicare system with the captivated managed care organization, instead of using a captivated organization management care. And I have seen that's been pretty successful for our state. In comparison, we have some of the lowest rates. So this, you know, our state has a good record of being able to manage this, and in terms of risk management, as well as any sort of stop loss aspects that Senator Wang was referring to. And you've illustrated as well as in the state employee pool. Can you also just describe to me for my last question, or sorry, my second to last question, where, how this would be set up in our state budget? Would it be an individual sort of separate fund, or how are we ensuring that the funds are not being commingled with other funds, including in the general fund?
Thank you. There are many voluminous even accounting rules about commingling dollars like that. And so it would not be acceptable from a policy perspective related to the healthcare effort here, but also from a simple accounting effort, we would not allow that to occur. I think the legislation is pretty clear that this is a self-sustaining program. It does not have impact on taxpayers unless they want to participate in the public option. You know, once we get the thing stood up and running, it's self-sustaining after that. And with the margins that we've been discussing, I think you can see that even if I double the 2.3 admin fee, which we won't, we are still far and below any of the others that are in the market. If I may suggest, and it's a little bold on my part, Representative, I think it might be worth asking the industry representatives or the company representatives when they appear, and I suspect they will, to break out that 15 or 20% and where do those dollars go. And I would also encourage that response be put in writing so you can really see.
Yeah, I've kind of looked at some of that myself in previous years when we've contemplated this legislation, and you know, I haven't been able to figure it out. I never audited insurance companies, so I don't have any personal knowledge on how that works. I would like to. My last very small question is in regards to something in the specifics. It talks about children being part of the plan until age 21. Why is it not 25 like we have in the under the Affordable Care Act, the ACA?
Josh, can I ask you to jump in here?
I think I can refer to which paragraph it is. I'm sorry, I don't have it right in front of me, but it's included in line coverageable.
Would it be similar to sort of state the intention here? And
Sure. I think that's the way
it syncs up.
Yep, I think that's the way to do it. So, you know, the enrollment the eligibility would be the same as it is with the state employee plan and the partnership plan. And so dependents do have the ability to stay on coverage until they turn age 26. In both cases, that's for medical. For dental, it's until they turn age 19. So there's a differential there. But there is no intention to have a different rules relative to how long dependents can stay on the plan relative to the program. And if that's in the language somewhere, we would need to go and clean that up.
Yeah, maybe I misread it. I will double check, and if I do find an issue, I will let the committee know about it. And oh yes, line 84. That's it.
Okay. We'll take a look at that, Representative, and thank you for bringing it to our attention.
86, excuse me. So thank you so much. I appreciate your time and look forward to listening to the testimony today from everybody.
Okay, I'm going to read off the next 4 speakers and ask that we have some questions that are mindful of the time, of the comptroller's time. Next up is Senator Anwar, followed by Representative Farrar, followed by Representative Nuccio, and followed by Representative Meskers. So I just want to give everyone that time to just keep in the back of their head. Senator Anwar, thank you.
Thank you, Madam Chair. Thank you, Comptroller Lembo, for your testimony and your hard work. I wanted to frame the questions, and I think Senator Wong may have set me up for asking some of the questions in some manner. Let me first start by putting it in perspective that if this bill becomes the law, and then we have a public option, we're not requiring people to choose this. People have that option to go into the existing marketplace and buy whatever they choose. Is that a fair statement?
It is, Senator, and in fact, the presence of this option, the hope, I think, secondary hope would be that it would put pressure on the other participants in that market to bring their quality and price in line if they possibly could.
Right. So some of my colleagues, when they're framing this question as if this is going to be the only thing that will be available, is almost like mischaracterizing the whole idea, because this is something that is out there in the marketplace. And then when people say we want the market to be there, but they say, well, we want the market to be there in a manner which may not be fair to all. If we want a fair market, it's a fair market to be able to give options to this option as well. So that's something I think may have been missed into the weeds that we were in a little while ago with some of the conversations. So again, option is there. I'm going to ask you some rapid fire questions, and these are some clarification. Is this going to increase the tax for the citizens in the state of Connecticut? 5-year horizon, 10-year horizon?
No.
Okay, thank you. That was easy. Is this going to increase the access for people?
Yes.
For health? Okay. And is this going to increase the affordability of healthcare for people?
If past practice is any indicator, yes.
Okay, good. And is this going to be publicly traded like others are publicly traded?
Gosh, no.
Okay, good. All right. And when one of my colleagues earlier had mentioned that they believe that the insurance industry has the best interest of the insured in mind, I want to clarify, because when they are publicly traded, is the publicly traded company's best intent to cover the insured, or the owners of that company, if you will, through stockholders? Do you have an understanding? I'm not very good at some of. Maybe you can help guide me this.
My understanding is that their primary responsibility is to shareholders.
Okay, so that's clear. So when the statement was made that all the legislators have the best interest to look after the industry, no, my interest is not to look after any specific industry. My interest is to take care of the people. So I want to separate myself from that comment, because I do feel that we are answerable to the people we represent, and yes, we want the businesses to be there, but we want the businesses to be in a fair manner. So there was a very interesting perspective. Now, I'm a small business owner, and I'm interacting with a number of physicians who are small practices. None of them are able to, being clinicians, being in healthcare, cannot manage the healthcare costs of their small businesses alone, across the board in small businesses. But then I see one of the organizations that represent some businesses, they say that the 70% of the businesses do not have a problem. So I'm confused. Have you heard otherwise?
I have not heard otherwise, and I think you have to look at the audience that is being surveyed. The polling, the social research that was done by the coalition in support of Senate Bill 842 really randomized who they spoke to. They did not speak to a subset of a membership of a trade organization or a subset of membership of a business organization. Those representatives who get regular mailings from that organization telling them why they shouldn't trust the government. So there is the data is not to be relied on too heavily. Interesting, instructive, but not binding.
Okay, thank you so much. The other question is, I'm also a state senator. If I wrote a letter that was written to you, to all the insurance companies that are managing with the same information, how many of them would be allowed to share the information that I would ask? If I changed the names of the people and then asked their CEOs, how many of them would send me letters with all of that depth?
I think the response is something like go pound sand. It's not information that you get access to and are not entitled to in their view. And we as a public organization must be transparent.
And I think that's why I loved how Senator Hwang was able to do it, to illustrate the point that we need a public option so that the public can answer and expect some answers in a manner which are going to be helpful, as opposed to an industry where those questions are not even asked or answered. And it's almost, I think it's well, I need to be polite. How should I say it? It's almost unfair to have two levels of scrutiny and look the other way for one of the biggest industries, and status quo is acceptable. Because the status quo is not acceptable to any that I've ever come across. And I'm in healthcare field. I wake up in healthcare field. I go to sleep in healthcare field. During the day, I do healthcare with my colleagues and friends. Not a single person is happy with status quo. And then somebody to say that the status quo is okay, but because there's a conversation on a public option, let's scrutinize them with such vicious passion that we will actually try to look at it. And I'd say, you know what, let's share that passion across the other side of the business entity that is working for the shareholders. And it would just be the fair thing to do. And then if you don't do it, then I don't know who people represent. So I'm passionate too, so I want to be able to say what I feel like it's worthy to say. This was not a question, this was just my venting and therapy maybe. So again, the small business definition, how do you define small business?
Defined as 1 to 50, which is consistent with other public definitions of small business.
And those are the ones who are hurting the most right now.
They lack
at least from
they lack any force in the market.
Yes, good. And the was if we were to, let me just summarize so far what I have understood from what you have said to me is that the taxes are not going to increase, the access is going to increase, the affordability is going to increase. It is to be an option that people can choose to use. They don't have to require to use. And people can send you polite, nice letters and they will get a response back as well. And you will be able to share some of the data that no other entity is willing to share in the depth that's of you. And this is going to help take care of the small businesses. And you are not public traded, so you're answerable to the people, including the and you're looking at a broader long-term strategy. One more clarification is when we are writing a bill, we are not writing a bill around a personality. Yes, you have an amazing personality, everybody loves you, but this bill is not about you. You are the architect, but it is about talking about a comptroller who could be in 50 years somebody else. Fair?
That is absolutely true. And we would be doing a disservice if it didn't live in perpetuity.
Yeah, so again, that's because I think we have to frame the questions in a manner so we bring it back to the common sense that needs to prevail so that we don't go in directions which are somewhat interesting, to put it mildly. Thank you so much again for it, for your testimony and your opportunity for us asking the question. And Madam Chair, thank you for allowing me to speak. Thank you.
Next, we have Representative Farrar, followed by Representative Nuccio.
Thank you, Representative Wood and Comptroller Lembo. Thank you for being here. I know we've already kept you in your seat for a long time, but thank you for answering all these questions for us and for just, continuing at this with the passion and really the determination of bringing more affordable and accessible care to our state. And I really had a question, actually, my background is very much in the nonprofit sector, most recently as an executive director. And I know how scary and stressful it was, for us as a nonprofit every year and facing the mounting costs of healthcare rates and also just not knowing if we could continue to provide healthcare to our very important staff. And, it really has been in this moment, I think, of COVID. We know our nonprofits are serving the most in need in our community. And I heard very recently from a nonprofit here in my district, Futures Inc., who serves individuals with developmental disabilities, just how much they're in crisis about their health care. They have a plan that they've been able to offer to their 130 employees. And they this year saw a $99,000 increase in their healthcare provision for their employees. And this was simply due to one participant's use of their healthcare in the plan. And this really led them down the path of needing to only provide what was a very high deductible plan to their employees. And when I heard this story, I know that this nonprofit in my community is not alone. And each year the benefits for our nonprofits are really become more out of reach. And I know in the case of Futures Inc. and so many nonprofits, if they had more predictability in regards to the care and the rates that they could keep staff, they could stabilize their service provision to so many who are vulnerable in our community. And they could also just have more healthy and well staff, which lowers costs. So I know in your original presentation, you mentioned a little bit about high deductible plans, but I really wanted to hear from you about how this proposal will address the high deductible plans that we're seeing in the marketplace and how it can really help so many nonprofits that might be in the same situation.
Thank you, Representative. I appreciate the question. Anyone who's followed this for some time knows there was a time in Connecticut where high deductible plans were not allowed. There was specific limitation on them, and year after year after year, we fought to keep that provision in place and not allow these types of plans to come into the market. Because these types of plans hang on a false belief that somehow a patient will be able to have skin in the game and will be able to make better, more informed, higher quality choices than their employer, who might be the sponsor, or even the insurance company who sponsors it. And that is just false. We know for the record that healthcare is not a market. This is not the kind of thing where you can go in and measure, pick up 2 cans of peas in the aisle and decide this one weighs a little bit more and it costs less, I'm going to go with this one. Or I've heard good quality about the other one, I'm going to go with that one. That doesn't occur in healthcare. We make sometimes irrational choices about where we're going to get our healthcare instead of using data to drive that. So the language of the statute, of this proposed statute, is very clear. I don't want to get ahead of myself, sorry, in that high deductible plans are not offered. So they would be more traditional plans, copay type plans that we run now. It's also important to remember that the push to high deductible plans pushed people further away from care, even with the requirements that there be first dollar coverage for a number of things. And I'm going to use one example, and that is when dad gets up on a Sunday morning and is making breakfast and says, "What is that feeling in my chest? Do I have indigestion, or in my house, agita, or am I having a heart attack?" The moment that person has to think about, I'm going to have to pay out of pocket for this if it's not a heart attack, is the moment that we want to avoid. That is exactly the wrong sort of thinking that we want. What we want in healthcare is people to stay on top of things, not overuse, but appropriate use in the appropriate places. So we have proven in the state plan through our health enhancement program, through our disease management programs, that bringing people closer to care saves money and improves quality of life, as you already mentioned in the goal for the nonprofit. So sorry, that was probably more than you wanted, but high deductibles are not part of this.
Yeah, and could you just reiterate, because I know there's a distinction in the bill that the small businesses are up to a certain employee, but nonprofits of any size, that can participate. Is that accurate? Because I think that is essential, I think, from the nonprofit community to know that that's the case.
It's nonprofits of any size, and nonprofits in their size, as you know, in many cases have grown for lots of reasons, consolidation, common interest. But a lot of that has been driven by state funding or the lack of state funding that have forced mergers between nonprofits where they didn't exist before because they were just trying to keep the services alive.
Wonderful. Thank you, Comptroller, for your time. I will yield to my other members and just really appreciate your time and perspective. Thanks so much.
Thanks, Representative.
Next is Representative Nuccio, followed by Representative Meskers, and then we'll be moving on to the next speaker, Senate President Marty Looting.
Good afternoon, Comptroller. I don't think we ever met, so this is our first face-to-face here. So thank you very much for coming.
You win for best background if it matters.
I wish it was real, although I see Representative Daffins,
I know, but
and hers I think is real, and there's jealousy in my heart. So thank you very much, though. So I have more questions than I probably can get to in this. So there's a few things that I wanted to try to focus in on. From the perspective of the plan, you had made a couple of comments here, and that you're pooling your experience between the state employee program and the partnership program currently. And that is then helping you to keep the rates low on both sides of the plan. But where I'm really concerned is I know the report that came out regarding the $30 million loss. So if you are not participating in a stop loss program, which you indicated that you're not, and you don't feel like it would be financially beneficial to participate in one, when you have that monumental loss of the $30 million, how is that then being aggregated and paid for? Where are we seeing that as the ultimate responsibility?
So Representative, thank you, and I appreciate the question. The 30 million is on a book of business about, I think, $1.5 billion. It's a big number. So you're right, 30 million is a lot of money, and it needs to be accounted for. And your question is what happens to that? Well, that gets baked in a shared risk arrangement with the other partners and is reflected in the rates going forward. But even with that, our increases in the partnership plan over the years have been anywhere from like 0 to I think 7 has been on the high point. And as I think you probably know, most folks, when they open their new rate renewals, would give their eye teeth for a 7% increase, much less a 0% increase. So that's how we deal with excess. And the other thing I'll point out, and I don't want to go down the rabbit hole about this, but I'm happy to sort of sketch it out if it's helpful, And that is, there's differences, as I've tried to articulate in the letter back to Senator Huang, between the appropriation and the actual healthcare account, because you've got employee dollars flowing in and you've got general fund dollars flowing in. So the savings numbers are a little bit sort of skewed, or the deficit numbers are a little bit skewed. But it's an important point. Nobody wants to run in the negative. And if we had, in fact, got the language corrected between the first year and the second year of the biennium, where it was incorrect according to the understanding and would have been correct in the change, we wouldn't be looking at this at all. So it's not a usual circumstance, is my final point.
Okay, so, and I guess that kind of leads me into my next part. The fact that this language is guaranteeing no more than a 3% increase is unheard of in the industry or most anywhere else that I've ever heard of. So just from my knowledge of how insurance works, I know I struggle with that, because your premium cost is always based on your claim experience. So if you have high claim experience, even if you're spreading it over the state employee plan and the partnership plan, from a premium perspective, and you're deflating your premiums to keep premiums low, when that high cost comes in without a stop loss plan or anything of the sort, the backdrop then becomes you have to raise your premiums. Like Representative Farrar was just saying, one of their members had high usage, and then the plan had to be adjusted to account for that, because overall, all health insurance is a socialized plan, and you count on your healthy members to help pay for your sick members. So in this case, by guaranteeing a 3%, no more than a 3% increase in any given year, my concern is if you have some catastrophic claims come in, if you have 3 preemie babies come in, there's a very high chance that you're going to exceed that 3%. And at that point, how are you going to keep the premiums low without covering the cost share? And at that specific time, when you have that deficit, who pays for that? How does that get paid for?
Representative, you clearly have a good understanding of insurance and how it works. So your presence on the committee is probably welcome. So thank you for your question. The 3% is a rate corridor, and it's got stop loss behind it. So it's the over under, right? I think as Josh was trying to articulate earlier. And it's not a sort of a year over year. It is that over under. Josh, are you here? Can you just go through that one more time for Representative Nuccio?
Yes. Let me just turn on the camera here. Yeah, Representative Nuccio.
I don't mind small children in the background. I had a few of those myself. You know.
Thank you.
Bring them on in.
Appreciate it. So yes, the 3% has to do with the annual premium adjustment that would apply to this group. And what it is, though, it's 3% plus or minus 3% relative to the experience of the entirety of the group as a whole, which would be inclusive of the state employees and partnership and whoever these new participants are. So if you assume that the partnership and state employee plan, the whole group has a 4% annual increase, then this sort of new group could range anywhere from a 1% to a 7% increase. So it's more of a rate corridor. And so that is to allow some additional reflection of the actual experience of this group on its own, which actually provides, I think, a little bit more protection both for the state and for these groups, assuming that in some years they may perform better relative to if we pooled the experience 100% without any allowance of variation for this newly participating group. So and relative to that, well, in addition, the legislation also allows or I guess requires the comptroller to mitigate risk to the state and provides some avenues for the comptroller to do that, including the purchase of stop loss insurance, whether that be aggregate or individual, and or the charging of a risk charge to this group, which would be set aside in a fund to fund any overages that might occur, like those that you just described. So I think there are components in the bill that envision, right, risk mitigation for those scenarios when this relatively small group might have some high claimants and run into a cost overrun.
So in saying that, I guess that was part of my concern with the bill too. The mitigation strategies that you mentioned are mays and not shells. So that's a bit of a concern when you're talking about mitigation strategies and having that. So if I hear you correctly, what I'm hearing is you're pulling everybody together, but your pricing is going to be the state union plan as one, the partnership as another, and then this new group could significantly be, or could potentially be a separate premium base because they're going to have a different corridor.
So the initial premium renewal, right, is based off of the experience of the entirety of the group. So all three populations. So if we look
Correct.
at today,
pulled together. Yeah,
pulled together, right?
You get the best rate by doing that. You get to socialize.
We get the stability, right?
Again.
And that's some sort of the key component. But in order to, and to be honest, we put it in there as more of a risk mitigation factor relative to the state plan, is if we let this then look at the actual experience of this group alone and see, did it perform better or worse? And we then further adjust their rates relative to their actual experience. It provides additional mitigation or risk mitigation for the state. So let's say that the group as a whole, again, has a 4% requirement, but this group really needed a 6, then with that 3% rate corridor, they can end up with a 6. But by tying it to the state employee plan within that rate corridor, we are at least providing them with some level of predictability for their annual rate increases, right? They're not going to end up with a 30% rate increase, which is a real scenario in the small group market that does happen to folks, but that's not something that would likely happen under this design.
Okay, so you just brought up a very good point there regarding the fluctuation in the small business market and how they're also rated too. So I had someplace else I was going with that, and it just went in and out of my head. So you had mentioned, I'm sorry, back to Comptroller Lembo. You had mentioned something that I found quite interesting. Being familiar with the plans, I know that the state employee plan is managed through Anthem. And this is, please forgive me for my nativity here, but is the partnership programs 100% solely managed through the comptroller's office?
Yes.
It is. Okay. So when you said you are negotiating provider rates and hospital rates directly for the partnership plan, the intent of this new partnership plan would be that you would also be the one negotiating partnerships, provider renewal, provider network programs and such?
Representative, I'm sorry if that wasn't clear. So when our negotiation is across the entire book of business, so I'm primarily negotiating for the state employee and pre-65 retiree plan, that those reimbursement rates get extended to the partnership plan, and they would get extended further to the new groups that would be coming in under the small business and nonprofit side. So it's a single negotiation, and the reimbursement structure is it's an aggressive negotiation, but it's still more than adequate. And the carriers and the providers and the hospitals seem happy to take the reimbursements that we've negotiated so far.
So that negotiation then is probably being headed up through Anthem, though, correct? Through their provider negotiation teams?
So no, yes and no. So in the targeted networks of distinction and centers of excellence that we're doing, those bundled payments that I had mentioned earlier, we have stepped out from behind the curtain and are negotiating directly. We tell Anthem as our TPA what those rates are going to look like. They embed them in the reimbursement system, and that's the way it goes. So it was hard, you might understand, having carriers, TPAs, bid on our business, knowing that was an absolute requirement because a number of the bigger companies in Connecticut and in the nation did not want to allow us to negotiate our own rates. And so in that case, they lose the opportunity to serve this group.
Well, I find that interesting because, you know, I'm a firm believer when we talk about affordability and access to healthcare, insurance is almost a byproduct of that, right? So if you know how insurance is built together, the majority, as you had mentioned, from an MLR perspective, from a federally directed perspective, at least 85% of every dollar has to be spent on healthcare, and that's a conservative number. So all insurance is really built off of claim experience and how much is being charged by hospitals and doctors, and you have consolidations and about a million other factors that go into that. So to truly deal with the cost of insurance, you have to deal with the cost of healthcare. And that negotiation process is pivotal, especially when you have a lot of hospitals that have consolidated together and have a bigger market share, can really direct how that negotiation happens. So I'm very interested to hear that you guys are actually negotiating your own reimbursement plan, your own provider networks and reimbursements back. So that kind of gets me to the three different areas that you're looking to bring this insurance to. Actually is pretty much going to cover between three different markets, because in the insurance world, one person is an individual market, 2 to 50 is small, and 51 and over is large. So with Taft-Hartley going from 1 to 100, you're actually incorporating the Taft-Hartley business on top of individual and large. And then in the small, you've got 1 in 50. So you're reaching over a bunch of different markets to bring in this populace here. I have a concern regarding the guarantee issue. And I understand fully why you would want to be able to select the plans that are coming into your policy, but by doing that, you risk leaving only the unhealthy plans in the actual market, which is then going to turn around and inflate the cost of insurance for everybody else who is in that market, because you're no longer able to socialize the bad risk over the good risk. So that, I think, is definitely an unlevel playing field from industry to what you're planning to offer. And that's something that really kind of makes me a little wary, because it is going to have a very big ripple in the actual market across the board. And another piece of the program that I would like to really clear up is you had mentioned there's a $50 million assessment that is in this language specifically. And everything that I'm reading, it almost makes it look like it's going to mirror the public health fee assessment. Is that accurate?
Representative, I can't really speak to that. It's not a section of the bill that I'm working on. And I think when you meet as a committee, Senator Lesser and others can probably flesh that out better for you. I will say, though, that the underwriting criteria for both of these groups is, as have been already articulated, the reason we would deny a group is for the reason that I've already articulated around partial group versus the whole group, and an attempt to wash bad risk through the plan. If there needs to be stronger language around that, so folks are clear about what that means, I'm happy to entertain that idea and work on language that we can all live with. There's already an unlevel playing field. So, small employers trying to afford insurance and get the best rates for themselves already in a horribly uneven situation. So I think the only jobs, insurance jobs are not the only jobs, right? We want to preserve those insurance jobs, and I hope that they will step up and sharpen their pencils or figure out how they're going to operate if this is the new reality. But I think there are other jobs that are there and other jobs that can be grown. And I think what you would be doing if passing this bill would be to support those as well. So we hear those words on level playing field an awful lot. And sometimes it means we shouldn't be doing this at all because it's not fair. And sometimes it means there's a specific piece of it that needs to be articulated.
I would agree, and I think there are definitely specific pieces. There are several places where the state, in this case, would have an unfair advantage over the cost of insurance. Back in 2016, when Governor Malloy reduced the budget by $4.5 million for a bunch of programs, within days, a state assessment was passed that was then put onto insurance companies to handle that. And when we get those assessments, I want to say a good 90+% of the time, government exempts themselves from paying a lot of assessments. Right now, there's currently 5 state assessments that I'm aware of in the state of Connecticut that go against insurance providers. Those are pass-through taxes, and those taxes directly impact the cost of insurance to insured members. So I ask a lot of questions regarding the 30 million and everything else, because when you take a populace where you're spreading the money out over a larger group, and then you pass a state assessment, or you have premium taxes or other things that then get applied to a policy. You had mentioned when you talked about the admin costs, you said you wanted to have the plans pay their equal share of the admin costs. But then when you mentioned insurance and in that sharing of cost, you said that they didn't want to take it out of their hide. Now, I find that a little unfair, because these legislation that is passed then comes back to the insurance company as a pass-through tax. If that person if the insurance company didn't participate in Connecticut's market, Connecticut wouldn't get any revenue from that. So when you take those dollars and you put them back over to the insurance company, they directly impact the cost of insurance, which makes it more expensive. And when the state exempts itself from that, that is the direct definition of an unlevel playing field, because one has to build in the fee and one does not. So when we talk about the $50 million assessment and the retaliatory taxes and premium taxes and everything else, these are all very distinct pieces of the cost of insurance, the cost of health care on top of the cost of claims. So if there's a conversation to be had where we could look at that, I'd gladly participate, because I think if you truly want it to be the same throughout everybody, then we need to work on having the same rules for everybody. You had also mentioned the MLR and it being high, and I know you've talked about this a couple of times, and I was just wondering if there's an opportunity for you to share the monthly MLR with the commission so they can look at it, because 2020 is definitely a very rare claim year. We saw extremely reduced claim capacity across the entire industry, across the country, probably across the world. So I'm a little wary anywhere when anybody starts talking about 2020 claim history, that it is very tainted. So if you could, do you think it would be possible to share the MLR over the months? And I noticed you mentioned that you believe all of your runoff is in there with a 30-day runoff, and that your number after actualized will actually be higher.
Marginally higher.
Okay.
Tiny.
Tiny. We take tiny counts.
Tiny counts. So I'm sorry, I just did what? Completely lost my train. You go ahead. I'm sorry.
I did it too. It's okay. We do it. We all do it. A couple other pieces that are in this bill. Some of them I actually I find favorable. With increasing the federal poverty limit to the 200%, I think that will really help capture a lot of the individual market in the small business area. That would help provide more subsidies to people who need help to kind of obtain insurance for that. There's also a question in here regarding, I believe, let's see, I'm sorry, around the undocumented portion of this. I believe it was was it 25 million or 20 million of the $50 million assessment was going to go for that. Currently, can undocumented individuals purchase healthcare on the private market today on the exchange? And is there any subsidy they can
I'm
get?
not, Representative, I'm not sort of expert in any way in the undocumented situation in Connecticut. And I think I wanted to make sure I said that at the opening, that there will be people behind me who will be fully versed in that. And I would encourage you to ask that question of them.
Thank you very much. I will write that down to make sure I ask them that. And then let's see. like I said, I had a lot of questions. I'm trying to go through because I think a lot of people have asked some ahead of time, and I don't want to monopolize the time here. But
And if it's
overall,
helpful, Representative, and to all members of the committee, if we don't get to all your questions and you want to shoot us an email with those questions, we're of course happy to answer those.
I appreciate that. One other thing that you had in here, I would really like to delve into at some point, is by offering the Taft-Hartley and the small business and the state employee and everything else, you had mentioned in the law specifically that you would not be considered a MIWA, but I think just by having all of those different populaces in there, it does constitute you being a MIWA.
That's why the language is there, but we're happy to discuss that further.
Okay. And again, I'll just end with, I think there's a lot of work that we need to do on truly looking at accessibility and the cost of healthcare. My concern is with this, A, the no stop loss and where does it go if we have the shortages, and B, really just truly addressing the cost of care. And Senator Anwar pointed out that this would make the market fair. I'm not necessarily on board with that one. And he mentioned something about, insurance companies being beholden to the stockholders. And I would say any publicly traded business is insurable to their stockholders. But as a doctor or any other individual too, if you have investors in your firm and you're not actually a profitable company, you will have no profits to share. So it is in insurance, in the market's best interest to make sure that they're looking at healthcare costs to make them affordable for people. So I don't want to point fingers at industries that I think are really trying to do a good job on reducing the cost of healthcare. And I thank you very much for coming with your team. I appreciate it. And I look forward to further conversation.
And Representative, just for clarification, there is stop loss, as you know, in here. There are it does say may, it does say that I have to protect the state against risk, and I'm losing my voice, I apologize.
We're talking you to dryness, I get it.
And I've been sipping water, but it's not working. And the other thing is the cost of care question. Sometimes it's said like, this doesn't do anything to manage the cost of care, and that is just false. And I'm happy to sort of work through what we've done to control costs, and it's evidenced by that number that I talked about earlier by way of savings to the state.
I appreciate that. Thank you very much.
Of course.
Thank you, Representative Nuccio. Representative Meskers is our final representative on the committee asking questions to Kevin Lemba, and then we will move to Senate President Marty Looney. Thank you.
Thank you very much to the chairs of the committee. So I have a preliminary question related to the risk pools and risk assessment. We were talking about using the public, the state employees, and the other plans in terms of figuring out the risk of the pools of insured. Are we combining the premiums in the risk pool, or are we just using the combination in terms of assessing healthcare cost when we're looking at structuring the plan? So are we still segregating out the risk and risk premiums and just blending the cost structure in because we can access or force the providers to add them to the pool?
Representative Meskers, I'll ask Josh to jump in again if you don't mind.
Okay, perfect. No, that's exactly where I go.
Yep. Thank you, Representative Meskers. No, the concept would be to pool the experience as well as the underlying price essentially of care.
But that's on the costing side, so that's the provider providing us. But the premiums are segregated and they're not blended in, i.e., the public sector employees are not assuming some of the risk of the insurance that you're providing under this plan.
Right, Josh?
Well,
it's
yeah.
So it's limited, but there's it's a pooled risk program, right? So if we are looking at the experience of the entirety of the group to set the base premium, then that premium impacts all participants in the group.
Right, but I segregate out the premiums into separately managed pools of capital. So one plan can be underfunded if the premium experience. So what I'm saying is you're using it to provide care, but the revenue streams are segregated risk pools. If you think it's
The revenue, yes, that's correct. That's correct. Yes. Thank you.
meaning
I
that the
apologize
employees
for
are not sharing yeah, okay,
Yes.
that's the
Yep.
issue that I thought was, so, you know, first, the presentation from all of you, I think we sat and had a long conversation earlier. The presentation has been very profound and good, and I'm wrestling with the subject, and I think you're aware of that in my conversations and questions. So what I'm trying to make an assessment on the question I have, a private sector comparable policy versus the policy you're proposing to offer to a nonprofit. It would be helpful for me, and I'm going to ask this from the private sector, so I hope the companies that are opposed to this are listening as well. The question is, what's the value of the policy or the cost of the policy to a small employer who joins this pool for the type of coverage they get? How much of that represents the saving or the improvement in price represents your management of the risk pool, your management of the nature of the provider of the insurance, and how much is represented in this assessment to the insurance companies that's going to work as a subsidy in the cost of the insurance, right? We're talking about a $30 million roughly assessment, potentially. I know we haven't figured that out. I want to know more about that because I'm essentially looking at how I'm assessing other pooled insurance groups to provide this access to nonprofits and others to the insurance. So it is indirectly a subsidy and or a tax. So I want to know how crucial that is to this proposal. So I want to know what it represents in terms of the cost of a premium, if possible.
Representative Messers, can you just clarify the 30 million relative to the public option? Because I don't know that these are connected.
Yeah, well, I'm trying to understand how the assessment we're proposing or potential assessment to help subsidize the plan, right? This public option.
Not this.
Okay.
We're talking about individual subsidy on the exchange. This is self-sustaining. There is a marginal startup cost, but this is not. That assessment has nothing to do with us.
So the previous comments related to the assessment, that led me to think that there was some assessment embedded in this, and there is not.
Well, no, not in the public option piece, not in the small business nonprofit Taft-Hartley piece of what we're doing.
Okay.
You're
perfect.
not subsidizing that.
Okay. So then the only question then becomes a simpler one, which is what's the estimated entry level cost? I mean, ultimately you're using a pooling to reduce the cost to the individuals or the nonprofits. So they get into a pooled group and risk mitigation. I understand that. The second piece of that is that you're also negotiating directly with the healthcare providers. So you think and you believe from your history, you're driving down healthcare costs. So on an ongoing basis, your compounding rate is lower. That's basically assessment. That's what I've gotten from the pitch. And the question is, what do we think that works out to? So tomorrow, I am a nonprofit you could put it in Fairfield. I know it's 30% more than Hartford. I don't care where in the state, but on an apples to apples basis, what does it cost me to get this insurance from Aetna, a comparable policy to what you think you can do here? Because you both, and the two drivers, correct me if I'm wrong, are the pooled, that you're entering into a larger pooled group, which reduces and smooths the risk to the individual policyholder because you're in a larger pool. And the second thing is you think you've negotiated a damn better deal with the providers, with the negotiations in terms of that, who gives us the healthcare. So that differential works is really what we're giving people access to in this public option, right? In a nutshell.
I think that's right. I'll say just at the top of your comment, this idea of like lowering costs that we believe and we say, and we can prove we have. That's the other piece of what you said.
Yeah.
So I think as we discussed when we met about this previously, they are working on premium, but I think there's a fundamental question here, and that is, will a decision, and it may be true of your decision, or should a decision hang on how much premium savings we're going to offer to that nonprofit that's waiting in the wings to buy coverage? or instead as a policy decision with the appropriate mitigation pieces in place, is this a good idea for the state to be moving forward on? The success of this, you're right, will be driven by the price point, the predictability, and the sales network that gets deployed to get this done. And if it doesn't work, it doesn't work. And we will have been wrong, and we will have wasted a lot of time, but not state tax dollars.
Okay.
So, I think as a management type person, I completely get where you're going with that, but I don't know that that's sort of the question before us right now, dare I say. It's presumptuous on my part. I hope you forgive me.
No, I know. I really appreciate it. Anything that helps me frame. That's why I still want to hear to the opponents in the private insurance industry as well, or what their plan is, because I think you've been eloquent, and I think you've been a strong advocate, and I really appreciate your presentation. So I'm wrestling with the issue because I want to understand, that full balance, and I can understand why, if I'm sitting here in the nonprofits, I'm interested in this, and why if I have been brokered out of insurance because of the cost structure, why this matters. So I appreciate all the effort. It's not lost on me what a heavy lift this is. So thank you.
Right. I appreciate.
Thank you, Comptroller Lembo, to you and your entire team. We really appreciate you spending several hours with us.
I'm going to say it's my pleasure, Representative Wood, but I think I'm done now, and I'm happy to cede the floor to our next witness. Thank you.
Great. Senate President Marty Looney, you're up. And next, following Marty Looney, is Representative Sean Scanlon.
Madam Chair, I got a note from Senator Looney that he had to leave to attend to another meeting.
No, I'm not. I'm still here.
Oh, you did? I'm sorry.
Yeah, no, I have to leave. Yeah, I have to leave at 1:30, so I won't be able to stay for questions, which I'll be happy to answer by email afterwards, but I'm certainly here for my testimony.
Okay, perfect. Thank you.
Good.
Please
Thank
go
you,
ahead.
Madam Chair. Thank you, Madam Chair. Representative Wood and Senator Lesser, Senator Huang, Representative Pavlak D'Amato, members of the Insurance and Real Estate Committee. I'm Martin Looney, State Senator from the 11th District and Senate President Pro Tem. And I'm here to testify in support of Senate Bill 842, an act concerning health insurance and healthcare in Connecticut. I was here for almost the committee's entire colloquy with Comptroller Lembo, and I think his testimony did highlight that our healthcare system in Connecticut does work well for some, but not for many others. It works well for those who are employed in well-resourced and well-endowed institutions, be they corporations or other institutions. It works well for those who are fortunate enough to be employed in government, either at the federal, state, or municipal level, and have decent health care through their employer. It works well for those who are employed in institutions or companies that have strong unions that have been able to negotiate a good benefit package for them, but it works not so well and terribly for so many others, especially those who are marginally employed by small businesses or not employed. And the challenge, as we know, is that many people in Connecticut are technically insured, but their insurance really only amounts to having catastrophic coverage because their copays are so high, their premiums are so high, and the costs are so high in connection with the policy that they are only able, their policies only kick in when something serious happens, and the rest of the time they are paying out of pocket. So state residents really cannot wait any longer for affordable health care. Those with coverage struggle to pay increasing premiums and keep pace with the skyrocketing cost of prescription drugs as well. Thousands of Connecticut households go without coverage because they make too much or barely too much to qualify for Husky or for subsidies, but still can't afford the full cost of private insurance. And before COVID-19 expanded healthcare inequality, the uninsured rate for those just above poverty was already rising. Small business owners face a system where they have no leverage to negotiate competitive rates and lack the human resources to establish an employer-sponsored plan. We can't wait for Washington to address these problems, although in the ideal situation, they would. I urge support for Senate Bill 842 because it provides solutions to address the most vulnerable parts of our current healthcare system. Comptroller Lembo has proven the ability to construct a state employer health system that a state employee health system that leverages the size of the state workforce. Under this bill, the same effort, knowledge, and effectiveness will be used to pool the needs of small businesses, nonprofits, and unions, while utilizing the administrative resources of the private sector to offer new state plans. Eligibility for Husky will also be expanded. Additional subsidies will be made available to those at or below the 200% federal poverty level, but who still don't qualify for Husky. These are households working to survive, barely surviving, including an individual making between $17,700 and $25,520, or a family of four with income between $36,400 and $52,400. Together, all of these provisions will help those left most exposed in our current system, the uninsured. The bill also includes various provisions to ensure programs already administered by government are connected to increased government effectiveness. The Department of Labor will coordinate with the Connecticut Health Insurance Exchange to help transition currently laid off individuals to plans more affordable than COBRA. People who lose employment are in danger of dropping coverage, and a little guidance at this point can be crucial to maintaining continual coverage. This bill is good for individuals, it's good for small businesses, it's good for our state's economy, and it's also going to be something that will help promote entrepreneurship, because we all know that many people who would like to take jobs in small businesses or form small businesses on their own because they have a creative idea that they would like to advance are afraid to do so, are afraid to take the leap without a net, that launching into a venture like that would be without guaranteed health coverage and health insurance for an individual, his family, or for any employees that he might hire in a fledgling small business. So when people are concerned about employment in Connecticut, about jobs in the insurance industry, there are also jobs that we are foregoing by not making safe and accessible insurance available to many who don't have it now and would be in a position to become job creators in small businesses. So I thank this committee so much for raising this important piece of legislation and taking it on as something that will be promising for so many people who live in fear every single day. Thank you, Madam Chair, very much. And as I said, if members had any questions for me, if you email them to me, I would be happy to respond in writing. As right now, I have to get on a budget briefing with OPM regarding the governor's budget for tomorrow. Thank you so much.
Thank you, Senator Lemmy. Next up is Sean Scanlon on? Okay, is Senator Christine Cohen available? Representative Ann Hughes.
Thank you, Madam Chair. Thank you, Mr. Chair, and all the members of the committee for allowing me to testify. I do miss being on your committee. I just wanted to highlight that lack of access to affordable healthcare is a policy choice. It's a policy choice, and in this pandemic, the barrier to accessible and affordable healthcare coverage, it becomes policy violence that literally costs lives. And it's violence that we are complicit in as a society and certainly as lawmakers of not taking action. We have criminalized poverty and race in our society and systemically entrenched barriers and disparities in our healthcare systems, which are painfully clear in this pandemic. And it's just exacerbated that. And that's why I am so strongly in support of SB 842. It's a proposal that can literally help everyone in our Connecticut community and is laser focused on delivering high quality healthcare to access to everyone, regardless of their status. And that's really important too, because in this pandemic, the fact that we have denied healthcare access to frontline workers, to essential workers, to people working directly with the public in vulnerable settings like long-term care settings, that has exacerbated the violence because this pandemic has spread through those communities disproportionately. This plan will literally save lives. And I want to say something about the conversation I've heard about risk to taxpayers. Delaying healthcare, especially primary care and preventative care, and access to care for chronic conditions is expensive. It is costing the taxpayers. We do pay for that. And they are not separate from the people that need the healthcare. I mean, that's what I keep hearing, is that like, we've got to protect the taxpayers, and yet we are offering an option that is not a high deductible plan, and it does not contribute to shareholders' profits during this pandemic or expensive CEO administrative overcosts. We are very proud of Comptroller Lembo's maybe first in nation of low administrative overhead costs for administering our plans in Connecticut. And we should build on that infrastructure and extend that kind of option to especially small businesses where employer-sponsored healthcare is such a drag on our economy. And if we can lift small employers and nonprofits from that economic drag so that they can spend more of their talent in serving the community and providing a workforce that is unencumbered and burdened with the high costs of employer-sponsored healthcare, our economy is going to recover far faster than the rest of the country. So this is not just good for business, it's good for the overall health and recovery of our economy and our entire community. So I wanted to make a big plea to end the policy violence of not taking this important action that is completely critically urgent at this time, and continue to be laser focused on providing us as the healthcare capital of the country instead of the insurance capital of the world. Thank you.
Thank you, Representative Hughes. Are there any questions? Great, thank you so much for joining us. Next up is Senator Christine Cohen, followed by Representative David Michel.
Thank you so much, Chairwoman Wood. I apologize for not being on when you called, but here now, I'm pleased to be here. Good afternoon to Chairs Lesser and Wood, Ranking Members Senator Huang and Representative Pavlak D'Amato, and members of the Insurance and Real Estate Committee. I am grateful for the testimony of my colleagues before me, their leadership, and I really echo many of their sentiments that they've shared. I'm before you today to testify in favor of Senate Bill 842, an act concerning health insurance and healthcare in Connecticut. You should have a copy of my written testimony, and if it's not in your possession yet, you'll have it soon, I'm certain. I won't read from that, I'll save you that, but I do want to make a couple of points. I'm certainly no stranger to this committee and have long been an advocate for reliable, affordable health insurance coverage. As a small business owner who wants to retain my best employees, I want to ensure they are well cared for. I want to provide benefits that enable them to remain healthy and do so without struggling to pay medical bills. But instead of making this a reality, the market has made it impossible. Yes, there was a time when we were providing 100% coverage for our team members, but as I'll illustrate, this quickly became unsustainable. And let me just quickly share with you my personal historical account, because this is what's happening to millions of people. In 2016, I was paying $1,053 with an $8,000 deductible for our family of 5. By 2019, our renewal rate would have been $1,720 with a $15,800 deductible. The deductible nearly doubled with premiums up over 60%. If you do the math, our family would have paid over $35,000 before ever seeing a benefit. This isn't health insurance, it's catastrophic coverage. Instead of protecting our constituents in Connecticut, we're doing the exact opposite. We're making them ill physically, mentally, and financially. Those with these high deductible plans often decide to forego care to avoid the costly visits to their provider. If they do seek care, their bills compile and become huge financial burdens. We continue to see families having to sacrifice their life savings to cover a deductible when faced with medical emergencies. We continue to see small businesses struggling to stay afloat as health premiums swamp any productivity gains or pay raises. What we've seen during the pandemic is an exacerbation of the issue, as we've heard both Comptroller Lembo and Senator Looney mention. Tens of thousands of families in our state were left without coverage, a consequence of layoffs during the months dealing with COVID-19. And families of color and low-income workers were burdened to the greatest extent in this regard. The long-term consequences of this are great. Losing lives that could have been provided with care, folks who were teetering on the poverty line, struggling to put food on the table. It's a serious humanitarian and economic impact. But we have the chance to get on track and to really move in the right direction. A public option will provide clear, simple, reliable, and an affordable plan backed by the state that will have quality, affordable care as its first priority. We're able to leverage the negotiating power, as you heard, of the state's employee plan and provide small businesses, nonprofits, families, and unions with vital care and equitable access to the same. I'm fortunate now as an elected official to receive premium coverage at an incredibly affordable price. And I just wonder why we're not allowing others to benefit from this as well. Healthcare is absolutely a right and should not be reserved for only those that can afford to pay. And I know we can do better and we should do better. So with that, happy to take any questions.
Thank you. Any questions from the committee? Great. Thank you so much for coming, Senator Cohen.
Thank you. I appreciate it.
Next up is Representative David Michel, followed by Senator Derek Slot.
Thank you, Madam Chair. Thanks to the good chairs, vice chairs, ranking members, and to the rest of the committee, the honorable members of the committee, for giving me the time to voice my full support for SB 842, particularly strongly pushing for Medicaid expansion as well as coverage for those not able to currently and including and not restricted to the undocumented immigrants. So I would like to concede my time to Ms. Holly Hackett. I believe she's on the call. Where is Holly?
Yes,
I am. Rep. Michel.
Thank you, Madam Chair.
Thank you, Representative Michel. Hello, Senator Lesser, Representative Woods, and esteemed members of the Insurance and Real Estate Committee. My name is Holly Hackett. I live in East Haven, Connecticut, and I am here to testify in support of SB 842, an act concerning health insurance and health care in Connecticut. I am a member of Mothers and Others for Justice and the new co-chair of their health committee. Health stands for helping everyone achieve lifelong trusted health care. We have all known for a long time that health insurance is expensive and inaccessible to many Connecticut residents. I'm sure you all are aware that 2/3 of all bankruptcies are due to medical debt. This pandemic has truly laid bare how this affects our Black and Brown communities and the undocumented. My apologies. The issues of not having access to equitable care are a real problem for our Black and Brown communities and myself, I'm low income and disabled. Husky health programs are one part of a larger effort to make healthcare affordable for everyone. People at low income levels, Husky is the best option because it offers comprehensive coverage, removes the barrier of deductibles and other out-of-pocket costs, and is funded in part with federal dollars. I strongly support the bill returning Husky A eligibility for parents to 2015 levels. By doing this, it will certainly help those of us who are low income and or disabled get the benefits necessary to be treated in a holistic manner. We really do need to remember that these aren't just numbers, guys. We are people. We count just as much as everyone else. We may be marginalized, but we count. And we need to be treated as such. We need to have access to the care that we need. We need dental care. We need vision care. We need care for hearing, because hearing commits to early onset dementia, vision care, help effects with your headaches and your brain function. And as far as dental care, that can lead to a very death. It could lead to death if not taken care of, as well as mental health, because people who don't look well don't have a very good mental health picture of themselves. So these are all things that I wish that everyone on this committee would try to remember when you're discussing costs and things like that. The cost is a human being. We are not just numbers, we are people, and we count and we matter. I myself have a $5,632 spend down. For someone who makes under $18,000 a year, that's ridiculous. I can't afford to go get medical care for my dental problems and things like that. I really think a lot of people on the insurance committee and real estate committee need to come down and speak to those of us in the community better and hear our problems and our issues. And so in closing, I will say that thank you for the opportunity to testify regarding an act concerning health insurance and healthcare in Connecticut. I support all efforts to expand coverage for as many Connecticut residents, including undocumented, as possible. This SB 842 is certainly a very positive step. We need to do more. All of our residents deserve more. Thank you so much.
Thank you, Holly, and thank you, Representative Michelle, for being here today. I have a question. So in addition to expanding Husky A eligibility, another portion of the bill allows, you mentioned that you yourself have a disability that allows working people with disabilities to purchase Medicaid on a sliding scale. That's actually an existing program, but one that's hard for a lot of people to access. Is that something that you think would be beneficial for folks out there in Connecticut?
Currently, I'm not at a point where I'm able to work, and a lot of employers will not hire you just for that 1 hour a month. So that's what it requires, the working disabled coverage. You have to work 1 hour a month, and you can't get that. I mean, that's almost impossible to do. And for someone like myself who gets ill depending on weather, which is why I'm a little slow today due to the snow, I'm affected by weather. So even if that 1 hour a month is scheduled, I don't know if that day, if it's going to rain, have a thunderstorm, if I'm physically going to be able to go that 1 hour.
Got it. Thank you very much. Are there questions from members of the committee? If not, thank you very much for your testimony. It's good to see you, and thank you for coming up. And I think we're all a little slow today because of the weather. We're all in that boat.
Thank you, Senator Lesser.
Thank you. Okay. I think next up we have Senator Slack. Senator Slack, it's good to see you.
Good to see you too, and thank you for taking my testimony. I am not here to specifically talk about Senate Bill 842, although I am certainly supportive, but I did want to shine the light on a different issue today. So I do want to thank, I had written good morning, but I'll say good afternoon to the chairs, Senator Lesser, Representative Wood, Ranking Member Senator Huang, and Representative Pavlik D'Amato, certainly committee vice chairs and all members. I want to thank you for your consideration of Senate Bill 89. It is an act concerning travel insurance and suicide. I prefer to call it Sean's bill. I've introduced this bill for a couple years now because of one of my constituents, Robin Brennan, and what she and her family endured after the tragic loss of their son, Sean. And she's going to share her story with this committee later on this afternoon, as she's done in previous years, and she has submitted testimony as well. Her son died by suicide prior to a scheduled trip for which they had purchased travel insurance. Now, her loss cannot be put into words or certainly reversed. She and her family must live with that forever. But her experience with the travel insurance industry and company is something that we can fix for other families going forward. The travel insurance firm she bought her policy with denied her claim for her son based on their assertion that the act of suicide was a deliberate decision, not the result of an illness. We know, of course, that depression and severe anxiety, suicidal ideation that can result from that are forms of mental illness. And as a society and as a state, we have started to acknowledge that in many ways, and we've made improvements in our healthcare system, and we've addressed issues like parity. So the stigma of mental illness is slowly being addressed, but this is one area that has been ignored. And, you know, it's understandable in a way. It's travel insurance, right? And probably most of us have not thought a lot about travel insurance, certainly not until this past year. But it's an issue now that's on people's minds. And if we're to combat, I would argue, the stigma of mental illness and treat folks with empathy and acknowledge suicide for what it is, then I believe we must pass Senate Bill 89. And, you know, I just want to briefly address some concerns that you may hear from the travel insurance industry. They're going to argue that they're going to oppose the bill. They're going to argue two things, probably at least. First, that if this mandate passes, it will increase the cost of travel insurance. And that might be true. I don't know that it is, but maybe it is. When I met with them, when I first introduced the bill, that's what they said. And I asked them, well, how much would it actually increase the rates? And they said that was impossible for them to determine. So they know it's going to increase rates, but they don't know by how much. And I would argue that many of us, you know, wouldn't be opposed probably to paying a little bit more for the, you know, very seldom use of having a family be protected when tragedy does arrive. Second, they might argue that people should take out additional coverage if they want to be insured for suicide, like a rider. Of course, that's unrealistic, it's impractical, and it displays a fundamental misunderstanding of mental illness and how it manifests itself. Like this is something that you could prepare for or hedge against. I believe the solution is simple. The travel insurance policy should cover suicide. Your support of this bill is not going to bring Robin's son back, of course, not going to bring Sean back, but it will protect other families when tragedy strikes. It'll be another step forward in this General Assembly's approach to mental illness and the progress that we've all made together. So thank you very much for your consideration of the bill, Senate Bill 89. And look forward to working with you to achieve its passage for Robin, for Sean, and for all families who tragically have to endure this. Thank you very much.
Thank you, Senator Slapp. Questions from Senator Wong.
Thank you, Madam Chair, and thank you, Senator Slapp, and please extend our condolences and thoughts to the family in which you're advocating for. I think it's important to note that this was not trying to get out of any obligation, that this was an obviously unforeseen and a terrible tragedy. And obviously on a contract basis, there is no consideration for it. I'm just absolutely stunned that insurance companies would not consider the loss of this family. And just to extend along that line, I would also ask that to look into the other aspects of travel plans, and in these days of COVID, where many programs or many anticipated trips were canceled due to safety concerns on COVID, that they should have gotten relief as well. So you have my commitment to work with you to try to protect consumers for unforeseen, incidences or dangers that may have occurred, in which they have to cancel long planned trips and financial obligations. They should not be bearing the burden. And I've heard untold stories about people struggling to get the insurance company to respond, and it shouldn't be. So I want to thank you for your advocacy and leadership in raising this for the family that suffered the terrible tragedy, and for many other consumers that are looking to get their money back.
Thank you, Senator. I appreciate your words and your partnership. Thank you.
Thank you. Senator Lesser, questions?
Yes, thank you, Madam Chair. And I just wanted to thank Senator Slapp for his advocacy. Obviously, nothing that the legislature does or that any of us do can undo the trauma and the pain that I know Sean's family is experiencing, and that I know that's not what this is intended to do. But it does strike me as an injustice, and I know that you have been zealous in fighting for them and fighting to ensure that there's a fair legislation in the state. And I think that this conversation got short-circuited last year because of the pandemic, but I just want to thank you for bringing it back up and invite the opportunity to work with you on it.
Thank you, Mr. Chair. Appreciate your leadership and partnership on this. Thank you.
Any other questions from the committee? Thank you, Senator Slav. Next, we have Thomas Conley.
Hi. Good afternoon.
Hey, Thomas.
How are you? My name is Thomas Conley, and I would like to thank the committee chairs of the committee for arranging this public hearing on public option for health insurance for Connecticut residents. Senate Bill 8. I would like you to think about if you received an email tonight that Connecticut has canceled your health insurance for you and your family. What would you do? Where would you go to receive your health care? Where would your family go? Say you found a private health insurance option. Could you afford it? Maybe you could easily afford it. But what if you could not afford it? You might be saying in your head that this will never happen to you because you're one of the lucky ones who qualify for the Connecticut State Health Care Plan. And you're right. My daughter was not so lucky. She worked for a large senior travel agency when COVID hit. She just received a promotion to supervisor to assist with complaints. At first, she was furloughed with insurance. Then one late Friday noon, she got email. You are terminated and your health insurance has been canceled. She was shocked. She cried. She did not know what to do. When she called, we will start for catastrophic health care for you. You may know what that is. Something like a $10 deductible kicks in. A person will go into debt, but if you love to get it, it will cap your large medical bills at $10,000. The story like hers has repeated over and over again, even before the pandemic. Now, even more, we need an affordable public option for Connecticut residents. Healthcare is not a need. I want a brand new car. Great. I want a set on the Connecticut shore so I can be there in the summertime. I want a yacht so I can go to Martha's Vineyard and maybe take a trip to the Caribbean. That would be nice right now. Healthcare is not a want. It is a need. Humans need include food, clothing, housing, and yes, it is a human right. To have millions of Americans denied health care is criminal. It should not be, especially during this pandemic. February is Black History Month. I will, with a quote from Dr. Martin Luther King. For all the inequities that exist, the injustice in healthcare is the most shocking and inhumane. Thank you for your time.
Thank you, Thomas. Any questions from the committee? We have Representative Kate Farrar.
Thank you, Tom, for sharing your story, and yeah, just hearing about your daughter, what she went through, she shouldn't have to go through, as you just mentioned. And I can't help but think that your daughter is one of so many women, the majority of whom have been unemployed in this crisis. And this bill really does provide a path forward, hopefully, to offer more affordable healthcare options. So thank you, Tom, for sharing your story and your daughter's story. It's very helpful to give all of those real life perspectives to what we are hearing about and hopefully can make change about. So thank you, Tom.
Thank you. You do everything you do. I know you're a fighter up there and appreciate it.
Tom, thank you for coming today.
Thank
Our
you.
next speaker is Pam Hunt, followed by Robin Brennan. Go ahead, Pam.
Good afternoon, Senator Lesser, Representative Wood, and members of the Insurance and Real Estate Committee. My name is Pam Hunt, and I am a personal care attendant, a PCA, who lives in Tapville, Connecticut. I am here to testify in support of Senate Bill 842. I'm a PCA who cares for my son, who has both intellectual and physical disabilities. I'm a single mom of 8, so thankfully I've qualified for Husky most of my adult years. However, as my kids have moved out, I've gotten closer and closer to the cap. Last year, I priced out insurance, and the monthly premiums would have been $600 a month on the private market with a $5,000 deductible. There's no way I could ever afford that. I'm a caregiver, I'm a cancer survivor and a COVID survivor who supports my son who has significant disabilities. And yet I'm close to the cap, which means I'm always in danger of losing my insurance. It's a shame that we have to be put in a position to maybe cut our income just to make sure that we can stay alive. Senate Bill 842 would allow workers like me to live and work with a peace of mind, knowing that our health and the health of our families are safe. It would allow me to give care worry-free because I would know that if I need care, I can afford it. We live in the richest nation in the world, yet we literally have people who are dying because we can't afford to go to the doctors. The real possibility of me being in that group is imminent, and it terrifies me. Please support Senate Bill 842. Thank you for your time.
Pam, thank you. Do we have any questions from the committee? Senator Lesser.
Thank you, Madam Chair. I have trouble finding the raise hand feature at times, but Pam, I want to thank you.
Wave.
I'll just wave. Pam, I want to thank you for your testimony. As a PCA, I assume that means you're on the front lines of caring for needy individuals in this state.
Yes.
You're a provider, right?
Yes.
So, you know, I think it is striking that we're having trouble as a state, as the richest state in the richest country on earth, providing health insurance to those people who are caring for us. So I want to thank you for what you do. I know it's a tough job. You know, I know we can do a better job, but hopefully this bill helps address the specific issue that you're talking about, the cost of health insurance, particularly for low-income working folks who are working every day and putting themselves in harm's way for COVID or for a zillion other things. So, thank you for your testimony, and hoping we find a way to help you.
Thank you very much, Senator Lesser. I appreciate that. Thank you.
Thank you, Madam Chair.
Senator Wong, thank you. Sorry, Senator Wong.
Thank you, Madam Chair. Pam, if I may, thank you for being on the front lines and providing critical services during the day of COVID, and also for your recovery from COVID, along with your fight against cancer. It's a constant fight. So you're truly an incredible hero. And I guess the most heroic thing is you're a parent of all your children. So thank you for the testimony, and we do completely agree, Democrats, Republicans, that we should be fighting to get you affordable and sustainable and viable health insurance into the future, particularly for all the important roles that you take. So thank you for testifying. I really appreciate it. It's a chance for us to say thank you again.
Thank you very much, Senator Wong, and thank you for having me. I appreciate it. Thanks.
Representative
What a great smile. What a great smile, Pam.
Thank you.
Hi, Ms. Hunt. Thank you for coming and sharing your story. And I think you bring up something that we need to focus on, I think, as a legislature across the board. And that is the way that we do things in the state regarding that, like you mentioned, the next dollar cliff. You know, when you're so close to being able to access subsidies or assistance, I think we need to stop looking at one single dollar means you are now fully sufficient to go out into the world and handle everything yourself. One single dollar, and that describes that. So, you know, I think, thank you for bringing your story forward. I appreciate hearing it, and I think you've given us all a lot to think about in terms of what we can do to help people with a range of help and not one single dollar.
Thank you very much, Representative Nucia.
Pam, thanks for joining us today. Next up is Robin Brennan, followed by Karen Siegel. Robin, are you here?
Yes, I am.
Great. Thank you.
Thank you. Good afternoon, everyone. And thank you, Senator Lesser, Representative Wood, and Senator Juan, and all the members of this committee, and also to Senator Slapp, Representative Gilchrist, and Senator Formica for all of their support and for this opportunity to speak in strong support of Senate Bill 89, or as I like to refer to it as Sean's bill. My name is Robin Brennan. I'm a lifelong Connecticut resident living in West Hartford. It's where I live with my husband, Jack, and where I raised my two children, Sean and Leanne. On July 14th, 2019, my family's world changed forever. Our beautiful son, 25-year-old Sean, died by suicide in the basement of his apartment. Unless you have lost a child, you cannot imagine the pain and heartache that we suffer on a daily basis. It is a pain like no other, and I would not wish it on my worst enemy. Our family loved to travel together. These were some of the best times we shared as a family. We had planned a big trip to Europe in September of 2019. But after Sean had passed, we knew we couldn't go. And I was grateful that I had purchased travel insurance through AIG's Travel Guard for the airfare. I felt confident that I was going to at least recoup the $2,600 that we paid out for the airfare that could help go towards the funeral expenses. I submitted my claim through AIG's website as directed, along with a copy of Sean's death certificate. 5 weeks later, 2 days before we were supposed to take off, I received a voice message from the claims adjuster notifying me that the claim was denied due to the cause of death. I was in shock. Suicide was not a covered cause of death. I was stunned. How could this be? My son was dead. This isn't a life insurance policy, it's travel insurance. So I called the adjuster to get a better explanation, and she said it was written in the policy and that I should have read it before purchasing. I was appalled. At no time did she offer any condolence, anything. It was very cut and dry. I was extremely upset, as you can imagine. A week later, I did receive a written notification of the denial of coverage. Again, no acknowledgement in the letter of our loss, just referencing the fine print of the policy. When I posted my disbelief and anger of the AIG practice on social media, I received an outpouring of support. West Hartford Town Councilwoman Beth Kerrigan was one of the people who saw the post. She in turn introduced me to Senator Slapp, who wrote the bill on our behalf. Since then, I've received an abundance of support, both inside this room, this committee, and outside. The support of the leadership of this insurance committee, as well as Senator Slapp, Senator Formica, and Representative Gilchrist have given me the courage to speak here today. I believe it was Senator Scanlon, and I apologize if it's wrong. It might have been Senator Lesser last year or in 2019, who actually spoke to AIG to inquire about the policy's exclusion. And what Senator Scanlon or Lesser reported at the committee meeting in 2019 was that AIG said we could have taken out an additional rider to the policy to cover that incident. Really? It was absurd. Sean was very excited about doing this family trip. He had just renewed his passport a month prior to taking his life. We had no prior knowledge or even an inclination that he was suffering inside of his own head. My son suffered from a mental illness. We could not predict that this was going to happen, as AIG Insurance suggested we take by taking out an additional rider. Mental illness is a disease like any other disease, yet the stigma associated with it keeps it hidden from public view. Sean suffered in silence until he couldn't take it any longer. Mental illness is real, and people are suffering in epidemic proportions. Suicide is the second leading cause of death between 13 and 34-year-olds. Those statistics are real, and we need to do something about it. This bill must be passed. It is the right and humane thing to do. I do not want another family to have to suffer or endure the trauma that we have had to endure during this process. Thank you for your support and your consideration for Bill SB 89. Thank you.
Robin, thank you for sharing that story with us. And I am just so sad that we're here today to try to legislate this, because I feel the company could have acted a lot better, but yet we are here, and I will tell you that I'm just very supportive of this, and you have a great team behind you. So, and I know I can't even imagine how tough it is to come before us and share this story. I'd like to open it up for questions, and we have Senator Huang, followed by Representative Farrar.
Thank you, Madam Chair. Pam, again, as I shared earlier, I am truly sorry for your loss. As I heard your testimony, I was so taken, and I'm so sorry for your loss. That being said, I want to thank you for your courage in raising this issue, but also making the commentary about awareness of suicide prevention, mental health, and those are all important parts of prevention and preventing these kind of tragedies from occurring. So I want to thank you for your courage in that. The other thing I wanted to add, and this is where testimony makes an impact. It is unbelievable to me the tone deaf nature of the insurance carrier, in this case, AIG, and their response to you. You have been so persuasive and raised an important issue that I know Senator Slapp, Senator Formica, and all of my colleagues will be vigilantly looking at, and hopefully get a positive solution so this doesn't happen to any other family in the future. So I want to thank you for your courage and your time in sharing your story with us. So thank you so much.
Thank you, Senator Wing.
Representative Farrar.
Hi, Robin.
Hi.
Thank you so much for being here. I am a new member to the legislature in this committee, but I've heard about this effort, as you noted, from Senator Slapp and Representative Gilchrist, and as a fellow West Hartford resident, I want you to know that we are strongly with you as a delegation, not just to pass this law in honor of Sean, but as I know you care about, to ensure that no other family has to go through this again. I can't thank you enough, and we will do everything possible to make sure that this happens this year and that no family has to go through what you did, especially with the loss of such a treasured part of your family like your son. Thank you, Robin, for being with us.
Thank you, Representative Ferreira. Appreciate your support.
Senator Lesser.
Yes, thank you, Madam Chair. I don't want to rehash everything my colleagues have said, but just wanted to thank you Robin, for the strength that you've shown and being here again this year. Hopefully this is the last year you'll have to testify in front of the Insurance and Real Estate Committee, and know how tough this is for you and also why it's so important. So, you know, I'm sorry the carrier isn't here to explain themselves. I've certainly asked pointed questions of them about your case, and I'm certainly looking forward to working with your representatives in West Hartford as well as Senator Formica to make sure that we can do right by your family and by any other family who would ever fall in this position. Thank you, Madam Chair.
Thank you, Senator Lesser, and I apologize. It was you that spoke to them and not Senator Scanlon.
That's okay. We get mixed up all the time.
Robin, thanks again for coming. We really appreciate you doing this and sharing your story.
Thank you, Representative Wood.
Next up is Karen Siegel, followed by Lola Elliott. Karen, go ahead.
Good afternoon, Senator Lesser, Representative Wood, Senator Anwar, Representative Comey, esteemed members of the Insurance and Real Estate Committee. My name is Karen Siegel. I'm testifying today on behalf of Health Equity Solutions, where I serve as the Director of Policy. We are a nonprofit organization with a statewide focus on promoting policies, programs, and practices that result in equitable healthcare access, delivery, and outcomes for all people in Connecticut. I'm not going to read the testimony that I submitted to you all. I just wanted to highlight a few key points. I know that everyone on this committee is aware of the dramatic inequities in health in our state, and also aware that these are not new to our current situation. And among these, inequitable access to healthcare is a key concern because being insured is necessary, even though it's not sufficient to accessing healthcare. And we know also that Black and Brown people in Connecticut go without insurance at disproportionately high rates, and that this is a result of structural racism and the related income inequality and employment discrimination that have led Connecticut's people of color to be disproportionately likely to work in jobs that do not offer health insurance. And so as a result, we see access to health insurance as a crucial part of advancing health equity in our state. So in short, we strongly support the restoration of Husky A eligibility for parents who are otherwise very likely to be uninsured or unable to use their insurance because of the high out-of-pocket costs. So just for example, covering 2 adults in a family of 4 just over Medicaid eligibility on the exchange this year would have led to about $6,700 in out-of-pocket costs, which comes to about 16% of the family's income. We also support pathways to insurance for all immigrants and see this as an equity issue because this population is predominantly people of color as well. And we wanted to make a couple of small recommendations regarding the proposal, and these are first to require standardized collection of race and ethnicity data, to engage consumers and particularly people of color in decision-making about the allocation of subsidies and design of the plans, and to ensure total out-of-pocket costs don't deter insured people from seeking healthcare. So I really appreciate the opportunity to testify today and would be happy to answer questions if there are any.
Thank you, Senator Lesser.
Thank you, Karen, for that list of suggestions. Regarding your third point about total out-of-pocket costs, in addition to Medicaid Husky A expansion, the bill also requires that the subsidies eliminate premiums for anybody else under 200% of poverty. Would that be a move towards that, or were you also looking at cost sharing on other development?
Yeah, I think that's a great start. 2 issues. One is that we couldn't assess the equity impact of that. We just don't have enough data, so I don't want to say anything too much in that area. But I do think cost sharing is still going to be a problem for lower income people and for families under the 200%, even without premiums. But that said, it's definitely a step in the direction of making healthcare affordable and making people more likely to be covered in case of a catastrophe.
Great, thank you. And if you have suggestions, I think the second suggestion about making sure that stakeholders are engaged, that seems straightforward. If you have suggestions about particular places in the bill from the first where data could be collected, that would be helpful, so we could figure out where to include it. Just because there are a lot of different tangentially related parts of the bill, we'll make sure that we're collecting that in the right places.
Yeah, absolutely. And we can share some suggestions about language, but I think there were suggestions made to the Office of Health Strategy about categories. And I think wherever possible, if we can get race and ethnicity data collected in a standardized way using those categories, both for the, whether it's for the subsidies, the public option, for the different programs in the bill, I think that would be really helpful in ensuring that it really is improving equity and coverage.
Thank you, Karen. I appreciate it. Thank you, Madam Chair.
Any other questions from the committee for Karen? Karen, thanks so much for coming. Our next speaker is not in the room, so I'm going to go to Josh Pollack, who is up next, followed by Eric George.
Hello, and thank you, members of the Insurance and Real Estate Committee, Chairs Lesser and Wood. Thank you for this opportunity to offer testimony in support of Senate Bill 842, an act concerning health insurance and healthcare in Connecticut. I'm the Reverend Josh Pollack. I'm the minister of the Unitarian Universalist Society East in Manchester. I'm also a leader with the Interfaith Fellowship for Universal Healthcare, a statewide clergy network representing thousands of people of different faiths who, like so many Connecticut residents, want a healthcare system that is easily accessible, provides affordable care, provides portable care in the event of job loss or transition, and which actually results in improved health outcomes. We've been advocating for a public option in healthcare in Connecticut for more than a decade, and while I support SB 842 in its entirety, I want to put special emphasis on my support for the public option, as I am confident it would be a better option for the staff at our church. Our church takes great pride in providing health insurance to all its employees. However, in recent years, we have watched rather helplessly and with increasing frustration as costs have risen, premiums have risen, deductibles have risen. This is true when we try to purchase plans on the state exchange. It is true with our denominational healthcare plan. At this point, we have been priced out of the market for decent healthcare plans, going from gold to bronze to silver to bronze. With the plans we can afford now, even once we hit our deductibles, there are still aspects of care that are not covered or not covered completely. We're at the point where our staff wonders why we bother. It is demoralizing. And if it is demoralizing for our small nonprofit, then I'm sure it's demoralizing for many others. My conversations with other religious leaders and with small business owners indicate that this demoralization and frustration are widespread. People want to do the right thing and cover their employees, but the kinds of plans we are able to purchase today are very poor quality. I want you all to know I'm really angry. I am actually at this point enraged that leaders in Connecticut's insurance industry have used their immense power to block the creation of a public option for years and had offered no effective solutions to address the healthcare crisis in our state. They may believe they'd offered effective solutions, but based on the health insurance options available to us, they have not. I know from my very personal experience as the leader of a small nonprofit trying to treat my employees well by offering decent health insurance that the insurance industry does not care about us. They may think they care about us, but the net result of what we can purchase is that they don't. They don't have our best interests at heart. They don't have the best interests of Connecticut's residents at heart. They don't apparently understand that a healthy population is a critical factor in a thriving business climate. They don't apparently understand that a healthy workforce is not only good for business, but essential for a thriving economy. So I am angry, and I say enough already, and I sincerely hope that you all will not cave into insurance industry pressure as this bill makes its way through your process. It's time to put the health of Connecticut residents first and the profits of insurance companies second. Thank you for this opportunity.
Josh, thanks for that testimony. I'll open it up to committee members for questions. Josh, thanks again for coming. We really appreciate your testimony.
Thank you.
Next up is Eric George, followed by Cassandra Murphy.
Thank you, Representative Wood, Senator Lesser, Senator Huang, Representative Pavlak D'Amato, members of the Insurance and Real Estate Committee. My name is Eric George. I'm president of the Insurance Association of Connecticut. The IAC represents the carriers in the home, auto, life insurance, and workers' compensation arenas. And I'm here to offer our strong support of Senate Bill 843, which would extend the sunset date for our flex rating law for personal lines insurance and return the statute to its original form from 2006. In 2006, the General Assembly approved legislation that established flex rating for personal lines. Flex rating allows insurers to react quickly to changing market conditions and experiences and implement modest rate changes within a certain percentage without the prior approval of the department. Now, you should know that carriers still have to file those rates with the department, and the department may still disapprove them if those rates are not filed in compliance with the law. So this streamlined approach allows insurers to compete vigorously and price their products aggressively, which strongly benefits consumers. Flex rating also helps to prevent drastic rate swings by allowing companies to quickly react to market conditions and make rate changes based on those conditions and how they evolve. It's important to note that changing market conditions may result in rate decreases as well as increases, and that any changes above the designated percentage cap require department approval. Under the law, as long as an insured's filed overall statewide rate increase or decrease doesn't exceed 6% in the aggregate for the year, and not more than 15% as an increase in an individual territory, the insured doesn't need to get the prior approval of the commissioner first before using the rate. And though flex rating has been in the statute since 2006, it was slated to sunset in 2008. And then over year after year after year, it has been extended. We have seen it extended in 2009 for 2 years, in 2011 for 2 years, 13 2 years, 15 2 years, and in 2017, this legislature decided to extend it for 4 years, which brings us to 2021. The bill before you, Senate Bill 843, also contemplates a 4-year extension to July 1st, 2025. The competitive marketplace is working in Connecticut to the benefit of consumers as more insurers are competing for business based upon price, product, and service. For example, since 2006, overall rate changes in Connecticut for auto insurance have been minimal. According to press reports, the number of auto insurance companies doing business in Connecticut has grown substantially, and the assigned risk pool has continued to shrink to all-time lows. There are very few, remarkably few in the assigned risk pool right now, especially compared to where we were, say, in 1988 when we had 200,000. So by continuing flex rating, Senate Bill 843 will further facilitate that competition. And be a positive boon for consumers in Connecticut, as well as the personal lines marketplace. So we do ask you to support Senate Bill 843, and I thank you for your time.
Thank you, Eric. Senator Lesser.
Thank you, Madam Chair, and thank you, Eric, for your testimony. It's good to see you again. What would happen if this committee chose not to extend the sunset on the flex rating provision?
Then the underlying statute would go away and would put Connecticut in a less competitive position because the vast majority of states in the United States have rating rules. They're not even really called flex rating because they're much more they're easier to deal with. They're much more flexible, and they give actually even more, less oversight. So Connecticut actually has quite a deal of oversight, but it would put us in a competitive disadvantage, not only as those insurers working in Connecticut, but also as the state is trying to attract insurers. That would not necessarily make Connecticut appeal to insurers.
Thank you.
You're welcome.
Any other questions from the committee? Senator Anwar.
Thank you, Madam Chair. Thank you, Mr. George. Good to see you again. I just wanted to clarify, we're in the midst of a pandemic. What has the insurance industry done to take care of the average citizen who does not have a lot of resources as one of the most financially stronger industries?
So excellent question, Senator. I do appreciate it. Especially early on when we saw drastic decreases in automobile use. And this happened in Connecticut, this happened across the country. You saw a lot of rebates provided by insurance companies from premiums already collected back directly to policyholders. So there has been accommodation made by the insurance, especially in the auto area, when we saw such a drop in usage.
So I'm looking at it from this lens of healthcare, and that's obviously because that's part of what our conversation is. Right now, we have a number of people, we have unprecedented number of people who have lost jobs in our state. So that's one challenge we are dealing with collectively. And the next phase is going to be the individuals who have lost their jobs, they're going to lose their insurance. So this is the time when there is a disaster, everybody rolls up their sleeves and helps out. So for the individuals who have lost their jobs, lost their livelihoods, what is your industry doing for them at this point, if they are unable to pay their premiums?
There might be a misunderstanding here, Senator Anwar. So I'm here representing the home, auto, and life insurance industries. The health insurance industries are actually going to be coming after me. So I'm sure that you're going to be very enthused to ask them those questions. But from the auto industry's perspective, we have definitely been providing accommodation back to our policyholders.
So Eric, I see all insurance companies lumped into one big group. So that's why.
If my membership reflected what you see, it would be a very different scenario.
Okay. All right. So then we'll have more conversation later, but thank you for your answer.
You're welcome, sir.
Any other questions from the committee? Thank you, Eric.
Thank you.
Next up is Cassandra Murphy, followed by Cameron Kessler.
Hi, good afternoon. Thank you. On behalf of the Connecticut Coalition of Taft-Hartley Health Funds, I'd like to thank all of the members of the Insurance and Real Estate Committee for allowing me to testify today regarding Senate Bill 842. I'm Cassandra Murphy. I'm the Executive Director of the Coalition, which is a non-stock membership corporation under Connecticut law, operating as a not-for-profit and tax exempt under Section 501c6 of the Internal Revenue Code. In general, the Coalition's 13 member funds, which represent approximately 50,000 covered lives in Connecticut, are tax-exempt multi-employer health and welfare funds, which are governed by various federal laws, including ERISA and the Taft-Hartley Act of 1947, and each has an affiliation with a specific labor union. The Coalition's mission involves using the combined strengths of its members to secure quality, affordable healthcare for the working people who participate in the funds and their families, and to promote the financially sound long-term survival of Taft-Hartley Health Funds. The continuing rising costs of healthcare are a significant strain on our members as well as the general public, and I applaud your efforts to bring forward potentially cost-saving health insurance alternatives. I'm not here to testify for or against the bill, but to share both the potential benefits for members and Taft-Hartley funds in general, as well as some of the concerns and challenges. And to be clear, each of our member funds are distinct entities with individual plans of benefits and boards of trustees, and their interest in pursuing a public option for health insurance is also unique. So for some Taft-Hartley Health Funds, opting into a public health insurance plan may ease their financial stresses by providing a fixed premium cost structure and leveraging the power of the existing state employee health plan. It would also alleviate administrative burdens as issues of plan design, vendor contracting, adjudication of claims, and appeals would shift to the public plan. For other Taft-Hartley funds, these same factors would mean relinquishing decision-making power over their plan of benefits bargained for by their respective labor unions, possible disruption of covered individuals with their healthcare providers, elimination of long-term administrative staff, and additional financial concerns that the bill raises. The proposed bill references a number of administrative fees and charges that may be levied against the multi-employer funds without stated limitations for the coverage period of at least 3 years. Additionally, this coverage will likely lead to expanded benefits and higher costs for some of the coalition's members, as their existing ERISA preemption does not require that they currently follow state insurance law mandates, though they are ACA compliant. Healthcare under a Taft-Hartley plan is largely funded by contributions from contributing employers for hours worked by their union members. That's negotiated under a collective bargaining agreement, which can span many years. And such contributions may not be readily increased to cover rising healthcare costs. So entering into an extended contractual agreement under a public option, which might become financially disadvantageous for a member fund, could violate the prudence rules under ERISA. So the coalition and its members need a better understanding of the plan design alternatives and the associated premium and administrative costs in order to determine if a public plan would be a feasible option. As I stated, each member fund is a distinct entity, and therefore this would not be unanimously utilized by the coalition's membership. And it's also worth noting that the bill may ultimately harm the coalition itself and our tax-exempt mission through the loss of members over time. But it's our hope that we can provide some more insight for you as to the unique challenges that our funds face and hopefully help some of them long-term. So again, thank you for the opportunity to comment, and I'm happy to answer any questions that you have.
Thank you, Cassandra. Any questions from the committee? Senator Wong.
Thank you, Madam Chair. Cassandra, I thank you so much for your testimony and reading through your testimony in preparation for this public hearing. Offer me a lot of the insights that I asked of Controller Lembo. And indeed, as a labor relations school graduate, I was very, very conscious of the Taft-Hartley funds and the unique nature of it. And if I may ask of you, your testimony is very self-explanatory. And I would ask if, as you and your organization, so members, deliberate and evaluate the pluses and the minus of Senate Bill 842, that I am able to engage in further conversations to learn how you evaluate and analyze it, because your testimony is probably one of the most objective one that we will get today from the standpoint of truly evaluating the program on the benefit for your members. So I want to thank you very, very much. And if you like to articulate a little bit more and your willingness to be able to share with colleagues on this committee and within this General Assembly to learn more about how your deliberations would be, I would welcome that.
Sure. So each one of the member funds individually would need to take a look at the plans that are offered and the costs associated with it. It would need to be evaluated by their actuaries to determine if it's a cost savings for them or if not. And right now, I think there are some unanswered questions. So getting answers to those and actually seeing the plan design so that we can take a look at it and see plan by plan if it's doable is the next step in our evaluation.
Yeah, you've got membership going back, as I'm looking at your membership fund on the right of your letterhead. And as a result of Taft-Hartley Act of 1947, you've got insurance groups that have a long actuarial insurance record and experience rating, and to open that up is something that I'm sure you all have to explore. I think the second part is the 3-year option, as you elaborated in your testimony, that many of your collective bargaining agreements have different timelines, and for you to be locked in as a result of 842 may not be conducive to your individual respective unions. And the third, and feel free to answer those, and thirdly, the ERISA connection, which I also raised in my conversation with Controller Lembo, poses a significant challenge for you and your members as well, right?
It does. There are still questions around how compliance would be handled under ERISA, whether or not that would be administered by the fund itself or whether that would be administered by the state plan. you know,
Sorry. And if you were forced to lock into that 3-year commitment and also have a assessment to exit the plan, that would be a big factor for you and your members, wouldn't it?
it would be a factor. I understand that the penalty to withdraw early is, you know, a small percentage of claims. And for some of our groups, that may not be challenging for them. If they are currently working with a staff in their office and they no longer have that staff, that makes it significantly more difficult to withdraw from the plan.
And for, if not all or most of your members and their health insurance groups, are they self-insured or fully insured?
They're self-insured.
So I think that is one of the important parts, right? As a result of your experience and actuarial risk rating, the longevity of your programs, and the unique aspect of your organization. And as a self-insured, you've been able to somewhat have some degree of control in regards to negotiations and interactions with health insurance companies right now, even without the opportunities afforded under the partnership program. Would that be correct?
Yes, we contract directly. The coalition contracts directly with Anthem Blue Cross Blue Shield right now as a medical network vendor. Most of our member funds access that contract. Not all of them do. And we only have so much control over the rates associated with that. But for other groups, those rates are just not affordable, and a public option might be a really excellent idea for them.
Well, I again, I thank Madam Chair for the indulgence, and I appreciate your acceptance of my request to speak with you more about this and learn as you evaluate this bill and this process. I really appreciate your thoughts on this and your testimony. So thank you very, very much.
Thank you.
Thank you, Senator Wong. Representative Nuccio.
Hi, good afternoon. How are you?
Good. How are you?
Good. It's going to be a long day. I had a couple of questions I was hoping maybe you could help me with. So you have 13 individual member plans. Do you bulk them at all together or pool for any kind of experience rating?
We bring together their collective numbers as far as negotiating the contracts, but you know, they self-fund their own claims. So their experience is very individualized.
So their experience is individualized, but you are pooling them, the 13 groups together for when you go out to bid to a company.
That's correct.
Okay, so if you had some plans that left with better experience and left you with the ones that were worse experience, that would have a negative impact on your claim experience rating for what was left of the plans, would you characterize that as correct?
I would not say that necessarily. The negotiations that we do are not really based on the plan's individual experiences. Losing membership numbers might impact our ability to get good contract rates, but again, the experience falls on each individual fund.
Okay, thank you for that. And in regard to the 3-year lock-in, can you explain a little bit more? So you had mentioned if there were increases that it would somehow go against what was contractually negotiated. So when you're negotiating with your unions or your unions are negotiating with the employers for health insurance benefits, are they negotiating for a 3-year locked in rate? Or if there was volatility in the market for a year over year percentage, would that negatively impact your members?
When the collective bargaining agreements are done, they include monies towards, you know, the health insurance portion of it, as well as wages and everything else. They're all very different. So some of them may be flexible year to year. Maybe there's a raise factored in where some of it could go into wages and some of it would have to go towards healthcare costs. The concern is that our boards of trustees wouldn't have any ability to change the plan of benefits if they needed to, if that money wasn't covering expenses, because the boards of trustees don't necessarily have influence over the collective bargaining agreement itself.
Okay, that makes sense. And then, so with your Taft-Hartley plans, you had mentioned some of your members have the insurance through the carrier that you have and some do not. Do you offer more than one plan option?
We do not.
You do not. Okay. All right. And I think that is all that I have with the regard of getting out of the plan. And you brought up exactly what I was going to ask, is if you had to get out of the plan and you had already let people go, then you would not only incur the costs of whatever the plan exit was, but also to get that one group back up and ramped up, because you don't share administrative resources, do you?
Not generally. Several of our funds use the same TPA, but many of them have in-house staff that adjudicate their claims and handle the administration.
Right. Okay. Thank you very much.
Thank you.
Senator Lesser, your hand is raised.
Yes, thank you, Madam Chair. Just thank you, Cassandra, for your testimony. Just two quick questions. One, I'm assuming that, while I think there's quite a bit that still needs to be worked out, that it's entirely possible that the plan designs made available by the comptroller might be a good fit for one of your members, but not for another one, and it's sort of case specific. And two, I was just wondering if I'm reading it correctly, is it accurate that the majority of the members of your association are members of the Connecticut State Building Trades?
I'm sorry, I didn't hear the end of your second question.
Oh, it looks just it looks like the majority of your members are members of the Connecticut State Building Trades, and I just wanted to just verify that that's accurate.
Yes, we have a couple of funds that are not building trades funds, but the majority of them are. And I'm sorry, please remind me of your first question now.
Oh, no, the first one, I just assumed that based on what you were saying earlier, that it's possible that some, that the plans made available by the comptroller might be a good fit for Plan A, but there may be another, there may be another member of the association that might decide that they're happy with where they are and they might not want to opt into a comptroller issued plan. Does that sound right?
Absolutely, based on their specific financial situations and what their boards of trustees want to do. Some may think it's great and it might be a good fit, and others may want to stay with the status quo.
Got it. Thank you. Yeah. So then that's in keeping with this being an option that would be made available to them. I just would point out that we did get testimony in support of the bill from Mr. Dave Roche, who's the executive director of the Connecticut State Building Trades. So hopefully he's speaking for his members on that. But thank you so much for your testimony and look forward to continuing to work with you on the finer points of the bill.
Great. Thank you.
Thank you, Cassandra. I'd like to apologize to the other speakers because I did skip over a member of the Connecticut General Assembly who has joined us. Representative Sean Scanlon is up next, followed by Cameron Kessler.
Thank you very much, Madam Chair, and good afternoon to the committee. It is great to see you. Very weird for me as the immediate past House Chair to be on the other side of this public hearing, but I wanted to quickly show up today to express my absolute support for this bill. This has been the third year in a row that I've had the pleasure to work with Senator Lesser and the comptroller on this bill, although I'm now doing it in a different capacity as chairman of the Finance Committee. This bill is critically important as it was before, but perhaps more so now that we have just all survived, many of us, some of us, unfortunately not, a global pandemic that tested every single aspect of our healthcare system and showed some very critical flaws in that system. So really excited to be here today. I hope that all of you are enjoying this long public hearing, as I'm sure you all are. There's many questions, I'm sure, that have come up, but I just wanted to express my support for this and my encouragement of you to support this bill once again out of committee It truly can save lives and certainly reduce the cost of healthcare for our constituents, and it's giving them a choice that they really, really need at this point. So I thank you for your time today. And Madam Chair, I turn it back over to you.
Thanks, Representative Scanlon. Any questions from the committee? Thank you for joining us. We appreciate your time.
Thanks, everybody.
Cameron Kessler, followed by Gretchen Raffa. And I just want to remind, I'm sorry to jump in, I just want to remind people we haven't been paying attention to the 3-minute rule, but considering where we are in this day, I'm going to be notifying people when that 3-minute time frame is up for speaking, and then we would open it up to questions from the committee. So Cameron, you're up. Thank you.
Thank you. Good afternoon, esteemed members of the Insurance and Real Estate Committee. My name is Cameron Kessler. I live in Hartford. I'm a current Master of Social Work student at UConn, a social work intern at the Connecticut Citizen Action Group, CCAG, and a children's librarian in Lebanon, Connecticut. I'm in full support of SB 842. I received my health insurance through a small business through my parents' insurance. While I'm lucky to be on their insurance, it does not provide me with adequate health care. My family's deductible is $5,000 per person, so that's $15,000 for all of us to be covered. I don't have ongoing health problems, which means I infrequently meet this deductible. In June of 2020, I had a routine emergency surgery. I had to have my appendix removed. Even though I have insurance, I had to pay $5,000 out of pocket all at once for this surgery. I only work part-time because I'm also a full-time graduate student, and I'm still paying these expenses off almost a full year later. Due to my low quality health insurance, I tend to avoid seeking out healthcare unless it's an emergency like my appendix, and many others in the state are in the same situation as me. During the global health crisis we're experiencing, this can't be the case. When people don't seek out healthcare when they need it, the consequences are life and death. That's why we need SB 842. It's for people like me and Connecticut residents across the state. Small businesses can't afford to provide high quality health insurance as it stands. I'm currently insured and I have health insurance, but I can't afford to receive health care. No one should have to avoid seeking health care because of its costs. We're experiencing a public health crisis unlike anything we've seen in the past century and maybe longer than that. So now more than ever, we need to ensure adequate health care for all of Connecticut, not just those who can afford it. If now is not the time to enact public option, when is that time? Enacting SB 842 would help Connecticut residents with the thing we're struggling with the most right now. We need affordable healthcare and we need it now. Thank you for your time.
Cameron, thank you for coming today and waiting patiently and sharing your story. It was really good to hear your perspective. Senator Lesser.
Yes, thank you, Cameron, for telling your story, and hope your surgery went well and that that you can get out of that medical debt quick. And what we're hearing, of course, is that I understand that one of the goals of having high deductibles is to discourage people from getting unnecessary medical care, but my God, people do need to get necessary medical care, and that is a problem, especially right now in the pandemic. So in addition to the public option part of the bill, there's also increased support to bring down deductibles and premiums for people who buy their own health insurance on Access Health. If that's something that you think would be helpful for folks?
I definitely think that would be helpful.
Great, thank you very much. And good luck to you.
Thank you.
Any other questions for Cameron? Cameron, thanks so much for coming. Next up is Gretchen Raffa, followed by John Brady.
Good afternoon, Senator Lesser, Representative Wood, and honorable members of the Insurance and Real Estate Committee. My name is Gretchen Raffa, Senior Director of Public Policy and Advocacy with Planned Parenthood of Southern New England, testifying in strong support of Raised House Bill 6389, an act concerning explanation of benefits. Planned Parenthood is the largest provider of sexual and reproductive health care in Connecticut, serving over 62,000 patients annually at 14 health centers, and we're also offering primary care. As a healthcare provider and advocate, our top priority is ensuring that all individuals have access to the healthcare and information they need, including the full range of sexual and reproductive health services. A decade plus after the passage of the Affordable Care Act, millions of uninsured individuals have gained healthcare coverage, and it has set the standard for services that we must be able to access. As a result, young adults have been covered by their parents' health insurance plans until the age of 26, which has allowed millions of young people access to health insurance. However, the unintended consequences of this effort may be breaches of healthcare confidentiality because of the billing practices of explanation of benefits, which provide a detailed statement to the policyholder, such as a parent or guardian, about health services paid for by the insurance plan. And a significant number of insured young people are accessing covered care, such as a full range of sexual and reproductive health care, behavioral health care, substance abuse counseling and treatment, mental health or substance use disorders, and our state law already protects minors' access to such care. The intent of this bill is just to establish other mechanisms to ensure confidential healthcare information is not shared with anyone other than the patient by requesting that the explanation of benefit about their care be redirected to another address, including email, or not issued. And this is just one step we can take to improve patient privacy. The reality is many adolescents proactively involve their parents and guardians in their sexual and reproductive healthcare decision-making. But for the young people who can't, often out of fear that they will face some type of punishment or abuse for being sexually active, confidentiality protections are essential. And this reality can be particularly pronounced among marginalized adolescents, such as those who are experiencing homelessness, identify as LGBTQ+, or are in the foster care system. This bill gives young adults the opportunity to access vital healthcare in a confidential manner and is consistent with state law. Several states have already adopted confidentiality provisions specific to EOBs, including Massachusetts, California, Oregon, and Maryland. And we can be the next state to ensure that when people get private health insurance coverage, they can use it and feel safe knowing that they have confidentiality. And that's why we urge passage of House Bill 6389. We have also submitted written testimony in support of Senate Bill 842, an act concerning health insurance and healthcare in Connecticut. Despite all the progress that has been made with the Affordable Care Act, we have seen far too many people in our state still lack access to quality, affordable healthcare, including those who are currently shut out of private and public health insurance coverage, including undocumented individuals. This is always unacceptable and even more tragic as we reflect on the one-year anniversary of a global pandemic that has claimed so many lives and left so many people with lifelong healthcare concerns. In closing, our state needs to act now and continue passing policy that allows greater access to healthcare coverage, including increasing Medicaid eligibility, which this bill does. People who are disproportionately impacted by COVID pandemic cannot wait. They need reliable, affordable, comprehensive healthcare coverage now. All people deserve access to healthcare as their basic human right, and this is why Planned Parenthood also urges the passage of Senate Bill 842. I thank the committee for your time in consideration of these important bills.
Thank you, Gretchen. Any questions from the committee? Gretchen, thank you so much for coming.
Thank you for your time.
Next up is John Brady, followed by Anik Neri-Levine.
Good afternoon, Representative Wood, Senator Lesser, and members of the committee. My name is John Brady. I'm a registered nurse and the Executive Vice President of AFT Connecticut, a union of 30,000 members in healthcare, education, and public service. I speak to you today as a nurse and a union leader, but also as an assistant manager of a small business, AFT Connecticut, which provides insurance to approximately 24 employees. I speak to you in support of SB 842. Too many of Connecticut's residents are suffering from runaway healthcare costs due to high premiums and high deductibles. Too often, our residents must decide between healthcare, food, and rent. This should not be the case, and we should not tolerate it. Medical debt is not only a burden to our residents, it is an economic burden on the state's economy. Small business and nonprofits are made to compete on an unequal playing field, as small group insurance plans can be cost prohibitive. This bill would offer high quality health care at an affordable price without high deductibles by leveraging the power of the state of Connecticut. It would add a measure of stability to the marketplace and allow Connecticut residents access to insurance that they could actually use, instead of having insurance which they cannot afford due to high premiums and they cannot afford to use due to high deductibles. It would help to equalize the playing field for small businesses and nonprofits, which are the economic drivers of our economy and so vital to providing many of our needed services. In my mind, this legislation should receive unanimous support. It is not only in the best interest of the people of our state, but it is business friendly, as it would greatly help nonprofits and small businesses, and thereby encourage entrepreneurship and innovation, two of the chief drivers of our economy. I urge your support of SB 842. I thank you for your service to the state of Connecticut, and I thank you for your time.
John, thanks for being here and being so patient today. Any questions from the committee for John? Great, thank you, John. Next up is Anik Neri Naveen, followed by Wyatt Bosworth. Anik, I believe you're muted. If you just want to unmute yourself and you can start over again. Thank you.
Thank you. I do that every time I get on Zoom. My name's Annika. I live in New Haven. I'm a beginning farmer. I work at a small organic farm right outside New Haven. I just graduated from UConn, and I love the work I do as a farmer. And I'm really passionate about the work because I am really passionate about the power of sustainable and just food systems to address health problems and climate change and racial injustice and all kinds of other problems. And the power of food to build our local communities and local economies. So I love this work and I want to keep doing it for the rest of the foreseeable future, but I don't get health insurance through my job. And I'm really stressed about affording health insurance going forward in my life. And I know that I'm a person with a lot of privilege, so that tells me that this is like a severe crisis that we have on our hands in terms of affording quality health insurance. So yeah, I guess I represent young aspiring social entrepreneurs in Connecticut who want to help make this state better. I love my community and I want to make it better, but it's hard for me to navigate that not knowing how I'm going to afford health insurance. So I want affordable quality health insurance for myself and for everyone in Connecticut. Thanks.
Annika, I am so sorry that I slaughtered your name.
Oh, happens all the time.
Yeah, but thank you for coming, and I'm just so grateful to see a farmer and a woman, young woman farmer at that. I'm a true farmer at heart, so thank you for going into that very rewarding field, very tough job. I just wanted to ask you, do you have health insurance now?
I do. I have it through my dad, but I'm about to turn 26, so I have to figure out my options going forward.
Yep. And so you would use our Access Health CT system on the exchange. And when you go through that process, I'd love to talk with you further just to get your feedback on it, because I don't, I personally used it. So I love to hear other people's stories. So we'll open up to questions. Senator Lesser.
Thank you, Madam Chair, and thank you, Annika, as well. I tease Chairman Wood sometimes about being part of the Rural Caucus from Rocky Hill, but we got to bring in some Rural Caucus members from the New Haven delegation, I think, next. So it's good to see you starting out a career in farming, and I wish you success in that. There's a concept in economics called job lock, where people can't start something new, can't undertake entrepreneurship or leave their current job because of fear of losing benefits. Clearly, healthcare is one of them. And I was wondering if that's something that you're seeing among the people your age, or if that's something that you're afraid of, is the ability to take a risk and do something new. Because I'm concerned about that, obviously in your case, but also just as we look at Connecticut's economy. How can we set Connecticut up for economic success going forward?
Yeah, what was the economic term?
Job lock, where you're locked into a job. You can't afford to quit the job because then you lose health insurance.
Yeah, I would say that between student debt and risk of losing benefits like health insurance, this is like a monumental crisis that's just trapping young people out of being able to like pursue their dreams and their best work and helping Connecticut be the best state that it can be. It's like, couldn't overstate how big of a problem it is. Yeah.
Well, thank you. I'm a little bit older than you, but I see that in my generation too, and I really appreciate your comments and hope the members of this committee take that to heart. I think it's a really big economic problem for our state and our country. So thank you very much.
Yeah, thank you.
Senator Anwar.
Thank you, Madam Chair. Annika, thank you so much for your testimony. And I think what you've alluded to is something very real and something we are seeing across the board. We are seeing individuals, our entrepreneurs are forced into taking a job just to be able to take care of their health needs because we have not given them the option. You are not able to take the risk because you are unable to afford the basic thing that we should actually be able to help our community with and the young entrepreneurs with. So one segment that's being impacted, the other ones I know for a fact at times are they're women and more so in bad relationships, and they are worried about their health and losing their health insurance, and they actually have to live in that situation for a long time because they don't have any option in that situation. The third one is an abusive workplace situation that people are surviving because they have some kind of a semblance to insurance, because the insurance that they're getting is also very poor. So we are not allowing the full potentials of our citizens to be achieved. And then that's the real issue. And I will hear many of my colleagues speak about young people not staying in our state, young people not, when it comes to making policies, then they go and go with the industry and not work with the young people and the people who need the help. So it's almost like two conversations that they're having, one with the theory and one with the reality of their votes. The words would be something, but the votes would be completely opposite to the reality. The specific question for you is, if there was a neighboring state which had a public option, would you end up moving to that state and go there because this state did not provide that option to you?
Yes, yes, I think so. I really resonate with a lot of what you just said. And I have a deep love for New Haven, and I want to stay in the New Haven community and help make it better. But if I can't figure out a way to support myself, and like, I do not lead an extravagant lifestyle, but if I can't like have my basic needs met, and there is another state, maybe not even nearby, if there's another state that feels like a more welcoming place for me to be able to live my life the way I want to and do the work that I am passionate about, then I could see potentially leaving and doing that work elsewhere.
Well, we are here for you. We are going to make sure that we are able to take care of our young entrepreneurs, young individuals who are starting their careers, who are just crossing the 26-year threshold, to have a protection for them so you can actually stay and make our state much better. So you follow the votes in this committee on this issue. Please do that. I know you have a lot of followers. I know you have been doing good work. So this happened, and thank you for raising our awareness on this aspect, which is very critical in this bill. Thank you. Thank you, Madam Chair.
Yeah, thank you.
Thank you. Any other questions for Annika? Annika, thank you for coming today. We appreciate you sharing your story.
Yeah, thank you all so much.
So I have just been informed that there's been a swap out of the next speaker. It is not Wyatt, it is Sue Halpin, followed by Louis Luna. Okay, let's go to Louis Luna. Are you on? Is Carlos Moreno on? Carlos, you're up. Thanks
Okay.
for coming.
Thank you, Representative. Thank you, members of the Insurance and Real Estate Committee of the Connecticut General Assembly. My name is Carlos Moreno. I'm the State Director of Connecticut Working Families Organization. We're a multiracial progressive political organization that builds power for working people. And we stand in full support of SB 842, the Connecticut Public Options Bill. I just want to make a few quick points. Number one, expanding access to care to those who suffered the most from the pandemic should be a top priority. And I believe that's reflected in this bill. The pandemic has exacerbated existing economic and healthcare inequalities between whites and people of color in the US. And the loss of jobs among people of color has led to health insurance loss that is approximately double across the US, with immigrant and Latinx populations experiencing the most disproportionate impacts. So that's why a strong health insurance expansion must include coverage for all undocumented residents in Connecticut and ensure individual health plans on the exchange are affordable for economically marginalized folks. On the Medicaid expansion, we're in full support, obviously. The Medicaid plays a critical role in communities of color, in part because structural factors limit economic and wealth building opportunities for people of color. Thus, people of color are less likely to be engaged in the labor market, often because of discriminatory hiring practices, and they're more likely to be employed in low-wage jobs, a cornerstone, a big part of our economy here in Connecticut. And many of these jobs do not pay benefits like health insurance or offer plans that are just too unrealistic for folks who are holding low-wage jobs to be able to afford. So Medicaid really plays an important role in connecting people of color to the care they need, and expanding the eligibility to 201%, I believe, is something that should be done for individuals and parents. On access to medical coverage, regardless of citizenship status, undocumented immigrants are barred from accessing health coverage on the exchange, barred from receiving Medicaid, as everybody knows. So as a result, they can't seek the proper health care that they need. However, they contribute more than $120 million in state and local taxes in Connecticut, and this is in the year 2015. I believe the estimations are a little bit higher now. And by that same very principle, they should have the same right to medical coverage on the exchange or medical care as any other taxpayer does. Expanding access for immigrants saves money for Connecticut in the long run. Many undocumented immigrants rely on emergency rooms as the first point of entry into our medical system. And they're required under the federal law to care for patients who come through their doors when they get sick because they don't have access to health care. That ultimately costs the state and federal government millions in reimbursements to hospitals. It costs the hospitals money too in unreimbursed claims. And it's just common sense that making healthcare coverage accessible to undocumented immigrants is a cost saver for Connecticut in the long run. So based on those points, we obviously support the public options part of the bill, which which provides the employer option and the nonprofit access to health insurance, as well as the Taft-Hartley plans, all critically important to many of our members as well. But I believe that this bill also is laser focused on providing immediate material relief to the folks that have been most affected from the pandemic right now, lower income and economically marginalized folks, mainly people of color. So for those reasons, we encourage and urge Connecticut lawmakers to support SB 842 this session. Thousands left out of the recovery need emergency care now. Thank you very much for your time.
Thank you, Carlos. Are there questions from the committee? Carlos, thank you for coming. I see Louis is on, who I skipped over. So Louis Luna, if you'd like to go next, you're up.
Thank you, Madam Chair and members of the Insurance and Real Estate Committee of the Connecticut General Assembly. My name is Luis Luna. I am in New Haven, and I am an organizer at the Connecticut Working Families Party. I support SB 842, an act concerning health insurance and healthcare in Connecticut. SB 842 will make health more equitable, dependable, and affordable by creating new public options for health insurance in our state. First, let me start by telling you a little bit about me. I'm originally from Ecuador, and I am a member of a multi-status family. That means that some of my family members are not shielded from deportation, and in turn, don't qualify for health insurance, unemployment benefits, or any type of federal aid, including any type of stimulus checks. As an organizer, I've been working and speaking to folks about their stories in relation to healthcare access, And what I have found is that people are suffering. I've spoken to people who are afraid to go to the doctor because they simply can't afford or are turned away because they lack insurance coverage. I also spoke to Evelyn, who will join us later today, who's undocumented. She's a childcare provider living in Bridgeport. Her husband had a herniated disc, and he was under tremendous pain, but went months undiagnosed because the family could not access a CT scan. Simply put, because the family did not have insurance or had the money to pay a $3,000 image, he suffered. He went back and forth to some specialists, an acupuncture doctor, he did some physical therapy, all paid out of pocket, and he finally saw a neurosurgeon. Finally, this doctor, they did a CT scan and they had to do a back surgery. And the hospital agreed to do this surgery only if the family agreed to do a $40,000 payment plan. This story is not unique. Thousands of families across Connecticut don't have access to healthcare and are burdened by debt and are not being taken care of. I'm also going to quote another story that I got from speaking to folks. This is from Ashley Antao. She writes, I work at a gas station and I was stabbed there in August 2019. When the ambulance arrived, I told them I could not afford to go to the hospital. But when they saw that I was bleeding, they forcibly took me in. The hospital asked if I had insurance. I told them I did not. They sent someone to see me from social services, but I got a huge bill for x-rays and blood work. I have received some help from social services to pay for it, but they do not cover the ambulance costs. And I'm paying for the ambulance in installments, several dollars every month. She's also undocumented. So I'm gonna stop right there and just from an organizer point of view, like by having these conversations with people across many cities in Connecticut, I see that people have these stories, and not having access to healthcare, especially during a pandemic, is something that families are going through this moment. And then I would like to finish by saying that during the pandemic, we started to see the importance of essential workers. And thinking about our farm workers, thinking about people who work in the food service, people who work in kitchens, washing dishes. A lot of these folks are undocumented and don't have access to healthcare. So when I have the story, when I hear these stories and when I speak to folks, it really comes very close to me and my family because some of my close family members are also undocumented and are going through this. So I urge this committee to support SB 842 and to make healthcare access more equitable to everyone here living in this state. And thank you for your time.
Louis, thank you for joining us today and sharing your story. Senator Lesser.
Thank you, Madam Chair, and thank you, Luis. Luis, I just want to be clear about what this bill does. My understanding is that currently under the law, it is illegal for many immigrants, many of whom are here legally, but also undocumented immigrants, to purchase health insurance on the exchange with their own money. Is that accurate?
That is correct.
And from your perspective, does that create special concerns right now in the middle of the pandemic? Right? If people who are sick can't afford to go to the doctor or don't have a primary care provider because they can't purchase health insurance with their own money, is that something that you would think of as a public health problem for the rest of us, for people who may have coverage?
Yeah, no, yeah, absolutely. I think that what I've been seeing is that people are in fact afraid to go to the doctor. I've also spoken to folks who are older, women especially, who have to go, who need a yearly checkup, either to do mammograms or pap smears, and they are simply not doing that because they don't have the access to do so.
And my understanding is it's not just undocumented, it's also people who are here, recent arrivals who are here, with status, who are here legally. That's something that you've seen as an issue.
Yeah, I mean, I think that healthcare overall is very expensive, and when you account deductibles and when you account out-of-pocket expenses, it's very expensive to everyone. Especially those who are working low-wage jobs and where those type of jobs don't offer healthcare. And I'm also kind of thinking about the like the construction business and landscaping and farm workers. There's not an option there.
Thank you, Luis, and thank you, Madam Chair.
Any other questions? Great, thank you for joining. Next, we have Kathy Flaherty, followed by Josh. Followed by Nora King. Kathy, are you here?
Yes, I am here. Thank you, Representative Wood, Senator Lesser, Senator Huang, Representative Pavlik D'Amato. My name is Kathy Flaherty, and I am the Executive Director of Connecticut Legal Rights Project in Middletown. We are a statewide nonprofit that provides civil legal services to low-income people who are eligible for mental health services from the State Department of Mental Health and Addiction Services. I am here to offer testimony in support of two bills. The first is 6389, the explanation of benefits, because often, as you heard earlier from my colleague Gretchen Raffa, young adults and other people in different situations want to have privacy in their medical care from the person whose policy they get those services covered under. So we are in strong support of that bill. And I'm also here in support of Senate Bill 842 for a host of reasons that are in my written testimony, including the fact that it expands the eligibility, returns the eligibility for Husky A parents back up to 201% of poverty. If you're not familiar with what the numbers are, I really encourage you to look at them. 138 it's a very remarkably small number, and going up to 201 is still a remarkably small number considering the cost of living here in Connecticut. But I speak for 842 on behalf of undocumented immigrants who currently can't get care, but especially in my role as an employee of Connecticut Legal Rights Project and as the executive director, the employer. Our costs of healthcare have gone up remarkably. The quality of that care perhaps has been maintained, but I gave you written testimony and I am happy to answer any questions about the details of what our insurance plan has been and how it's had to change over the years. And we are a small business. We currently have 11 people on staff, hope to soon go to 12. Only 4 people at the office get insurance through us because if they have the opportunity to get it elsewhere, they do. I am one of the people who gets insurance, the employer-sponsored health insurance, because my husband is a self-employed graphic designer. If it wasn't for my job, we would have no employer-sponsored health insurance. We never design a health insurance system like this if we were designing it from scratch. And I do believe that this public option to spend less on employee benefits and have more money available to serve our clients.
Great, Kathy. Thank you for sharing your story. Senator Lesser.
Thank you, Madam Chair, and Kathy, it's good to see you. Full disclosure, Kathy is one of my constituents, and seems like she's everywhere. Just a question: how much does Connecticut Legal Rights Project spend on health insurance every year as a small nonprofit?
Well, we are that. Of course, that's the one number I didn't get you, but I can get you the exact number. But I do know that 88% of our budget is employee costs, which is salary and benefits. And I think the benefits package is like all the benefits, fringe stuff is about 37%. So it's a lot of money. And considering that, you know, we have purchased a plan that covers 4 people and their families. What we also do is we reimburse our employees who are able to get health care elsewhere if it's cheaper for us. And it is. I mean, we have people who are married to state employees. We have people who are married to state retirees. And it's remarkable the cost of those plans compared to the cost of the HSA high deductible plan that we have. And just to answer a little bit, you know, when we first switched from the more regular point of service plan to an HSA plan, we used to self-insure the deductible for people. But between 2017, 2018, and the 2018-2019 year, our costs went up as employers 18.8%, while the deductible also went up from 2,600, 5,200 to 2,800, 5,600, and we had to stop contributing and self-insuring that HSA because we couldn't afford it. And now we are currently at a 2,800, 5,600 deductible for folks. And one thing I will tell you is that when you offer a plan like this to your employees and you hire somebody who's new, who needs health care, they can't afford getting their health care when they first start because they can't afford that deductible. We need to have a better option for people. I think that public option may do that. And that's why I really look forward to the committee supporting and passing it.
Great. Thank you. Thank you very much. And thank you, Madam Chair. And as we look forward to looking at ways to support our nonprofits, nonprofit providers across Connecticut, it sounds like this is something we should be looking at. Thank you.
Thank you. Representative Dathan. Thank you very much. And thank you, Kathy, for your advocacy here. It's really appreciated. And your testimony today. Just wanting to know, in your role, do you ever represent people who have bad debts with hospitals or medical centers due to non-coverage?
We directly don't do that kind of representation at Connecticut Legal Rights Project, but certainly in my involvement in Keep the Promise Coalition and just being a legal aid lawyer for 20 plus years, deal with a lot of people whose consumer debt is really medical debt, and that's hanging over their head. Most of our clients receive their services from the state. So if anything, they may be dealing with welfare liens and things like that, which is for a topic for another day. But certainly it's an issue.
So my more question has to do with if there is a bad debt and it can't be resolved through the legal process, and the hospital deems it uncollectible, who ends up having to fund that? Do you know? Is it how does the hospital recoup its cost for some of these large, uninsured services? So things like if somebody goes to an emergency room or, and has an accident and it's, $20,000, $30,000 or even graver in the hundreds or millions of dollars. And that debt seemed uncollectible. How does the hospital cover those? Are you familiar with that? And have you seen that in your work?
That is a fabulous question, and I think is one that's probably better answered by somebody from the Connecticut Hospital Association. Okay. I'm representing individual people, not large hospital systems, and so they are going to be very different bases of knowledge, and that's a knowledge I just don't have.
Okay, thank you so much for your testimony. I'll save my question. Thanks.
Senator Anwar.
Thank you, Madam Chair. Thank you, Kathy, for your testimony, and thank you for sharing your experience. I just wanted to touch base on the collection practices. Actually, I have put a bill on the collection practices challenges. This has been but really abusive by some of the larger healthcare systems to individuals where they're going out of their way to in order to recoup their money for somebody's agency in their future earnings in a manner which is unfair. So I have a bill looking at this aspect, but this is shares the experience that people are having in real life and some of the ways healthcare systems are being abusive. But thank you for your testimony.
You're welcome.
Any other questions? Great, Kathy, thanks for coming today.
Thanks so much for having me.
Next up is Nora King, followed by Sue Halpin. Nora, are you here? Sue Halpin, you're up.
This is the second time, Madam Chair. It's like she's a, no.
Okay, we will pass on to, is Joelle Fishman available? Oh, sorry, Sue Halpin is here. She's waving. Just unmute yourself. Joelle Fishman, you are next.
Can you guys hear me okay?
We can.
My apologies. I'm on my phone. For some reason, my computer did not want to admit me. So I am joining my phone, and that technology is a little new to me. So forgive me. I wanted to find my testimony would be good. So thank you for having me. I appreciate the opportunity to come before you. My name is Susan Halpin, and I'm here today on behalf of the Connecticut Association of Health Plans. Our association, as many of you know, is comprised of Aetna, Anthem, Cigna, Connecticut, Harvard Pilgrim, and United Healthcare. And I'm coming before you today to ask you to officially and respectfully oppose Senate Bill 842. You've heard a lot already today about the partnership plan and about the finances behind it and where we see it coming from the industry. So I just wanted to go through a few things. You have my written testimony, and 3 minutes be hard for those of you that know and have met with me. Usually takes me about half an hour to get through this to this bill. I think first I need to say that all of our carriers believe that access to quality, affordable healthcare is paramount. And we are committed to working with every stakeholder on this phone today and in the legislature and in the community to reach that goal. It is core to the mission of all of our carriers. The bill that's before you today, and I think it's caused, some confusion, and I don't profess to know all the details myself after, diving into it for the past couple of days, but it's really two bills in one as we read it. The first section is about the comptroller's plan, and the second half of the bill is really about assessments and subsidies for the health insurance exchange, known as Access Health CT, and then again for some Medicaid expansion stuff. So they really are two very different things. And actually, in a lot of ways, they contradict one another. So it's kind of hard, and I think you saw that through some of the testimony today, rather hard to talk about both kind of all as one. But on the first section of the bill, I think it's important, and I think this was already hit upon, but the bill as we read it goes way beyond small employers and nonprofits. It extends into the larger group community, and it includes individuals. If that's not the comptroller's intent today, he certainly has the authority for the bill to do that. And I think that's also really important, is there's a tremendous amount of authority granted under this bill. And when I talk about the two measures contradicting themselves, on the one hand, there is a proposal to assess a $50 million charge on health carriers and premium payers, and therefore premium payers, and then and that's to subsidize the individual market, but yet we're setting up a whole nother market, or the potential for a whole nother market over under Comptroller Lembo's purview. You heard a lot about the partnership plan and how it sits outside the scope of the state employee plan, but it mirrors it in many ways. You've heard about the deficits that the plan has run. One thing you may not have heard about in this conversation is that this is not a new concept. This is an old concept. It's been rebranded over the years to be the Connecticut public option. But, this goes back probably prior to 2008. But in 2008, Governor Rell actually vetoed the initial bill. It's been known as Mega MEHIP, Sustanet, or just plain pooling for those of you that have been around as long as I've been around. I mentioned Governor Rell's veto in 2008. Malloy asked the Department of Labor for guidance in 2012 because he was concerned about what would happen if the state lost its risk exemption. And you heard some of that earlier today. The ERISA exemption would open up the state to substantial liability, not just about form filing, et cetera. It allows the state to be sued. So as you move forward on this, that's something that's very, very critical that you take a look at. There was a lot of talk about the comptroller's report, and Senator Wong and the comptroller went back and forth. It's been provided. That data was required under Public 19-117, and it's pretty substantial. And I don't mean to be presumptuous. It's certain legislature's purview to spend money and to invest in things that they choose to do. But it seems like despite a lot of conversation about transparency, there's really never been a full audit done of that program. Why it matters to us in the private sector is because, frankly, we talk about an unlevel playing field and it kind of just gets cast off. We can't compete. The private insurers can't compete in the private market. The partnership plan has the ability to set prices too low and offset them with taxpayer dollars. There's the conversation that happened earlier suggesting that people did not have to go into the partnership plan. That's true. But we can't sell if we can't compete, and we can't compete if all the advantages are in one person's or one segment's hands. And I probably am reaching my 3 minutes. Yeah, I did it. Hit it already. I saw it. I will.
You want to just do a closing sentence or two, Sue, and then we'll open questions.
Yeah, sure. I think we talked about that. I mean, I think there's really the option that's afforded under this public option is really, a couple different ones. One, it's not sustainable the way it's currently created. So either premiums are going to rise for those folks that are in the partnership or this new plan. If they want to exit, they're going to look around and chances are the market will have dried up and there won't be an alternative in the market. Taxes will increase dramatically to fund it because the state can't sustain deficits of that nature, particularly when it gets larger and larger. And three, or provider rates will get slashed. And that's something that hasn't been talked about, that in my Q&A, perhaps I'll be given an opportunity to talk about what we see as the impact on provider rates. So
let's
I'm finalized. I'm done. I'll take your question.
Senator Lesser.
Thank you, Madam Chair. I want to thank Sue for your testimony, and I was just joking beforehand that you were avoiding us, but I know that that's not the case. I know you.
Never, Senator, never. I'm always available.
I know. So I just want to talk about. I mean, one of the things that you've emphasized in your testimony is the urgent need to strengthen the Affordable Care Act and the existing health insurance exchange that we have in partnership right now with two carriers, Connecticut and Anthem. Although I know you would prefer not to have an industry assessment, would you agree that additional state-based subsidies for exchange products would have the effect of strengthening the exchange?
Yes, I think we agree with the concepts of state-based subsidies. I will tell you in the 4 or 5 days that we've been looking at this in more detail, I think it needs a little bit more conversation. Somebody asked me just the other day, and I couldn't answer the question, and JP Weisky is going to testify later for industry as well, but somebody asked me, would these subsidies be exempt from state income tax, right? By giving someone because federal subsidies are exempt. State subsidies, I don't believe are currently. So you could, in effect, increase somebody's income liability and or trigger extended federal tax liability. So, but yes, these I think in the way that they're created it's an important conversation to have. And we're not opposed to that. We are opposed to funding it on another segment of the market, especially a segment where we're kind of getting hammered for the affordability factor, and we're kind of carrying a large load of assessments and taxes that the comptroller is not subject to either. So you got me started, sorry.
No, I appreciate that. And just with regard to how we fund it, am I to understand, like, as I understand it, the industry saw a substantial tax cut. We're estimating somewhere in the neighborhood of $300 million just on the Connecticut book of business when the repeal of the health insurance provider fee went into effect July 1st of 2020. Is that correct that carriers did see a $300 million cut when the provider tax repeal went through?
That is incorrect, actually, and it's a concept of embattling past severance. We are subject to rate review and approval before the Connecticut Department of Insurance. That AT from the federal level was repealed effective this fall, 2019 or 2020, as far as I understand it. The Department of Insurance, and I believe you can confirm that with them because I had to confirm it with them, did not allow rates to reflect inclusion of that tax. So of January 1st of this year, 2021, we did not charge for that tax, and it is not reflected in the rates that companies and our employers are paying. So if it were then added on, it would be a new 1.5 to 3% tax.
So, but just going back, I'm setting aside for what happened, looking prospective, July 1st of 2020, was there a major tax cut passed by Congress that went into effect?
I use the effective date, and that's what you always have to look at, is the effective date that it happened. And it was taken out of our rates. The department is very, very careful about that. The things that we are, concerned about when we're competing with the comptrollers. We are under intense scrutiny with the Department of Insurance, and that rate was not reflected in what we are charging for policies that went into effect January 1 of the year.
No, I understand that, but I guess just when did the federal tax cut that your members all received, or many of them received, when did that go into effect, if not July 1?
I understood it to be this fall, but we have a couple people testifying later today that may be able to give you a better answer. So I will defer to them if that's okay.
Okay. And now this bill seeks to, one option that many states have adopted, Maryland, New Jersey being among them, has been to simply keep the expiring federal tax in place at the same level as a state option. This language before us does not have that. Instead, it has a much smaller replacement with some language that I think may be familiar to your members. Is that accurate?
I'm sorry, is it different? Is that was your question?
Yeah, is it assessed differently, and is the size of the assessment considerably smaller than the tax cut that your members just received?
I can't comment on the tax cut. And again, I would say that I'm sure that this was due for the premium years that it was included. I'm getting some text here that I may be able to respond to you quicker, but in terms of your question about the assessment that's included in the second half of 842, it follows along the lines of what I understand is the public health fee assessment that carriers are are assessed today for the programs that I believe Representative Nuccio referred to earlier that were cost shifted onto the insurers that formerly were under the Department of Public Health. And those were things like lead prevention, easy breathing programs, a lot of really, probably very good programs that during a previous deficit were shifted onto the insurance fund, which the carriers all pay. And therefore it's grown to about $11.8 million today that the carriers pay. So that 50 million would go on top of that 11 million, which would go on top of the 30 to 36 million that the carriers pay for the exchange today, on top of a $40 million assessment for the insurance fund, on top of a $209 million premium tax. And then, it's a little bit different because there's something, it's very tangible about the immunization fund, but that's upwards of $70 million. I think the problem here with this, and I hear your point, I really do. And I think we appreciate the sensitivity of the committee in not looking to trigger retaliatory taxes. But I think as you and I have had a conversation, and we've had conversations over the years, I feel like we're reaching a tipping point. Right. There's only so much more juice in the lemon, so to speak. And I think we're reaching that at this point. So while we may agree with you that the subsidies and shoring up the exchange are, a good idea and certainly, important for folks, we just question the financing mechanism and the funding mechanism that's been proposed. And we question also that the fact that the insurers are the only ones being asked to come to the table when there are a lot of other stakeholders involved here, from hospitals and pharmaceutical companies to the legislature, frankly, the General Assembly and the state. So I think there's a part for everybody to play if that's the direction that the legislature chooses to go in.
That last point seems totally fair and a reasonable conversation. And you raised a couple of issues that our friends over at the Finance Committee might want to take a look at some point, both that and the question about whether or not subsidies are tax exempt. In April, your members won a Supreme Court ruling that allowed them to recover $12.3 billion in risk recovery, risk corridor payments that had been owed to them during the Trump administration. And I'm wondering if some or all of those payments should be returned at some point to people who had paid higher rates than they would have otherwise paid had those risk corridor payments been in effect. Is that a potential source of funding that we could potentially use to jumpstart assistance to folks who are trying to buy affordable coverage?
I'm afraid that's not something I'm prepared to comment on today. I just don't have enough information, and I'm certainly willing to get back to you on that issue.
One part of the bill, again, intended to strengthen the private market in Connecticut and make insurance more affordable, seeks to create what are in effect a high-risk pool by extending Medicaid coverage to people who have permanent disabilities who are in the workforce. Is that something that would potentially strengthen the private market?
Well, I may have understood it differently than you described it. So could you describe it again? Because we were struggling to understand that part of the bill, to be very honest with you.
So there's an existing program that's existed for 20 years called the MedConnect program. It was set up by Congress under a program called Ticket to Work. And under the program, people who are who have a certified state disability are able to purchase Medicaid above the ordinary threshold, and presumably those folks are higher cost, higher need folks than typical folks, and so that would be effectively creating a high risk pool outside of the exchange that we would be making available. Is that something that could strengthen the viability of the exchange as we have right now?
I think that's one of those issues where the devil is probably in the details. And like I said, I don't think we've had, enough time to adjust, to digest the bill, to comment on that. Certainly high risk pools and reinsurance have proven helpful. I think, again, it goes back to how Are you intending to fund it? Is it a state authorization, a state appropriation? Is it an assessment on fully insured, meaning small employers in that market? Is it an assessment on the Medicaid folks? Is it a drawdown of federal match? You know, there's all kinds of things that are included in that. And I think conceptually, it's certainly an idea worth pursuing and one we'd be happy to have a conversation about. But it goes back to the funding issue that we've been talking about.
So I appreciate that, and I'm happy to have that conversation with you and your members. And just to understand the balance of your concerns, which regard the part that pertains to the comptroller's office, it seems that your concerns sort of boil down to two main buckets. And I don't mean to speak for you, and correct me if I have this wrong. But one is the question of a fair and level playing field. Are they operating under the same or similar rules that your members have to operate under? And the other is whether or not the plans are going to be subsidized by the taxpayer. If we could satisfy both of those questions, would that satisfy your concerns with that section?
Again, the devil is in the detail. Always have those conversations. You're certainly hitting the high points of our concerns. Although I will say on the comptroller of this, having been, as I mentioned in my earlier testimony, battling this in one way, shape, or form, I was not always the point person, but since 2008, I guess we question the underlying assumptions of that proposal, both as, you know, from a competitive standpoint and as your flagship industry in the state of Connecticut, that we are the insurance capital of the world, and not sure that we can fundamentally get behind the state itself competing with its flagship industry. But, you know, always happy to have those conversations. And with respect to the second part of the bill, the latter part of the bill, I think you're absolutely right. We'd be happy to have those conversations, but we just don't believe, we believe there isn't a lot, there's no room left to add another assessment on top of premiums. We'd like to get rid of the assessments that are there currently and the taxes that are there currently, and we might be able to sell more affordable products. When I'm asked, you know, what would you do, you know, to address the concerns, you know, the first I say is first do no harm, right? Because you've got several other proposals before your committee this session that tie our hands in terms of trying to manage the costs, the underlying costs of care, which are what drive premiums ultimately. So I say do no harm. Second, I say let's look at what we have and, you know, what are we doing to the policies that are making them unaffordable, and look there. And then we can go beyond there to some of the conversations that are happening under the Office of Health Strategy, where I think it's not, you know, it's not dynamic the way the term public option is. It's not, you know, it doesn't resonate high, you know, headlines. But that work, whether it's happening at OHS or it's happening in the community, because it is happening both places, that's where the real conversations need to be had. That's where the real change is going to come from.
Well, as you know, those conversations are continuing to happen, and those are beyond the scope of this bill. I don't think anybody's pretending this bill solves all problems with healthcare. I think we're trying to address an immediate crisis in the price of health insurance and the availability, particularly for individuals trying to purchase coverage. And yes, we've also heard a lot of concerns from the small group market. So, you know, I understand that there are all sorts of problems in the world that we also need to address, but some humility, at least on our part, would probably be. So thank you, Sue. I appreciate the conversation. I appreciate the committee's time. I know there are a lot of people waiting to testify, and I don't mean to take up so much of this.
Thank you, Senator. Always a pleasure.
I'm just going to go in order. Hands were raised. Representative Dathan.
Thank you very much, Chairman Wood, and thank you very much, Susan, for your advocacy for your client, your lobbying, I should say, for your client. I just wanted to get some clarity here because on one sense, you know, you talk about how that this plan is going to be such a drain on the state by having massive losses. And then on the other hand, you say at the same time, it's also going to completely decimate the industry. And I'm trying to understand how we have both situations. Can you explain that for me?
I sure can. So now the way that the comptroller sets the rates for this buy-in, they're not sufficient to cover the premiums that are being, or to cover the claims that are coming. So, this year is an anomaly because of COVID. So if he's running at a 94% MLR, as we say in the industry currently,
Can
he
you
is.
say what's an MLR, please?
Sure. MLR is a medical loss ratio. So when he's saying he's running a 94% MLR, it means he's spending 94 cents of every dollar on medical care, which you can argue is good or bad, but you need to budget for it, right? You need to understand what that means. And he referenced the fact that, typically health plans follow the ACA standard, which is 80 to 85% MLR. And the rest is administrative costs. I found interesting what he said his administrative costs were. I think that's something that as public program should be looked at. What is included in that? I know we have to follow very, very strict rules about what's included in that. Forgive me, but I have to point out that in Connecticut, a lot of MLR is called insurance jobs, right? I mean, those are your administrators that are funding, that are giving back to our economy in more ways than just working here. So an MLR is that standard. When he's selling a product that's running a $30 million deficit that would otherwise have been collected in premiums, he is selling it cheaper. You're absolutely right. He's selling it cheaper, and folks are going to go into that plan because it's cheaper. We're not allowed to do that. The Department of Insurance has a responsibility for making sure that our rates aren't too high, but they also have a responsibility for making sure our rates aren't too low, so that company X doesn't come in from out of state and buy up the business by lowballing the price, and then they don't have the reserves in order to pay the claims. Because at the end of the day, the most important thing that insurance can do and function as is to pay the medical claims that are associated, with healthcare costs. If you don't have the reserves to do that, then you're not solvent, and the Department of Insurance would bring you under receivership immediately. In this case, he in the case of what's been happening for the past couple of years at the comptroller's office, he would under receivership under the Department of Insurance if he were in our shoes. And so when we say it's not a level playing field and we can't compete with that, you're right. People will go into it. That's why we say it's a path to single payer. And there are people that may philosophically, want that to happen. And I can respect that. But I think we can't dilute, we have to understand that is what's being laid out here, right? Because it's individuals, it's small groups, it's nonprofits up to 100 employees. Nonprofits are considered a small group in the regular market if they're 2 to 50, or they go into the larger group. And I know this is complicated stuff, so bear with me, but your question is really good one. So when the idea that the groups aren't pooled today is incorrect. Small groups, an Anthem, an Aetna, a United, they take all of their small groups in Connecticut and they rate them as a block. And we're required to rate them only on certain factors. Those factors include age, geography, family size, benefit design, network standards, maybe a couple more. I think there's 7 in total, but they really deal with family size and those other ones. So you put it in the mix master only with those factors, and out comes a rate, right? And that's pooling. And it's called adjusted community rating. And it was done purposely so that certain small groups didn't experience wild swings from year to year. And So yes, because of all of the things that go into that, it's expensive. And and I say we collectively, the legislature, regulators, did that purposely to pool those small groups. If they can go now into the comptroller's plan, and the comptroller's plan has the ability to approve or deny and only take healthy risk, and they're going to get a cheaper price, all that healthy market is going to move into the comptroller's plan. What happens in the private market then is it's a death spiral. You can't afford it because that collective body that's left, those rates are only going to go up because the less healthy risk is left. And either everybody's going to go into the partnership plan or everybody's going to be screaming about their rates. There's going to be no middle ground there. And I think that's why we say the industry will, be a path to single payer.
Okay, so just for clarity, I'm an accountant by trade, and so you've explained MLR is basically a cost of goods sold to me. Is that right? Basically.
Say it again. Yeah. Say it again.
Cost of product manufacturer, cost of goods sold. So if you're looking at that delta, the 20% in these instances, 15 in others, how would you build up those costs? I mean, how would they break down into percentages? What percentage is profit? Which percentages are taxes? What percentage are administrative fees? Can you explain that a little bit? Because I'm just trying to have an apples to apples comparison on some of the general plans that you're talking about. So kind of like a profit margin on policies sold, administrative margins, tax margins, and other things like that.
Sure. And I can get you a better scenario than what I'm going to give you right now. But typically in this world, the carriers run around a 3% profit margin. And I think if you compare those to other stakeholders in this debate, you will find that that's, a pretty reasonable and rational, profit margin. What else goes into those administrative costs are certainly the actuaries that are, doing the work, the claims processors that are doing the work, the fees, tax, and assessments. And we're trying to get our arms around this in anticipation of this debate. But I'm going to take a guess. I've seen it, and it depends on your market and different things, but 3 to 4% is probably a good estimate on fees, taxes, and assessments. And then, within that, there's a lot of other, functions that happen within insurance. A lot of insurers are investing in wellness programs and doing other innovative things because, the old idea of an insurance company receiving a claim and paying out a claim is really not accurate anymore. I mean, these are global health specialty companies. So have one global carrier right here in Bloomfield with their home office. They are doing all kinds of data analytics to drive population health. They're doing all kinds of, case management and outreach themselves. So there's a lot going on, but I can get you a better understanding. And the 80 to 85% MLR is really important to understand too, because that fluctuates. I mean, I'm not going to say that there aren't years where our carriers could be running, in the 90s for an MLR. But the difference there is it's not the taxpayer that's picking up the figure. I mean, we're going to have reserves sufficient that the department makes sure we're sufficient, to make sure we can cover those swings, of claims experience.
Yeah, and I know in the state of Connecticut, we run our own Medicare system, and instead of how other states do it, I talked about it a little earlier, and our claim history there has been, we have not been running deficits in that organization. So of the sort of 15 to 20, I got a good understanding of about 7-8% And I'm guessing that some of the other things you talked about are included in that sort of 10, 12%. You just didn't give me specific numbers. Is that right?
Yeah, and I, like I said, I can break it down for you better as follow up.
Yeah, just was curious.
Important. We have to rebate. If we do not spend those thresholds, we are required, the health carriers are required to rebate that back to the customers.
Okay.
So I think that's another big distinction.
I've missed those rebates, so I would have loved to see a rebate. I'm sure everybody else on this call has received them, and that's why we're here today. Anyway, moving swiftly on, I would love to hear how the industry is moving to move healthcare more affordable for my constituents. I knocked on thousands of doors even during COVID, and you know, the biggest complaint I consistently heard from individuals is the rising cost of healthcare and premiums. The fact that their premiums keep going up, the deductibles keep going up, they have to spend more and more time fighting to get claims reimbursed. It's, you know, I would say, you know, the only break that I heard in that was when Eversource really had some issues with service this summer, and people were upset about their bills rising. So, you know, we have two consumer issues that I'm hearing at the doors, but consistently healthcare is mostly them. So I'd love to hear what you're doing or what the industry is doing to lower the cost of healthcare, because in my 2+ years of public service, in my constituents' experience, it's completely the opposite.
Well, I think you have to, it is, if there were a silver bullet for this conversation and for this idea, it would have been found, if not by us, then by you, right? There is not a silver bullet here. These are all things that work in concert with one another. And that's why I added in my earlier comments that, you know, the conversation needs to be had about healthcare costs. And whether that's our costs, you know, we've certainly, I don't know that there's anybody that's been more of an open book on costs or been picked apart more than the insurance industry. But I would say that there is a conversation that needs to be had about whether healthcare itself costs what it should. And there are so many dynamics in that. You mentioned the Medicaid program, and it's really important to talk about Medicaid, because I think you probably get calls all the time also from providers looking to increase Medicaid rates. Medicaid pays, depending upon, you know, the group, some are better than us, but around 70 cents on the dollar. Right? And you hear that all the time. I know I all the time. Medicare pays a little bit more, a little bit better than Medicaid does, but still not what's sufficient. And what is sufficient, we don't know. We know, for instance, our carriers, according to a Kaiser report, pay 215% of what Medicare pays for a standard hospital visit. So, and you would think that maybe that's bad, but when you look at it, we are among the lowest across the country in that. So clearly, the other issue that we have with a public option, and Comptroller Lembo very clear about this, that he wants to go out and negotiate, you know, lower rates with all those healthcare providers, his pool. Well, what happens is that's a third fee schedule where providers aren't be getting paid what they should. It's going to be another government fee schedule, and the response to that is going to be requesting the commercial carriers to pay more. And I know that's a complicated thing to follow, but and that's why this conversation needs to happen. You know, the hospitals and the payers, they do battle every day, but they can come back and both agree that, you know, we need to be looking at, you know, the cost of care itself. Similarly, we have you know, a pharmaceutical company, which, you know, is driving 15 to 17% trend year over year in your healthcare dollar that you were just asking about. Why are things going up? I would invite you to look back at the rates that were filed this fall with the Department of Insurance, and rates went up only slightly, like 1% or lower in many respects. Now you have to look at averages. So, I don't want somebody to come back and say that I saw it as this, you have to look at averages the way that you do, but, we're managing those leases and can we do better? Sure. And what are some of the things the carriers are doing? They're doing innovative payment models. They're working with providers to do, pay for, kind of whole person care. And they're doing those analytics that we were talking about to look at quality measures to see what's happening, whether it's working, how it's responded. For instance, Connecticut, many other states do capitated models. I think you were the one talking about capitation earlier. If you're doing capitated models here in Connecticut during COVID, providers would have been fairly well positioned to weather the storm because they would have been getting paid a per member per month fee to cover folks in their care. The way the system works for the large part today is they get paid every time somebody comes through the door. So you want to align the incentives in this in the provider market so that you're driving quality, you're driving whole person care, and you're not driving unnecessary care by virtue of the payment model. So those are just some of the things. You also have carriers that come in with other products into the market just since last year, and more will be coming where people have a more competitive choice out there. So I do think there are a number of things that are happening in the market today in response to the crisis. I don't think folks are sitting on their hands, so to speak. I think they're working very, very hard to address the issue as well.
Yeah, it's been many years in the making, and I agree with you that it is a multifaceted approach that we need to look at. And I would hope the Hospital Association, with all your, your Connecticut Association of Health Plans and other health plans, with all the buying power that you have, because you work across, the industry, you would be able to put pressure in on, the rising cost of medical things and services, appointments, surgeries, all of that thing with your buying power. And I'm hoping that is one aspect of how we can resolve this as a full industry, a full model approach. I'm gonna stop asking questions because there's a few other people, and I'm sure your phone's only gonna have so much battery. So thank you for your time, Susan, today.
Yep. Thanks, Lucy. Representative Dazen, sorry about that. Senator Huang, you're up.
Thank you, Madam Chair. Susan, thank you very much for appearing. And look, your organizational members, Aetna, Cigna, Connecticut, Harvard Pilgrim, United Healthcare, they're all integral parts of our state's economy, has a business, has employers, and part of community philanthropy. So I want to thank you for that. And it's really important. But, and it's a big but, the reputation sometimes for frustration and disdain based upon rising premiums, bureaucratic processes, and sometimes having to say no to people. Your industry may have unfavorables that could be a close second to, even for ourselves, politicians. That being said, and kidding aside, it is important to understand that you have a tough task ahead of you. So what I want to be able to do in this testimony is talk about facts and financials. Insurance is all about managing risks. And so for me, I just want to focus in on talking about facts and financials. So for example, the experience that you've had and learning about the Taft-Hartley and the unions, that the craft unions that we talked about. Now, they're self-insured and they pool together to lower their health insurance risks. But your members are the administrators of them, right? So can you talk to me a little bit more about pooling and what that means, and how these kind of small groups are in essence pooled risks, are they not? Can you explain that a little bit?
Sure. Yeah, the way that the small group market works today is we must take all of our small groups, 2 to 50 employees, and pool them together currently and rate them on just a certain set of factors: age, geography, and family size. So the idea behind that is you're adjusting for those, peaks and valleys in what otherwise would be claims experience or, significant high cost industries. When people talk about going into the self-insured market, one of the things, that you have to appreciate is then you are claims experience, right? Then you're getting rated based upon your claims, based upon potentially your SIC code, what industry you're in, et cetera. So there are certain protections, consumer protections. This small group rating law, when it was passed as a consumer protection for small groups. So, you hear a lot about the rising costs, but there are reasons for those rising costs. I'm not defending them. And, costs have gotten more expensive, but the concept there is still a good one, which is, you're adjusting only on certain factors so that nobody experiences the high highs or the low lows.
Okay.
Does that help?
It does. So I'm using the Taft-Hartley and the Coalition of Unions and Cassandra Murphy was excellent in her presentation. But I'll get the example of that. So they are self-insured. If they join into this partnership, they could benefit by a larger pooling, and they may even experience savings for the first couple of years. But what happens is, going into a larger pool, right? Their risk analysis may increase, because you're looking at a larger population versus their historical self-insured grouping. They could, the first couple of years, and this is what we've seen in the partnership, is the fact that the first couple of years, the risk hasn't caught up, because you have a larger pool and it diminishes the actuarial numbers. But over time, as the pool risk expands, your managed loss ratio increases, because you're kind of changing the dynamics and the risk of the pool. It does happen, right? From your client's experience of having years and years of actuarial analysis, that's really what happens in risk pools being expanded. Would that be a fair statement?
I'm sorry, I'm having a little trouble following, and it may be because I wasn't able to hear all of Cassandra's testimony, but certainly you reach I'm going to borrow my good friend Christine Cappiello's answer. General Motors probably has the largest pool of employees in the country that they're providing insurance for.
And they're self-insured.
And they're self-insured. And there's only so much savings you're going to get out of a large group at some point, right? There's a law of diminishing returns, I guess, is what I'm trying to say. So that's why I think everybody looking at these wellness programs and a focus on prevention and, what can we do at the front end as opposed to the back end, and look at value-based payment arrangements. I think that's why those things are in play now, because, and that point too, with, the idea of pooling being the kind of end all and be all for, driving rates down. It's not. At some point, you're either going to have to increase the premiums, increase taxes, or cut provider rates in some shape or form. And one of the fears that we have is if those provider rates get cut for yet another government program, the result is going to be felt in the commercial market. So, that's kind of, there's all kinds of levers. If you pull here, this is going to happen over there. And if you flip the switch over here, there's going to be an unintended consequence over here. And we're trying to bring forward today is kind of a list of all those unintended consequences so that people can appreciate really the magnitude of what's being proposed.
And I appreciate that, because you're talking about multiple levers, and some have mentioned that, you know, the proponents and the components of Senate Bill 842 lays a path toward a state takeover and a managed single payer structure, right? That could potentially displace our current existing private market health insurance industry. Could you explain and maybe comment on that? I think you were going down that path, but talk about the unintended consequences, even though right now you may be partnering with it, but the trickle down effect, it could be very devastating to the industry.
Yes, and a couple of things. And you're right, Senator, and I appreciate your acknowledgement of the industry as a major economic engine in the state. I mean, it's over 25,000 supported jobs from the industry. So it's fairly substantial. I mean, I'm trying to remember what state employee size is, but I think it's probably around 50. And that's if you included everybody else that was, related to the industry, it's probably about the same size. So I appreciate that acknowledgement. Right now, the comptroller has been, very clear. And I'm sure all of our companies are very thankful to be contractors to the comptroller. You have CVS Caremark that does the pharmaceutical plan. You have that does the dental. You have Anthem that does the state employee plan. You have United that does the retirees. Wells does the wellness plan. So clearly we have, our companies are partnering with the comptroller on a regular basis. More and more people come into the partnership plan, the more individuals and companies, the less there's going to be in the private market. And let's just, for argument's sake, I'm not saying this would happen, but let's just, for argument's sake, does that mean that Cigna is only a dental provider in the state? When you draw it kind of down this path, that's what you see. And I think there's another really important part of the bill that if you haven't been following it as long as we have, it might, escape notice. There's a section in the bill that just basically says that the comptroller does not have to contract with licensed employers. He can contract with vendors. So, my question is, what is the unintended consequence of that? Is the idea to go with, one of the PAs that are out, or one of these other types of content groups that, may do, negotiating? He's already mentioned that he is out negotiating individually with providers for lower rates. So I think that partnership, while it's there today, and I think again, our carriers are very, very appreciative of the opportunity to partner with the comptroller's office in that way. I think that this lays the stage for a divorce from that partnership.
It's important. I mean, like I shared earlier with Controller Lembo, we share the common goal in regards to making sure that people have access to affordable, quality, and accessible healthcare. And that's the measure that I'm focused on, and the experience of your organizational members, having done that for many years, should not and cannot be discounted. Let's talk a little bit about from the standpoint of what Representative Dathan suggested, and I agree. Your organizational members aren't sitting still in regards to looking to reduce costs. You must be aware of the incredible pressure to reduce your cost and the cost of healthcare. I think your industry was very helpful in looking at the 1332 reinsurance exchange. You looked at benchmarking. So to answer the focus of that, your industry is indeed looking at how we can reduce healthcare costs, because it's an unsustainable rate of increase that you're dealing with, and beyond the PR hit, it's a fiscal rise that's absolutely unsustainable. Can you elaborate a couple of the things in which you are kind of collaborating and as an industry and also with us as legislators to try to contain cost, and maybe cite a little bit on the two examples that I just articulated, and look at model states have done it, like Massachusetts. Maybe you can articulate a little bit for me on that.
Yes. And I think, you're right. And when we talk about what we have done in the past with the state, I'm reminded of it when we talk about the assessment that's in the bill, because this industry has come to the table numerous times during my tenure with the association, both to work on bills that were important to the legislature, whether it was around mental health parity or other issues. We supported, or at least stood down, maybe is a better way to say it, on previous assessments that were levied to stand up the Office of Health Strategy, to participate in some of the cost shift of assessments that were done at a different time, to work under, we support, not only do we support the Department of Insurance through assessments, we support the Office of Health Strategy. We support the Office of Healthcare Advocate. We support positions in DMIS and DDS and OPM and others. So we are partnering with the state in many different ways. We worked very, very hard. A few years ago, the idea was to create an all-payer claims database, an APCD, and to put data into one central repository so that analyses could be done on the cost of care and where we could fix it. Sorry, my phone is ringing while I'm on the line. So we participated in the APCD. We sat around various subcommittees figuring out how data sets could be, a lot of things above my pay grade and my level, the user sets and all kinds of things, and how we could support that. So we've been at the table there. We've, I think we heard the will of the legislature and the will of the administration about putting more affordable products out on the market. I think you've seen that this past year. We'll see what the uptake of those products are. And people are investing in these new structures and new models. And so I think, there has been a lot over the years where this industry has partnered with the state and its various subsectors, if you will.
Absolutely. Just before this hearing, I took a look at what are top 20 employers in the state of Connecticut, and it is filled with insurance companies and hospitals. And I'm looking at the potential consequences of a bill of this scale. It would significantly alter the landscape, impacting those entities. So I think it's important to note that in these difficult economic times, perhaps the timing of this may not be correct either. The last thing I wanted to ask of you, and I found that very interesting, is the fact that in hearing so many people's feedback, the Affordable Care Act, for all its misgivings, one of the most important positives is the fact that pre-existing conditions are now required coverage. So for every one of your insurers, individuals with pre-existing conditions cannot be denied. Is that correct?
That is correct.
And it may reflect in the cost and the premium increases to manage the risk. Would that also be a safe assumption as well?
Absolutely.
Now, from what I've read in Senate Bill A42, the selectivity of the administrator of this program, in this case, the controller, has the ability to deny or accept individuals into the pool and the partnership in a source of an adverse selection. And I think, in the words of Controller Lembo, seems a long time ago, he said it would be fiscally irresponsible to not have that in Section 2 of this bill. Now, you can't do that as an industry because you're regulated by the insurance industry. and by the Affordable Care Act that anyone with pre-existing condition needs to be covered. But following the language of the law in Senate Bill 842 as written right now, the ability to deny or approve is up to the jurisdiction or the control of the controller. So possibly individuals with pre-existing conditions that may be too high of a risk in any pool could be rejected. Would that be correct as you read it?
That is correct as we read it, and it's one of our primary objections to the bill.
Well, I thank you, and I know I've taken a lot of time. I really appreciate your insight. And listen, I think we all can do better from a standpoint of articulating and providing critical services. And I appreciate the work that you all have done. And I hope that we talk about facts and fiscal responsibility and how we manage in addressing solutions. And there is no party, there's no Democrat or Republican to this. We just need to find solutions. So I appreciate your work and I appreciate all of your organizational members. But I also understand that something needs to be done. And I hope every shareholder is at the table having this discussion and contributing. So I want to thank you for your time. And I want to thank Madam Chair for her time as well. Thank you.
Thank you, Senator.
Thank you, Senator. Representative Nuccio.
Good afternoon, or I should say good early evening. How are you?
I'm good. How are you?
Good. This is my very first public hearing, so this is quite the zinger to be on, I guess. So thank you for coming, and I have a few questions that I wanted to ask you. The first one, I'm going to kind of circle back to something Senator Lesser started with in relation to the high fee or the HIT tax, the HIT, however you want to refer to it here. So there have been multiple states that had pre-existing or new legislation, including Maryland, New Jersey, Delaware, and Colorado, who had built in language into their legislation that said if the high fee went away, they would then in turn charge a premium tax assessment to fund other reinsurance. Actually, all of them are funding other reinsurance initiatives. You had talked about Connecticut, and I know for fact that standard contract language clearly states that taxes and assessments are part of the total cost of the healthcare program. So the states that were mentioned, Maryland, New Jersey, Delaware, and Colorado, all range from 2.1 to 2.75% of premium. And they were in replacements of the high fee to fund reinsurance. So I was wondering if you could give a little more layman's term, like background on what exactly the state of Connecticut did in relation to the notification that the high fee was going away, and how that affected the rates overall that have been filed for the state, knowing that contract language specifically says that taxes and assessments are part of the overall cost, and they're not something that we can arbitrarily decide to keep or not keep.
Correct. So I think it's like you said, it's part of the insurer-employer contract. So it's and I want to make sure that folks understand it was employers that were paying those taxes. Connecticut is unique in the sense that we have a number of the largest insurance carriers in the country domesticated here. Actually, 5 out of our 5 out of our 6 major carriers here are domesticated in Connecticut. Actually, back a few years, the legislature and the administration under Governor reduced the premium tax from 1.75% to 1.5%. That money isn't money that goes into the coffers of the health insurance company. It allows us to sell our products cheaper.
Okay, I'm going to pause you 1 second.
Yeah.
When you're
Yes.
talking of premium taxes are only applicable to fully insured insurance plans, correct? Not ASO plans.
Correct. So they
So
would, Premium
It's a
tax.
tax, right? It's a tax that's on an insured product, which is only about 30% of the entire populace of the state of Connecticut from an insured perspective, correct?
Correct. And that's a point we make repeatedly when we're testifying or offering comment to folks, because everything that the legislature does or the state does is only applicable to that 30%. So every mandate that you will see on upcoming agendas, things about capping copays, the capping the insulin copay is a perfect example. It certainly was beneficial to some, and I don't want to dismiss that, but it didn't do anything to address the actual cost of insulin. And it was only applicable to 30% of the market, because that's the fully insured market. So you're absolutely correct. So going back to the premium tax issue, when our carriers sell in other states, they are subject to the higher tax of what is the state that they're doing business in, or our state. So if they go into one of those higher states that you mentioned, they automatically pay that higher state's tax rate. But if they go into a lower state, I don't know if this is accurate, but let's say they go into Delaware, and Delaware only has a 1% premium tax, then Delaware gets to charge an extra 5% of our companies. So the impact can be enormous for anything that may be counted in that calculation going forward for business that we might be doing in other states. So a $1 million hit in Connecticut could end up being a $50 million hit across the country, because we have those domesticated entities here. It's a proud distinction for Connecticut, and it comes with that particular consequence.
It also comes with a good revenue base for the state of Connecticut,
Yes.
too, because we are domiciled here. Yeah,
Absolutely.
The next thing, you kind of just got to that, and it's way too complicated of an issue to really get into, but that what you were just mentioning there was pretty much the retaliatory tax that you were talking about.
Correct.
Okay, and then you had mentioned something that I thought was really interesting also, in regards to the $30 million, and the fact that if an Aetna or a Blue or a United or anybody had run with that, they would then fall under basically the Guaranteed Risk Association, and they could be deemed insolvent. And at that point, that company is broken up, and those charges, those dollar amounts, are then spread over all the other insurance companies. So when Penn Treaty went insolvent, we saw hundreds of millions of dollars being spread over insurance companies because of that insolvency. Whereas in this case, the taxpayer is the backstop instead of the company or the shareholder in that case.
That is correct. Across the country, known as guarantee funds, and they've been around for a very, very long time, and they do exactly what, as you just described, they're the ultimate consumer protection.
Right. And then the last thing I wanted to ask you is you had mentioned something. I wholeheartedly, as you know, as many other people that have talked to me know, I'm very concerned with the cost of healthcare, and I've never been a big fan of the HDHP, and I've never been, a big fan of how a lot of these plans work and incentivizing and such. But one key thing I think we need to talk about, and you mentioned the diabetes, the legislation that passed definitely affected the cost share of a diabetes injection or the insulin, but it did not affect the cost of the insulin. And that cost then just gets put back into the cost of insurance, which then increases the cost of insurance, which is what we're trying to not do here. So it's a cyclical thing that we keep kind of doing these same things that increase the cost while trying to reduce the cost. And you had mentioned having somebody ask you again on the provider rate thing. I think this is a very important piece that people should understand too, because if MLR is 85%, or if the state of Connecticut's plan of MLR is 97%, that means 97 cents of every single dollar is being spent on health care. And that is the driver of the cost of the insurance policy. So can you talk a little bit about how you think this plan would have an impact on provider rates? And if you have the information, also the consolidation of hospitals and providers, and how that also impacts the cost of healthcare.
Sure. No, there's been, issues in particular with government-run programs and the reduced compensation that they pay to large health systems and small health systems, right? We talk about Medicaid rates all the time, and we are picking up the cost of that. Likewise, we're picking up the cost of Medicare and their rate structure, which is lower than commercial rates. And if the comptroller goes in this direction, and let's just say he is successful, and I think folks need to look at those cost savings, because they're directly, it's twofold over there too. There are cost savings that have been built into the budget around these negotiations that he is undertaking. So you have to look and see if you're meeting those cost savings targets at the same time the partnership is running the deficit. Clearly, as I said from the beginning, we need to get all stakeholders around the table. However, the dynamic has come to play. There's a lot of folks that point fingers in different directions, but we do have just a few very large hospital health systems in Connecticut at this point, and they can make for some pretty rocky negotiations if one carrier and one hospital are in a disagreement over how they will contract with one another. And that does take a chunk. I mean, it's very hard to sell a policy in Connecticut if you don't have the two largest health systems in the state in that policy. Then you are not competitive. So yes, market concentration has certainly had an impact. It's something, again, these are the hard conversations to have, right? These are the things that we need to be working to address, because unless we address those things, unless we address the 15 to 17% pharmaceutical rate, unless we address Medicaid rates, unless we address Medicare rates, and unless we address, market consolidation, all of those things are pieces of why healthcare costs are what they are and why premiums are what they are.
Thank you. And it's worthy of noting that it is quite the ball of it's like when you were young and you would throw the elastics around each other and make the big ball of elastics. Trying to unwind that ball is a lot harder, but it's definitely worth the fight, because you bring up very good points. And again, I always go back to when I talk to people, all insurance, all healthcare insurance is socialized, just the way that it works. So if you're looking at the reimbursement for Medicaid, or you're looking at the reimbursement for Medicare, and you're looking at a doctor, well, if a doctor decides that their rate is $100 an hour and Medicare is going to pay them $40 and Medicaid is going to pay them $50, they're going to look to make up that balance of that $100 an hour throughout something. And that is where it goes to the regular insured market then. And in that insured market, that's the part that, we're trying to bring that down. But if you don't have people who are willing to negotiate those rates and come up with the fair and unified rate across the board, we're fighting against ourselves. Every time we do something to mandate something or to make it better by shifting it onto one other populace, which kind of circles me back around to the 1332 waiver we started talking about. If we're doing a 1332 waiver to help fund the exchange, which is a bigger product, and you're asking just the insured premium payers to pay this rate for this entire other product. So you're really just cost shifting from one person to the next, and then we're complaining that that number is too high. So we're the dog chasing their tail. So I guess my thing is I would welcome the conversation to get the insurance companies around a table and legislators around a table to truly start to conquer the cost of healthcare instead of looking for a new populace to shift the dollars onto. And I thank you for your time today.
Thank you.
Thank you. Representative Muskers, you're up.
Thank you very much. Thank you, Madam Chair. Sue, I want to tell you first off that Your group should be very thankful for your presentation. I'm impressed. Having sat, down on Wall Street for a number of years, one, it's cogent and it's thoughtful and it's heartfelt, and I very much appreciate your representation. A lot of valid points being made today, and bring us back to that exact concern, particularly from the last speaker, Representative Nuccio. Very helpful. We are sitting here with a compounding issue of 5, 7, 8% a year in costing, right? That's what we look at on an average basis. Now, at the margin, we're shifting costs in public options versus private options, and shifting to those who are paying for the paying for a private contract. But essentially, we're still compounding at a 5 to 7 to 8% annual cost. The insurance companies are only spreading risk and passing through the cost structure for medical care. But it's becoming unsustainable, right? I mean, today we look at the average constituent who talks to me, and they've got a $10,000 or $15,000 family deductible. They've got co-pays. They essentially have catastrophic insurance in one of the most wealthy countries in the world. So that is the problem, and I welcome what was said prior, that we need to sit down and talk about where we're going with this. And even with Senator Huang, I agree. The public versus a private option in healthcare insurance, if it doesn't address the issue of cost, is the big dilemma. I mean, this is why all of the U.S. companies stepped away from pension plans years ago, and they decided to burden shift to a 401k. So the employees are dealing 401k, and now most people are looking at the Social Security system as their core base and pension plan plus a 401k savings. Healthcare is going to get to the same point where the average company is going to say $37,000 or what, $32,000 or $34,000 a year, compounding at 5% becomes an unsustainable cost per employee, which means it's going to end up in the public hands if we can't get control of healthcare costs. So I would welcome that same conversation. I think it's important that we deal with that. What I would ask from in the conversations on this public option, I'd love, given your summary of the cost, I guess, shifting or the assessments, is there a way in a rejiggering of the assessments that we could work towards a more affordable healthcare program from the private sector? Because we're taking those assessments to provide healthcare. And if it's cost shifting both into our plans, those public plans we have, and it's raising the cost to all the individuals or the 30% who are insured in the private sector, we ought to think of those optionalities as proactive decisions, just not adding one on top of the other, which is what your concern is with this being another supplemental cost, or with us potentially running at a rate where we don't have either a guarantee fund, as you're suggesting, and or a backstop in the event we're it's a question of whether we're underwriting our true costs, if we're burden shifting the cost, which is the other suggestion you were making, and that we're burden shifting the cost to the private sector by not compensating the hospitals for their costs, a la the federal government Medicare. And then the question is whether we are adequately funded on the premium side, and we're running a risk that we have to come back to the taxpayers or to the participants with assessments because we don't have enough money. I mean, it's a mess. It's a very hard. There's so many moving parts.
There are.
I'm almost confusing myself with the linear logic as we discuss it. So it would be helpful to have that conversation. I think we need to take a step back and ask on that decision tree. And also, looking at the plan design, what you would need from the legislature in the form of legislation to be able to step up to the plate and do a similar type of plan without a public management. Is there a role for the private sector to pick up a comparable plan with comparable coverage with certain forbearance from the state or the regulators to be able to do that, either as a community of insurance companies or whether we could design something that was biddable and manageable from the private sector, because that's one of the concerns that Tony was mentioning, was the idea that this drifts into the public and becomes the ever-growing source.
Yes.
And lastly, I am concerned particularly about the idea that last piece, which I think you weren't as emphatic, but it was clear that you're worried about being cherry-picked in terms of insured pools of people.
Yes.
And I would hate to see, that spiral in the private sector where, you just have you just have a difficult pool to insure.
Yes. I mean, you zeroed in on so many of the key issues. And I did, by the way, just want to acknowledge that I heard your comments earlier about some of the figures that you would like to see, and we will pull those together. I can tell you that, and I'm not sure if this was exactly what you had asked earlier, but some quick math, if you will, about the kind of the per member per month of the additional dollars. Now I'm trying to figure out my.
It was basically, I'm trying to get a comparison between the private and public sector option on the coverage and the cost, and who's paying that cost, right?
Yeah, and my colleagues are going to get mad at me because they gave me this data, and I think my brain isn't working right now.
That's all right. If it comes out later, I'm just as happy. In summary, I want to understand, if it costs a company $37,000 to insure, if we take the framework of the public option, how much lower is it going to be? And that's a basic, cost saving, et cetera. Or is it, and I am worried that that option, I am concerned that if it's the right option, and it's a good and sustainable option, and not that it's a stopgap that doesn't really achieve what we want to do. And I'm not prejudging it. Those are my concerns. I think there's so much more data we have to consider, that I would, urge us to weigh in on the data and consider, whether, I don't know, I'm relatively new to the legislature, whether we consider a second hearing or how we engage the public, because I think there's a lot under, and there are components of this of this bill, that there are components that may have more merit than others. It's just, this is, I spent many years listening to financial pitches from the most sophisticated people in the world, and this hasn't got my head spinning, but I don't have the answers or the surety that I feel we should have before I step forward to vote. And just to let you know, that's where I stand. But thank you.
I appreciate your comments. Thank you very much. And we'll get you that data.
Thank you, Sue, for your lengthy debate or discussion here. We really appreciate your time, and I'm sure we'll be talking with you again soon.
Thank you, ma'am.
Next up, I did call Joelle Fishman next, and I did see that Nora King, who I skipped over, also joined. So Nora, you will be following Joelle, and Melanie Flaherty will be up third. So the first one up is Joelle Fishman.
Thank you, Chairwoman Wood and Lesser, and the members of the committee. My name is Joelle Fishman. I live in New Haven. I'm testifying today on behalf of the Communist Party in Connecticut in favor of SB 842 to provide public options for equitable and affordable healthcare coverage. As the horrors of COVID-19 have exposed, our healthcare system is woefully inadequate, and nobody should be left behind without healthcare. The racial disparities for infection and for death from the virus make it clear that not only are thousands of people unprotected in general, but that there is even less protection in Black, Latinx, and Native communities. So the proposal for public option is not new, but it is long overdue. And states have been left on their own, and we in Connecticut must take action in this legislative session to pass public options that are equitable and affordable. And I believe that the personal stories that we heard today, very wrenching stories, emphasize that the profits first status quo is simply not sustainable. From our neighborhood organizing, we're keenly aware of the fact that the immigrant community has been cruelly stranded and left to its own mutual aid during the pandemic. The public option must serve all Connecticut residents. If a section of the population is shut out of healthcare, there's no safety for anyone against the virus. And so we also support the Husky for Immigrants campaign led by immigrant youth and the immigrant community that's parallel with this discussion. The public options in SB 842 address the healthcare crisis and also the crisis of racial inequities in healthcare. This bill is a big step forward to save lives, enable job mobility, assist retirees, of whom I'm one, and boost our economy. It's not the whole answer. However, to fully achieve healthcare as a human right, we need a national health service in our country, and Connecticut can be a national example. So I want to appreciate very much the intensive work that has been done over many, many, many months to produce this bill and to respond to the 71% of people in our state who support public options. And we urge this committee and the full legislature to act in a speedy manner and pass SB 842. Thanks so much for allowing me to participate.
Thank you, Joelle, and thank you for being so patient with us today. Any questions from the committee? Great, thanks so much for coming. Next up is Nora King.
Hi,
Melanie Flaherty.
Hi, everyone. Thank you for letting me speak again. Sorry, I had to step out because our kids are on remote learning today. I'm in support of this bill. I mean, there's a lot of things I've learned on this call that I didn't actually know. I can just tell you my perspective as a small business owner in Connecticut and as a single mother of 2 children, some of the issues that I am facing I consider myself middle class. I have my own business. I live in Fairfield County, which is extremely expensive. There's days where I'm like, what am I doing in this state? I happen to love our state, but those are things that go through my mind every day. And when I first started my business was a while ago. It was actually before I had kids and before I got married, and I basically could afford health insurance. I actually was with Anthem back in the day, and it was like not a lot of money. And, you had the issues with the pre-existing condition and everything like that. And then I got married and went under my husband's policy, which was great as a small business owner. We got divorced. He has the children on his plan, and I'm back on my own. And I have to admit, the last 5 or 6 years having insurance has been a nightmare. I spend $1,100 a month. It's a now it's $7,200 deductible because it got raised. It went from 10% to 20%. And on top of it, every time like you have an issue or anything, oh, we don't cover that. And I'll give you 1 or 2 examples that I've come across, but I had the unfortunate, I don't get sick a lot. I try to take care of myself. I go to the doctor. I do all the things that you're supposed to do. But as many of us, I'm getting older and definitely concerned. I was skiing with my children the Christmas before last, prior to COVID. I fell. I cracked a rib, and I'm kind of like in survival mode, right? I've got 2 kids. I'm divorced. I'm raising them. I'm doing everything for them. And so all of a sudden I go call up to go to my doctor, and they're like, yeah, we don't take Anthem Blue Cross and Blue Shield anymore. They don't pay our people. They want to pay us like $14 an hour. So then all of a sudden I realized it was a problem. I had no ortho care to go and see what was going on with my rib. And I kept calling and calling, and basically I had to drive all the way up to Monroe in order to get care, which is without traffic, a good 40 minutes. With traffic, it could be like an hour and a half. And Anthem Blue Cross Blue Shield didn't seem concerned. I was upset. I reached out to Lucy Datham, and she's not even my rep where I live, believe it or not. And she was the one out of everyone I responded to who stepped up to the plate and helped me and put me in touch with people. And Terry Wood helped as well this year when I realized they weren't, they hadn't fixed the problem. So she put me in touch with advocates at Anthem, and Anthem could care less. And basically all the advocates, like, we can't do anything. There's nothing we can do. We can bring something up to them. We can't do anything. So a year later, I go to renew my policy because I'm on the health exchange. And, you know, like I said, they raise my rates, they go up, they do this. Still haven't fixed the orthocare problem. So there's still no emergency orthocare here in Fairfield County for Blue Cross Blue Shield. And Blue Cross Blue Shield doesn't care. They just don't care. And then let's tie this a little further. And this is kind of graphic, but you know, I'm getting to the age where I need a colonoscopy. And basically I was on the phone talking to them and they're like, oh yeah, that's covered for preventative. However, if you're in the middle of the procedure and they find a polyp or anything, it's not covered anymore. Then it's covered out of your pocket. I was like, what? And I'm like, what are you talking about? And they were like, yeah, then it's you and you have to pay for it. It's only preventative. And I'm like, so what am I supposed to do in the middle of the procedure? Tell my doctor to stop and not remove anything? I'm like, it made no sense to me. But this is how they're treating people. This is what is going on with these big insurance companies. And then my insurance person said, well, let me try to put you on a private plan. But you know what? If you're riding your bike or you're skiing, now I'm not an Olympic skier and I'm not like, but I ride my bike with my kids. I take my kids skiing. They won't cover anything at all on some of these private options. So as a small business owner, this is my option. This is my only option that I have right now. And
Nora, you've hit your 3-minute mark. If you want to just wrap up with a couple sentences, we'll move on to questions.
Yeah, sure. So, I mean, really, this is what has happened to me in healthcare. And as a small business owner, I honestly, I don't know what to do anymore. I mean, I feel like this is what we're dealt with. These are
Nora,
this is
thank
my
you
option.
for coming and sharing your story. And I'm glad that you were able to reach out to some of our legislative rock stars that tried to help you. And this is really stressful just to hear you dealing with this. So I really appreciate you spending the time and waiting pretty much all day to share this with us. It really does mean a lot. So thank you. First question is from Representative Datham.
Thank you very much, Madam Chair, and thank you, Nora, for coming and speaking to the committee today. It's really important that the committee hears your story. Just wanted to talk about, you mentioned that you did look on the exchange as part of your trying to find better coverage. Is that correct? Access Health CT?
Yes.
Okay, so you tried to get the best deal that you could find, is what I'm saying. Do you have any other businesses that you work with that have had better luck? Small businesses like yourselves, maybe. I know you're in the actuarial field. Any other actuarials that are also struggling with this? And as an industry, does this hurt your work going forward?
Yeah, I mean, when I started having these problems, I started shopping around. And like I said, I called the private, I called like my industry, like the Appraisal Institute, different people that there was nothing. There was really nothing. And I really was going to pull the trigger on, I have a really good friend who's a dentist. And she has private insurance, and it was less expensive, this private insurance. But then when I actually read the contract and she doesn't ski, she doesn't ride her bike, she doesn't, none of that stuff was covered. So, if I fell and broke my leg, none of it would be covered. So there's no option for me right now. I have horrible coverage and I have no options. Yeah, I'm going to wait till Medicare, I guess.
Okay, well, I understand. I guess more of my point is, as a small business person, I just wonder how many people are really, hurt by this. And it sounds like, this is a big issue by you and other businesses that might want to start up here in Connecticut.
No, I agree with that. I think it hinders people from having their own business.
And you do shop around. It's not like, you just pay up the fee every year. That was my other question.
Yeah, I mean, I don't have an option. And I mean, I'm not going to not have health insurance, though I have thought about it. Trust me, I have thought about it. I'm thinking, you think, well, maybe I'll just take the chance and use that money and save it.
Yeah, well, I know many people that, get their monthly insurance bills more than their mortgage payment. And that's a frightening prospect, especially when you have a small, healthy family. It's disconcerting. So my next meeting is hanging.
Lucy, a point like I don't think people understand is that when you sit there and add up all the insurance you spend money on, home insurance, E&O insurance, health insurance, dental insurance, car insurance, honestly, you're working for like a quarter of the year just to pay for all these things. I mean, if you start adding them up, and I keep everything in QuickBooks, you can see exactly how much of my salary actually goes just to be insured.
Yeah, I hear you. I think we're in the same boat. And I apologies that Ted Doolittle's office couldn't help you, the healthcare advocate. He's been a great resource for so many of my constituents, and apologies that wasn't more useful. But thank you again for your presentation and taking the time out of your schedule today to be here.
Thank you.
Any other questions from the committee? Thank you, Nora, for joining.
Thank you.
Next up is JP Whiskey. Am I saying that correctly?
Whiskey, close enough.
Whiskey.
Thank you.
Followed by Lucy Nolan. JP, you're up.
Great, thank you. Thank you for the opportunity to testify and to be back. Wish I was there. It's much warmer there than where I am at, believe it or not. I am the former deputy commissioner in Wisconsin. As part of those duties, I was the architect of the 1332 plan, the healthcare stability plan in the state of Wisconsin. Happy to answer questions on that. Also a recent co-author of a study for the North Dakota Insurance Commissioner's Office related to hospital and health insurance costs. For those of you that have trouble sleeping at night, we have a 156-page report, or we can give you an executive summary if you're interested. That's about 32 pages. I think my written testimony highlights a lot of my concerns, a few big issues just to highlight. I have some concerns with the proposed public option related to some of the ACA rules. The way the ACA is structured legally, it appears to me that the structure that the comptroller is proposing to use is not consistent with the ACA. The ACA, for example, requires single risk pool requirements in individual, small group, and large group markets. Those are bundled together. That creates a problem. That also creates adverse selection issues for the industry because they're not allowed to do that any longer. A number of those have gone the way of the dodo. We're also concerned about some of the adverse selection issues, allowing the commissioners or the comptroller to remove, to not allow some plans in. We have some concerns related to the fact that the plan has never been audited, it's not audited separately, it's not looked at separately. If you look at the state of Wisconsin website related to the state employee plan, the transparency there is significantly higher. I would also note, and there's a number of other pieces, the lock-in fees are sort of shocking. That's something the industry cannot do. The rate guarantees are something that the insurance industry cannot do by and large, which is, I think, a concern. I would also note on the 1332 related to the retaliatory taxes, we do think that some of those will be a problem. I can talk about that in detail if there's interest. I can also clean up discussion if there's interest in the risk corridor question, along with the health insurance tax. Lastly, related to the subsidy issues, I think it's important to note, not that we have any position in favor or against, but it's important to note, as Susan highlighted, that there are federal tax issues that apply to those subsidies, that since they're state subsidies rather than federal subsidies, that that's taxable income for the consumer, and that creates eligibility problems potentially, along with tax liability, which is a problem. And lastly, I would just note that there are ERISA compliance issues, that it puts the state employees plan at risk of ERISA compliance issues broadly. And then the pooling issue, I think, has a potentially significant negative impact. I highlight in the testimony Kentucky Care, which essentially went bankrupt in the 90s. A little different animal, certainly, but they went bankrupt in the 90s when they did a similar pooling experiment. So I'll stop there and happy to answer any questions. Apologize for talking so fast as well.
Oh, great. You actually did it under your time here, so congrats. I was wondering if you could talk a little bit more about the transparency issue. I did notice that we got a lot of bills asking for an audit to be done, yet the Comptroller Lembo was on stating that the plan, was kind of an open book, and that was also asked by Senator Anwar. So could you just elaborate on that a little bit more?
Sure. As Deputy Commissioner in Wisconsin, we were subject to audits on, we ran a number of funds. As part of that, we ran a local government property insurance fund, which was the largest insurance fund in the world at that time, monoline insurance in the world, billions in assets that we insured. We ran a injured patients compensation fund, essentially a medical malpractice fund, and a state life insurance fund. Each one of those separately are subject to a legislative audit every 3 years functionally. On top of that, each one of those plans are subject to the insurance department itself. We have specific auditors inside the insurance department who audit those funds, as well as audits that apply to the state employee plan by both the Legislative Audit Bureau, and then all the insurers inside our state employee plan were subject to specific and separate audits, and they had to meet sort of statutory accounting requirements. So the idea that this is a transparent, when you're able to take money from one pocket to the other and switch it around and not have any idea where everything's going, is a totally foreign concept, at least in my experience in state government. So that's sort of the concept where I came from, is there were significant legislative audits every 3 years on every state agency and separately in every state fund.
Thank you. And can you elaborate on the retaliatory taxes? Because I think, we hear that they're not going to be as substantial as the insurance industry is saying. What is your opinion on that?
If you have seen one state's retaliatory tax law, you've seen one state's retaliatory tax law, right? So every state deals with it differently. So in Wisconsin, I can guarantee you the way it's applied is, having chatted with Wisconsin's department expert on retaliatory taxes, is they look at whichever tax is highest and they're going to tax the higher tax of either the state tax or whatever their home state domicile is taxing, regardless of whether or not any of the domestics, Wisconsin domestics would actually have to pay that. On the other hand, if you look at there's about 200-page NEIC guide on this. So if you want the details, you can certainly go through it line by line. But in other states, you will certainly not see them applied if there's no domestics. So I think functionally it means that there are going to be retaliatory taxes applied in some states, but not necessarily every state. And sometimes those retaliatory taxes will mean that those companies will be uncompetitive in those states for selling health insurance or other insurance lines.
And when we say taxes, that also includes assessments.
Yes, that's correct. And again, that varies state to state, and that varies assessment to assessment, and it varies. There can be variances based on credits and other things that happen. For example, we had in Wisconsin significant credits that attached to our premium taxes, and that meant for most of our domestics they paid zero in premium taxes. But that also meant that some states didn't reflect those credits, and so they had higher premium taxes in states. That also applies to agent fees, agent licensing fees. Pretty much every fee is subject potentially to retaliatory taxes. Yes.
Thank you. Senator Lesser, you're up.
Thank you, Madam Chair, and it's good to see you again, Mr. Whiskey. I think you were here most recently last year, is that right?
Yes, sir. Thank you. Yes.
Okay. I won't belabor. We talked to some length about your record working for former Governor Scott Walker. I'm not going to go over that again this time, but I remember the discussion quite well. Just sort of building on Representative Wood's question, though, you're talking about retaliatory taxation. I have actually taken the time to spend some time going through the NAIC retaliatory tax guide that you referenced. Can you speak to whether or not, in your to your understanding of if an insurance user fee has been subject to retaliatory taxation? Connecticut currently has some, and as far as I know, they're not being subject to taxation in any state.
So an insurance user fee, I'm sorry,
Well, if you look at the language in in the bill that's before the Connecticut General Assembly.
Okay, the insurance user fee, my understanding, I'm sorry, my understanding in talking to the Wisconsin folks and how it actually gets administered is that they believe that, I talked to them about this, and they felt that it would in fact be subject to their retaliatory taxes. Again, I can't tell you that that's going to be the case in every state. I can't tell you that it's going to be the case when push comes to shove. If Wisconsin takes a look at it, they may take another look at it. But functionally, it is subject, and it varies state to state. And so I think there's some doubt as to how it would apply.
So Connecticut has those assessed. I apologize. I just want to be brief, sort of in the interest of getting to some everyone on who wishes to testify. But Connecticut currently has user fees in effect. Is Wisconsin currently assessing retaliatory taxation on Connecticut domiciled insurers?
I'll have to double check that, but I believe my understanding is that they are. But I will double check and find that out.
And they are looking at our existing user fees like we have on the surcharge that everyone in Connecticut's familiar with on the for crumbling foundations. That's currently being charged.
So I'll have to check into the specifics, but it is a very specific insurance company by insurance company analysis. It is done almost exclusively by hand on each insurance company when they look at it. So when I talked, it was on generalities. We talked about various kinds of fees. The indication to me was that in the state of Wisconsin, if it moves and there is a fee attached to it, they were going to apply it to the state. And again, I would be willing to bet that you could probably get a list, maybe even a large list of states where, in fact, that fee would not be subject to retaliatory tax.
Well, the question that I have and the frustration that I have, and you probably can sense the frustration in my voice, and it's not directed at you individually, but it's that in conversations with industry, I hear a lot of generalities. And then when we talk, when we look for specifics, sometimes they're there and sometimes they're not there. And so as someone who's working in the industry, I would, and as a policymaker, I think would be helpful for the committee, if there is an issue. Obviously, we take very seriously our status as a domicile for many large industry players, but we need to hear concrete specifics, not generalities. And if there is a concern, I hope it's specific, not to assessments in general, but to the specific wording of the legislation being considered by this committee.
Yeah, I understand where you're coming from. I will tell you, in my experience, we had a huge issue related to one of our domestics. Humana happened to be a domestic of Wisconsin, and had a huge issue from a retaliatory tax standpoint that we had no understanding how any other state could apply it as a retaliatory tax, right? And so it was a frustrating thing for us to even consider fixing. And it was, they had considered moving their domicile away from Wisconsin as a result. So understand your frustration. And they had experienced exactly the same issue.
But I don't think you may understand my frustration, but I don't hear you answering my question, which is that I think it's really, the language that's here was carefully crafted in collaboration with our partners in industry to try to address the retaliatory taxation issue. So I understand you're in Wisconsin and you're speaking in generalities, but if you're raising the specter that there may be additional retaliatory taxation issues that we're not aware of, I think that you owe it to this committee to be precise and to speak to the specific language in the bill. And if you're able to do that, that would be enormously helpful. But if not, I think that may be the case where you may be raising a specter that may not be present danger for us at this
I appreciate
With
what
that, Madam Chair, I want to thank you for the meeting.
Yeah, thank you.
Representative Nuccio.
Good evening, sir. How are
Good
you?
evening. Thank you.
Quick question for you. Can you give a little more detail around, you said one of my favorite words in your testimony, and that's transparency. So I was wondering if you can give a little more detail around some of the stuff that you've seen in other states, because I agree with you. I think we need to be extremely transparent when we are spending taxpayer dollars and how they're being utilized, especially in a time when everybody's being very conscious of how they're spending their money and what's coming at them. So can you give a little more background around the transparency that you've seen from other states in regards to insurance policies, the spend, and where any backstops may come from?
Mm-hmm. And are you talking, and apologize for clarifying, you're talking about private insurers versus public, or both?
Public, mainly public.
Mainly public, okay. So, my main experience obviously comes from Wisconsin. I sat on the group insurance board, which governs the state employee plan. Those meetings were public in nature. Every single one was a public meeting. There were public reports from the actuary that dealt with the two different pools that we administered, similar to Connecticut, the local government pool, as well as the state employee pool. We had an idea specifically what the loss ratio was on any plan, how it was running throughout the year, and the public knew that. They knew the specific numbers. They knew the numbers based on not only based on the specific in general terms, but the specific plan design, on the language. All that information was public. The bidding process for everything was a public bidding process. Some of the numbers, if there were competitive issues, could be redacted, but pieces of that had to be sort of public in their nature. And then on top of it, they were, and as I talked about, subject to public audits as a piece of it. And I will tell you, quite frankly, we had a very embarrassing mistake by one of our accountants in the Injured Patient Compensation Fund that we would have loved to have been able to hide. It wasn't a material issue. It was fixed almost immediately. It was a misreporting of a piece on a data, but we should have been, and we were publicly pilloried for that accountant's poor and shoddy work. And as a result, we had to have an additional layer of work until that individual actually left state employment. And we had additional levels of review. And it was a one-time mistake. But again, it subjected us to additional audits over the course of the year. So the state knew exactly what our loss ratio was inside that fund, how everything ran, the specific contracts, what they cost. The legislature had all those reports on a regular basis.
Thank you. And can you tell me, was that legislatively driven, that transparency and that impact?
Yeah, so it was primarily legislatively driven, although there were separate, inside the state audits that were required. But it was we had a separate bureau, the Legislative Audit Bureau, that reported every 3 years, again, on every state agency, every single program separate and outside of those state agencies. So each state agency was subject to a separate audit about what they were doing, how they were doing it, how the money was being spent. Yes.
Thank you very much. I'd like to go on record to say that I would absolutely welcome that kind of legislation. Thank you very much.
Thank you.
Thank you, JP. Stay warm.
Thank you.
Lucy Nolan is up next, followed by Carleen Wonder.
Hello, good evening. Hello, can you hear me?
Yes, we can hear you, Carleen. We're gonna have you go next, so go ahead.
Okay, thank you. Good evening, Senator Lesser, Representative Wood, and members of the Insurance and Real Estate Committee. My name is Carleen Wonder, and I'm a personal care attendant, a PCA. I currently live in New Haven, Connecticut, and I care for consumers in Ansonia and New Haven. I'm here today to testify in support of SB 842. I have been working as a PCA for 13 years and find fulfillment in my work. It makes me happy to see my consumers living comfortable lives and to know I have helped them to overcome their disabilities to pursue the luxuries others are able to enjoy. To give someone that opportunity to pursue their independence is truly an uplifting feeling for me. At the same time, I'm deeply saddened by the fact that because of the outrageous costs of health insurance, I'm often not afforded this same opportunity. As a PCA, I'm not offered health insurance through my employer. I was fortunate this past year because I was able to qualify for Husky. However, I took on 15 more hours a week in October and will now make too much to continue to access Husky plans. This has left me feeling stressed, fearful of even the smallest medical inconvenience. To make matters worse, I'm a diabetic and rely on insulin to survive. Even while I'm on Husky, my insulin is $400 a month, which is financially crippling for me. Occasionally, my pharmacist would give me a slight discount on my insulin to help me afford this life-saving medicine. On top of this, I have been forced to ration my insulin, taking less than the recommended dosage given by my doctor. While I know that it is dangerous, I have no choice. I simply cannot afford it. I have even looked into private insurance plans, as I know my Husky insurance will soon be gone. So through the health exchange, however, even the cheapest bronze plan, I was told by Access Health, was $795.16 monthly premium, which again, I cannot afford. If Connecticut had a public option, it would greatly reduce stress in my life. It is a burden when you're unable to afford the healthcare you need. People should not have to rely on the whims of others or the charity of their pharmacists to ensure they can afford the medicine they need to survive. The people of Connecticut deserve better. Please, I beseech you, I implore you to do the right thing and pass this bill. Please support SB 842. Thank you so much for your time.
Arlene, any questions from the committee? Senator Lesser.
Thank you. I want to thank you, Carlene, for your testimony. It's heartbreaking.
You're welcome.
A lot of the bill is specifically focused on people in very much in situations very much like yours, expanding access to Husky and also making sure that the premiums on the exchange and the deductibles are affordable, and also that the exchange covers basic issues, things like insulin. Nobody should have to ration their insulin. It is outrageous that in the richest state, the richest country on earth, you're in that position. We passed a big law last year that's specifically supposed to help folks like you. Nobody should go without insulin. And so what I would hope that you could do is reach out to me after this hearing. I'd love to work with you to try to make sure that you get the medication that you need to stay alive, because that is not safe, and we want to make sure that you're in a safe place. But thank you for what you do, and please, I hope you can reach out to me, and love to help you after this hearing.
Thank you so much, Senator Lesser.
Carlene, thank you for coming today and sharing your story. Next up is Grace DeMayo, followed by Roberta Alves.
Good evening. My name is Grace DeMayo, Senator Lesser, Representative Wood, members of the committee. Thank you for hanging in there all day, and thank you for the opportunity to testify before you in support of Senate Bill 842. I'm speaking today in my role as Director of Advocacy at the Hispanic Health Council, and we believe that the Senate bill will make healthcare more equitable, dependable, and affordable by creating new public options for health insurance in the state. Senate Bill 842 would be especially helpful to organizations like the Hispanic Health Council. We're a statewide community-based organization, and our mission is to improve the health and social well-being of Latinos and other diverse communities. We do this largely through the work of community health workers, and community health workers are uniquely positioned to complement and enhance the capacity of the healthcare system through their being positioned in the community. They address social determinants of health and therefore really address inequities in health experienced by low-income people and people of color in the state. One of those social determinants is access to affordable quality health care. Interestingly, much of the work done by our organization is done under contract from state agencies. Ironically, our agency has had increasing difficulty over recent decades due to escalating costs in providing those same community health workers with affordable healthcare coverage for them and their families. So it's actually a struggle within the organization to achieve our mission for our own staff who are from the communities they work in, saving lives in the communities they work in across the state, thousands of lives annually, and multiply that by CBOs across the state. And we have a real problem of equity equity within CBOs in the state around the opportunities we have in addressing health equity for our own employees. Of course, the next layer of that, and you've heard lots of stories today, for the sake of time, I'll just reference that then we look at the folks that we actually serve. Folks who are low income, vulnerable, inequitably challenged by the pandemic, but prior to that, by all those same social determinants that have made them sicker. And one of those inequities is inequitable access to health insurance. So when we think about the populations across the state that need a solution, we need a solution that is quality, comprehensive, and affordable. And Senate Bill 842 addresses those three elements and does it for the populations that are most at risk and most in situations like the prior speaker so painfully shared. We've heard many stories like that throughout the work of our agency. So given that, for the sake of time, I'll just summarize and say healthcare is a fundamental human right, one which should be assured through universal access to quality, affordable health insurance coverage. Given that, I strongly encourage you to please vote in favor of this bill. It'll do a great deal towards assuring equity to health and healthcare for so many in our state and address a real problem that community-based organizations are experiencing. Thank you so much.
Grace, thank you for coming here today and waiting patiently. Do we have any questions from the committee? Great, thank you again for your testimony. Next up, we have Roberto Alves, followed by John Murphy.
Oh, thank you.
Hi, Roberto.
Well, Senator Lesser, Representative Wood, Senator Wong, Representative Pavlik D'Amato, and members of the Insurance and Real Estate Committee of the Connecticut General Assembly. My name is Roberto Alves. I'm a city councilman in Danbury, Connecticut, and I support SB 842. And I urge all the honorable members I have the privilege of addressing today to support it as well. SB 842 will make healthcare more equitable, dependable, and affordable by creating new public options for health insurance in our state. We're a year into this pandemic, and the ongoing health crisis is one that requires immediate and meaningful action to expand access to affordable and dependable healthcare. Make no mistake that access to healthcare is also an issue of race, and the inequalities in our healthcare system are impossible to ignore. Keep in mind that pre-pandemic, 6.8% of Black residents and 13.1% of our Latino populations were also uninsured pre-pandemic. This legislation will help address the disparities in our system and the racial inequities within it. Additionally, healthcare costs are an overwhelming burden on our small businesses, of which there are over 350,000 in the state, all of whom face their own challenges outside of and related to the pandemic. If we want them to get back on their feet, we need to create additional options for employers so they can provide more affordable healthcare for their employees. This bill will help level the playing field for small businesses and at the same time strengthen our economy, in addition to keeping workers healthier and more productive as a result. Now, I want to share something a little bit more personal that wasn't part of the written testimony. And as I heard, and I've had this on throughout the day as I'm working and also being a teacher to my young children who have been in distance learning. I am a proud American. I'm a proud city councilman. I'm an even prouder husband and father. I am a recent US citizen. Got my citizenship in 2017. Before that, I was a permanent resident green card holder. But as a child, I wasn't documented. My family came into the US, I was 5 years old. Like so many who came, they came for a short period of time, they overstayed their visa. As children, you have no say in that. You just go to school, you see your parents work hard, you see your community work hard. You see them be scared of, where the money is coming from as they're going to the local grocery store, spending money in the community. Our undocumented community put in millions, billions of dollars into our economy every year. We need to help them too. When I was 16 and still undocumented, I had an injury. I was playing backyard football with friends and I ruptured my spleen. That was a serious injury. I was in the ICU for multiple days and then stepped down from ICU and then on bed rest at home for well over a month. I missed a significant amount of time of school. My parents shielded me from the financial side of it because I was a community-oriented person at that age. I served in the Danbury Police Explorers. I constantly volunteered. I was a translator for our neighborhood. So they didn't want me to worry about that. God knows what they did and how they figured out the community to help, pay for something as serious as a splenectomy, the surgery involved. I am happy to see that this bill, allows undocumented individuals to buy in and be a part of or qualify for health insurance. It's time our state steps up and does that. I urge you all on the committee to support this bill. We need to support ourselves. We need to support everybody in our community. And our undocumented folks, they give so much. And sometimes we get in the national climate, and we don't get a lot of that in Connecticut, but there's some of it. People get, thrown to the side, or they're sometimes not respected. But what these folks are people who are here to work. They're our neighbors, they're our friends, they're your children's friends in school. And their kids grow up to be small business owners like my sister is, to be city councilmen like I am, to give back to their community.
You've hit your 3-minute mark. If you wouldn't mind just wrapping up.
I appreciate that. Sorry. That really is that. So thank you very much, everybody, for their time and the marathon you have been on today. I appreciate that.
And I want to apologize to all the speakers because I do have an alarm that I guess no one is hearing. So I hate to interrupt people, but I'm going to have to do that because we are letting people speak over the time limit. Roberta, I appreciate you coming and sharing your story. You are a councilman in New Britain, did you say?
Danbury, Connecticut.
Danbury. I was wondering, does your municipality buy into the partnership plan?
I'm not familiar with that, no.
Okay. Thank you. Any questions from the committee? Senator Anwar.
Thank you so much, Madam Chair. I just wanted to thank you, Councilman, for your testimony and sharing your story, because I think when people, the undocumented have been dehumanized in an organized manner by a certain group of people. And when you share your story, you humanize the people, you humanize their challenges, but also humanize the contribution and then the amount of tax. And arguably, some of the undocumented may be paying more taxes than some of the people in pretty high offices in the recent past. So I just wanted to thank you for your testimony.
Thank you very much, Senator. It's my pleasure.
Roberta, thanks for coming on today. Next up is John Murphy, followed by Joshua Mitchtom.
Good afternoon, Representative Wood, Senator Lesser,
John, can everyone hear John? Because I heard him and then it went. Okay, John, I could hear you when you first came on. It doesn't look like you're muted, but I'm having trouble hearing you. Maybe, do you have an ear bud in or anything like that? Yeah, you're really very, very soft, and I don't think anyone can hear what you're saying.
Madam Chair, maybe we could let someone else go and go back to John when he has his audio fixed.
All right, John, we will come back to you after Joshua Mitchtom.
Hello.
Thank you, Representative Wood, Senator Lesser, members of the committee. I am a Hartford City Councilman. I'm speaking in that role and also on behalf of Councilwoman Wildelise Bermudez, who's testifying to another committee at the same time. So we're trying to divide our duties. I did submit some written testimony, so I won't go over that. But I really want to emphasize a little bit kind of what Councilman Alves was saying from Danbury. You know, I've heard a lot of talk, which is frankly over my head, about the economics and the regulation of this. But at base, we are talking about people's lives. And in Hartford, certainly, you know, the median household income in Hartford is about $30,000. It's less than half of the state median household income. And the average for family coverage is $20,000. You're talking about a lot of folks who are working and trying to get by. And this is not even getting to folks like undocumented folks who can't buy in regardless. And there's just no way to get access. And that lack of access to healthcare radiates outward to a whole host of other problems, right? When parents have to get their care, let's say from a free clinic or the emergency room, they have fewer options, they have more travel time. That's kids who are not making it to school on time, kids who are maybe more likely to get sick because their parents aren't treating their illnesses. Kids miss school, they fall behind in school. Classrooms have more disruption. I mean, this is something that affects both the economy of the community and the prospects of children and of whole families in our communities. And I think I just can't emphasize enough that if the question is that this is going to disrupt the insurance market or that it's going to cost us money, my feeling, fine, it's worth it. There should be almost no price too high to provide some stability to our most precarious families. And as a councilman, probably the most common constituent ask for assistance I get is helping people find specialists. I think it was Luis Luna from Working Families Party who talked about someone who couldn't find a surgeon. All the time I have clients who, I'm sorry, not clients, constituents, I'm a lawyer in the daytime. I have constituents who don't know what to do because they're kept from working and they're kept from providing for their families, and they just don't know what to do. And I see it also in my work with the undocumented community that I do outside of city council work. It is a constant stressor to families. It keeps people from working, from living a full life, and their dependents feel it. And it causes uncertainty for folks who have a tremendous amount of economic and legal uncertainty already. So I would just urge members of the committee to support Senate Bill 842, and really to keep in mind that if there is anything worth spending a lot of money on and worth disrupting the insurance market on and worth inconveniencing the competitive advantage of large insurance companies, if there's anything, it's this, because we're really talking about the well-being of our most precarious communities. So I'll leave it at that in case folks have questions.
Thank you, Councilman. Do we have any questions from the committee? Thank you for being patient and staying on with us for so long. We appreciate your testimony.
Thanks to all of you for your work.
Okay, John Murphy, do you want to give this a try again?
Can you hear me now?
Yes, we can.
Oh, great. Sorry about this. Good afternoon, Representative Wood, Senator Lesser, members of the committee. My name is John Murphy, and I'm here today to testify on behalf of United Auto Workers Region 9A and our Regional Director, Beverly Brakeman. We support Senate Bill 842, an act concerning health insurance and healthcare in Connecticut. Workers and families are losing their health coverage in great numbers due to the pandemic. Small businesses are struggling trying to offer healthcare that is too expensive to their employees. Expensive, high deductible plans make healthcare inaccessible to many, and racial disparities continue to have gone unaddressed, worsening longstanding inequities in our state. Connecticut needs to act boldly to curb the ongoing healthcare emergency. The constant struggle that every labor union faces at the bargaining table with their employers is how to provide quality, affordable healthcare benefits to their members while also leaving enough money on the table to negotiate wages. Non-union workers face even greater costs, leaving many with high copays and high deductible plans. These types of plans do not provide dependable health care. Out-of-pocket costs can be prohibitive, causing many to forego routine medical care and having a negative effect on wellness, long-term health, and financial security. The pandemic has also shown the need for new options for workers who lose their jobs, since most workers access their health care through their employment. No one should have to worry about losing affordable health care access for themselves or their family, along with losing a job. Reducing health care expenses will expand the state's economy and ease the financial burden on families and small businesses. Expanding access and lowering costs also puts more money in the pockets of working families, which in turn is good for Connecticut's economy. It's really beyond time to put people before profit. Profits are rising for private insurance plans as millions of Americans line up at food banks and homeless shelters. We need to act now to help the people of the state by creating public options to address this urgent crisis of affordability and dependability in this pandemic and beyond. We urge the committee and Connecticut lawmakers to support SB 842 this session to expand high quality, dependable, and affordable health care by creating new public options for health insurance. Thank you.
Thank you, John. Are there questions from the committee? John, thank you for being here. Next up is Jay Siklik, followed by Gavin Karan.
Thank you, Representative Wood, Senator Lesser, members of the committee. I'm Jay Siklik. I'm an attorney with the Center for Children's Advocacy and the Deputy Director of the Center. The Center is New England's largest civil rights legal organization dedicated to fighting for the civil and legal rights of Connecticut's most vulnerable children. In addition to my written testimony, I'm grateful to testify in support of Raise Bill 6389, an act concerning explanation of benefits. This is a critically important bill standing for an important principle: that all individuals who enjoy the privilege of being insured under a health insurance policy are entitled to the privacy when seeking such care that is sought confidentially, and in a manner that's consistent with the rights that are inherently imbued to all young adults and minors in this critically important healthcare arena. For many years, we at the Center, along with advocates whom you've heard of earlier today, have been pushing for greater access to healthcare for those most at risk. We've been pushing for this act in order to start the process of ensuring confidential treatment in those most sensitive confidential areas, such as reproductive health care, HIV diagnosis and treatment, access to PrEP, which is prophylaxis medication for the prevention of HIV transmission, behavioral health, and substance abuse care and treatment. This bill does not extend or expand any existing rights. It merely allows those individuals who are entitled to confidential care to access that care without the fear of an explanation of benefits being sent to individuals against the wishes of someone who's entitled to that confidential care. Make no mistake, this is not a panacea for this issue. It does not affect a policyholder's right to view the status of their deductible, nor does it put the policyholder on the hook for copays that are incurred as a result of confidential care. But it's merely one step along the lines of increasing access to sensitive and confidential care. This bill, these protections are long overdue. It's time to continue this path towards increasing access to care, guaranteeing confidentiality, and ensuring that all eligible individuals in our state are empowered to seek assistance in those most sensitive situations, especially when care is so critically important at this particular point in time. Thank you again for giving me the opportunity to testify, and I appreciate the time.
Jay, thanks so much for coming today. Any questions from the committee? Thank you, Jay. Up next is Gavin Curran, followed by Gavin Guerrera. Gavin, can you unmute yourself?
Yes, hello. Good afternoon, esteemed members of the Insurance and Real Estate Committee and Connecticut General Assembly. My name is Gavin Curran. I'm a certified organic farmer urging strong support for SB 842 to create a public option in Connecticut. During the beginning of the pandemic, I lost my job along with my healthcare. We should never have tied insurance to employment. However, with COVID-19 pandemic and the downturn in our economy, that should be even more clear. I believe we're in urgent need for comprehensive universal healthcare, and this bill will be a significant step towards decommodifying healthcare, which is a human right. Thank you for your time.
Wow, that was the shortest one here.
It's gotta be quick. It's been like 5 hours on the wait, so I wanted to be really short. Any questions I'm happy to answer.
No, we really appreciate it, and thank you for being a farmer and going into that field and sharing your story with us. Representative Dathan.
Thank you so much, Gavin, for your presentation and quick analysis there of what you went through. I'm sorry you had to go through that. It's really tough. So when you lost your job and were you offered COBRA through your former employer?
I was, but it was about $1,000 a month, which is out of my income level for healthcare. I mean,
that was my question. Did you compare the rate for COBRA to what the exchange had to offer?
Because it was February, I guess I was maybe not aware of the fact I could reapply. And then my new wife actually had healthcare, so I was able to get it through her. So I was covered for, under Husky for a short amount of time, and then I was able to get her health insurance. But I was really, afraid for a while because I wasn't sure, what to do. And it's not really clear based on, the laws, and like no one shows up to your house, tells you, you can apply for health insurance. And this has been the first time I was, let off from a job with healthcare.
Okay. Yeah, I'm sorry to hear that. Yeah, I know COBRA for many folks is super, super expensive. Mm-hmm. Through your job as a farmer, are you able to get any other subsidies for your insurance, or is it you just satisfied with your wife's coverage?
I do qualify for a subsidy. Okay. It's still about like $200 a month for healthcare for the two of us.
Okay.
Which is better than 5 or 6, but it's still fairly expensive.
Yeah, when you you're having a job that is really a labor of love, and I totally understand. So I appreciate what you're doing for our state, and thank you again for your time today. Have a good one.
Thank you.
Any other questions from the committee? Great, thank you, Gavin. Next up, we have a Gavin Guerrera, followed by Jonathan Gonzalez Cruz.
Hi, my name is Gavin Guerrera. I'm from Weston, Connecticut. I'm an independent filmmaker and a member of the ever-growing group of what's known as the gig economy. I'm offering testimony in support of SB 842, in particular the public option. While my situation may not be unique, it is stressful and somewhat difficult to comprehend because I'm by no means poor. I make a decent living by reasonable human standards, and I'm the sole financial provider for my family, yet I find myself under constant financial strain, primarily due to the cost of meaningful health insurance. As a gig worker, one is an independent contractor and understands that your contract of employment lasts as long as the project you're on. And on the last one, I was very fortunate to have health coverage. That project ended at exactly the same time as the COVID lockdown started. Film production ground to a halt, and I've been taking advantage of COBRA to maintain coverage for my family at a cost of $2,500 a month or $30,000 a year. And that's just premiums. I am blessed with a beautiful 8-year-old non-speaking autistic daughter that suffers from a life-threatening but manageable affliction known as Crohn's disease. This illness needs to be closely monitored and treated with infusions and blood work on an ongoing basis. We are fortunate enough to live 50 miles from New York City, where one of the world's leading authorities on the disease has accepted my daughter as a patient. Not wanting to jeopardize her health care, but hoping to cut expenses, I started looking for replacement plans on the Connecticut Exchange, only to find that despite her proximity, her doctor would not be covered. Resigning myself to working within these restrictions, I started looking to see if the plans offered were at least cheaper than the $2,500 a month I am currently paying. It turns out that there really was no comparable plan, and that the plans offered carried high base premiums coupled with outlandish deductibles, out-of-pocket costs, co-insurance, and no guarantees that the treatments my daughter receives would be covered without a fight. At the end of the day, knowing that we will in fact use our insurance, in fact rely on it, these affordable plans on the exchange get right back to at least $30,000 very quickly. I don't have the luxury of just hoping that we don't get sick. My daughter is sick and will need a lifetime of care, her disability notwithstanding. As a single member LLC, I don't qualify for group rates, but I also don't qualify for much by way of subsidy. I'm truly falling through the cracks. To clean up an apt saying, garbage rolls downhill, and I can tell you it's getting pretty putrid near the bottom of this particular hill. However, I'm excited to see that this discussion is proceeding and that we might be able to set an example to the rest of the country. The time to act is now. We need a robust public option. But beyond all that, I mean, having sat through hours of testimony here, it's a little infuriating to listen to talk about actuarial tables and taxes and all that. I mean, these are people, you know, we have real people, and what's a tax, you know, kind of incentive in the face of that? I mean, there's nothing that was said today that really made me feel like we were taking the human cost as seriously as the business cost. And, you know, I really feel like, you know, until it affects you personally, it almost doesn't affect you personally. And we need to get out of the politics of me and into the politics of we, because, you know, we're all kind of in this together. And I really don't know how to navigate these waters, you know, as hard as I work and as much as I make, that I should still, you know, have to, you know, suffer or struggle. I'm not suffering, but I'm certainly struggling. Just seems outlandish to me. Like it just doesn't make any sense. So thank you for your time.
And I want to just say thank you for coming on and sharing your story with us and waiting for so long, you know, to do so. But it really means a lot to hear from you on this, and I appreciate you coming on here. Questions from the committee, Representative Dathan.
Thank you very much, and I really appreciate your testimony, Gavin. Just a quick question with your daughter with special needs. Is she eligible for Medicaid at all?
So she is for supportive services, but this really is more about her Crohn's disease than her autism. I mean, my wife is a stay-home mom and takes care of her very well. I mean, now during the COVID lockdowns, we are homeschooling her, or at least distance learning her, and all of her needs are met therapeutically and what have you. Mind you, no autism therapy is covered under insurance anyway, be it speech therapy, occupational therapy. The only coverage that is covered, only therapy that is covered is behavioral therapy, and that's a whole different discussion that we can have for a different time. But no providers really accept insurance anyway, and if you've been on the exchange and you've seen what out-of-network coverage looks like, you might as well just pay out of pocket, because it gets to be really expensive really fast. And there's like this weird thing that I noticed about paying people out of network, right? So if they charge you $100 an hour and the insurance company says, well, you know, best practices is only $60 an hour, and we're only going to pay you 40% of $60 an hour, the other $40 of that 100 comes out of your pocket anyway. Right. So it doesn't make sense. I actually crunched the numbers to see if it was even worth having insurance. Like, what if I just paid out of pocket? Right. Would it come to $30,000 a year of coverage out of my pocket if I didn't have insurance at all. But then of course, I'm over 50 now and I need insurance because, life doesn't get easier over 50. So, I mean, these costs are, I mean, talk about American exceptionalism, right? I mean, somehow we think we got it right here as the only country that doesn't provide this for their citizens. And I just don't get it. It doesn't seem right. I mean, just fundamentally doesn't seem right. So thank you.
No, I get it, Gavin. I actually gave birth to 2 children under the NHS in the UK and gave birth to 1 child here in America. And seeing the bills that came across my desk for my daughter's birth, I was like, this was straightforward. I just couldn't even imagine how some folks do it. And the outcomes I had in the UK with my 2 children's birth was exceptional. And I'm not suggesting that a single payer is the right move. I actually not sure if it is the right move for our state. But what we do need to offer is an option for people to choose to buy something that might be less expensive. And with the open market and the open economy that we have, we need to have options. So I appreciate you spending the time today to tell us your story, and good luck to your family. Thank you.
Thank you. Thank you very much. I really hope this gets somewhere. Have a great day.
You too. Next up is Jonathan Gonzalez Cruz, followed by Michael Byrne.
May I just start?
You're on. Go ahead.
Okay. Hello, good evening, members of the Insurance and Real Estate Committee. Thank you for giving me the opportunity to share my story with you all. And before I share it, I actually want to bring up, my name is Jonathan. I recently graduated from the University of Connecticut with a master's in quantitative economics. And before I share my story, I wanted to bring up quick notes. Cigna in the third quarter of 2020 made a profit of $41 billion. And before that, they paid their CEO $19 million. United Health has revenue of $257 billion and pays their CEO $18 million. So I wanted to establish that first because these are not small businesses. These are not mom and pop shops. These are billion-dollar industries who are spending $1 million to lobby against this bill, which will help working people. And so when I was a graduate assistant, I was fortunate enough to opt into the state employee plan where a month for both medical and dental coverage, I would pay about $80. Once I graduated and was no longer a state employee, that increased to $400 for the same coverage because now the state was no longer negotiating my prices on my behalf. So simply put, individuals, when they're buying private insurance, the insurance industry has the upper hand and they bring up those prices. I also want to share my story with when it comes to shopping for health coverage for my family because we were undocumented. We can't buy into healthcare access. Because the ACA excluded us in terms of Husky, we are also excluded from them. And so in turn, going to the private market was my only option. In truth, when I looked in there, it was gonna cost more than $300 for me. It was gonna cost about $1,000 for both my parents. And for my brothers, it would have been about $300. So that alone would have been $2,100 a month. That is not acceptable for any working family here and in the state. We cannot afford that. And I'm sorry if I'm coming off across emotional because earlier today, Senator Huang said that maybe right now is not the time for this bill. And to be honest, I completely disagree with that because during Christmas, my mom, who is uninsured and who has been struggling with lung issues, was bleeding from her nose around 10 o'clock at night. And we were so scared because we knew that if we went to the hospital without insurance, we might get a huge medical bill that will put us in medical debt for many years. In fact, medical debt is one of the biggest that people in this country experience. And so in turn, I urge every single one of you to please support this bill and to please stop defending billion-dollar insurance industry. Yes, we are the insurance capital of the world, but we should be the healthcare state of the world where 100% of our residents have healthcare coverage. Please, I urge you because my mom needs it. I need it. Working families across the state need it. Please stop being persuaded by $1 million lobbying that the insurance industry is doing. They will be fine. They have always been fine. They have billions of dollars. But you know who doesn't? I don't have billions of dollars. My neighbors don't have billions of dollars. And so in turn, I urge you to please pass this public option because it will help people pay perhaps $80 a month versus about $400 a month for the same type of coverage, simply because they as an individual were not big enough to negotiate prices for the insurance.
Jonathan, thank you for coming and sharing your story. I do see how emotional you are, and it really means a lot to hear, how this has affected you and your family. And I appreciate you waiting and being patient and sharing that story with us. Do we have any questions from the committee or Sam? All right, thank you so much, Jonathan.
Thank you.
Michael Byrne is up, followed by Phyllis Frazier.
Hi, thank you. I don't know if you can see me on video. Yes. Hi, my name is Michael Byrne. I'm here today representing the United States Travel Insurance Association, otherwise known as USTIA. Thank you for the opportunity to provide comments on SB 89. So it's the travel insurance suicide exclusion bill discussed earlier, and really appreciate all the testimony throughout the day on Connecticut struggling with ways to provide healthcare to everybody. And these are obviously very personal and very sensitive stories, and appreciate hearing those from everybody. The USTIA's members include insurance carriers, third-party administrators, insurance agencies, and related businesses involved in the development, administration, and marketing of travel insurance and travel assistance products. First and foremost, most importantly, we are extremely sympathetic to the heartbreaking situation that we understand motivated the introduction of this legislation in prior sessions, and its reintroduction as SB 89 this year. I can't imagine the courage it takes for Ms. Brennan, who testified earlier, and I believe last year. I can't imagine the courage it takes for her to testify about her son and her experience with her travel insurance company. I signed back on just as she was finishing. And if you're listening, Ms. Brennan, still, I'm so very sorry for your and your family's loss. I'll refer the committee to my written testimony for background on the travel insurance industry and thoughts on the general issue of mandating provisions in private contracts in a competitive market for a discretionary product like travel insurance. Perhaps that's a broader public policy discussion for a later date, possibly in collaboration with the Connecticut Insurance Department. And I did hear the earlier comments about and am well aware of and sensitive to the public perception of the insurance industry, especially in challenging times like these. USTIA does not object to SB 89, subject to a modification that we believe addresses the various testimony before you, namely language clarifying that travel insurance will cover trip cancellation due to the suicide of an insured spouse, child, or other dependent. We also would like to incorporate into Connecticut law through SB 89 a framework to provide regulatory certainty with respect to the sale of travel insurance, including for transparency and disclosure of what a product does and does not cover. We would very much appreciate the opportunity to offer that language to Senator Slapp and the committee for consideration. Thank you again for allowing me the opportunity to talk with you today on behalf of the United States Travel Insurance Association. I'd be happy to answer any questions.
Michael, thank you for coming. I was wondering if your group had a discussion regarding AIG in this topic, if you had any feedback to the customers that are losing out on this. Like, was there any discussion as in, we would appreciate you resolving this offline or anything like that?
I have not had any discussions with AIG specifically. They are a member of the USTIA. I do believe that the policy at issue did contain language that expressly excluded any suicide, which applied to this particular case. That policy language was filed and approved with the department, but I also read the testimony and understand that Ms. Brennan obviously had a very terrible experience with her insurance carrier, and seems like, at the very least, again, I don't know how it was handled, but at the very least, some condolence, sympathy, understanding, acknowledgement may have helped in this situation. But I'm not aware of specific discussions about how they may have handled this particular situation or others like it.
I mean, and how often does something like a suicide happen when it comes to travel insurance? I would assume it's extremely low. Yet they made a point of putting their foot down and, not being very empathetic to the situation. So I was just wondering, how common is it?
I don't know. I like you, I can't imagine it's that common. I imagine it's very rare, and probably even more rare as you separate between the suicide of an insured, him or herself, and a family member of an insured. I can understand, and I heard some comments earlier. Obviously, people are pretty surprised about, or seem pretty surprised about how this was handled, and I can understand the general reaction as to why can't they just pay this, right? It doesn't happen that often. Can't you just be sympathetic? And again, I don't know about this specific situation. I don't know how I would have handled it if I were that company. The contract language does not provide for it. Could they have paid it anyway? Yes, I think that happens in other cases. But then, there's obviously others whose contract wouldn't cover other instances that wouldn't get paid. And not that this was the reason they didn't pay it, because I don't know the reason they didn't pay it, but there are rules, I think in Connecticut and probably every other state, against paying a claim that's not covered. Generally, you can't provide a benefit that's not provided under insurance policy. And I'm not suggesting that a company stand behind a law to not pay a claim in this situation. I think it was like, $5,000. It's, and you look at it and say, why can't they just pay under this situation? And again, I don't know. So I can understand the outrage, this disappointment, and surprise, but that's all I can say, really.
Great. Any other questions from the committee? Great. Thank you, Michael, for coming today. Next up is Phyllis Frazier, followed by Betty Marafino. Phyllis, are you on? Phyllis, you can unmute.
Yes, can you hear me?
Yes, we can hear you.
Okay, good evening, Senator Lesser, Representative Wood, and members of the Insurance and Real Estate Committee. My name is Phyllis Frazier, and I live in Willimantic, Connecticut. I have worked as a direct support staff at Sunrise Northeast for 21 years. I am here today to testify in support of SB 842. As a direct support staff, I work with individuals with intellectual disabilities, helping them to learn new skills to improve the quality of their lives. It is incredibly rewarding to work with my individuals and to help them live normal lives. While of course this is my job, my individuals feel like family to me. One incredibly challenging aspect of working at Sunrise Northeast is it is outrageously expensive health insurance. The family plan offered by Sunrise, for instance, it's $5,200 a month. This is more than I make in a month. I've spent over 20 years of my life working for this company. I feel insulted, and this is what they offer my coworkers and I in terms of health insurance. While I don't make enough money to afford the plans offered by Sunrise, I make too much to be eligible for Husky. At 62 years old, I live in fear that something will happen and I will face a medical bill that sends me into financial crisis. Even small procedures are difficult to handle. I currently have a cavity that I cannot afford to address, and soon that cavity may become a root canal, which will only be more expensive to be taken care of. Thank God the vaccine and testing have been free, because if it wasn't, I would not be able to afford it. If Connecticut had a public option, it would take some weight off of my shoulders and allow me to breathe a little easier. I would know that if something happened to me, I would be taken care of. There are thousands of people out there just like me, people who earn too much and too little at the same time. Please do what is right by us as we do for the people we care for. Please support SB 842. Thank you for your time.
Thank you, Phyllis. Senator Lesser, questions?
Yes, thank you, Madam Chair, and thank you, fellas, for your testimony. Mr. Frazier, did I hear you right? You're a healthcare worker, and your employer offers you health insurance that's over 100% of your income. Is that right?
Yes, for a
Premium on your health insurance is over 100% of your income.
For a family, yes.
Thank you.
Thank you.
Phyllis, thank you for coming today. Next up is Betty Marafino, followed by Jordan D'Angelo.
All right, that's it. Yeah.
Diane, can you mute? Thank you. Okay. I thought I saw Betty Marafino. There she is. Betty, you are on mute. If you just want to unmute yourself, you can talk.
Good evening, Senator Lesser and Representative Woods, and thank you guys on the panel for sticking it out all these hours with us. I've learned a lot listening to this. I'm a resident of West Hartford, and I am president of the Connecticut Alliance for Retired Americans. And for our 50,000 plus members in Connecticut, 842 is our #1 priority this year. And listening today to everybody speaking, I'm struck by the human cost of the stories that we've heard. And I'd just like to share a couple of examples. Last year, I was invited by Representative Scanlon to serve on a committee that went to a number of towns to talk about healthcare. And at every one of those panel discussions, physicians would get up and talk about how very often they see patients who are sicker, and they're sicker because they put off going to the doctor because they just couldn't afford to pay for whatever they needed. We also heard from physicians who said that very often they would prescribe a medication. Their patient would go to the pharmacy and they'd get a call from the pharmacy, and the patient would say, "Do you know how much this costs? I just can't afford to pay for it. Is there something cheaper than I could get?" And that really puts people in a bind. A couple of years ago, we in the Connecticut Alliance for Retired Americans received a grant from the United Healthcare Foundation of Connecticut to go into the communities and collect healthcare stories. And what we heard from most people was the following phrase: "I'm scared to death. I am so afraid that I am going to lose my health coverage, or when I go to the pharmacy, I won't be able to afford the medication." And nobody should be in that position of being scared to death. And just let me close on a personal note. My husband and I are retirees. We were community college professors for a number of years. And so now that we're retired, we have the state healthcare plan, which is a good plan, which everybody should have that kind of a plan, because the fear of will I be able to afford this is gone, and nobody should have to live with that fear. So thank you very much for listening.
Betty, thanks so much for sharing your story. Any questions from the committee? Thank you, Betty. Thanks for being patient. Jordan D'Angelo, followed by Joshua and Angela.
Hello, good evening, Senator Lesser, Representative Wood, and members of the Insurance and Real Estate Committee. My name is Jordan D'Angelo, and I'm a personal care attendant, PCA, that lives and works in Winston, Connecticut, caring for my mom. I'm here to testify in support of SB 842. Caring for others has always been a part of my life. When I was a teenager, I cared for my grandmother when she had dementia. So when it became obvious that my mom needed someone to take care of her, I knew that she would benefit from a personal care attendant. So I stepped into that role. I enjoyed taking care of her, and I enjoyed taking care of my past patients as well. It makes me happy to know that I am able to allow her to live in her own home and do so comfortably. With that being said, it is also difficult caring for my mom. There's emotional tax to watching someone you love who is sick. And even though I'm only paid 40 hours a week, I'm essentially working 24/7 to take care of her. Home care workers in our state are professional caregivers. The work we do allows people to receive critical care while remaining in their own homes. We don't just clean their homes or help them in and out of bed. We help them socialize and continue to do the things that they love. We care about our consumers. They're human beings and deserve to live normal lives. And it saddens me deeply that while we work so hard to provide a dignified life for our consumers, we are treated with utter disregard by the society we live in today. Unlike many people, health insurance is not afforded to me through my job. Furthermore, I make too much money to be eligible for Husky. At 27, I have not had health insurance in almost a decade. I have needed glasses since at least 2013, but I simply cannot afford them. When I was 23, I was unfortunate enough to have suffered a heart attack, and I was taken to the hospital by ambulance. The ambulance ride alone was over $1,000, and I'm still paying that off today. Additionally, the doctor at the hospital urged me to see a cardiologist, but I could not, and I still cannot, because I cannot afford it. Even routine preventative measures are out of the question for me. It has been so long since I've been to the dentist, I don't even remember when I had my last routine cleaning. If Connecticut had a public option, essential caregivers like me would be able to access healthcare instead of needlessly watching our bodies deteriorate. If Connecticut had a public option, it would mean that I could stay in Connecticut instead of moving to another state like Massachusetts, which I'm still looking into doing, unfortunately. If Connecticut had a public option, it would mean that I could access the care I need without triggering financial crisis for myself or my family. Please do the right thing and pass this bill. So that everyone in our state can have access to high quality and high value healthcare. Please support SB 842. Thank you everyone for your time.
Jordan, thank you so much. I really appreciate that. I know how hard it is to share your story, and I'm really glad you did today. Any questions from the committee for Jordan? Great, thank you, Jordan. Next up is Joshua DeAngelis, followed by Liz Gustafson. Liz Gustafson, I thought I saw your name on. Why don't you go ahead next?
Hi, everyone. Thank you for staying active and here and listening to all of this important testimony. Senator Lesser, Representative Wood, and distinguished members of the Insurance and Real Estate Committee. My name is Liz Gustafson, and I am the State Director of NARAL Pro-Choice Connecticut. I am testifying in strong support of HB 6389, an act concerning explanation of benefits. Although EOBs were created to increase transparency and protect consumers in the insurance claims process, this bill addresses a crucial barrier to accessing healthcare by ensuring that when multiple people are on the same insurance plan, confidential healthcare information is protected and not shared with anyone other than the patient. This bill also includes an accountability component of carriers, requiring them to act with a degree of urgency within a specified timeline when receiving an email or mailed request for suppression or redirection of an EOB. Those seeking any healthcare service should feel confident that this care will remain confidential for a variety of reasons. Disclosing any patient's private information negatively affects everyone, but particularly young adults who are insured through a parent's plan, minors who are exercising their right to access services, and adult spouses who are dependent on a partner's plan and may be in a controlling and/or abusive relationship. Individuals seeking care related to sexual and reproductive health, domestic violence, sexual assault, mental health, and other protected services may face the fear of their private medical information being disclosed to family members or are deterred from seeking those services altogether. Patients should not be stigmatized or punished for seeking healthcare, and instead should be empowered to make decisions with full freedom and autonomy. In 2018, the Patch Act was signed into law in Massachusetts with the same premise: to protect an individual's confidential and private healthcare decisions and to address deterrence faced by those seeking care in fear of others finding out. Connecticut enrollees should have the same protections from insurers, as confidence in knowing healthcare will remain private and confidential will have a profoundly positive impact on public health outcomes here in our state. I strongly support HB 6389, and I urge the committee and Connecticut lawmakers to vote favorably to protect the confidentiality of patients utilizing their private insurance plan. I also do want to note that we also submitted testimony in strong support of SB 842, as everyone deserves access to high quality, affordable health care, regardless of their race, gender, sexuality, zip code, immigration, or employment status. Thank you so much.
Thank you, Liz. Any questions from the committee? Liz, thanks so much for coming today. Diane,
thank you so much.
You're welcome. Diane Ariza, followed by Dr. Gregory Shangold. Dr. Greg.
I haven't.
I see Dr. Gregory Shangold, if you'd like to go next.
Sure, be happy to. Good evening, Representative Wood and other distinguished members of the committee. Good job staying in all day. Feels like one of my shifts. On behalf of the physicians and the physicians in training of the Connecticut State Medical Society, thank you for the opportunity to provide testimony on Raise Bill 842. For those who don't know me, I'm an emergency physician practicing in Connecticut for the past 18 years. Physicians will always support access to healthcare by creating affordable insurance options that work for both patients and providers. We really have an opportunity to be a pioneering state in this health insurance reform, similar to when we passed surprise billing legislation many years ahead of other states and in front of the federal government. But we must get this right. We do have several questions and concerns about 842, and it's our hope that we can collaboratively work on these questions and address our concerns through the legislative process. We must remember that access to insurance coverage does not necessarily lead to access to care. Both prongs of the bill, 842, both the expansion of the state employee plan and expansion of health insurance, do not seem to address network adequacy standards. We do feel that some sort of standard needs to be implemented into the bill. An influx of new patients into the state employees network will stress the current physician network. In order to provide meaningful access to care, network adequacy standards must be promulgated to ensure a robust physician care network. So many times narrow networks have been used to drive down cost or not include fair payments to physicians. And this further is complicated about getting enough physicians to stay in our state. We train an enormous amount of residents, but for some reason, we retain very few of these residents compared to other states. So we also commend the committee for limiting the deductible to the IRS minimum. High deductible health plans have had negative consequences on both patients and the physician-patient relationship since they've been going higher and higher over the years. Numerous studies have shown the negative effects of high deductible health plans as much of the testimony today. As patients are responsible for more of the healthcare dollar, we see significant delays in accessing care that in the long run result in more expensive care and hospitalization. We strongly encourage that the recommendations of the work group convened by the Legislative Act 2 years ago now be included in and incorporated into Raise Bill 842. If I have time, there was also a question raised in earlier testimony about physicians not collecting the patient responsibility. And physicians often do not collect that patient responsibility. As an emergency physician, we only collect about half of the money that is allocated towards patients. And unlike some other entities, this is not a business expense or a tax write-off. It's just lost revenue. Additionally, many physician practices have to put more and more resources in to collect that patient responsibility. But many people are right where they forego care because of the monies that are owed.
Thank
So
you, Dr.
lastly,
Shangold. If you could just wrap it up in one sentence, open it up to questions.
So lastly, the concerns about the regulatory process, we'd like to be part of all the implementation, but we are concerned that so many things are just left to a regulatory process, which can be adequate now, but change with different administrations and over time. So we would like to see those concerns addressed in the legislation. Thank you again.
Dr. Wong. You're on mute, Senator Wong, even though it doesn't look like you are for some reason.
I am. Thank you, Madam Chair. Dr. Shangold, thank you very much for your testimony, and to all of your colleagues, thank you for your work on the front lines. It is greatly appreciated. Did you submit testimony?
Yes, we submitted testimony from the State Medical Society. It might be under the State Medical Society, not under my personal name. Okay,
I'll go look for that. Because I wanted to ask you to possibly repeat the original phrase you said. It isn't about, addressing the issue of network adequacy. Do you remember what you said that really piqued my interest? It isn't about the first part or the second part, it's about network adequacy.
Well, I think I started that statement by saying having insurance doesn't mean you have access to care. And if we have more and more people now that have this state insurance product, but there's not enough physicians to provide that are in that network that participate with that insurance product, then what you're going to have is longer waits, and those people won't truly be accessing care. So just having the insurance product on its own doesn't mean that you have access to care. There are areas where there's just not specialties as it is right now. And so network adequacy and things that promote doctors to want to join a network is going to be just as important as the discussions you're having now.
Absolutely. And I think that's an important part of the consideration. As a medical provider and being one of the important components of healthcare delivery, would you agree to the statement that most people don't fully understand the incredible cost of healthcare?
I do agree with that. I mean, many people, it's such a complicated thing. I know when I deal with my personal healthcare issues and my families, I have trouble navigating through the process. And I'm a managing partner in a private emergency group. I'm the president of the State Medical Society. I think I have the inside track, and it is a complicated part of the task force. Something we talked about on the health high deductible health plan task force, which was last year, was work by UConn's Dr. Victor Vilagro about literacy in healthcare, and that many people don't have the literacy. And one thing we talked about is trying to improve that literacy so that people do pick the right plan for them, to understand their plan and what co-insurance, co-pays, and deductible all means.
And I appreciate also your statement, and that's why I'm eager to get your testimony. I don't see it in our files, and if we could, I will definitely follow up with you to get it, where you said we need to reserve judgment and take a look at this current proposed legislation. And I appreciate that. And this is what the public hearing is all about, for the long day that we've had today already. But I appreciate your pause in recognizing that this is a step of a discussion, but it is not the panacea and the solution for the incredible myriad of challenges that we have. And my heart breaks for some of the stories that I'm listening to. And we all want to strive to get answers for that, but the solution is not always easy. And I said in the beginning of these public hearings that I've been reviewing and trying to understand this issue for over 35 years. The reality is, if people had the answers, we would have it already. So I want to thank you for being on the front lines again, and to all your colleagues for what you do during this COVID pandemic. And thank you. Thank you, Madam Chair.
You're welcome, Senator Wong. Senator Anwar.
Thank you, Madam Chair. Thank you, Dr. Shankel here. Thank you for your testimony. Now, have you heard in your leadership position from individual physicians and practices the challenges they are having with healthcare for their employees and for themselves?
Absolutely. So you've seen this trend over the past 5 years where many private practices, because of the business pressures, both on collecting from the insurance and also being a small business and running a business, have decided to sell their practices. And that's where we get some of the consolidation issues. So a lot of them have closed up, and COVID has only exacerbated that. There was a recent article that I think was covered in a lot of the media of these pressures of practices that have closed down because of COVID now, where they've had to invest in PPE and the lower volumes and many of these pressures. So certainly dealing with insurance companies and not having denials and having to spend time on the phone to get approval for necessary care. The amount of people that avoid essential care and non-essential care because of high deductibles, all of those pressures in the billing side have put enormous pressures on physicians. And I think the net result is you get less private physicians, and unfortunately that decreases access to high quality care.
So and this amongst the various reasons that we have in our state, but we are losing clinicians, physicians across the state because of a variety of reasons, but this aspect is one of them. Is that a fair understanding?
By this issue, I guess I want to make sure I say what this issue is.
In other words, we really have a disaster looming with the number of physicians in the community. They're decreasing significantly in the state of Connecticut. There are a number of reasons why doctors are leaving the state of Connecticut or retiring early, but one of them is that they are unable to afford the increasing cost of healthcare in their practices.
I think many physicians who run private practices feel it's their duty to have the best products that's out there, you know, and having some of the products, I can tell you, so I've been running our business for 13 years now, and the amount of cost that we put into healthcare has been going up and up and up. And as a small business who also is on the other end, my premium increases that we have to pay for our health insurance don't match the benefit increases that we get on the provider side. So we are lucky if we could get 1.5 to 3% increase per year on the provider side, but we're often talking about 5, 8, 10, 12% increases on the premium side. And so you can see as a business, that's a lot of stress. And some people have decided the answer is just to stop practicing.
Yeah, I think that's so important. I'm glad we were able to hear that, and I'm glad my colleagues would be able to hear this, because there's some people in our legislature who feel that the status quo is acceptable and everything is good. There are business organizations who claim that there is no problem or there's not much of a problem on this end for the cost of healthcare in our state. So I'm glad we were able to take care of that part from at least your experience. I also wanted to clarify, what is the official position of the Connecticut State Medical Society around public option?
So I would say the official position can't be put into support or oppose. We support the idea. We think everyone should have access to insurance and access to high quality, safe healthcare. So whatever vehicles get us to that end, we support. We think this is a good start, but we do have some reservations as the bill is written. And we would like to work with people to amend that. But that network adequacy, and certainly I think Kevin Lembo said that right now they're going to be using the rates that are these commercial rates. And I don't want to get into Susan Halpin's all about cost shifting, which is also important. And I understand that from the insurance industry. But obviously the rates if we got Medicaid, if this ultimately resulted in some sort of Medicaid or just Medicare, that would not be survivable. And if it resulted in more high deductible health plans, even though you negotiate a payment with an insurance company of a high rate, if that all goes to a deductible, which you can never collect, that can't be a solution either. So to use some of the information that came from the high deductible task force, I think is also important, where we're not exposed to all of that risk.
Right. And I think one thing is very clear in this, and I think Senator Lesser will weigh on this as well, and Kevin Lembo and others who have been working on this for quite some time. This is not a Medicaid expansion. This is not intended to be and not will be a Medicaid extension. That's very clear. And there's no cap that has been placed on the services that are going to be provided. So it's not a mechanism to try and restrict. We will not be able to get the quality and the access if there is a restriction placed on the healthcare providers in the system. So that has been well understood and recognized, and that is not a part of the bill. So if that was not a part of the bill, would you feel more comfortable saying that, well, this looks like a solution? Because what's being saved, there's obviously the magic in this situation is that the public option is not paying $250 million to the top 5 employees. That's the saving right there, which are the ones who are lobbying and like crazy because they don't want to be in the marketplace to be able to compete when you have people making $50, $100, $60, $70, $80,000 in a plan, as opposed to $150 million, $50 million, and God knows what has been happening in the bigger insurance industry. That is where the saving is, and also the efficiency and the numbers and the healthy pool that we have had, relatively speaking, and also the targeted small businesses. So that is where the saving is, and the saving is not at the cost of the providers at all. And that's I think the brilliance of this plan. I think Senator Lesser can also allude to some of this in a second, but I truly appreciate your testimony and thank you for all your good work, sir.
Thank you, Senator.
Senator Lesser.
Thank you.
Yes, thank you, Madam Chair, and it's very tough to follow my friend Senator Anwar, but thank you, Dr. Shangold, for your testimony. And I don't really have a question. I just wanted to appreciate that you've been just a wonderful person to work with on this project of making sure that everyone in the state gets affordable access to health insurance. And certainly I share your concern about network adequacy and want to work with you to make sure that the concerns that you articulated are really fleshed out in this bill. So that's something that the physicians and providers across Connecticut can really embrace. So I want to thank you for sharing those concerns, and I can commit from my end to working with you to make sure that we address each and every one.
Likewise, Senator, I've always enjoyed working with you, and I know how accessible you are and how passionate you are on the issue, so thank you.
Representative Nuccio.
Hi, Dr. Shangold, how are you?
Hi, Representative, nice to see you again.
Nice to see you again. Thanks for hanging out for this long. So you brought up a couple things that I think are really interesting and worthy of pointing out. So you talked about the depth of network and the fact that we're losing physicians. And I was wondering if you could maybe comment about how that's affecting rates or the consolidation of physicians and how that's driving rates, because you then brought up something that I think is very key that needs to be focused on. If your negotiated rates are 1 to 3% a year and your cost of insurance is higher than that, your insurance is then contributing to the higher cost of insurance, higher cost of healthcare. So, this is this again, the dog chasing the tail the whole time. And that's a point of interest, I think, that is worthy of delving into, even if just for 45 seconds more than we already have. So I was wondering if you could maybe just comment a little bit on those two things.
Just to be clear, you want me to comment on the network adequacy question and losing the physicians in the state?
That in relation to also how that is prompting consolidation, like of the big hospitals and physicians groups underneath, and how that's kind of contributing to the cost of healthcare.
Right. So I'll refer people to a survey done by Physician Foundation, which was over 3,000 physicians nationally, but the numbers correspond here in Connecticut as well, which has seen this trend of where in the past there were 75, 80% of physicians were in private practice. And now that number in Connecticut is down below 50%. I believe it's 46%. So the consolidation is happening where they're selling. And when you talk to individual physicians and you ask them why are they doing it, it's that combination of the pressures they get from insurance reimbursement and all of the problems with that, where they're just not getting the time and effort. And so they've become employees of other entities and looking for other things than just treating patients. But on top of just that consolidation, and I'm not involved with the negotiations from these big entities, but I can imagine, if you, when you negotiate, you obviously use leverage. So the more leverage you have, the more that negotiation can go one way or the other. So that's obviously there, but because of antitrust laws, I don't have access to any of these negotiations. And that's one of the things. I don't know what my colleagues make because we can't talk about those type of things. So as far as Connecticut goes, there's multiple things also. I haven't heard, and I honestly, I've been here for most of the day, but I've had to do some other work. So, but we haven't talked about the medical education or malpractice reform. And two of those are huge parts of cost of healthcare. And so a lot of that is being paid for and wrapped into this whole discussion. So if this wasn't complex enough, paying for defensive medicine and paying for the medical education process, just for example, someone graduates after 4 years of med school, they often have $500,000 of debt. So somewhere along the line, that person has to repay that debt. And then if you put on top of it the malpractice premium that you have to do and all of the testing that gets done to avoid large settlement suits, these are all individual costs that go into this as well. So other states have done things for both education and malpractice reform to attract doctors, if not just general reasons to come to a state. But Connecticut, when you look at any national survey, is it an attractive place to practice medicine? Many times is not in the top tiers of other states. And so I believe there's another bill, it might be in public health, that says, let's get a task force together to look at things to bring physicians to the state. But if you don't have a lot of physicians and they're getting squeezed in a certain way, then that all can decrease that network adequacy. And if a physician says, I can't take that rate, this is a take it or leave it contract, because they're the small fish in the pond and the insurance company is saying, take it or leave it, you won't have access to these patients. What is the doctor going to do? They either are coerced into taking it until they just can't take it anymore and they roll up and they sell or they leave practice. And that's really what's been happening.
You mentioned a couple of very good points. My daughter is going for her doctorate in psychology, and when she's done in about a year and a half, she will have between $150,000 and $200,000 in student loans. So it's a very big cost to become a doctor or even a nurse at this point in time. So one of the things that I'm wondering, as a doctor, you have the ability to negotiate with multiple insurance companies if you so choose, correct?
Because I'm in a private group, yes, we negotiate with the individual insurance companies, and in emergency medicine, it's slightly different too, because there's federal law that dictates how we take care of patients as well. So there's a lot of complexity there.
Yeah, there's you can't turn anybody away. So
right.
That is definitely a federal regulation there. So
now we have surprise billing both on the state and on the federal to
right. If you're a
mitigate
non-par
all those things.
participator and everything else, if you're not disclosing, it's getting more and more complex. So you mentioned a concern about the negotiated rates, and I hear that time and time again. And one of my concerns and one of my questions for the comptroller was regarding the negotiated rates, knowing very well how Medicare and Medicaid are paid in the state of Connecticut, and then the balance of that off onto onto the insured people. So with this plan, I agree with you that there's a concern for negotiated rates. If the state is negotiating on their own and using their entire pool, you could see a lot of pressure downward on provider rates. So I definitely hear you with that. And I look forward to sitting down to try to come up with some sensible solutions to kind of corral the cost. And of course, bring more providers back in so we do have a depth of network. And there's diversity and variety in the doctors, in the plans that people will have. So thank you very much for your time. And on a side note, I just want to mention to Senator Lesser, when you had your, I'm not sure if it's a son or a daughter, but how cute. Thank you for putting a baby on after 8 hours of public hearing so far.
Here to provide entertainment where I can. Thank you.
You know, just hold them up. Is it a girl or a boy?
It's a boy. Yeah.
Hold them up just a little bit every now and then, you know, just to show.
Boy, and I
He'll
did
be
ask
making
Sam
other
if he had any
cameos.
questions. Dr. Schenkel, thank you for joining us. I don't see any other questions, but I really appreciate your time. And it was a great discussion. And I don't think you're going to see the last of us after this. So thank you.
My pleasure. Thank you, committee.
At this point, we're about halfway through our speaker list. So I did want to thank the committee for sticking it out and being so involved with all the questions and discussion. I think it's been great so far. Next up is Lisa Windjam, followed by Mary Claire Whalen.
Thank you, Representative Wood, Senator Lesser, and members of the Insurance Real Estate Committee. I'm Lisa Windjam, the Executive Director of the Connecticut Office of the National Alliance on Mental Illness. I'm here today in support of Senate Bill 842. I have submitted written testimony, so I'm going to try to be brief and share a story with you that backs up some of what is in my testimony. NAMI is the nation's largest mental health organization dedicated to building better lives for all people affected by mental health conditions. NAMI Connecticut and its 9 local affiliates provide support groups and education programs for people with mental health conditions and their loved ones, and advocate for policies to improve the lives of people affected by mental health conditions. I'm testifying here today both as the leader of this organization, which is committed to making sure expanding access to health insurance. It is part of our national and our state policy platform to make sure that people with mental health conditions get the best possible care. I'm also here as the head of a small nonprofit organization in Connecticut that is struggling to provide our team with quality health care. And I have been listening on and off today while doing an incredible amount of fundraising letters and getting those out into the world. And I heard my colleague Kathleen Flaherty talk about her own situation with healthcare with her organization. And we have the same issues at NAMI Connecticut. Although I've lived in Fairfield for over 20 years, up until October of 2019, I was employed by not-for-profit organizations in New York State. And I was employed by a small national organization in New York City and had wonderful, wonderful healthcare coverage. And when my position was eliminated in 2018, and I was talking to some of my friends who are small business owners or who have spouses who are small business owners, they were stunned that my COBRA premium for medical, dental, and vision was far less than their premiums here in Connecticut. And when I took my position as the executive director of NAMI Connecticut in October of 2019, I stayed on COBRA. And I stayed on COBRA because my COBRA premium for my spouse and I is less than what will come out of my pocket under NAMI's employer-provided health plan. It's really challenging in a small nonprofit with a mature staff. I won't call us old, but I will say we're mature. And with Connecticut's system of underwriting group insurance plans based on each participant's age, we suffer greatly because our staff is largely over 50. I also think this gives employers an incentive not to hire people over 50. We do cost more. We're worth it, but we cost more. And
So,
it's
can you just, you're at your 3-minute mark if you just want to wrap up with a few
so
sentences.
I just want to say that, you know, as an employer, this is so important to us to be able to provide our staff with quality, affordable healthcare, because right now our plans aren't good. They have high deductibles and they cost us a lot of money.
Thank you. Any questions from the committee? Representative Dathan.
Thank you very much, Madam Chairman, and thank you, Lisa, for your advocacy with NAMI. You all are a wonderful organization, and I'm so glad that you do so much for our community. I am not sure if you, thank you for your testimony on the 842 bill, but I actually had a question on the explanation of benefits bill. I don't know if you've been following that bill as well.
I have, we're a small team and we're limited in how much we can testify, but I heard my colleagues, I heard my former colleague Gretchen Raffa's testimony, and I support that, the position that Planned Parenthood and NARAL take. You know, we're concerned too about especially young people seeking mental health care. And, you know, there's already cap on how many visits they can seek without their parents' consent. And we know that we would rather see young people get mental health care than have their parents be involved in that care if they feel it's not safe.
That's it. That was what I was going to ask you. And I was going to ask, do you think that, you know, more people might be able to get help if they knew that the explanation of benefits wouldn't be going to a parent or a young adult? And do you think that that could help people with mental health issues in our state?
I absolutely do. I think it could help young people, and, you know, I think it could help people who don't want to share with their families that they're seeking mental health services. Mental health still carries a tremendous amount of shame and stigma. We're working every day to eliminate that, but it would help a lot of people.
Great. Well, that was all I wanted to ask. Thank you so much for your time.
Thank you, Representative Dathan.
Thanks for coming and being patient with us, Lisa.
Thank you.
Next up is Mary Whalen, followed by Wendy Marcoux.
Wow, I cannot believe we made it to me. That's amazing. Good evening, Representative Wood, Senator Lesser, and members of the committee. My name is Mary Claire Whalen. I'm from New Haven, and I work on a small nonprofit farm in Woodbridge growing vegetables for my local community. I also work for the New Connecticut Farmer Alliance, which is a chapter of the National Young Farmer Coalition. I'm here to testify because I think that one of the best ways to support Connecticut farmers and farm workers and grow a resilient and thriving food system will be to pass Senate Bill 842. I submitted written testimony, but I'd like to add a few details. Farming is my passion. It's what I love to do. I've been doing it for 7 years, and it's also a public service. As of now, I'm able to access affordable healthcare through my mother as a dependent, which enables me to keep returning back year after year and learning more at the same small farm that I love. My greatest hope is to one day open my own farm in Connecticut, building on my years of experience in the industry. However, I do not believe that I will ever be able to take that risk to open my own farm without the assurance that I will have access to affordable health care. So I'm faced with the question, do I follow the lead of dozens of young Connecticut farmers and move? Do I go into a different career? And I know I'm not alone in this fear. In addition to my on-farm work, I'm the coordinator of the New Connecticut Farmer Alliance, a group of more than 400 farmers in the state. As of 2019, 42% of our members listed health insurance for farmers as their #1 policy priority. It was the most popular choice by far. So I'm saying more than land access, more than accessing new markets, more than increased training opportunities or mental health support for farmers, all of which are crucial issues, young farmers are worried about healthcare. We need to support young farmers and farm businesses who work hard and at razor-thin margins by giving farms access to the state healthcare plan, as outlined earlier. The average age of a farmer in Connecticut is 59 years old, and we desperately need young farmers to step up to the plate. This is the only bill up for discussion this session that I believe might have some hope of making access to healthcare possible for beginning farmers. Crucially, I'd like to add that a strong local food system is a diverse one. Much of our food in Connecticut is grown by farmers and farm workers of color, including undocumented farm workers. We need to support them too through this plan, not just because it's the right thing to do, but because they hold years of experience and skilled labor, which makes our food system stronger and more resilient to shocks like COVID-19. As a farm worker myself, I know for a fact how much access to healthcare would encourage me to return back to the same farm instead of moving into another industry or taking my skills elsewhere. And finally, as you can imagine, farming is a very physically demanding job, and catastrophic coverage just will not cut it. If I hope to serve my community by growing local, healthy food for them, which is a healthcare issue in itself, I need to focus on preventative care and take care of my body now so that I can hopefully have a long career ahead of me. I hope the committee will consider how passing Senate Bill 842 will contribute to strengthening and enlivening the CT food system, and how much this healthcare access is desperately needed by farm workers like myself, who have been on the front lines of community care during this pandemic, growing the food that we all need to live. Thanks.
Thank you very much for sharing that testimony with us. And I'm just really proud to see so many young people in Connecticut that are going into farming, and the work that you do is benefiting all of us. So thank you. Any questions from the committee? All right, Mary Claire, thank you for coming. Next up is Wendy Marco, followed by Ellen Andrews.
Hi, good afternoon, Senator Lesser and Representative Wood and members of the Insurance and Real Estate Committee. My name is Wendy Marcoux, and I live in South Windsor, and I'm a direct support professional for Whole Life. I'm here today to testify in support of Bill of 842. Caring for people has always been a passion of mine as well. I first began working with children and eventually moved on to working with adults. Within my position at Whole Life, I care for people with mental and physical disabilities. I help them learn new skills that they can use every day with their everyday lives. Through this work, you develop bonds with the individuals you care for, and it's fulfilling, and you see that with them, and then with you help. While I enjoy this work I do with Whole Life, I feel disrespected whenever I attempt to utilize our health insurance plan. The monthly premiums are manageable, however, but the deductible is backbreaking. For individual plans, the deductible is $3,500, which means that unless I am in need of a serious procedure, I must pay out of pocket. Furthermore, I make too much money to qualify for Husky in the state. So unless I want to be uninsured, I am stuck with this plan. Working as a direct care support professional, I am tasked on a daily basis, caring for others, but I live in a constant fear that sometimes some things will happen to me and I have no one to care for me. As for I do live alone. When you board a plane, you are told, in case of an emergency, that you're to take care of yourself first, correct? Before you take care of others. So how can we expect as professionals and as caregivers to continue serving communities when we do next to nothing to ensure to take care of themselves and ourselves? In Connecticut, we had public options. It would make a huge difference in people's lives, I think, if we would serve as a safety net for people. If we lost our jobs or we got hurt, it would serve as a real safety net for us. Please do the right thing and pass a bill so caregivers like me can continue to do our jobs with peace of mind and support what we need. Please support this bill 842, guys. We really need it.
Wendy, thank you for waiting and being patient. I hear an echo.
I'm sorry.
Oh, is that you, Wendy? Thanks. Well, thank you. I just want to see any questions from the committee. Wendy, thanks so much for coming.
Thank you.
Ellen Andrews, very nice to see you. You're up.
Oh, nice to see you too. Thanks. Yes, I'm Ellen Andrews from the Connecticut Health Policy Project. I want to thank you for this opportunity to share our thoughts on SB 842. I should clarify, I think we were listed as supporting the bill on our testimony, and we don't have an opinion. We don't support or oppose 842. There are parts of it we love and parts of it we have concerns with. we love restoring coverage for Husky parents. I've been doing this a long time. It's 21 years just at the Health Policy Project and years before that. 5 years ago, 11,000 Connecticut working parents lost coverage due to budget cuts. And, some of the people who were cut were able to be brought back in other eligibility categories, but still 11,000 lost it forever. At the time, the administration framed the cut as a transition to coverage through Access Health CT. But because of tracking that the legislature insisted happened, DSS was able to show that virtually none, very, very small number, were able to buy insurance, and even of them, many had to drop it within a few months. It just isn't affordable for people at that level. So the transition never worked. We need to fix that. It's been 5 years, and we need to bring those parents back. The impact of parent cuts on families is profound. If you think it doesn't affect kids, you're very wrong. We did a study. We followed 8 families who had lost coverage in a previous cut. And I'll just talk about one. Elizabeth was a substitute teacher in New Haven. She and her son, Sean, live in New Haven. They lost coverage. We were able to get Sean back on. That was a mistake, but we couldn't get Elizabeth back on. She had high blood pressure and had medications, which she could no longer. She had to choose between rent and her medications. She chose to pay for rent, and she had a heart attack. After she was discharged from the hospital, she got better, but she now had a much longer list of medications. But she had Husky, thankfully, for 6 months, because now she qualified, although she had to pay a spend down, which she had no idea how she was ever going to pay that. But after the 6 months, unfortunately, she again had to choose between rent and medications. She chose rent again, and she had a very serious heart attack. She was in the hospital for quite a while, and it was no doubt a very expensive stay, and the state paid that. So the state paid probably $80,000 in hospitalizations, but for $260 a month, keeping her on her medications. It was just, it was terrible for her heart. Now has been seriously damaged. Her son had to go live with relatives while she wasn't well. And it was just a stupid waste of money. So restoring Husky parents is the right thing to do for taxpayers and for families. So we love that part. We also love the part about subsidies, because the exchange, as I said, is not, it just doesn't work for many people. And coverage for immigrants as well. I think the COVID pandemic has made it clear to us that somebody else's health is directly related to my health. And, you don't want to be, my sister lives in Toronto. She doesn't worry about the last person pressing the elevator button, whether they could go to see a doctor when they weren't well. And she doesn't worry about the people caring for her children.
Ellen, thank you. I'm sorry to interrupt, but you've hit the 3-minute mark. Do you want to sum up it with a sentence or two?
Sure. We have concerns about the public option. I guess one point I would make is to be careful not to overpromise. As a nonprofit, we signed up for MEHIP, which was the first iteration of the through the Comptroller's Office of a public option, and we could afford it the first year. It was more expensive, but we did it because it was the right thing, but we could not afford it the next year. So be very careful. And my concerns are in my testimony, so I'll leave it there.
Thank you. And my question to you, Ellen, is that some of the concerns that I had seen you writing about regard the transparency issue, and I was wondering if you can talk a little bit about that.
Sure. Yeah, in Medicaid, I'll probably deny this, at the MAPOC meeting later this week, but we do know an awful lot about that program. And that is because of sustained advocacy by advocates as well as legislators. I used to staff the Medicaid Council, and we just required that they let us know. So we get monthly, I get very great deal of detail on how we're spending in that program by eligibility category, by what service level every month. And we don't have any information like that. We get quality information, which I think we're getting on Thursday or very soon on HEDIS measures, an entire spreadsheet on how we're doing in terms of ED visits and getting people in for checkups and follow up after discharge, avoidable hospitalizations and ED visits. We get none of that from the state employee plan, and it's a very expensive plan. I'm sure people are getting care, but we don't know that much about it, and we don't. So if it doesn't work, I don't know how we'll know, to be honest.
Yeah, I did hear some things when you say it's a very expensive plan, like the cost that, say, a family of 4 in the partnership plan, that cost is almost double what the private sector is. I don't know, and I guess we don't know that because we haven't seen data that backs something like that up, correct?
We do have data actually on what the partnership costs are. I have them here somewhere, but it's over $1,000 a month just for somebody who's a single plan, and goes up to, I believe, $1,800 a month, depending on which county you live in. And well, this was in 2019, according to HHS. Small businesses under 50 employees were spending a total employer and employee share for premiums about $7,600. So the state employee plan from the partnership is already going to have to come down about 40% to get to something that over half of small businesses can't even afford at $7,600, or they're not, it's 38 point something percent that are taking it up. So, I mean, I hope that it works. I really do. That's our reason for being at the Health Policy Project, is to get these kinds of things to work. I'm very concerned about the numbers, and we don't know enough to feel, I certainly don't know enough for the Connecticut Health Policy Project to feel confident about it. The other problem is that there's an opportunity cost. The more we wait on this, and I know that candidates have heard from people that they want some relief and they need it now. We've been working on this a long time, and we're ignoring the input costs, doing something about drugs, doing something about consolidation, which we heard a little about today. Those costs are out of control. And, I rarely agree with Susan Halpin, but, we both agree on that we have to work on the foundational costs, or we're just, messing on the margins.
Thank you. Senator Wong?
Thank you, Madam Chair. And Ellen, thank you very much for sticking it out. And I have always appreciated reading your material. You and your organization have a sensitivity and an awareness of the social responsibility and the social emotional dynamic of healthcare. And you back it up with using analytics. So it's a really unique compliment that I want to applaud you. And I really do enjoy reading your material. And I know we've communicated that way on that. But I also appreciate your approach in this, in the sense of using the analytics, but understanding there's a social consciousness side to it. And offering the thought and the caution to not overpromise. And I think that's one of the challenges, is no one is opposed to the idea of increasing access, maintaining the quality, and reducing the foundational costs. No one. But I think one of the cautions we wanted to be able to do is to not overpromise, to not create an expectation that this is the panacea. Because indeed, as I said repeatedly, if we knew all the answers, we would have done it many years ago. So I want to extend how you have approached this and to thank you. And for you, one of the thoughts I had is, what are your thoughts on the 1332 exchange in being able to utilize the ACA exception and federal funding to be able to provide some degree of relief and not look to increase an assessment or a tax on insurers and within the plan and taxpayers?
Yeah, I share your concerns about a tax. Maybe I'm not as concerned as others are, because it's true that Susan says how, it went, premiums went down this last year. I don't know about you, but none of the consumers I talked to have noticed that it went down. So I don't know how big a deal it is, but I still, just as an issue, just as a concept, it doesn't make sense to me to tax premiums for some to make it less expensive for others, because every time you add a dollar, there's going to be somebody out there who can't afford that extra dollar, and you might be increasing the number of uninsured. And I think we should be looking to broaden the base of revenue for what we want to do. I want to thank you so much. I am going to bring this back to every one of my board members. Nobody's ever said they enjoy reading my stuff. That's really nice of you. Thank you.
Look, I absolutely do, because it is so well thought up from the context of the sensitivity and the social responsibility concept that is so essential, and everything that we have to do as legislators and policymakers, but also you back it up with the analytics and the analysis, and it's really I think it's a conscientious approach to solving many of the challenges that we have. So please do accept that and extend that to your board member. The other thing you also pointed out that I wanted to extend to the chairs, and a procedural. You're absolutely right. As you read through the plethora of public testimony that's categorized here, we only have two categories. You either support or you oppose. And you just made the offer that you neither oppose or support, and you wanted to be able to have thorough discussions and reservations. Perhaps we should, in our category, create a third category of saying question mark or maybe, because I think we just had the same issue occur with the Connecticut Medical Society. And as I was reading through, and I hope we'll get to be able to talk to the Connecticut Hospital Association, they're also cited on this as being supportive. And as I read through the testimony, it seems, and I'll look forward to talking to them, that they have some reservations about SB 842. So I would ask through the chairs and maybe procedurally that when we looked at public hearing testimony, that we create a third category for testimonies that raise this very important question and may be neutral in their approach to the proposed bill.
I didn't get a chance to answer your question though about, that's a great idea. On the 1332 waiver, they're still pretty new for states. I would, again, I think it's an exciting idea in the Affordable Care Act. It's very broad, and you gotta love stuff like that when the feds give you room to dream. But I think some states that have not been able to use it the way they wanted to, maybe overreached in terms of how, universal healthcare and things like that. So I look forward to seeing what comes out of that. I hope it is an open, transparent process. I'm very concerned about it going through the Office of Healthcare Strategy, which has not been in SIM or in their latest cost cap program, have not been open and transparent, and have not engaged voices that didn't say what they wanted to hear, basically. And that troubles me.
Well, transparency should be an absolute priority in this, in regards to looking at the fiscal viability of any plan. The second area in regards to cost containment that you cited in your testimony is prescription drug cost containment. You're absolutely right. It is an escalating cost. And I know for us in the Senate Republicans and House Republicans, we looked at maintaining or being able to contain prescription drug costs. Can you elaborate a little bit of your suggestions?
Sure. One suggestion that I liked, especially when we thought we didn't have any money in the budget, now we have a little bit, so I might have other ideas now, that is to, states are looking at this. Hawaii, Washington, and Massachusetts so far are looking at a tax on unjustified price increases. When a company takes a drug that's been around, it's not new, they've already recouped their R&D, and they just increase the price because they can. The states are looking at taxing that increase at 80%. And I think it's a great idea. It should get around the legal challenges that have stopped some other states. with some of the other kinds of, drug review boards and some other things that they've tried to do, setting prices, that kind of thing. We're not setting a price, we're just going to tax it if you make it too high. And I'm not a lawyer, but that's apparently can survive a challenge.
Thank you. And the third area that we are advocating from a cost savings perspective is utilizing benchmarking. I know Massachusetts have utilized benchmarking to be able to contain and measure about across the board and equitable sources in having good data and measure, which I applauded your organization with doing. Do you think benchmarking is a critical element for us to begin the process of cost containment?
Yeah, I'm of two minds. I always like more data. It always, one of my former bosses said, "Oh, Ellen's eyes are glowing. She must have gotten a new database." But unfortunately, Massachusetts' benchmarking cost cap has not worked as well as they had hoped. It's good that they know where the problems are, but it has not made coverage affordable. There's serious questions about whether it's really, and whenever you say you save money, it's always a comparison to an assumption about what it would have been. So it's not clear that they saved money. So a report in and of itself doesn't do anything. It's what we do with it.
Well put, Ellen. I don't think Massachusetts is the only one that's prone to using reports and numbers to support our theories and hypothesis. That being said, but it is a good start, and it gives us barometers where if we're truly transparent and we use data to really focus on the issue at hand, which is reducing healthcare costs and increasing access, I believe you'd be interested in the proposal that we will have deliberations and a public hearing on, because we've been working on it for a couple of years, and I would really welcome you and your organization's input, because our goal is the same as everybody else's that testify here, to be able to provide quality and accessible and affordable healthcare and containing the skyrocketing cost of healthcare insurance. So, Ellen, I want to thank you very, very much, and I'm sure we'll be talking some more. So thank you, Madam Chair.
Thank you. Thanks.
Thank you, Representative Nuccio.
Good evening, Ms. Andrews. How are you?
I'm good. How are you?
Hanging in there. So you mentioned a couple of things that I was going to see if you could elaborate a little bit on. You've got some valuable insight into the last time the state really kind of tried something like this with the MEHIP plan. And I was wondering if you could give us a little historical context on that. And the second piece around that is when you decided to leave the MEHIP plan, were there any punitive, oh Lord, I can't even talk now, it's been so long, any punitive fines for leaving? And with this new plan, there are definitely, there's wording in there that there will be a penalization if you do try to leave the plan that's on the table right now. And I expect that that's going to have a pretty big infrastructure cost for anybody who decides to no longer participate. So I was hoping maybe you could start off by just giving us a little bit of history of the MEHIP plan and the occurrences of that.
Yeah, I honestly don't. I actually looked at back at my notes, and I don't remember. It was 10 years, 12 years ago, and I don't have a lot on it. And I know that they made changes to the plan after that, but it still didn't work extremely well. And then they created the partnership plan, and that had changes that I knew for the test. I don't recall those. And then there's a partnership 2.0. So it's been through a lot of iterations. But no, it was just a year, like most plans, and there was no fee when we left, thankfully.
So I applaud the state for constantly trying to innovate a plan that didn't work and make a new plan and such. But this one would obviously be for the 3 years for some and 1 year for another. But I do think the infrastructure cost of leaving would be a little undue on the side of the person who's trying to leave. Now, you had mentioned the prescription cost, and I'd like to just point out that the prescription cost is the highest dollar spend for every $1 spent in healthcare. and the ICER legislation that you're talking about, I'd be very interested to see this committee take that and look at that, because one of the things that I think, again, contributes to the actual high cost of health insurance and health care is the predatory practice of, you take a drug like insulin that cost a penny to make and you charge hundreds of dollars for it. And then subsequently, when we pass legislation that attacks the one piece that we want it to, which is the cost share, it doesn't necessarily do anything with the actual cost of that drug. And to me, it's not always popular to say, but I do see that as like predatory billing. It is a needed prescription. It is a life-changing prescription, but the fact that I understand the need for research dollars, but to me, to target that certain kind of medicine that is a life-requiring medicine and then mark it up so high to be able to support other initiatives, to me, is something that I think we could take a look at and look at that ICER concept to see if there's something we could do there to implement some legislation to lower that cost. And I think that's about all that I had. I thought I had another question for you, but I'm down to scribbling on like little bits of white pieces of paper now.
My phone number.
Yes, thank you very much for coming. And as I said, I think this committee could definitely benefit from seeing the ICER legislation.
Sure, great.
Thank you. Senator Lesser.
Yeah, thank you, Madam Chair. Thank you, Ellen. It's good to see you. I have just a couple of questions. First, I wanted to follow up on some of the Senator Wong's questioning earlier with regard to the 1332 waiver. Specifically, the proposal that he referenced would put Connecticut in a trajectory towards requesting or implementing a reinsurance program. As I'm sure you understand, reinsurance will have the effect of lowering premiums on the exchange, but that is not necessarily the same as lowering costs for people on the exchange. And for folks who are receiving subsidized coverage under the exchange, lower premiums paradoxically could result in higher costs in some cases. Is that your understanding too?
Yeah, reinsurance is, if the state wants to spend money to even out and lower premiums, I'm not going to disagree. I think there are more efficient ways to do it, because every time you give a subsidy to, pass it through somebody else, you're going to lose some money. So I would prefer to see it more efficiently in subsidies. Then you can target it directly to the families who need it. And reinsurance also troubles me just from an economic perspective, and I'm not an economist. My training was in a real science, a proper science. But I concern about reinsurance. Say the attachment point is $100,000, that everyone over $100,000, say a frequent flyer in the emergency room, insurers would have no incentive anymore to try and get that person the services that they need, get them some care management, get them some housing, whatever they need to solve that problem. So I'm worried that it would actually to some extent, make things worse. So I'm not a big fan of reinsurance, but if you want to put money into making subsidies for people, I'd be all over that.
Thank you. So I appreciate that clarification, because when you expressed enthusiasm earlier for the 1332 waiver process, I want to make sure that folks didn't misunderstand what you were saying. And
yeah, I wouldn't have called it enthusiasm.
Yeah. With regard to your concerns about the public option, it sort of reminds me of an old joke. The food there is terrible, and the portions are so small. I'm a little confused, because I understand that the MEHIP program did not work, but given that there is very little, if any, fiscal note for the idea of underwriting, small group nonprofit insurance, if it is in fact unaffordable, so what?
Well, I think the issue of overpromising. I think there are opportunity costs. It is, if we could work on the foundational issues like consolidation and drugs at the same time, that would, you'd have a point. But if we, and Connecticut doesn't tend to do more than one thing at a time, I'm worried that.
With respect, Ellen, I don't think that's accurate. We've raised other titles in this committee, including health prescription drug reform bills. And I noted with interest Representative Nuccio's comments just a minute ago about the ICER legislation. That's something that this committee is looking at. I just don't think that this bill is intending to be an act concerning everything in the world of healthcare.
Well, glad to hear that. That's good. That's really good.
Okay. So the concern is not that you think it's necessarily bad policy or a bad thing to do, just that it may not be the thing that you would focus on if you were chair of this committee or member of this committee. Right.
And I think there's, talking to other nonprofits and to people, I think that it would be good to get expectations to a level that people weren't thinking this was going to solve everything. And there have been people that are really desperate who think this is going to solve everything for them. And I hope it will. But just in case, I think we should be looking at other things as well.
And so just because you support the expansion of Husky A, do you support the additional subsidies for the exchange plans?
Absolutely, yes.
Do you support the expansion of the MedConnect Medicaid buy-in program?
Yeah, I actually spoke to some people at Legal Aid about this, and we had some questions about it, whether it was it the way it was written, it wasn't clear whether that was through the traditional Medicaid program or whether that would be through Access Health and using Medicaid funds in sort of a premium assistance way. That would worry me more, especially for people with disabilities. That Medicaid is built for them. It's comprehensive coverage and has a really good panel to handle people with all the needs for people with, serious illness and disabilities. So I think it would be better to keep it within the Medicaid program. That would be my only caveat.
Yes, it would be within the Medicaid program.
Great. Yes, put that on my yes list.
Great. Thank you very much.
Sure.
Ellen, thanks so much for joining us and sticking with us tonight. We appreciate it.
Thank
Next
you.
up is Holly Hackett, followed by Thomas Burr. I don't see Holly. Is Thomas on?
I'm here.
Thomas, you're up.
Wonderful. Thank you so much. Good evening, Senator Lesser, Representative Wood, and members of the Insurance and Real Estate Committee. My name is Thomas Burr. I'm the Community and Affiliate Relations Manager at the Connecticut State Office of the National Alliance on Mental Illness. NAMI Connecticut is in support of Senate Bills 842, an act concerning health insurance and health care in Connecticut. And for the record, Ellen Andrews is a tough act to follow. A few minutes ago, you heard from Lisa Winjum, our executive director, and you have my written testimony. So I will simply speak on behalf of myself and add that I am speaking as someone who currently works for a nonprofit corporation. However, prior to that, I worked in the high-tech industry as an engineer for over 20 years. As someone who has been a health insurance consumer for over 40 years, I am struck by how many things, cars, cell phones, TVs, have all gotten so much better, faster, and more feature-rich, while healthcare has gotten more and more unaffordable and problematic over this very same time frame. We here at NAMI Connecticut field calls constantly from people who need help getting the health care they have paid for from insurance companies who seem to just want to deny, and deny again in paying for the critical and necessary mental health care for themselves and their loved ones. At this point, like Minister Josh Pahalik, who spoke earlier today, I am simply beyond frustrated with the health insurance industry. They come to these hearings saying things like they want to be part of the solution, when from my perspective, they are just a big part of the problem. For example, it took us 5 years just to get a mental health parity reporting bill passed back in 2019. And that was, in my opinion, only because of the embarrassment from the landmark Witt versus UBH decision in California. Again, an insurance company just being a huge roadblock to good, effective healthcare. In summary, all I can say is that I'm done. The healthcare system is bloated, corrupt, and unsustainable. It provides little or no value to too many people. Bring on the public option. It can't possibly be any worse than what we have now. So please pass SB 842. Thank you. And now I'd be happy to answer any questions you might have.
Hey, Thomas, thanks for staying with us all night. We really appreciate it. Thanks for your testimony. Do we have any questions from the committee? Thanks, Thomas.
All right, I'd just like to add, Senator Wang, yes, we do need a third choice as far as testimony, as opposed to opposed or for, because the marijuana bill's coming up and we're not going to be for or against it, but we want to weigh in.
Thank you, Thomas. Next up is Alan Shakata, followed by John Lazaru. Alan, you're up. You're muted, Alan. Just unmute yourself. Thomas, you are not. You need to mute yourself.
How's that?
Good. We can hear you.
I can't see you.
Okay.
Ah, rats. Well, actually, if you could hear me, that's not the end of the world.
Yeah, go ahead.
Okay. Well, I have a little different perspective. I am actually in the insurance business. I've been the principal owner of my own agency, MacMan Insurance Associates, for almost 25 years in May. Been in the insurance business for about 31 years. I do sit on the advisory board of most of the carriers here in Connecticut. And we as an agency service thousands of individuals, hundreds of small groups, and almost 1,000 Medicare agents as well, Medicare clients. Without directly stating it, this bill appears in the short time that we really had a chance to read it, to be leading us down this path to single-payer healthcare, which it is a little ambiguous the way it's worded, and health insurance is anything but ambiguous. So among some of my concerns that I would like to just bring up, and I've heard over 8.5 hours, quite a few concerns from both sides. And I will say right up front, I am also an agreeer that instead of nay or yay, I would like a third option as well, because there are some things I do like, and if it could be part of a solution, not necessarily one way or the other, it might be more palatable for more people. But some of the things that was in that 35-page bill, page 6, stated that the public option cannot be offered alongside any other health insurance, and lack of competition has already hurt the individual market and the small group market via premium hikes and forcing higher cost sharing ever since the ACA was passed. Pre-existing conditions and market fairness on page 3, section 2 of your bill references the approval of applications. This is worded so ambiguously that it can be interpreted as a violation of the ACA's pre-existing condition protections. It's not clear if the public option has to follow the same guidelines as private options. If it's a different set of rules, adverse selection will lead to a private market share's demise. Claims management, page 7, letter E, paragraph 3, specifically references charging groups to make up for claims overages without specifying when that would be or for how much. A small employer getting a bill 3 months into their plan for double the premium because of one sick employee would ruin a small business, which is why many groups, CBIA being one of them that I've been a member of for 25 years, says 60% of the small businesses are against this bill. But I'm open to hear. Financially, our state is already in the red. The assessment charges laid out on the carriers and participants don't suffice. How does the state expect to handle funding? Will it not be on the taxpayers that are already leaving the state, leaving many states, but this one is difficult right now? The $50 million potential fee for carriers and insurance providers could only result in higher costs on insureds, layoffs at the carrier level, or both, including my own agency. Customer experience, the bill is far too general in describing the applications, servicing, and customer relations processes. It seems to reference using the exchange, navigators, state agencies to manage everyone. These groups are currently understaffed and frankly not knowledgeable or accessible enough to handle the residents they serve now.
Alan, you've hit your 3-minute mark. If you just want to wrap it up, that'd be great.
Okay. Specifically, I just think that would be a little irresponsible to pass this bill, at least until we've had more time to dive into it, discuss it, and maybe find other solutions that they can do, possibly alongside of the private market instead of just getting rid of one or the other. Being I'm over my time limit, I talk too much, but after 8.5 hours of waiting, I finally had my chance, so I'm welcome to hear any questions that you have.
Alan, thank you. We appreciate you waiting and giving your testimony. Senator Wong.
Thank you, Madam Chair. And Alan, thank you very much for hanging in there. And, you know, after 8.5 hours of testimony, I think you present a uniquely different perspective. You're not a big policy person. You're not one of those wonderfully, you know, importantly emotional stories that we've heard, and you're not getting it from politicians and policymakers. You seem to represent a perspective of clients that you serve. And can you talk about where this bill, and you kind of articulated, where this bill lacks significantly in its approach and in its formation of servicing the clients, the people that are looking to use this product and whose lives will be impacted by it? It seems that this entire process doesn't account for what important role you have in working with people that are buying the insurance, getting the insurance. Can you elaborate the kind of the process you take in kind of enrolling them and helping them choose the process, and from your experience, why you think this public option or SB 842 may be lacking?
Well, the devil is always in the detail, and being that there was very little of that disclosed in this bill, it's very difficult to make a educated decision when you don't have facts. There's a lot of innuendos, there's a lot of things that might be, and there's things that can go either way. It doesn't really discuss if brokers are even going to be a part of this. So to answer your specific question, what do I do as a broker? We coddle our clients. We educate them in a lot of ways. We've had clients for almost 30 years, so they know how we work, and they count on us to help them make these decisions. I will never forget when Obamacare was created back in 2010, when it really came into earnest in 2014. Mr. Obama made a statement like, you know, just don't worry about it. You don't need brokers. Just go online, pick your plan, and that's how it will work. And the problem is so many people that we work with, number one, if you go on Access Health, a plan like that, that gives you 75 options, and then there's subsidies involved, and trying to determine what plan makes the most sense. It's not like throwing darts at a board and hoping you get the right one. This is your medical insurance for yourself and your family. We, I believe, understand the needs of our clients far better than people that don't even know who they are. And most of the people we deal with are far more educated now because of us in an ever-changing marketplace. I mean, we are the first to say that the one common denominator in our industry is change. Nothing stays the same from one year to the next because of the metal levels that were created, and because of that, what they call AV calculator that makes the plans differ from one year to the next. A lot of people will say, I'm happy with my plan. I did not get a very large increase. I'll stay with that exact plan. And we have to tell them, well, it's not going to be exactly the same. And we try to educate them. The copay might have gone up a few dollars on an office visit or a prescription or a deductible. That's how basically it fits within the metal level that was created when Obamacare started. I do feel, though, there is some good to Obamacare. We've been able to work with whatever is thrown at us. Our job is to help our clients end up with the best possible plan that's going to help their family. Now, in reading this whole bill, and granted, you handed it to me at 4 o'clock on Thursday, didn't have a lot of time to be able to really understand it. But in reading it enough with two of my associates in my office, there's definitely a lot of vagueness in regards to how many options are there going to be in the public option. Is it one plan or is it several plans? How does a person that's coming to the state for advice, who's going to advise them? Is it going to be a navigator? Is it going to be the people that took over the shop exchange, which was a mess? And I know from firsthand experience, I have a person in my office who worked there until all of them were laid off 9 months into the I'll just say the time of that, and now it's taken over by the state, and it's horrible. It has very, very little traction in the entire group marketplace. But yet, whoever is trying to give all this advice, I don't believe will be as helpful as we are. We are very supportive of our clients, and we understand that their needs are important to them. And you can't just say what one person has, their neighbor's going to want the same thing, because they're all different. In group plans, if you have 2, 3, 4 options in a group, that makes more sense if there is a contribution, because they don't all have the same medical needs. There should be different choices to have. I don't know what those choices are, because the public option, at least in the bill we saw, doesn't really give you a lot of detail on some of the things that I find are very important. But one last piece, the networks that are used, we don't even know who they're using. Is it going to be one of the main carriers? Is it going to be a conglomeration of all of them, or is the state going to create their own network of providers based on however they negotiate with the doctors? The gentleman who ran the doctor of the Connecticut Medical Society hit on a lot of points that I would hit, so I'm not going to go back over them again. But in reality, the doctors are fleeing the state because it's very difficult to work. I mean, malpractice has cost them a lot. They're not making as much. A lot of private practices are joining forces with others, so they maybe can create a large group setting where now they might be able to get better rates. There's a lot of different strategies that go into making sure your clients get the best possible solution. And I do think that the broker, in our case, especially us, because we've been doing this for so long, can give much better advice than maybe somebody from the state who doesn't really know these people.
Yeah, and you raised some great examples. I think the state takeover, your experience with the exchange has been challenging, I guess, being kind. But you also hinted that the insurers aren't always in the best light either, and it's important that both entities look to get rid of your business and your connection to the consumer. And what are your take on that in the sense that the flaws of both entities, and what you would suggest that could be a better solution to reducing costs? You talked about malpractice, you talked about different components, but from a consumer and a direct consumer contact point, do you have any suggestions?
I would love to see more detail on what the public option or options can be and how they could fit in, but I would say side by side with the private marketplace today, as opposed to saying it's one or the other and everyone has to go one way or the other. I just feel like you're not giving employer groups and within them the employees enough options and choices that might be more helpful for them. For instance, in the individual market, totally different than the group market. I get that. Company like Anthem Blue Cross, big company. They have a great national network. Blue Cross is in all 50 states. However, in their exchange product, in the individual plan, you cannot leave the state of Connecticut. Same thing with Husky, can't leave Connecticut. Now that may not be important to some people, but we have quite a few people that live in Fairfield County, where I am, that feel that for whatever they're thinking, that New York has the greatest doctors in the world, the best hospitals, and Connecticut is just not as good. I don't agree with that, but the fact is we have many clients, especially in lower Fairfield County, that feel a necessity they have to go into New York. You can't do that with Anthem Blue Cross now, or Connecticut for that matter on the exchange. I don't know on the public option, is that network going to be Connecticut only, or is it going to be able to allow you access to the country? People that may want to go to Florida in the winter months, or even for a couple of weeks, or anywhere else in the United States, does that mean they're not going to have in-network access as soon as they leave the state of Connecticut, like Husky. Husky is a wonderful tool, and I don't even mind expanding that and making it more available to more people if necessary, but it's an option. I don't think it's an all or none situation because I think too many people would get hurt by that.
And I think it's a fair statement to say that under this proposal and under the materials that you have and your experience with a state managed program that is conscious about managing cost, I don't think it'd be appropriate to use the term that you will be able to keep the same doctors, the same network, and the same choices that you would have prior, as was promised under Obama, the Affordable Care Act. Would that be a fair statement that people should not expect that they should be getting the same thing as they're getting now for the prices that they're paying?
Yeah, I think that's a fair statement. I mean, unfortunately, that's a famous statement is don't worry, you can keep your doctors, you can keep your plan, obviously, and the rates are going to be significantly cheaper. Those are all three fallacies that were just not truthful. Now, I don't know if that was the intent, but that's what ended up. I like to deal with fact. I don't want to keep going on theories and fantasies. I did listen to many of the speakers today who had some really heartfelt stories, and I feel for them. I also have an autistic child, and we live with that. He's now 28 and doing very well, and he's the reason I'm now in Florida and not at your snowstorm, but I'm down here because I like you, Tony, and I respect you, and I said I would testify today because this is meaningful to me. I do feel that I do understand our system the way it is, but I also understand, like I said earlier, changes are very commonplace in our industry. I don't have any problem with creating new options. In fact, I think it's good. I remember when Obamacare started, I was not very much a fan of that. But as it turned out, because the rates did escalate quite a bit, it did a lot of good things for people who really needed to be covered. I would be more of a proponent of possibly raising the amount that you can make to get a subsidy. Instead of around 49,000, maybe somehow make that number 75 or whatever the number actually makes sense to allow more of the middle class people who do make decent money, but not that much money, to now, instead of at 51,000 paying an exorbitant rate, maybe now they would be eligible for a subsidy, and that might make more people a lot happier, because I do feel it's important that they do get to keep their network. Husky, yes, does have some good options, especially for people that do have illnesses, but so do all the other carriers, and they have a whole lot more doctors to choose from in the non-Husky networks.
Thank you. And one last question that you raised that is an important differential in the private marketplace and in all the insurance that you sell, health insurance, the coverage of pre-existing conditions and the abolition of adverse selection processes under the Affordable Care Act. That is a fact in your current private market insurance programs, correct?
Both individually and group. I mean, to even, well, one exception to that, and it's not part of the ACA guidelines, but there are now, in the last 2.5 years and in more earnest in the last year, what we call level funded plans. All the carriers are now offering them in the group market. There's a minimum number of participants, typically it's 5 or more, but what it does is it does get underwritten. It's basically doing, to some extent, what the state at least is talking about, although I don't know because I don't see the details, but it allows the carrier to look at the risk because they do have health questionnaires. And based on the health, they could either say, yes, we'll take the group. No, we're not going to take the group, or we can raise the rate up, which is the way the individual market used to be before Obamacare changed all that in 2014. Now that is a little different because what makes that different in a level funded plan, they don't cover preventative vision and dental for kids. They don't cover in vitro. Those are the two big takeaways as far as benefit. But the big plus that it gives you is if they are taking healthy groups and the groups do well with their loss ratio and they come in below the claim cap, they actually get refunded some of their premium back, which is a plus that all fully insured plans do not get. And those are some of the things that we explain to groups It may make sense for some, it's not for all. That's why I'm not a big proponent of all or none. I just feel that's not really the best method for this state or anywhere else for that matter.
Well, Alan, I appreciate you calling in from Florida, and could I leave with this common thought that I think resonates with your over 30 years of experience, and what I've heard from many of your customers is that you present the facts, you give them the best service that you can, but you never overpromise, and you deal with giving them the information that they need to make the best decision and provide products that offer that. But I think you're very, very conscious and very, very diligent about making sure that you're not going to overpromise that you have all the solutions in this. And that's important to note as we undertake any policy and anything that's so dramatic and so sweeping from the standpoint of the current proposal on Senate Bill A42, that we have to be very conscious that we're not overpromising and not be able to deliver. And
one other point, Tony, if I can make it.
Sure.
The other part that I am concerned with this bill, because I don't know, again, without the detail, when it comes to servicing an account, that's where we, I believe, specialize. When we do meetings for groups, we tell them right up front, whoever we use, whichever carrier it is, and it's very cyclical in regards to rates, they all vary, but now the networks have become much better, much bigger. But the question is, when somebody goes to the pharmacy and the pharmacist tells that person, sorry, your plan was canceled, who are they going to call if they're in the state option? Are they calling the state? Are they calling Mr. Lembo? Are they calling a navigator? Who handles those issues? And the only reason I say that is it's happened to my wife twice. Where they said, no, sorry, your plan's canceled. And she said, no, my husband owns an insurance agency and I pay the bills. The bills have already been paid. We're not canceled. The point being is there what the carriers love to call system glitches. These happen all the time. That's reality. Unfortunately, what we tell groups is there will be hiccups all the time, whether it's in getting your ID cards on time, or a claim isn't handled properly, where we're different than most agencies, let alone the state of Connecticut. We will fight for them, and we will have, because we do have a lot of contacts within the carriers, because we obviously write a lot of business, we will get your situation fixed. And we do it in a timely fashion, because normally they're panicked. They're at a doctor and they said, sorry, you can't go for your surgery tomorrow. Yeah, we pre-certified it, but now we see your plan's not active. Well, we know it's an issue, but we know we can fix it. I would love to know, how is the state going to do that, and who's going to do that for our clients? They're used
the devil's in the details, right, Alan?
That's correct.
So thank you very, very much, and thank you, Madam Chair, for the indulgence. And I just was told by family that it's National Pizza Day.
Well, good. Then you could have dinner once. I have yet to eat.
Yeah.
But that's okay.
Thank you, Madam Chair. Thank you, Alan.
Thank you.
Thank you, Alan.
You're welcome.
Next is John Lazaru, followed by Ashley Starr Frechette. Hopefully I said that correctly. John, are you with us? Yeah, I can see John if you just want to take yourself off mute. Okay, we can come back to John. Ashley, are you there?
All right, sorry, can you hear me?
We can hear you.
Great, thanks so much. So good evening, Representative Wood, Senator Lesser, and members of the committee. My name is Ashley Starr Frechette. I'm the Director of Health Professional Outreach at the Connecticut Coalition Against Domestic Violence. We're the state's leading voice for victims of domestic violence and the agencies that serve them. We have 18 member organizations across the state that work to serve almost 40,000 victims each year. So I'm here tonight to ask you guys to please support House Bill 6389, an act concerning explanation of benefits. As a few people talked about earlier, EOBs currently are automatically generated by health insurance companies, and they're sent to the policy holder of that insurance policy, not directly to the patient who sought that service. The inability to control where these automated statements go disproportionately impacts vulnerable patients like victims and survivors of domestic violence. Many victims and survivors are actually on that same insurance plan as the person that is abusing them, making this current practice extremely dangerous to individuals dealing with this. So intimate partner violence is, as we all know, it's a national public health concern. 1 in 4 women and 1 in 7 men have been severely abused by an intimate partner at some point in their lives. And in fact, here in the US, intimate partner violence is actually more common for women than breast cancer and diabetes combined. IPV takes an incredible toll on the physical and emotional health of victims and survivors, and it leads to increased need for medical services. The way that Connecticut is currently allowing EOBs to be automatically generated and sent directly to the policyholder, not to the patient who physically sought those services, can put victims of domestic violence in serious danger. It may also prevent them from seeking necessary services due to the concern that the abuser would be notified. This may also prevent, nothing has highlighted this need more for this bill than this COVID-19 pandemic, which brought on an increase in the complexity of the issues that our survivors are facing. With everyone stuck at home, the need to ensure that these automatically generated EOBs wouldn't be the reason that a victim or survivor is put in harm's way is really important. Currently, HIPAA prevents medical providers from disclosing most aspects of patient care, and we think that insurance companies should be held to that same standard. So passing House Bill 6389 would allow victims to choose a safe and appropriate method of receiving their EOBs without the fear that the abuser would get a copy. So I strongly urge you to please help protect victims and survivors of domestic violence by passing this measure. I also wanted to mention that CCADV does support Senate Bill 842 to increase access to affordable health care for immigrants and providing a choice between private insurance and publicly sponsored plans. We think that should be a priority. Affordable health care for all is essential for victims and survivors of domestic violence, especially with the increased need for health care services. So we hope that you will consider both of those requests, and thank you for the time tonight.
Ashley, thank you for spending so long waiting to speak. We appreciate your testimony. Any questions from the committee? Representative Dathan.
Thank you so much, Madam Chair, and thank you, Ashley, for your heartfelt testimony this evening. It is really important that we support victims of domestic violence. I know a few other states have similar bills. Have you been able to connect with any of maybe similar agencies that advocate on behalf of domestic violence victims on how this initiative has helped their communities?
Thank you so much for the question. That's a great question. So Massachusetts has a similar bill that works really well and has been very helpful because it's such a simple thing that can be done to help people from something that could be so dangerous. And also Futures Without Violence, their national leader for all things domestic violence, and they also support this and have helped us with the language for this.
Great. I really appreciate you testifying. Have a good evening. Thank you for waiting.
You too.
Thanks, Ashley. John Lazaru, you are up, followed by Natasha Aziz.
Hi, sorry about that. I'm actually at work. I was hoping to do this early in the day, but it didn't happen.
Well, thank you for waiting so long. We really appreciate this.
On top of all, when I got to work at a group home, come to find out one of the staff possibly has tested positive. So in a contaminant situation, we're in full PPE. I will talk loudly and do the best I can. So good afternoon, Senator Lesser and Representative Wood, and members of the Insurance Real Estate Committee. My name is John Lazaro. I work for 16 years in this field. I'm a member originally of Tri-County ARC and ultimately for whole life. I work in Down syndrome group homes. I work with the mentally handicapped. It's a great field. I love what I do. I love working with the clients. They're really the best people on the planet. They don't really care about anything except that you showed up to take care of them. They like music, their games, going out on outings. Hopefully we could start doing that again. But I'm here to testify today in support of Bill SB 842, because even though I love what I do, the insurance is simply unaffordable. The family plans, let me just pop my mask off. I'm in the back of the med room here. The family premium for our family health plans are just astronomical in our division. The bottom rung plan, like if you get just the basic coverage, you're looking at like $800 a month with about a $12,000 deductible. If you want to get something that's actually like real insurance, you're looking at something anywhere $1,300 to $1,400 or more and a $7,000 deductible. In putting that into perspective, that's roughly like a $1,400 mortgage. That's more than my car insurance, utilities, food, almost everything combined. If I tried to get a loan for that at my income bracket, I mean, a loan officer would laugh at me. We do not qualify. Yet somehow I'm expected to pay that, no questions asked, for the insurance. I mean, if you compare that to what my workers and I make as a wage, it's about 50% right out of the gate of everything that we would earn for a full-time paycheck. That's $16.80 an hour, $2,688 a month. You're looking at about, if you hit your deductible, you're looking at about 71% of a total full-time paycheck before taxes, before anything else is removed. It's simply undoable. In addition, my wife, who's a para in the school system, is in a similar box. Paras are not allowed to have family insurance. They can only do individual plans. So we're left in the really terrible spot of both her and I have basically the bottom rung catastrophic plan for ourselves. Our kids are precariously covered by Husky because we just slide under the cap, but it could go south of the border at any moment. Where, now, if I'm frozen for an extra shift of overtime, that could make all the difference in the world. We could be over the cap. Now, we're doing everything that we can. There are many workers like me in this box where, you know, we could have, one of us could have dropped our job, gone on food stamps, lowered our income and qualified for family Husky, but that doesn't seem to be the American way to do this. We're doing it the right way. Both my wife and I are working full time. We're pulling ourselves up by our little bootstraps and trying to do the best we can, but we're literally being priced out of the insurance. The family insurance plan, we're literally boxed out of. There's just, I work with so many of my fellow union members that are, this is the number one thing that sinks us.
John, thank you so much for sharing your testimony. I can feel the stress in your voice for how hard this is for you and your family. And I can see you're at work and probably waited for a really long time to speak. So it means a lot to share this with us. I was wondering if you could elaborate a little more. Are you using the Access Health CT as a place to go for your healthcare, or are you using a private broker?
For the renewal for the Husky, it's the Access Health. The rest, for my wife and I, we use really whatever our employers choose. I kind of laugh when you have people come on and say that, well, we're here to offer a variety of choices. You don't really have a choice. Whatever your employer chose and essentially steam shovel down your throat, that's the plan. Right. If your doctor's in it, they're in it. If they're not, you pick another doctor. And for many of us, I mean, example myself, I have a $6,700 cap before my insurance pays anything. I ended up in the hospital mostly from the stress of the COVID situation and everything, working here at work. You never know when you're going to be relieved or someone's going to call out because they're sick. Ended up in the hospital, blood pressure 196 over 118, hit with a hospital bill of $3,000. I'm not at my cap. There's nothing else to do but throw it on a credit card. I don't want to destroy my credit. It's going to take years to pay it off. And by the time the program, you know, you reach to the end of the year, you may or may not hit the cap. You probably won't. It's $6,700 and it'll just roll again. I mean, all of our debt that my wife and I have accrued is primarily doctor bills. That's it. That is the number one barrier between us and the American dream for myself and many of my fellow union workers. I don't know for certain if this bill is the 100% fix. I don't know that. But for where we're standing at right now, anything is better than absolute failure. Where I'm at right now is paramount to nowhere. There's no way out of this box. If you're a family in Connecticut under, say, 85, 90 grand, I don't know what you're supposed to do. This healthcare right now for a family, for many of us, is literally one full-time job just for that. And that's before housing or food or anything else gets added to it.
Right. John, thank you. I'm going to pass it over to our colleagues to ask you some more questions. We have Senator Anwar.
Thank you, Madam Chair. Mr. Lazaro, thank you so much for waiting the entire day. And I apologize, some of the legislators may have taken longer with some of the people to make some points. But I do, what you said is something very powerful. What you said to us was that, do we have a perfect bill? But in the presence of a failure, a slightly imperfect bill is better than the current failure, because we as a state are failing the people, working people. And then if you look at the Alice reports, we actually have the working poor is increasing rapidly, and the ability for people to get insurance is decreasing. So that's exactly the challenge that we have. We have spent about 2 hours talking to a salesman on insurance to prove a point that business or that individual would be impacted. So I am just heartbroken with what we have done to our community and our state. And I'm so thankful that you have come and spoken, and so many more people have come to speak about the truth, their reality of what they're facing every single day, rather than some of the alternate realities that people are experiencing. We have the responsibility to take care of the people who are vulnerable, who are hurting. And I'm so glad that we have a bill that can at least start to address this. And thank you so much for saying, and all of us have heard you, the wait was worth it. Thank you. Thank you so much.
Thank you.
John, thanks for coming on. Next up, we have Natasha Aziz, followed by Allison Weir. I don't see Natasha. We'll go to Allison Weir, followed by, and then Dr. McLean is after Allison.
Thank you, Representative Wood, Senator Lesser, and members of the committee. My name is Allison Weir. I'm with the Greater Hartford Legal Aid. I'm a policy advocate, and I'm writing here in support of SB 842, especially the Husky expansion provision. And I urge you to consider expanding the income limits for all adults covered under Husky. I've submitted written testimony, so I won't dwell on too much, but I just want to add a couple points. The income limits under the 3 Medicaid programs for adults, Husky A, Husky C, and Husky D, are all substantially too low. While children under Husky A are eligible with family incomes up to 201% of federal poverty level, their parents are only eligible up to 160% of federal poverty level. It's even lower for adults without children covered under Husky D, who are covered only up to 138% of poverty level. And for adults who are elderly or disabled covered under Husky C, the income limits, which vary by regions in the state, don't even reach 95% of poverty level. We urge you to consider moving income limits up for all adults to be covered, comparable to children. Increasing the income level for adults becomes even more important as the minimum wage increases. Legal services, of course, supports an increase in the minimum wage. However, one unintended consequence of that increase is that people get closer to the benefits cliff for Husky. It was mentioned earlier that the bill will provide subsidies for the exchange for up to 200% of poverty. But even with that, the out-of-pocket costs could easily eat up any wage increase from an increase in the minimum wage. For example, a single person working part-time at minimum wage for a $12 an hour currently earns, say, $17.70 for 17,774, which is 138% of the federal poverty level. Raising the minimum wage to $13 an hour pushes him over the limit with an annual income of $19,000. But with that, even even the subsidies are entirely covered, the premiums are entirely covered, the out-of-pocket costs of $2,500 for the year would eat up all of the additional wage he's made. So we really ask you to consider raising the income level for Husky from Husky D as well as Husky C, where the income levels are so low. And these are people who can't work. And the 95% of poverty level is nothing. And if they don't have that, then they don't have Husky C, they don't have any insurance really, because they have so many out-of-pocket expenses. Even if all the premiums are covered, it'll really be detrimental. The other thing about increasing Husky is that 50% of the costs of restoring the income limits would be covered by the federal government under the federal federal Medicaid match, which would increase Connecticut's expenditures. Increase the impact of Connecticut's expenditure, and also bring in more federal money into the government. So I'll try to, in the interest of time, cut my comments short. But if you have any questions, I'm happy to answer them.
Thank you, Allison. Any questions from the committee? Senator Lesser.
Thank you, Madam Chair, and thank you, Allison, for your testimony, and I guess everyone for their perseverance at this hour. Obviously, I understand why Medicaid advocates are looking for higher eligibility thresholds across the board. I think that's self-explanatory. You made a very good case. The bill does, where outside of Husky A, require that the exchange. I don't know if this is a much consolation or not, but the exchange eliminate premiums for everyone under 200% of poverty. I understand that the exchange is not necessarily appropriate for everyone, and that may leave some cost sharing problems and may not work for some of the older folks on Husky C that you were describing. Would that be a significant positive step, or are we chasing the wrong goal there?
I think for Husky D, for the adults without children, it'd be a significant positive step. But Husky C really does need more structural supports. I appreciate also that the bill makes it easier for people to connect into the Connect program. But the folks who are in Husky C at the low income level point, they're really kind of stuck. They can't work. I think we've heard testimony today from folks who've said this has been a real problem, even trying to get an employer, even if you could work just a few hours a week, just to get an employer to agree to schedule that.
Got it. Thank you. I think one of the struggles that we're having is just keeping the price tag affordable. And so that's why, if we were going to raise eligibility to one level, it seems like Husky A was the lowest hanging fruit there.
Certainly understand that. But, I again, policy advocate, wanting to help our clients as much as possible.
Totally understandable. And I'd be doing the same thing if I had your position. So that makes total sense. Thank you.
Representative Farrar.
Thanks. Hi, Allison. Following up a little on what the senator covered, one of the things we heard from the previous speaker, and you got into a little bit, is really the effect of the benefits cliff on so many families. And I was wondering if you could kind of speak to how you feel like this proposal resolves some of those cliffs, and as you said, where there's more work to do.
Well, certainly raising the Husky A for parents helps the benefit cliff for the family generally. It also makes a lot of sense in that if parents are insured, the kids are more likely to be insured. We've seen a lot of research showing that kids who may be eligible for Husky aren't necessarily enrolled in it if their parents are enrolled in it. So keeping the family intact really does help a lot with that. Again, with the benefits cliff as well, a family of four, we've heard just the speaker before, his kids are covered, but he and his wife are having a lot of trouble, and he's, thinking about not taking overtime, or just if he takes overtime, could easily get pushed out of that and the kids won't be covered either, which is another situation beyond the 201. But certainly the 201 for Husky A is a big step in helping reduce the benefit cliffs for the family.
Thank you. Thanks for being here.
Representative Nuccio.
Hi, good evening. Thank you, Madam Chair. You know, I haven't said that today, and I'm sorry for that. I keep slipping my mind, but thank you. Good evening, Ms. Weir. How are you?
Well, thank you, Representative.
Thank you for sticking around with us. I think Representative Farrar just kind of took what I was going to say a bit. I understand you just pointed out a very pivotal piece of information. As we increase the minimum wage up to $15, it is going to continue to push, you know, the intent of that is to the workable wage and everything else, but it's also then going to push people out of the range of subsidies. And the next dollar cliff is something that is very real, that I think hopefully we will be able to look at and expand and try to come up with a sliding scale, because just because you get to one level doesn't mean you still couldn't use a little more help. Maybe you don't need 100% of the help, but you still need a portion of the help. So you pointed out a very good thing for us to hear, to remember, and then to commit to working on. So I appreciate that.
Thank you.
Allison, thanks for joining us. Next up is I'm sorry?
Thank you very much.
Oh, you're welcome. Oh, I love your cat. All right, Dr. McLean, followed by Merrill Gay.
Great, thank you. You can hear me okay?
Yes, we can.
Super, just want to make sure, thank you. So I think you were expecting Dr. Robert Russo from the State Medical Society, but since the Medical Society actually already had a chance, he graciously gave me his slot. I'm Dr. Robert McLean. I want to thank the chairpersons, Senator Lesser and Representative Kerry Wood, and the rest of the members of the committee. I speak before you as an individual living in Connecticut and as a physician practicing in New Haven for over 25 years, and as the immediate past president of the American College of Physicians. I'm here to speak in support of Raise Bill 842. This bill, once it becomes law, will help the state of Connecticut take a significant step forward in efforts to provide affordable health insurance coverage for all of our citizens, and therefore I really urge you and the General Assembly to pass it. I've been concerned for quite some time about the inequities across our state regarding affordability and accessibility of both health insurance and healthcare itself, as many have raised. We have found ourselves in a dysfunctional and disjointed healthcare delivery and payment system that leaves way too many people out. The Affordable Care Act in 2010 made some steps forward in increasing availability, a great deal, and affordability only somewhat, and of health insurance, and to many through the state health insurance exchange. Yet, yes, people can buy health insurance, as some have said, but the small business component never developed as envisioned, and high deductibles and copays still make healthcare unaffordable for many individuals. The presence of some sort of public option plan as envisioned in this bill will go a long way toward filling those remaining gaps. Over many years, I and others I've seen on this meeting have been involved in state government directed initiatives around health reform, ranging from the Primary Care Access Authority back in 2007 to Sustanet proposals in 2009, which is where I first met Comptroller Kevin Lembo, and to more recently, the Health Innovation Steering Committee under Lieutenant Governor Wyman. I have closely witnessed many great ideas go nowhere due to both budgetary restraints and powerful opposing interests. I believe many of you do believe that your responsibility as elected public servants is to help the individual citizens of Connecticut. When I was president of the ACP last year, I was involved in the development of a series of policy papers around comprehensive health reforms needed to address the ills of our current healthcare delivery system. In the testimony that I submitted, there's a link to that. The first of those papers address coverage and cost of care, and I really would encourage you to look at it. Based on extensive research of strategies tried in different states and countries and on the simple fact that our existing healthcare system is, quote, inefficient, unaffordable, unsustainable, and inaccessible to many people. The ACP in those papers stated that one path to achieve universal coverage that was affordable within our current pluralistic system would be to incorporate a publicly financed coverage option. I think you realize that this would not simply be Medicare for all or Medicaid for all. There are significant problems, as some have raised, with current Medicare and Medicaid payments to both physicians and hospitals. Payments in any public option cannot be based on those rates alone. It would not be financially sustainable for small physician practices or hospitals and health systems to live on those. And some of those entities actually may be opposing this bill or aspects of it because that payment uncertainty is not explicitly addressed in all of the language of the bill.
Dr. McLean, if you could wrap it up,
Yep.
your 3 minutes is up.
Absolutely, thank you. To many of our small employers and individuals who cannot obtain adequate health care and affordable health insurance in our state, I urge us to support this bill. And I'm happy to take any questions. Thank you.
Thank you. We do have questions. Senator Anwar.
Thank you, Madam Chair. Thank you, Dr. McLean, for waiting all day and then for the testimony. Again, I know you well because you have been the president of American College of Physicians. That's a national organization. So it's a source of pride for all the physicians in the state of Connecticut that a Connecticut doctor was the leader for the entire United States for the American College of Physicians. And do you know the membership? I was last looking, it's like 160,000 physicians across the country.
Over 160,000 specialists in general internal medicine and specialists in internal medicine. So there's about 20 or 30,000 that are medical students, a lot of residents, a lot of practicing doctors, doctors across all sort of practice settings, medical specialists, as I say. Yeah, it's the whole gamut. It's a wide spectrum of a lot of physicians. And a lot, I would say probably of the general internists, most of them are doing primary care. So a lot of the push behind this comprehensive health reform really was looking at the importance of a primary care backbone, which is kind of a whole nother topic we could speak for a couple hours about. But I know that, you know, the state has been trying for years to try to figure out how to incentivize that and make that work better.
Now, this highly specialized, becoming an internal medicine specialist takes a lot of effort to get to that point. I know that because I'm an internist myself, and before I became a specialist as well. But I want to mention about in 2020 in January, the Annals of Internal Medicine, which is one of the top medical journals, there was a very strong position or a prescription from the physicians across the United States was written. Can you speak to me about that, please?
Sure, I made reference to, so the paper, the series of papers, essentially the American College of Physicians had been pushing for really comprehensive health reform for many years and supported the Affordable Care Act back in 2010, not because it was a perfect bill, and this is not a perfect bill, and as you have said, it is a foot in the door to do something that we need to do. When we have a system that is so dysfunctional, we have to stop accepting imperfection, or we have to accept that we have failure for so many people, and we have to do something. So the ACP, you know, saw the ACA for all of its good. As I say, it made healthcare more available, but quite frankly, it just wasn't affordable for many, many people. We've all lived that, and the exchanges are great in terms of what they tried to do, but they are simply too unaffordable in many ways for many people. The high deductibles, all that stuff. So the ACP said, okay, listen, you know, the ACA is not going far enough. What can we do? What do we need to do? And they really went out and they said, what has worked and what has not worked in different states, which has served as pilots in some ways, some of them with public option kind of programs, and in other countries. Clearly, you can't take what's happening in social democracies in Europe and bring that over to our, you know, multi-pluralistic country. They're different, but there are things and aspects that worked and what works and what doesn't. And their conclusion, with the goal being we need to have a healthcare system across this nation that does not have job lock, as somebody talked about earlier. So you have to kind of try to move away from some of the employer bases. You have guaranteed coverage, you have universal coverage and affordability. And they came to the conclusion that a purely market-based solution does not work. It will not get you there. Healthcare is too expensive to rely on the market to do too much. And if you're going to really look at, if we're going to blow it up, although we can't, how would we get there? There were two options that actually made sense that they led a path to in these series of papers. One was a multi-payer option, which includes a public option in a way to keep the market honest, which is what you all are talking about here now. And the other one was what a lot of people want to hear, but a lot of other people don't, which is a single payer finance system, which has a little bit of a cultural shift than the others. But those were two systems which they lay out a path could get you to where you need to get. So the public option within still allowed a multi-payer pluralistic system. There's a path to get there. And I think that is what a lot of people favor. People, especially who live and work in the insurance industry, we can't discount that. But I think we have to recognize that leaving this to the market alone, you're not going to get affordable, accessible health insurance for everyone.
So, and this was written before the pandemic.
Absolutely, it was published in January of 2020. I mean, these are old problems. Yeah.
Right.
The pandemic, though, to your point, I think, has shown that our backbone, our system is broken. The public health aspect of it was broken. We couldn't do stuff that we needed to. I mean, it had been underfunded and undercut for a number of years in the recent administration. There are multiple, blistering sores, to use a medical, visual, that were demonstrated from the pandemic. But it merely demonstrated what had been there for a long time, and we all knew it. And all you had to do is talk to the people who have struggled getting health insurance, getting coverage. Many of them spoke eloquently today from our state. I think it was John Lazaru a few people ago. He basically said, there's no choice. If you're lucky enough to be employed and they offer insurance, you don't have a choice. You're given what the employer gave you. And if it has a high deductible that you can't afford, you're stuck. So I think you have to recognize there are certain aspects people like the choice if they are in an employer that offers choice. Sometimes there's a little choice, not a whole lot, but it's broken. And we need to kind of get at it. We somebody else said tonight, let's stop talking about numbers and taxes and that. Let's talk about people's lives. I mean, the people who told some just really sad stories of struggles. It was heartbreaking. And that's reality, and the state government has a role and can do so much if they're willing to start to go down this path.
This is very helpful. And right now, I think some of the people are trying to push for the status quo, despite the ground reality and the worst or terrible case scenario that we have seen post-pandemic, to say that, well, stay the course and continue this, and it's going to market pressures are going to fix things. It is going to be irresponsible to stay that course and then try to find technicalities, minor technicalities, and some specific sales industry people or analysts for these insurance industries would come up and then give rationale to try and protect their jobs. So I truly value what you're saying, and the fact that you're a practicing physician, the fact that you have been a leader at the national level of one of the largest medical organizations, and the fact that this organization has publicly stated that public option is the way to go to save the lives of the people. And then that's the prism that you've looked at. And you've also called about sustainability in that. So, and could you speak to the sustainability? Because people are saying, well, this is not going to be sustainable.
Well, I mean, there's a lot of talk about that. I think you have to figure out money is going to be spent on healthcare by somebody. It's going to be spent by individuals through taxes are helping pay for Medicare and Medicaid. People are potentially not getting paid as much as through their living wage because their employer's paying benefits. I mean, the employer-based system is tremendously complicated. I think that people had frustrations with it because of job lock and those issues. I think that the pandemic, when so many people lost their job, I think raised some real awareness of the weakness of the employer-based system, because when they lose their job, they lose their insurance. And then suddenly they're scrambling and they're trying to get on Husky or Medicaid or see what they're eligible for, or maybe they can buy it from the exchange, but they can't afford the exchange premiums. And if they can do that, they can't afford the deductibles. So it's this just horrific circle or cycle that people get into of not having money to pay for insurance. And then they go, well, if I'm really sick enough, I'll go to the hospital. So then the hospitals pay for it, or don't get paid for it. So then the hospitals have to go to the state and say, we have this unfunded, huge amount of money that people never pay for. So because we give all this charitable care, you have to reimburse us on this. So you get all the cost shifting stuff. I mean, it's a mess. It's incredibly complicated. We cannot blow it up and start again as much as many of us would like to. And so how can we start to kind of chew at the problems around the edges? Probably the most feasible thing that I think will help the state get a handle on this is something like is proposed in this bill. It's not wrapping in, Medicaid to this. I think a lot of people say, why don't we do that? Then your numbers are bigger. It's just, that's too big a nut to crack right now, as much as I think that would be a great idea. But it's huge. And I think this is one step. It's not perfect. It's not addressed every little nuance and ambiguity, as many have said. I think it has to go forward with kind of the right incentives and some of the nuancing that probably needs to still be worked out. But it is a step forward that is just critical. And as you said, the status quo is not acceptable. And the pandemic has clearly shown that.
Thank you so much, Dr. McLean. Thank you for your testimony and time you've stayed with us all day today. Thank you, Madam Chair, for allowing me.
Fascinating to watch, I'll tell you.
Dr. McLean, thank you for joining us. Next up, we have Meryl Gay, followed by Torino Jimenez.
Senator Lesser, Representative Wood, and members of the committee, thank you for this opportunity to testify. My name is Meryl Gay. I'm the Executive Director of the Connecticut Early Childhood Alliance, and I testify on behalf of our 94 members in favor of Senate Bill 842. There are three primary reasons we support this bill. The three big things this does is to restore the income eligibility for parents up to 201%. For our members, many of whom are child care providers, there are a surprisingly large number of our members who fit into that 10,000 or 11,000 parents who lost care when this was changed in 2015 or 2016, I guess. The next thing that we support is the creation of a public option, because many of our organizations are either small businesses or small nonprofit organizations. And anything we can do to figure out a way to reduce their costs and provide better quality care, better quality insurance plans for those small businesses is particularly helpful right now as the childcare industry is reeling from the impact of the pandemic. And then finally, the expansion of subsidies to support the undocumented workers who do some of the hardest work and lowest paid work in our economy, who right now are effectively cut out of the healthcare system. They can't be on Husky, they can't use the exchange, and so there's not much left for them. So those are the three reasons that we support this bill. I've had childcare providers talk to me about losing their coverage when the income limit dropped on Husky. I've had providers talk to me about when a spouse lost a job and therefore they lost the health care that they had, not being able to figure out that when they took COBRA for a month or two until they realized that they couldn't afford it, that then made them ineligible to get onto the exchange for months until the next open enrollment period. So this is a real problem for lots of people right now, and I urge you to support Senate Bill 842. I'd be happy to answer questions.
Thank you. Representative Comey.
Okay, thank you. Hi, thank you, Madam Chair. By the way, you are doing a fabulous job. I appreciate everything that you're doing here. Hi, Meryl. It's good to see you, and thanks for hanging in with us for this long day. I know that you said that you represent an early childhood industry of 94 members of your organization, but I also happen to know firsthand that you advocate and work with on a daily basis with 300 or more providers and folks in the industry. So let's not sell yourself short there. But you were talking about, I wanted to talk with you about the fact that we all know that our economy and our economic success is really strictly linked to our ability to find affordable and quality childcare. And I was wondering if the impact, you just briefly touched on the impact of the small business owners. Can you talk a little bit about what happened during COVID and how programs have had to reduce their numbers of kids that they're serving, and what that has meant to their programs, but also the teachers and the people that work for them?
Yeah, so we're at about 70% of the capacity we used to have pre-pandemic. There are programs we're told to reduce the number of children they could have in the classroom to help promote social distancing. And particularly in the cities where a lot of the school districts have gone hybrid or fully remote, it's dramatically impacted the number of parents who are participating in preschool programs. So in the big cities, most of the preschool programs are operating at about 50% capacity. That's meant that staff's been laid off, and it means that those childcare providers are really struggling to stay afloat. The healthcare in, all those folks who've gotten laid off have lost their health insurance. And that's if they offered health insurance in the first place, particularly some of the small business ones that are not part of the school readiness program. They don't get any subsidy. There are a number of them that have not been able to offer healthcare plans to their employees. And so those folks are really struggling for an affordable option. They know that it's hard to retain staff when you can't offer them a health plan, but they aren't in a position to do it because they're barely hanging on.
And I think, I had heard some stories as well, Meryl, that there's a lot of job sharing. They're keeping their staff on because they're hoping to get back out, after post-pandemic, that they're hoping to get back to full operating and it is so difficult to find early care teachers, and that they're doing some job sharing and things like that in order just to give everybody a little piece of the pie, if you want to call it that.
Yep.
And then and by the way, the reduced number of slots is not just happening in the cities as well. We have programs here in the suburbs that are not full, that have room, and it's, as you know, difficult to keep the business going. Is there anything that you think that can be done to maybe improve the ability to hire, to find to retain these workers, and do you think that in your stories with health insurance, is that a number? What do you think it is on the priority list?
Well, certainly during a pandemic, everybody's awareness of health insurance is a lot higher. these have typically, childcare jobs have typically been low-wage jobs. They, in some places, they have been the sort of second job in the family, and there's somebody else in the family who has health insurance, and that's how they've made it work. But now, particularly as other breadwinners in the household are getting laid off because of COVID, you have families who used to be covered now finding that they are without coverage. We had one provider who talked about her husband losing a job in Massachusetts. You know, they were dealing with an HR department in Massachusetts. They elected to take COBRA and then realized they couldn't afford it because not only was he not working, her revenue from her family childcare business had dropped substantially. And so they dropped the COBRA and then were told by the exchange that because they'd accepted COBRA in the first place, they were now no longer eligible. They could not use the sort of life event of losing a job as the reason to qualify for the exchange outside of the normal open enrollment period. So, you know, those sorts of things, but just it is very clear that the issues of the childcare industry are, you know, both low wages and lack of benefits. So, you know, we have a complicated issue there, but this bill would help a lot in increasing the eligibility for Husky. I worry that there are families out there where the parent is not eligible and they don't realize that their child is eligible. They assume because they're not eligible, their kids aren't as well. And I think that there's national research looking at the data where there have been changes to show that you have a lower percentage of children insured through the Medicaid program when their parents aren't eligible. So I do think that the simpler we can make it, the better.
And they also happen to be more majority women and minority owned businesses as well, yeah, who are also being impacted most by the current pandemic and things like that.
Yeah.
Thank you very much, Sharon. That's all.
Thank you.
Meryl, thanks for staying on with us tonight. Next up is Torino Jimenez, followed by Taylor Biniars. And I apologize if I'm saying any names wrong. Taylor, you can go next. Following Taylor is Ellen Zinzer.
Okay, just want to make sure. Can everyone hear me?
Yeah, we can hear you.
And you got my name 100% correctly, by the way.
Good.
I'm a little shocked. Dear members of the Insurance and Real Estate of the Connecticut General Assembly, my name is Taylor Biniars. I am from Ellington, Connecticut. I support Senate Bill 842, an act concerning health insurance and healthcare in Connecticut. It would make healthcare equitable, dependable, and affordable by creating new public options for health insurance in our state. I am 24, turning 25 this June, and I am paralyzed by insomnia most nights thinking about what happens next year. I actually work in this field, politics, but with no degree, it's mostly seasonal, which I don't hate, but it's not like seasonal political jobs come with benefits. I want to briefly mention a few things that impacted me. I sprained my ankle 3 times in one night. The doctor said it literally would have been better if I had broken it. I actually thought I had broken it, but I waited until the morning to go to an urgent care as my copay for that was much cheaper than going to an ER, even though I was in a lot of pain. This Saturday, for those who know me for more than 10 minutes, you know that my dad is my best friend. He had a heart attack. Thankfully, due to quick medical care, he's doing well. But the second thought that I had after that was about money and the cost that it must be. And while it shouldn't matter, he has a really good job. I breathe through my mouth. I haven't been able to breathe through my nose since I was 6. It doesn't seem that important, but it makes me more vulnerable to cavities, which I cannot afford. And I don't expect my parents to pay for them. So I stopped going to my dentist 3 years ago. When I can't afford to go, they will probably be root canals. Lastly, I've been depressed since I was 11, in therapy since 15 years old, and on medication since 17 to deal with it. I have dealt with cutting and I'm not ashamed. My therapy has gone back to once a week, which is $25 per copay. It is $100 a month and $1,200 a year. It may not sound like a lot to some of you, but to me, it is everything. And the root of my fear for next year is if I can survive without it, if I have to. Basically, every other civilized country does this, and there's no excuse beyond capitalism and greed for why we do not. I know that there are a lot of facts that others will testify with, but this is my life, and one life is worth more than all of the profit. I am ashamed that our country hasn't realized that yet. Thank you.
Taylor, thank you for coming and sharing your story with us. It's a very powerful one, and I appreciate you waiting for as long as you have and taking the time to talk with us tonight. Questions, Senator Anwar?
Thank you, Madam Chair. I'll be short. Thank you, Taylor, for waiting the entire day, and thank you for coming and speaking. And send my love to your father. He's an amazing person. I know you, I know him. I did not realize he had a heart attack, and I will call him too. But again, your testimony it touches my heart as well. And most powerful word I hope some of my colleagues would hear is that they look at numbers, but they're not looking at lives. And today, enough people have come and spoken about how lives are being impacted and hurt and harmed. And they will count their pennies and they will work for insurance industry to do what they can. But it's important for us to recognize that we are elected by the people to represent and protect you. So thank you so much. Thank you.
Thank you. I'll pass it on to my dad.
Yes, Taylor, best wishes to your dad. Thank you. Next up, we have Alan Zinzer, followed by Betty Bakley.
Hello, my name is Alan Zinzer. I live in Woodbury, Connecticut. I'm a small business owner. I'm actually a business broker, and so my job is getting inside the guts of Connecticut's privately held businesses and understanding the challenges in terms of what drives value, how they transition them, and inviting new owners in to take over ownership. You know, Senator Lesser earlier today made a very interesting point about State Bill 842 enhancing the relative attractiveness of Connecticut as a place for small businesses. And this really was kind of one comment, but it really is very, very true. And I think as a business broker who's actively involved in the small business sector, I want to kind of testify to the truth of that. Many of the businesses that I have for sale are really attracting an active response from surrounding states. Some of our buyers are coming in, a lot of buyers coming in from New Jersey, from New York, and we're really able to kind of sell them on why Connecticut is an attractive place to do business. And a lot of that has to do with high per capita incomes, our beautiful landscapes, access to major metropolitan regions, good schools, healthcare, a good healthcare infrastructure, and really what's important, like even what's today, is really accountable and transparent state and municipal governments. And one of the things that with this bill is we're really going to be able to offer them an ability to leverage on the state of Connecticut's buying power in the state insurance markets. And that is going to be a huge advantage, not just for owners and their families, but for employees and retaining key employees. And this is really a slam dunk, business-friendly kind of act. And I'm very, very happy to testify to that. On Friday morning, I joined the Public Policy Committee of our local Chamber of Commerce. And, you know, they end up voting against it, using a lot of the kind of familiar sounding doublespeak that we hear, that this is a government takeover. And even earlier today, we heard from industry representatives talking about a fair and level playing field. But really, this is, again, doublespeak, because their fair and level playing field is a very fractured and inefficient market for people like me, small business owners, to get coverage for myself, my family, and my employees. This is a really badly needed bill. Thank you for your efforts, and thank you for hearing me today.
Alan, thanks again. You've heard us say to everyone, we really appreciate you sharing your story and spending so much time to share it. So I appreciate it. Senator Lesser.
Thank you, Madam Chair, and thank you, Alan. I think I heard you earlier today. I think it was about 12 hours ago. So it's time flies when you're having fun, I suppose. I appreciate your comments, and I just would note that I think Massachusetts was the first state to provide state-level subsidy assistance for families and small business owners purchasing health insurance on the exchange. And since then, Boston has emerged as one of the nation's leading hubs for entrepreneurship. So, it's hard. I don't know that correlation equals causation. It's hard to draw a straight line from one to the other. But, I take your point to heart that as someone who buys and sells businesses, it sounds like we might be onto something. Thank you, Madam Chair, and thank you, Alan, for your perseverance today.
Thanks, Alan. Next up, we have Betty Stakely, followed by Audrey Patterson.
Senator Lesser, Representative Wood, and members of the Insurance and Real Estate Committee. My name is Betty Stakely, and I live and work in Waterbury, Connecticut. I have worked as a CNA at Autumn Lake Healthcare at Bucks Hill in Waterbury for 28 years. I am here today to testify in support of Senate Bill 842. Working as a CNA has been my life's calling. I love taking care of the elderly and feel truly fulfilled knowing I help give them a good quality of life. I call them my babies. Oftentimes, our residents can't take care of themselves, and so I care for them. Some of our residents do not have families, and so we are their family. While I truly love the work, I do not love the healthcare insurance offered to me through my job. My health insurance is expensive, yet doesn't cover the important medication that I need. For instance, I live with severe rheumatoid arthritis and require an injection of Humira every 2 weeks. This injection is not covered by my insurance and will cost me $2,300 every 2 weeks. I need these injections to work to survive. I am fortunate because I have been able to have this program that is there, a limited program called My Abbott Assist. The only issue with this program is that there are a limited number of people who can participate, and I have to reapply every year to participate. Every year I worry I will not be eligible and will be forced to pay the $2,300 every 2 weeks. How will I survive then? I, of course, looked for other insurance that would cover these injections. I earn too much money to qualify for Husky and cannot afford the outrageous out-of-pocket costs of other private health insurance plans. Between the high premiums and the back-breaking deductibles, these plans are just not realistic. If Connecticut had public options, I could access the life-sustaining medication I need without the stress and anxiety. I would be able to see my doctor, the dentist, or other healthcare professionals to participate in preventive health care practices. I will be able to save money and live with the peace of mind knowing it is within my power and budget to care for myself. There are thousands of people like me in the state who need your help. Please support Senate Bill 842. Thank you for your time.
Perfect timing, Betty. Betty, thanks for coming on tonight and sharing your story and for taking care of people that need you. It's a really honorable profession. I'd like to open up for questions. Senator Lesser.
Thank you. I don't think I raised my hand, but I was looking for the button, so you read my mind, Madam Chair.
Oh, look at that.
Betty, thank you so much for sharing your story and for sort of illustrating exactly why there are so many people in the gaps between where Husky ends and where affordable health insurance begins. And we've heard that from you, but we also heard it from many, many other people today over a very long day. And so I appreciate it. I know you've got a lot on your plate right now, and but these stories that people are telling are changing people's hearts, and they're really telling the story of what we need to do. So thank you.
Thank you, Betty. Audrey Patterson. Audrey Patterson is next, followed by Teresa Armijo. Audrey Patterson, you are up. I can see you if you just want to unmute. You're muted.
Hello, can you hear me now?
Yep, you're good.
Great, thank you. Well, good evening. I originally was saying good afternoon, but now it's evening. Good evening, Senator Lesser and Representative Wood and all the members of the Insurance and Real Estate Committee. My name is Audrey Patterson. I live in Vernon, Connecticut. I am a direct support staff for whole life for 31 years. I also work in a similar position for network for almost 11 years. I am here to testify to the support of the SB 842 bill. At Whole Life and Network, I work with people with mental and physical disabilities. I enjoy my job. I love my job. I love the people that I work with. As you can know, 31 years, I have learned what I mean to them. I know I make a difference in their lives, and that is a joy and a pleasure for me. But I have to say, 2020 put a different face on my job. The pandemic shook us up. We as essential workers, healthcare workers, group home workers, community program workers, we didn't have the luxury, and I know some may say that's not what they thought that they were doing, when they were able to stay home and be safe. We had to go to work in spite of the fear, in spite of what we knew could happen to us. Now, I was a victim of COVID. And you hear about it, but you don't really feel the impact until you hear the words, "You're positive." My heart dropped because I'm over 60 and I have underlying medical conditions. So I know I'm considered vulnerable as well as being in the classification of Black and brown people. So when I heard that, I had to worry about my insurance and whether or not I'm going to be able to take care of myself. What if I end up in the hospital? What if I get really sick? What if I die?
You have a few minutes to just
These thoughts go through your
wrap
head.
it up.
So when I used up my COVID relief pay and got well, thank you, Jesus, I had to go back to work and care for people who were also COVID stricken. That was scary because I said, what if I get sick again? I don't have time on the books. I barely have enough hours to cover myself if I had to go out again. My insurance, I got the cheap version. They give us different options, but I had to pick what I could afford because I'm a single woman. I live alone, so I pay all the bills. I have rheumatoid arthritis, and I have other medical conditions that require ongoing medical care. I also have to rely on Humira, which is one dose is over $2,000. And I have to worry if I'm going to be able to maintain that medication Or is that a medication I got to get off of because I can't afford it anymore? Because I have insurance that don't cover it. I have thyroid problems, which means my doctor is monitoring it to make sure it don't turn into cancer. Every time he says you need to go get tested, we need to check your thyroids, I panic because I know my insurance don't cover it, which means that's another bill added to my debt. Right now, I have over $3,000 in debt just in medical bills. And I struggle to pay it. I
Audrey,
supposedly got an
hear me?
ultrasound back in September, and I didn't do it because I couldn't pay for it. I should never deny myself medical care because I'm worried that I can't pay for it. I'm doing a work that requires me to put myself at risk every day. The least that I should be able to rely on is an insurance that would take care of me when I'm not okay, when I'm sick. My deductible is $3,500. My premium is over $3,600 a year. That's over $700. That's over $7,000 a year that comes out of my pocket. Insurance is so vital for essential workers, their families, their children, their spouses. We got to be able to take care of ourselves. We are doing a work that is always risky. I'm asking you to support the SB 842. So people like me, my co-workers that work like I do, 2 and 3 jobs just to pay for our insurance. Just think how much we could do better with that peace of mind that we're protected and that our medical care is there for us. We shouldn't go to work under stress. We shouldn't be afraid to get sick, but we do. We worry about it every day, but we do it anyway. I'm asking you to please support the bill. I thank you for your time.
Thank you, Audrey. Thank you for coming on and sharing your story with everybody. We really appreciate you waiting so long. So thank you. Do we have any questions from the committee? Audrey, thanks again for joining us and have a wonderful night. I want to just remind everyone that we do have a 3-minute limit and I'm doing my best. We still have a lot of people to get through tonight. Next up, we have Sal Luciano, followed by Christina King. Sal, you are ready to go.
Thank you very much. Good evening, Senator Lesser, Representative Wood, and members of the Insurance and Real Estate Committee. My name is Sal Luciano. I'm president of the Connecticut AFL-CIO, and we represent about 250,000 people. Before the COVID-19 pandemic, 51% of Connecticut residents struggled to afford health care. That's the blistering sores that Dr. McLean was talking about. More than 5% of the state's population was completely uninsured in 2020. Almost 7% of Black residents, 13% of Latino and Hispanic residents, and 43% of Connecticut adults reported foregoing or delaying care because of cost. Many were one medical bill away from financial devastation. Today, with more than 200,000 Connecticut workers still unemployed, most have also lost the healthcare coverage that protected them and their families. They cannot afford expensive COBRA, you heard that here tonight. Meanwhile, Black, Latino, and Native Americans are contracting COVID-19 at higher rates than whites, reflecting and compounding healthcare disparities that have long gone unaddressed. SB 842 creates a new option for those most often excluded in the current employer-provided health insurance marketplace, employees of small businesses and nonprofit organizations. Nonprofits and small businesses will be able to voluntarily choose from a range of network and benefit designs, including dental care, offered at competitive prices, realized by leveraging the negotiating power of the large state employee plan. It allows more than 350,000 Connecticut small businesses who are struggling during the pandemic to provide more affordable coverage for their employees. Comptroller Lembo has historically kept rate increases far below those experienced in the private sector. SB 842 does not replace health plans offered by private insurers on and off the state health insurance exchange, Access Health Connecticut. It does not replace Medicaid Husky for low-income, disabled, and elderly residents, but it does expand eligibility so that more working-class families will be covered. Many small businesses and nonprofit organizations cannot afford to provide health insurance to their employees, especially during the pandemic. When people can't afford health insurance, they often avoid the doctor, skip medications, or delay recommended screenings. That's not good for anyone's health or well-being, and it also ends up making healthcare more expensive for everyone. SB 842 is common sense, cost-effective plan to expand healthcare access and reduce costs. A majority of Connecticut voters, 84%, believe we must make changes to our healthcare system. 7 in 10 voters favor a public healthcare option, and 72% of small business owners also support this proposal. We urge the committee to heed their call and act favorably on SB 842. All the sad stories you heard tonight, they do not want your sympathy. They want healthcare. Thank you very much.
Thank you, Sal. I hear an echo there. Do we have any questions for Sal Luciano from the committee? Senator Lesser.
Thank you, Sal. Thank you, Madam Chair, and thank you, Sal, for your testimony. It's great to work with you and the working men and women that you serve over the AFL-CIO. I have a question about the Taft-Hartley portion of the bill, because a few hours ago we heard some testimony that suggested that while this may not be the best fit for every Taft-Hartley plan, that this may not be there's some question about whether or not this was a good deal for labor. And I just wanted to see if you could weigh in on that section in particular, because I think there was a little confusion about that earlier.
Yes. In my testimony, I say Senate Bill 842 creates a new option for those most often excluded, including the Taft-Hartley plans. The plan designs emphasize preventative care and wellness, encouraging patients to utilize high-quality, lower-cost providers, unlike the high-deductible plans currently flooding the small group and individual markets, so people avoid going to their primary doctor and instead get the most kind of expensive and wrong care, which is in the emergency room. The bill also creates new options for labor unions with multi-employer Taft-Hartley plans. Unions can choose the plan that most aligns with their negotiated benefits, allowing them to retain bargain wage increases and other benefits.
Thank you very much.
Any other questions? Great. Sal, thank you so much for joining us tonight. Next up, we have Christina Kane, followed by Alyssa McDonald. I don't see Christina. I thought I saw Alyssa. Alyssa, why don't you go ahead?
Hi, esteemed members of the Committee of Insurance and Real Estate. My name is Alyssa McDonald. I'm a lifelong resident of Bolton, Connecticut, and I'm currently getting my master's at UConn. In the fall of 2018, I graduated from college and I was diagnosed with ulcerative colitis, which is basically my immune system attacked my colon, and it's not fun. I was hospitalized twice. I had colonoscopies. I had 6 blood transfusions, and I finally ended up getting a drug called Remicade, which I get through an IV. It's a biologic and it's an immunosuppressant, and it's very expensive. So through all of that, I was actually really lucky. I have really good insurance, and it's probably the most difficult time in my life when I also felt the luckiest. And I have that insurance because I have it through my parents' work with the state of Connecticut. And it was a lifesaver, quite frankly. And I'm here to support SB 842 because we need to extend insurance like that with good insurance, high quality, where you can get the access you need to insurance based on what your doctor says, not doing all the math out constantly to figure out if you need it, or sorry, if you can pay for it because you know you need it. And we need to expand that access to more people. I'm going to have ulcerative colitis the rest of my life. It's a chronic condition. My parents' insurance is not, I'm not going to have it in 2 years, but I'll still need infusions that are really expensive. I'll still need colonoscopies every other year. It feels like every year, just forever. And having, some sense of security that I could access good health insurance that covers these things would be so important. And particularly as a student who's graduating with her master's, it's to me a big reason to stay in Connecticut. And, when I got diagnosed first, I thought, oh, well, now I can't really work for a small business or nonprofit because they'll never be able to have the insurance I need. And, to have this as an option would just be such a, this one huge anxiety, because, having a chronic conditions, really enough. The other thing though, is I also look around the way the world is today, and, losing your insurance because you lose your job during a pandemic, it just is ridiculous. Like, how can we let that happen? And it's happening every day and it's happening everywhere. I've been sitting here all day listening to people, and I think the thing that really struck me most is thinking about really wonderful people who helped me when I was, at my worst points of my life, working through a pandemic, who didn't have access to the health insurance that I had access to. And for that reason, I think that I really strongly encourage you to pass this bill. We have to do something. We can't just let this keep happening. It's ridiculous. And also, really, before I turn 26 would be great.
Alyssa, thank you for sharing your story, and I'm so sorry you are going through all this. But hearing your story and you sharing that with us is really powerful. So thanks for doing that, and especially waiting so long. Any questions from the committee? All right, Alyssa, thanks so much. Up next, we have Michael Goodman, followed by Stephen Wanzik-Karp. I don't see Michael, but I see Stephen. So Stephen, why don't you go ahead?
Good evening. Thank you very much. I'm Stephen Wanzik-Karp, Executive Director, National Association of Social Workers, Connecticut Chapter. We represent over 2,300 members. All industrialized nations except ours have some kind of nationalized healthcare system. Since we don't have that, a public option really is our second best choice. I'm not really sure why people are concerned about having a public option. Over 50% of the residents in this country already have public health insurance. One of the things you have to consider, if you are working for a small business, if you're working in a nonprofit, if you're a Husky parent who's over income, if you're an undocumented immigrant, if you're recently unemployed, there's a very good chance you either do not have health insurance or you do not have health insurance that you can afford to use. So what does that mean? It means you don't get preventative care. It means you don't get early detection of illness. And it means when you finally show up in a hospital emergency room or in a clinic, your condition is far worse than it should have been. The cost involved to the healthcare system is far greater. The cost to the individual is frankly just inhumane. One of the things that I used to do, I actually now have health insurance from my national office. That's only been for 4 years. For over 25 years, it was my job to find health insurance every year for my employees because we're a small business. At the most, we had 4 to 5 employees. Every year, it would be a good year if we only had a 10 or 12% increase in our premium. It was not such a good year when we had 18 and 20. We had a 30% increase one year. So what do? We changed insurance companies. So my staff now has to find different providers. We start shifting more and more of the cost from the employer to the employee. So now I have staff who maybe can't even afford the coverage that we're paying for them. Social workers are essential workers. It's very ironic that those of us who are working in health and mental health care, in many cases, either do not have adequate coverage or cannot afford the coverage. We're delivering healthcare services, and yet many of my folks can't afford to use that coverage. One of the things I'm not sure has been mentioned is sort of the churning effect in nonprofits. Nonprofits and social services constantly lose their social workers and other staff to public agencies. Now, part of that is simply because those nonprofits can't afford to pay as much as a public agency. But you know what? If those nonprofits could have affordable health care and not have to shift so much cost over to the employee, that would slow down the churning. And what that churning does, it not only hurts the nonprofit, but it hurts the clients that are being served. Because if you have a client in social work, it's all about the relationship between the client and the worker. If every year the client has a new worker, it just really doesn't work well at all. So this would actually make a difference. I want to say something real quick about Husky parents. Husky parents who are over income. We know from years of documentation, from years of research, that when the parent doesn't have health care, the child doesn't generally get health care. So we're not just taking health care away from a parent, we're actually taking health care away from the children. And what happens when that parent gets sick and they don't have coverage and they can't get assistance, but they have children to take care of? We need to expand Husky A to 201% of poverty. I also
Stephen,
take
thank
note.
you. Stephen, you've hit your 3-minute limit. If you just want to say another sentence or two to wrap it up, that'd be great.
Sure. So the bottom line I would say is that it's really not a humane system. We need to do better. We can do better. This bill is the bill that will help us move forward and get more coverage and more access to care.
Stephen, thanks for being here tonight. Appreciate your comments. Any questions from the committee? Representative Comey.
I don't, thank you, Stephen. I really don't have so much as a question as just a comment, and to say that you know, we ironic that the folks that are supposed to be caring for us don't have the care that they need in any sort of manner. So
It's very ironic. I mean, it's ironic that, well, it's more than ironic. I think it's inhumane that people who are providing healthcare services and essential workers are amongst the people who don't have adequate coverage or any coverage at all, particularly in a pandemic.
Stephen, thanks so much for coming on and sharing your comments.
Thank you.
Next up, we have Lauren Millay, followed by Lynn Ide.
Hi, can you hear me?
Yes, we can hear you.
Okay, great. Thank you. Hello, Senator Lesser and Representative Wood and the committee. My name is Lauren Mallet, and I am a resident of Norwalk, Connecticut, and also the executive director of Norwalk Mutual Aid, which is a grassroots community organization that popped up during COVID that is trying to ensure equity and a good quality of life for everyone in our community. So I'm speaking in support of the bill SB 842, an act concerning health insurance and healthcare in Connecticut, because similar to someone who spoke before me, I also have ulcerative colitis, and it's been a journey for me, to say the least, in the past 3 years, trying to figure out what is wrong with me, get diagnosed, do all the diagnostics, etc. And it's expensive. It's expensive and it's stressful. And if you know anything about this disease, stress makes it worse. So I fortunately did not lose my job in the pandemic. I got a new job, which was great. My previous employer had a great health insurance plan, switched my insurance. So I had a moment there where I had to wait, to pause with my new therapy because my last therapy stopped working, as it often does with this disease. And after that, I then had a transition period to my next job, which then put me on their insurance, which was another waiting period. So it's just been a lot of limbo, all while my condition continues to get worse. And so what I feel is very important about a public option is being able, as an individual, to have access to an affordable plan that no matter what happens in your life, you know that you have the same stable insurance. Because even when you do get a new job, you don't know what that insurance plan is going to look like, and you don't know how much your care is going to cost. So the same medication that I was previously on, the next week I go to fill it at CVS and they tell me it's going to be $300 for 1 month's worth of medication, $300. So I just think that this is a step in the right direction for folks who don't have jobs, which are a lot of people now, thanks to the pandemic, and also folks like myself who are in transition. You want to be able to take on new opportunities and not have to think, can I take care of myself at my new job? Am I going to be able to keep my new job? Because if their health insurance doesn't cover my disease and all of the therapies and screenings that I need for it, you don't know what to do. You're caught between a rock and a hard place. So I really, really encourage you to support this bill, and I think it'll be a great step moving forward. Ultimately, what I would love to see is single payer, but if we can't have that, at least have this as a safety net for folks like myself. And
Lauren, thank you for joining us this evening and sharing your story. I wanted to open it up to the committee to see if there are any questions. I don't see any, but Lauren, thank you for coming and sharing your story with us. It means a lot.
Appreciate it.
Next up, we have Lynn Ide, followed by Izzy Greenberg. Lynn, I do see you. Hi, Lynn.
Good evening. Hello, everybody. Thanks for hanging in there, committee members. My name is Lynn Ide, and I'm the Director of Policy and Program at the Universal Healthcare Foundation of Connecticut. And I'm not going to read my testimony to you, which I've submitted, but I am going to highlight a few things that I'd like to share with you and ask you to think about and offer to work with you on. Really, for too long, healthcare has been elusive, exclusive, and expensive. And I've been working on healthcare reform in Connecticut in one form or another since 1985. And I really want to take exception to some of the remarks that have been made in the hearing this evening that were suggesting to do something that we don't know enough about. I think if you listened to the people who spoke from their hearts today, not the people who have a self-interest in what happens one way or the other, including myself, you would understand why we need to take a leap of faith and do something now about this issue for people. The need for bold action is crystal clear. 2020 laid in plain sight the gaping fractures in the way we deliver healthcare to people in our state. Employment, family status, income, race, and zip code determine who is in and who is out. COVID-19 and racial injustice are both pandemics that plague us all. There aren't a lot of new ideas, and there aren't a lot of questions about what we can do about this, despite some of the things that have been said. There actually are a lot of answers about what we can do about this. The question is, do we have the fortitude to move forward and actually do it? Or are we going to let power and self-interest eclipse the faces and the stories of the people that spoke with us here today and the hundreds and thousands of people around the state who didn't even know anything about this hearing and couldn't be here with us today? Too many residents in our state lack health coverage they can count on. And we believe that Senate Bill 842 offers you a chance to take one giant step forward to meet the essential need for quality, affordable health care. It's not the end. It's not the only thing we need to do. We need to do a lot more, but this is a continuation of our job as advocates and leaders in the state to meet the needs of the people who need our help the most.
Lynn, thank you very much.
I will just wrap up with one sentence, please.
Go ahead.
This bill is built on the promise that our state can use its leverage to help more people find a path to health security and equity. It is a public options, plural, bill that offers employers and families new choices to use their hard-earned dollars for health coverage. Thank you very much. And I look forward to working with you all on this.
Lynn, thanks for your comments. Any questions from the committee? Great, thank you, Lynn. Next up is Izzy Greenberg, followed by Stephen Glick.
Hello. Good evening. I know you guys have been going at this for many hours, so I will be brief. Let's see, I'm sorry. Are you hearing me? It doesn't look like I'm showing up here, so I just want to make sure it's coming through okay.
We can hear you. You sound great.
Apologies. Thank you. Okay. My name is Izzy Greenberg. I'm from Middletown, Connecticut, and I'm the director of the Middlesex Coalition for Children, which serves to improve outcomes for children and families in Middletown, Middlesex County, and statewide. I'm testifying in support of SB 842, which will make healthcare equitable, dependable, and affordable by creating new public options for health insurance in our state. I don't want to go through all the reasons why. I think that has been reiterated ad nauseum over the last 10 hours you've been here or something, but I will just say that this is an equity issue. It's a women's issue. And I think if we want a strong economy for children, for families, too many people are not getting the preventative care they need. They are taking jobs that are inappropriate for them solely because of health insurance, or that are not paying well enough to support their families so that they can get health insurance. It's a very stressful situation to be just at that line of affordability. And so for the many, many Alice families that are just over the line of qualifying for subsidized insurance, but that is very, very far from being able to afford insurance under most conditions. So I just want to say that for our families, for our children, for our state's economy, I think that that this would be a good move. That's it.
Love you. Izzy, thank you so much. Questions from Senator Lesser.
Thank you, Madam Chair. I just want to thank you, Izzy, for all that you do for families across Middlesex County. Thank you for your testimony tonight.
Thank you so much.
Representative Comey.
Thank you. Hi, Izzy. Good to see you. You in your testimony, you said that you talked a little bit about the out-of-pocket costs. Can you just briefly touch base on that? Something we really haven't talked too much about.
Yeah, I mean, I have good health insurance, and I got a bill for one of my kids' medications today, and it's $75. And we had a whole conversation in our family, like, is this worth it? Is this a medication that we need? That seems like a lot of money for, and that's a small amount. Some families are paying a lot more. And I have good health insurance, so I am not complaining or making this about me, but I can imagine the conversations that are happening in homes. And I've had conversations with families, family, I think dental is a really big issue too. So I don't want to forget that, because that is definitely a healthcare issue. And that is not covered under so many plans. But, to pay for preventative care, to pay the co-pays, a lot of families are doing that kind of care for their children, which is fantastic, but then foregoing it for themselves. And we talk about this so much in the world of child advocacy, which is, a home. To have a healthy home for a child is not just about that child's health. It's a whole system, it's a whole community. And if the parents in that home, the parents in that community are not able to access health for themselves, if they are totally stressed out, the pandemic has made this all too clear that everyone's right on the edge. So many families are right on the edge. And, to be at that place where you're stressed out, you don't know if you can afford the healthcare you need. So your child might be getting it, but if you can't care for them, so there's that.
We just lost Izzy.
For Alice families especially, and I think this is a percentage of families that is very
Izzy, we're going to have to go on to another speaker. We have lost you a couple times now. We appreciate you coming. I don't
So
see
much more than, yeah. All right, can you hear me still?
Sorry, yeah, we've lost you a couple times. If you feel free to wrap up.
Yeah, I have kids homeworking on Zoom too.
Oh.
Yeah, listen, it's expensive and parents are making really hard choices. That's the bottom line. Parents across the board are making really hard choices about what to pay for. And healthcare is extremely expensive. And so, oftentimes that is at the bottom of the pile, unfortunately.
Thank you, Izzy.
Yeah, thank you all.
Stephen Glick, I do not see. Is Terrell Williams here? Okay, how about Julie Schubert?
Yes, I'm here.
Okay, Julie, you are up next.
Okay, thank you. So I want to start. I'm Julie Schubert. I'm the past president of Connecticut Benefit Brokers, a chapter of the National Association of Health Underwriters. So co-chairs Lesser and Wood, ranking members, and members of the committee. I'm submitting testimony for the SB 842 on behalf of our colleagues and members. Our organization represents the independent health insurance agents and brokers who work with individuals, family, small and middle market business throughout Connecticut. We advise, educate, and help facilitate the purchase, utilization of benefits. We know that Connecticut needs higher quality, competitively priced insurance options for everyone. However, a public option for small groups, nonprofits, is not the solution. The legislation raises a number of key concerns and questions for us. Therefore, we can't support this bill. We fear a public option will cause disruption in the marketplace with the existing insurance industry and the state specifically as it relates to jobs. The industry is a significant source of employment in Connecticut, not just for those who work in the carrier space, but also for the thousands of jobs in smaller independent agencies that we represent. This sector will suffer with the government entering the market. I also want to point out that the insurance carriers, they have to spend 80 to 85 cents of every dollar that's collected on claims. And then the rest is what they get to keep for admin and profit. So I think that's an important thing to note. The other thing that I wanted to note is that the small groups are pooled. They're pooled together in the book of business that the insurance carrier has. As written, this bill will give the state an overwhelming advantage over the medical carriers that compete. It could cause certain carriers to no longer do business in the state, or worse, leave it altogether. For example, this legislation allows the state to set up a multi-employer participation program. Basically, it's a MIWA. However, our state does not allow MIWA, and we also don't allow association plans that are allowed under the federal law. This creates an unfair advantage for carriers and the small businesses. We have concerns about the consequences of adding a state health insurance tax. Just last year, the federal government recognized the negative impact these taxes had on rates and repealed the tax on a bipartisan basis. We actually saw insurance premiums reduced by that exact tax amount. This tax hike will directly increase the cost of health insurance. The legislation raises questions as to the management of the public option. To date, the state has not demonstrated the ability to manage the current partnership plan. The partnership plan, from what I see, lost $10.3 million in 2018, almost $32 million in 2019, not covered by stop loss. We would expect the 2020 utilization to be good because nobody was utilizing care in 2020. I think the comptroller said it was 94% for the calendar year, which, to be honest, during a pandemic when people aren't using services is not the best either. So I can't imagine the large losses in previous years is solely due to the geographical rating. So I'm not sure that that's going to correct either. I think it's important to note that a number of states that have already attempted to establish similar programs were forced to abandon them due to the financial losses. So can the taxpayers of Connecticut afford to be the backstop for this additional financial risk?
Julie, you
So-
have met your 3-minute mark. If you just want to wrap it up with a few sentences, that would be great.
Yep, I just want to say that we do, however, support the creation of the innovation waiver and the high risk reinsurance pools. And we do think that there is some work to be done around them, but those things we do favor. We would also like to be included in any questions that you guys might have. And I do want to thank you for your time.
Julie, thanks for coming tonight. We appreciate it. Representative Meskers.
Thank you, Julie. That was very informative. So that last comment, I'm going to challenge you on, not because I disagree, but I want the information. So we talked about 2020 and the MLR of 94%.
Yep.
And you're questioning that. And basically, it's a medical expenditure for 2020 when we're in the midst of a COVID crisis and the hospitals were in large part shut down. So discretionary spending was shut down. So the normal MLR should be where? And where do you think the private sector was on the MLR in 2020?
So I'm not sure where the entire private sector was, but I will tell you in some of the renewals that we worked on in our middle market or some of our self-funded groups where you could see those claims, we've seen the MLR as low as 70, 60%, 80%. So I will tell you the insurance carrier loves to see the MLR at 80, 85%. So the fact that you're at 93% does not leave a lot of dollars to pay for admin costs and that kind of thing.
So, but look, I think it's a late night. God knows I've been on this forever today.
Yes, we all have.
So definitionally, what you're telling me is that this was the year that should have a big premium capture with low expenditures. So you'd be looking at whatever the rate on a public or private sector plan, that with nobody being able to go to the hospital to use it for discretionary services, you'd be hoping to see 70, 60, 70, 75% as the MLR, and therefore the premium capture and the profitability or whatever required reimbursement would be very high. So it suggests that this at 94% was running at a pretty aggressive underwriting schedule, so that if it had been a normal year, the plan might have been running at a significant deficit.
Yes, that's what I believe.
Okay. So I wanted to I'm not trying to position myself on my vote, to be very clear. I want to understand the numbers clearly. And so that's why I asked you that. So thank you very much for that. I would love to have a follow-up conversation. So if you get a chance, use my public email. I'll send you my cell phone. We can talk offline and follow through on stuff. Okay?
That would be great.
Thank you. Thank you, Madam Chair.
You're welcome, Senator Lesser.
Thank you, Madam Chair. I had planned to weigh in. I was just sort of taken aback by some of the MLR figures that you threw out there. What do you think we should have expected this year in terms of an acceptable medical loss ratio, especially understanding the limits within the Affordable Care Act?
Right. So the first time that I heard the medical loss ratios for 2020 for that particular plan was when the comptroller was giving his testimony. And when you look at the private sector and a lot of your plans, they ran way below 90% utilization because people weren't utilizing the hospitals and those high cost things. So when you're running at 94%, you throw in a couple of hospitals and, maybe some MRIs that were needed and scans and that kind of thing, you could be over that 100%. So that's where I was taken back that, pushing that 94% and then 89, I guess, for the calendar year was what he had said, to me seems pretty high.
And have you reviewed the medical loss ratio experience by the state employee plan over the last number of years?
I have not.
Yeah, I mean, the reason I obviously this is an exceptional, this has been an exceptional year, and I understand why it's difficult to baseline that. But, you know, federal law now says that a carrier can't make more than 80% or have a medical loss ratio of over 80%, which for folks who don't spend their lives talking about insurance law means no more than 20 cents out of every dollar that you pay in premiums can go for administration and profit. And these are for-profit companies that have all reported, or a lot of them have reported record profits this year. I mean, this has been an exceptionally profitable year for the insurance industry in Connecticut and across the country. But you know, compared to any other line of work, 20% margin is a lot. And I just am, you know, I'm a little bit skeptical of a claim that's the ceiling, not the floor. I think we can do better, and I think that the comptroller's plan and other plans have not explicitly have done a lot better than just simply an 80% MLR consistent. You know, acknowledging that the 2020 was an atypical year in absolutely every respect.
Right, and don't forget that 20% goes back to pay salaries for people living in Connecticut, and there's a tax base on that. So, you know, plus there's monies that go back into cities and towns and all of that from the carriers as well. So, you know, I think there are partners, and having the state try to be an insurance company and compete with our carriers, I'm just not sure is a great idea. The other thing that I you know, we talk a ton about affordability. I don't see any pricing on any of this legislation. So I hate to think that you get 100% down the road and we pass this, and then we look at rates and they're not affordable. So that's a major concern.
Of course, and if it's unaffordable, then it will have no impact on the market whatsoever, because nobody will buy it, and that, I think, it sort of will have its own logical conclusion. But hopefully, you know, this will have all been a wasted effort if that's the case. But we'll see. Thank you very much for your comments, and I think that sums up my question. Thank you, Madam Chair.
Thank you for your time.
Representative Nuccio.
Hi, good evening. Thank you, Madam Chair. Good evening. So I just wanted to kind of clarify something that I just heard and make sure we're continuing to use the correct terminology here. The 80% is on individual market, and 85% is on the non-individual market. But I want to be very clear.
Actually, 80% is small group, and then the 85% is large group.
Okay, so the key thing here is that it's not a 20% profit. It's approximately 3% profit that the insurance company gets in any given year. Is 20% to cover all administration of the entire thing, including provider networks and everything else. So just making sure we're using the correct terminology, right? So thank you for clarifying for me the 80 to 85, the small. I was thought 80 was on individual, but thank you for clarifying.
Julie, thanks for coming out tonight. We appreciate your comments.
Thank you. Thank you for your time.
Great. Caitlin Shake is up next, followed by Diane Keefe.
Hello, good evening. Can you hear me?
We can hear you.
Okay. Well, thank you for having me. My name is Caitlin Shake. I reside in Stratford, Connecticut. I'm a full-time registered nurse, and I support SB 842, an act concerning health insurance and healthcare in Connecticut. We're in a healthcare crisis, and the lack of dependable and equitable access is hurting Connecticut residents. Even before the pandemic, 51% of Connecticut residents struggled to afford their healthcare, and 43% of Connecticut adults reported foregoing or delaying care because of cost, leading to a workforce that is less healthy and an economy that is less robust. During 2020, because of the pandemic, unemployment rates have skyrocketed, and thousands of workers and families have lost critical coverage when they needed it the most. Healthcare costs are a key driver of Connecticut's high cost of living. Reducing healthcare expenses, especially for low and middle income residents, will expand the state's economy and ease the financial burden on Connecticut's families and small businesses. Currently, as an individual, my health insurance plan through my employer has a deductible of $3,500 for Tier 2 treatment and $5,000 for out-of-network access. If I had a family plan, my annual deductible would be $7,000 as an individual and $10,000 for Tier 3. In the late fall of 2020, I had an unexpected health event and required medical evaluation. It was a weekend, and I spent an hour looking up and contacting healthcare offices that were open and accepting patients. Eventually, I realized my options were limited and resorted to finding an urgent care facility categorized as a maximum savings participant. According to my health insurance plan, the only location designated as such was in the state of New York. With the limitation of maximum sites in my vicinity, I ended up at the third location I found because the other walk-ins said that they were unable to accept any more patients that day due to the influx of people coming in seeking assistance due to COVID-related health issues. Once I was able to find a location, I spent 5 minutes with the provider and I ended up with a $100 bill. When I was referred to a specialist after that appointment, there was only one provider within 50 miles radius of my home. After finally being able to schedule an appointment, my visit required a full evaluation and multiple tests. Thankfully, since I was able to be seen by a maximum savings provider, I was responsible for only my copay. However, if I was only able to be seen by someone classified as a standard savings or Tier 2, I would have been responsible for the bill in order to meet my annual deductible, on top of a nearly $3,000 premium that I'm paying annually. Flash forward to my annual eye exam, which I had a month later with my eye doctor of 15 years. And during the exam, one of my metrics was abnormal, prompting the eye doctor to conduct several tests and schedule a follow-up for another round of testing. The bill sent to me stated that from the 3 additional tests done, my bill was almost $1,000. I was shocked. The eye doctor informed me of additional testing necessary to provide a proper diagnosis, which was, and just for the record, it's not in my testimony, but the way that they coded it was through my medical insurance and not through my eye coverage, which for many people is separate.
Caitlin, you have reached your 3-minute limit, so if you just want to summarize your final comments, that'd be great.
I, like many other residents, and as a nurse working on the front lines during the entirety of this pandemic, which is ongoing, did not return by the suggested date until I was able to figure out how I was going to pay off the bill from my first visit. What working class or middle class family can say that they like or love or can depend on their private health insurance plan or that it's dependable? What individual or family can say that it is affordable, that it works for them or allows them to seek the medical care that they need in a timely manner? They don't. Our state government needs to do better to protect and promote the health and well-being of our residents by supporting SB 842, a public health insurance option that will be truly affordable for working and middle-class residents, expanding accessibility to our residents and increasing providers in the networks. It ensures equity to combat the healthcare disparities leading to negative and fatal health outcomes for communities of color. If living through this pandemic, witnessing Connecticut residents suffer and die has not helped any members of this committee to evolve and understand the urgency and need of expanding healthcare affordability and access, I do not know what is going to actually motivate you. The time is now to support and pass SB 842. Thank you.
Caitlin, thank you, and thanks for staying with us so late. Any questions?
I just want to make a comment. I know I'm not supposed to, but I think that having this, public testimony via Zoom is great because I worked all day. So I just threw my name on the list to possibly testify and got home, and I'm 76. So I got to do this instead of driving all the way up to Hartford. So thank you for doing it.
Yeah, we're hearing a lot of good feedback. I'm glad it worked for you. Thanks for coming. Okay, next we have Diane Keefe, followed by Stephen Heffer.
Hi, I'm Diane Keefe. Thanks for listening this evening. I will be brief. I live in Norwalk. and I support SB 842. I was Director of Business Development for a New York City-based healthcare services company that provides on-the-job enrollment assistance to employees of large and medium-sized companies whose employees qualify, in some cases, for Medicaid and CHIP. For the past 35 years, I've been worked in the private sector in the financial services industry, and it was only in the most recent 6 years that I spent time in the healthcare sector. My company worked as partners with health insurance brokers, but I cannot tell you the number of times a health insurance broker found out about what we did and decided not to work with us to show our solution to their clients because it would take revenue away from them as their group that they insured declined. So I hope you take the testimony from health insurance brokers with a grain of salt this evening. Companies in the restaurant industry, in the childcare industry, in the grocery store industry, retail, hotel, and nursing home sectors were our largest customers. You might notice that these businesses are not the highest margin businesses in our country, but they do provide essential services and their employees need healthcare. Many of these employers were offering high deductible plans, but they also offered bronze and silver plans, but their low wage employees could only afford the highest deductible plans. So many times they would choose to reject those plans, and that's when the employers would bring our company in to help them see if they could qualify for public coverage. There are many working poor people in the United States and in Connecticut, of course, that qualify for free public health insurance. So I do support the provision that increases a family of four's eligibility to $53,000 from its current slightly over $36,000. Connecticut is among the 48 states in the United States that require someone to have a green card for 5 years in order to qualify for Medicaid or CHIP. In California or New York, you can have a green card for 5 minutes and qualify. So we are already limiting coverage in many ways, and I support every measure in this bill that would make it easier for working people to qualify. It's a market failure that we have so few affordable options for people, and saying that the insurance companies are limited to 15 or 20% for administration and profit is really, I don't think, strict enough when you're delivering an essential service like healthcare. We need to do better, and I think the public option will do better. And if by any chance the public option costs the state money in some cases, I will note that the state budget is projected to be in a surplus this year because of the smart taxation of capital gains, which even though so many people have lost their jobs and are suffering financially, the stock market is managing to keep the state of Connecticut able to afford a surplus. Now is the time, with a pandemic on our hands, to insure more people and not let any more people go through the cracks by having it only associated with being employed. Also, I would point out many.
You've just hit the 3-minute mark, so if you just want to do your final comments to wrap it up.
Sure. I just wanted to highlight that the largest businesses have self-insured and have been able to purchase stop loss coverage. So the state of Connecticut, thank goodness, has attracted $60,000 to their 60,000 employees to their partner plan. And I hope that they attract at least 60,000 more to this plan once it's passed. And if it isn't passed, I would hate to be the senator or Republican who, hate to be the senator or a General Assembly member who votes against it because it really is not in the service of the people of Connecticut. Thank you very much for your time, and thank you for being patient.
Thank you, Diane. Do we have any questions from the committee for Diane? Diane, thanks for spending so much time with us to deliver your comments. We appreciate it. Next up, we have Stephen Heffer, followed by Brendan Peppard. Is Stephen here? Okay, is Brendan Peppard here?
Yes, I'm here.
All right, Brendan, you're up next.
Great, thank you. I'm Brendan Peppard. I'm Regional Director for America's Health Insurance Plans here in the Northeast. Chairs, members of the committee, it's been a long day. Thank you very much for the opportunity. I'll just hit a couple of the points since several of the other people before me made a lot of the points I would make. I'll say one thing, that our healthcare system does work for millions of Americans today. We've heard a lot of stories, however, about people today for whom it does not work. We know that premiums are out of reach for a lot of people. And we also know that aspects of our system can and should be improved. But a one-size-fits-all government insurance system is not the answer. Bluntly, a public option would lead Connecticut citizens to pay more to wait longer for worse care. Proposals such as the one being discussed will have significant unintended consequences. Let me just hit 3 points. The proposal is anti-competitive. We've heard this. Public option would have a distinct advantage over traditional health plans in which it would be in direct competition with. It would likely force providers to accept below market rates or unfairly subsidize only this coverage with taxpayer dollars. Providers may be forced to raise their rates in contracts with other providers, other products, to cover their losses from participating in this public option. We've heard several of the providers talk about how you can't reduce the rates to a Medicare equivalent rate. And third, patient access may be adversely affected. We've heard some of this as well. Rural hospitals particularly, and providers serving rural communities may not be able to sustain large blocks of business at below commercial rates. We believe there are policy solutions that exist that build on the best of both the private and public sectors that can improve affordability and coverage for all Connecticut residents. Further, if providing subsidies is a priority for the legislature should fund it through general fund dollars or some other broad-based source, not through a tax that helps one segment of the population at the expense of another. And let me, instead of going into my concluding remarks, hit question that Senator Lesser raised earlier. The Supreme Court ruling on risk corridors. It was not a windfall for the industry. Despite those payments, health insurance providers who received those payments will never be made whole for the losses they sustained in the early years of the ACA. The risk corridor program was designed to partially make up for those losses, but not to make them whole. The risk corridors program was designed means that even when these payments are made under the formula, health insurance providers bore 100% of the losses above that threshold. All right, and so I'll stop there and see if there are any questions. It's been a very long day. Thank you.
Thank you, Brendan. Senator Lesser.
Thank you, Madam Chair, and thank you, Brendan, for your testimony. I appreciate the clarification on the industry's position with regard to the risk corridor verdict, I guess, the Supreme Court. Can you just clarify? So, since that program went away for those, I guess for the three, I think there were 3 years that were affected in Connecticut by the absence of that program. Did Connecticut policyholders pay higher premiums than they would have otherwise had to because of the absence of that program?
To some degree, that's a hypothetical question, Senator. I have difficulty answering it because we just don't know. That money was not paid back to the carriers. It was supposed to be. That, as you know, that was designed as part of the ACA as a startup program. No one knew how the ACA was going to perform in the initial years. And in fact, for most carriers, it performed poorly. Some carriers did make money and they had to share some of that money back, and they did. They made their payments back. So this particular settlement was just enforcing the existing ACA rules, which should have been followed back in 2014 through 2016. So to answer your question, I can't say whether carriers would have rated differently. I just don't know. I don't know the answer to that.
But I think the purpose of this program was to drive down premiums and costs for insurance policyholders in Connecticut and across the country. And in the Supreme Court opinion, it's directing over $12 billion to the nation's insurance carriers. And yet, as far as I can tell, we're not getting the rebates that we would sort of expect if that program had been in place during the years of the disruption. And I don't mean to, this is not in the bill. I don't mean to distract the committee from what actually is in the bill. I think that's important. But I was struck in the beginning of your testimony by discussion of subsidies and a one-size-fits-all government-run program. I think those are your words to a T. And the reason I'm mentioning it is because the only subsidies that I see in the bill are directed at your industry, and the only subsidies that I've seen litigated in the courts were $12.3 billion that just arrived in the coffers of your carriers, which I'm not saying they weren't entitled to under the law, but those are subsidies that exist in the law. So, as we look at the landscape, I think we have to recognize that there are subsidies. There's subsidies for private carriers to underwrite insurance for the residents of the state. And the conversation here today is exactly how do we fine-tune them to maximize affordability. The only plan that is not asking for a handout, as far as I can tell, I listened to the comptroller's words carefully, and I didn't hear him ask for $1 in subsidies. But I am hearing you discuss the best way to come up with subsidies for your industry, and I'd be interested as well in getting some more clarity as to whether or not the policyholders from 2014 to 2016 in the state are owed a refund at this point.
So again, Senator Lesser, those would not be rebated dollars. Rebated dollars occur when a carrier exceeds the MLR threshold. These were carriers who lost money, which means they didn't just exceed the MLR threshold. They, in many instances, exceeded well over 100% MLR, meaning they had absolute losses. And so this was designed to not so much subsidize the industry or reduce costs. It was a risk corridor program is designed for a new market to ensure stability and encourage entrance because there's so much uncertainty and rating is so difficult. The subsidies you're talking about in this legislation today aren't for our industry. They're for the individuals to purchase premiums. As we've heard many people talk about today, this doesn't get at the costs. This gets at an attempt to set premiums at a level that people can afford. And I'm not going to dispute that. We've heard testimony today from many people who say they can't afford the premiums. Healthcare costs a lot, and it's the cost of healthcare that goes into the building of the premiums.
So just with respect to the risk corridor, since you did bring it up, I feel
I brought it up because I was trying to answer your question.
No, I appreciate that, and I'm interested in the issue. The risk corridor payments went both to carriers on the exchange, but it also went to a number of carriers that are not on the exchange. Is that right?
That is detail I don't have at present. We'll follow up with you.
Thank you very much. And if you have details specifically about risk corridor payments received by Connecticut carriers operating in Connecticut on their Connecticut books of business, that would be really helpful as well for the committee.
Okay. I'll see what we can find.
Thank you very much. Appreciate it.
Brendan, thanks for your time today.
Certainly.
Tom Swan is next, followed by Zena Bennett. Tom, are you there? I could see you. I just can't hear you.
Yes, finally I'm here. Good evening, Representative Wood, Senator Lesser, other members of the Insurance and Real Estate Committee. I want to thank you for putting in 11 hours already on this important bill. And I think the reason you're seeing so many people continue to line up and to participate is because the importance of this and how desperate they are to see a real public option here within the state of Connecticut. I'm the executive director of Connecticut Citizen Action Group, and on behalf of our thousands of members throughout the state, I want to commend you for raising Senate Bill 842 and voice our strong support. Others have talked about how the current pandemic have helped to make the case as to why this is even more urgent. And we've heard from so many people today about just how evil high deductible plans are and how they don't provide people real security on the healthcare system, and how the lack of affordability is actually costing people's lives in this country. We strongly support the proposal to allow the Comptroller's Office to design and offer an option for small businesses, nonprofits, and Taft-Hartleys. I've heard some people question about whether or not this is the proper role for, the role of government versus markets. Connecticut has done this before in other areas. We established a procurement office for energy several years back when cost of energy were going through the roof. And we heard the same arguments we're hearing from insurers and industry types about how terrible this was, but it wasn't. It not only made the standard offer for people more affordable and better, it forced a lot of the bad actors in the retail energy market to start to behave better and to offer better rates and cost less money. Nobody can justify the $2 billion in stock buybacks that Cigna had this year. Stock buybacks, $2 billion, but our premiums and copays go up every day. A public option will make it more true and force these companies to actually compete instead of being on a scam that pushes things off more and more to individuals. We strongly support the proposal in this bill to restore Medicaid to 201%. And as Meryl Gay brought up earlier, how it would be very helpful for parents to know, for more children to be covered when their parents had the same, and for the parents to have the exact same coverage. It makes no sense that we're not taking full advantage of this plan that has no copays and no out-of-pocket expenses. The proposal in this bill that would make healthcare affordable for undocumented residents in Connecticut is not only the morally correct thing to do, it is a smart thing to do in terms of public safety. From the pandemic, we all know that if we don't all have access to healthcare, then we're all at greater risk at times like this that go on. We agree that the plans on the exchange are too expensive, and that high deductible plans make access to care impossible for too many. We have some concerns about financing and how this is structured, but any increased subsidies cannot go for high deductible plans. It will just give more money to insurance companies and create a false sense of security for families that go on this.
And your 3-minute mark if you just want to wrap up your comments.
Yeah, the last thing I want to do is the dishonesty that we've seen by many elected officials, and particularly the entire Senate Republican caucus, in sending out emails that misrepresent what's included in this bill and encouraging their constituents on their publicly built email list to participate and send in testimony opposed to this legislation, where they have misrepresented and said people are going to be forced on Medicaid, is shameful. And it's not the type of practice that should be allowed in Connecticut, and we should discourage it. Thank you for your patience. We support this bill because it will address inequalities in our healthcare system and strengthen Connecticut's economy.
Thank you, Tom. Appreciate you waiting to speak. Any questions for Tom Swan? Great, thanks again. All right, next up, we have Zena Bennett, followed by Chris Ipantima.
Good evening, Senator Lesser, Representative Wood, and members of the Insurance and Real Estate Committee. My name is Zena Bennett. I am a certified nursing assistant at St. Joseph's Manor in Trumbull, Connecticut. I am also a proud 1199 delegate because through the union, I have been able to have a voice in the workplace and at the Capitol. I am here today to testify in support of SB 842. I currently live in Bridgeport with my 2 sons. I became a CNA because I believe in preserving the quality of life as best as I can. I value the work that I do, and every day I try to make life for my residents as easy as it can be. My oldest son is only 13 years old and suffers from chronic asthma and some very complex GI problems. My son's asthma medication cost has gone up due to the change in his condition and the change in the type of medications that he has to take. He now has to take 2 different types of medications every day. For one of them, the cost is $120 for a 30-day supply. And now the pharmacy says that the doctor has to make the prescriptions out for a 90-day supply only. The other medication cost is of $30. As for myself, I've been diagnosed with seizure disorder in the past 2 years. My seizure medication cost is $70 for a 30-day supply. I cannot afford that much for medicines on the salary I'm making, and yet both my son and I need these medications to be able to survive. My employer, Genesis, recently switched their healthcare plan again, but my children and I are still not able to see all of the doctors that we need to. For one, the copays are still not good at all. For example, it cost me $55 to see my primary care doctor and $60 to see a specialist. I can't continue to go on and try to afford all these costs on top of the medications and the specialists. It's just not feasible. It's not feasible. And it's really hard and it's difficult with somebody who has these medical issues and who has a child who has medical issues and still not be able to, like, you work hard all the time. You're sometimes doing doubles or have to get a second job, and it's still not enough. It's really not enough. I know there was more to my testimony I submitted, but I get emotional thinking about it because as a mom, I have to make certain choices when it comes to this.
Well, we understand the emotion, and we appreciate you coming and sharing that with us because it means a lot to hear your story. So I just want to say thank you. I know it's late, but thanks again for coming. Do we have any questions from the committee? Senator Lesser.
Thank you, Madam Chair, and thank you, Zena. I know the hour is late, but I want to thank you for your testimony and for sharing your family's story. I don't know that this bill would solve all of the problems out there and help every family that needs healthcare but can't afford it. But I will point out that some of the parts of this bill will really, I think, speak to your situation. And one of the issues is you mentioned your son's asthma. One of the issues is whether or not people who have high deductible plans can get asthma medication without having met that deductible. And the bill says that, at least on the exchange plans in Connecticut, if this bill were to pass, people would be able to get their asthma medication without having to worry about a deductible. So your story matters, and the stories of other people who've been here tonight and waiting many, many hours matter. And I want to thank you for sharing that story, and maybe it'll make a difference, but thank you.
Thank you guys for hearing me tonight. Have a good night. Stay safe.
You too. Thanks for coming.
Thank you.
Chris DiPatina from CBIA, followed by Michael Goldstein.
Thank you, Chairperson Wood. Can you hear me okay?
Yes, I can hear you okay.
Okay, Chairpersons Lesser and Wood and members of the Insurance and Real Estate Committee. My name is Chris DiPatina, and I'm the President and CEO of CBIA, the Connecticut Business and Industry Association. Here with me is our Assistant Counsel, Wyatt Bosworth. I've submitted written testimony, so I'm not going to read that here, and I'll use my time instead to remark on some key points. CBIA, as many of you know, is Connecticut's largest business organization with thousands of members, small and large, from across our state, representing a diverse range of industries and employing nearly 500,000 Connecticut residents. 95% of our member companies are small businesses with less than 100 employees. Prior to joining CBIA in August, I spent the last 20 years owning and leading small businesses in Connecticut, including my family-owned manufacturing business in Middletown, Pegasus. I've also sat on numerous trade association boards, and as a result, I've interacted with thousands of small businesses from across our great state. I can confidently say that on behalf of the small business community, we oppose SB 842, a state-run health insurance plan as proposed with this bill will destabilize the health insurance marketplace, require taxpayer and/or employer subsidies to finance the program, and negatively impact an economy already struggling to rebound due to the pandemic. There's no doubt that the rising healthcare costs are a major issue. In a recent survey of our membership, 98% of respondents reported they were concerned with rising healthcare costs. However, our members disagree with this bill that it's the best way to address these concerns. 69% of our surveyed respondents oppose the concept of a public option, which affirms what I've also heard from numerous small businesses. The concerns are supported by the performance of the municipal plan, which in 2019 ran the deficit of 31.9 million, more than tripling the losses it incurred the previous year. The bill attempts to alleviate Connecticut residents from being the backstop by authorizing the comptroller to establish a risk fund to pay claims that exceed premium payments, which will then have the small employers underwrite the fund. Also, unlike private carriers who are bound by the guarantee issue, the comptroller will have the authority to approve or deny applicants at will. The cherry picking of risk groups will destabilize the market and rates and rise significantly, adding to the already burdensome premium costs. CBIA is working to advance common sense bipartisan solutions to rebuild our economy. However, this bill, if passed, will hinder that mission by handicapping one of the state's largest economic drivers. It is exactly these type of bills that increase our costs and prevent Connecticut from generating economic growth needed to create budget surpluses so that we can fund critical areas like our cities, education systems, transportation, social services, among other things. While CBI members disagree with the approach taken under this bill, we remain committed to working with you all to bring much needed relief that the current healthcare landscape demands. There are a number of bills pending before the committee that do this, and CBI welcomes the opportunity to work with the committee to make healthcare more affordable for Connecticut small business owners and their employees. Thank you for your time.
Thank you. Senator Wong.
Thank you, Madam Chair. The hour is long. I'll get right to the point. Thank you very much for your testimony, Chris. Let me go through your testimony and talk about the survey that you did, where 69% of your respondents opposed the concept of the public option. It seems to run counter to a survey that the Controller Lembo has, promoted that said 72% of small businesses support public option. How do you reconcile that?
Well, I think for that question, I think it's a great one. And I think it's all on how you ask the question. I think the comptroller's responses was all about businesses wanting to solve the high cost of healthcare, which is no doubt businesses want to do that. But Senator Wong, whether the public option is the right avenue is how you ask the question. And we had an overwhelming number of respondents that said no for a variety of reasons. One of the reasons was 50% don't trust the state to manage a health insurance program. 57% said they were concerned that taxpayers would subsidize the plan. I don't think those questions were asked in Comptroller Lembo's survey.
I think you're absolutely right, because as I said earlier on this morning, the fact that everyone virtually agrees that we need to contain cost and that affordable, accessible, and quality health insurance is what everybody desires. It's how we get to it. And I really appreciate your clarification on that. That's extremely helpful. The other thing that I also noticed in the testimony was the fact that I raised it with the controller, that unlike private carriers who are bound by the guaranteed issue and oversight by our insurance department, this bill and the powers afforded to the controller would really allow them to approve or deny applicants at will. I mean, even the controller used the word cherry pick. Risk groups is definitely a concern that I have. And I always point to one of the great things that happened relative to the Affordable Care Act, which is the fact that people with pre-existing conditions will now be able to get coverage. Under this possible language, the fact is you can approve or deny individuals. It really creates a risk that it is not all that is promised. Your thoughts on that?
Yeah, that's our point about destabilizing the marketplace, right? We could swing the marketplace radically here if we're cherry picking individuals. And there's been a lot of testimony today. We've had a chance to sit in and listen to most of it about rates going up and the need to address that. A lot of those rates going up are the experience rating. And so if we're cherry picking and a lot are going to the state plan, we're going to have a lot of folks who are high risk out in the private market space, and that's going to increase premiums for a lot of employers.
Yeah, thank you. And I'll get right to the point that I'm really appreciative as a business leader and a small business, family-owned business. You're about solutions. So am I. And I think the two solutions you posed were to take a look at cost growth benchmarking and planning, just like what we did in Massachusetts, maybe do it better, but to benchmark and get some parameters and measures that are real. Can you talk a little bit more about that?
Yeah, Wyatt knows it better than I do, if you don't mind, Senator, and he'll jump in here. He's been studying the Massachusetts plan.
Hi, Senator. How are you?
I'm great, thank you.
Good. So Wyatt Bosworth, Assistant Counsel. CBIA has supported benchmarking initiatives proposed in the past. We were extremely happy to see the governor's executive order number 5 signed last January. And this really goes to the issue of trying to control cost, because until we can get a grasp on controlling the excessive rate of cost growth in this state, we could shift as many lives as you want into as many pools as you want and subsidize them with as much money as you want, but it's not going at the root issue. The root issue is cost. So I won't go into too much detail about the Massachusetts plan, but I can tell you that in Massachusetts, they have really served as a model for the rest of the state in holding health insurance companies and health providers accountable to meet their benchmarks. I can tell you from 2012 to 2018, they had an aggregate cost growth that was below their established benchmark, which is impressive given the fact that the state never had to issue any performance improvement plans, meaning that they didn't actually have to penalize the insurance companies for going above that and holding them accountable. And that's just amazing because it's delivered billions of dollars in premium savings to the residents of Massachusetts. And I think the Office of Health Strategy is doing a really amazing job at getting that executive order off of the ground right now. But I think there's a number of bills before you that would codify that and resist any future patchwork that may be done. I'll give you an example, Senator. Vicki Beltry came to us a couple months back and asked us about the potential to add employer workers' compensation claims to the All Payers Claim Database. And we absolutely support that. And we're working with our property and casualty companies right now, the Insurance Association, to get that data up on the APCD so we can begin examining those costs. So that's number one. And number two, I definitely agree with the aim of the proponents of this bill, or I should say CBIA agrees. We have a serious donut hole problem on the top and bottom end of the exchange right now. Expanding Medicaid certainly helps cover that. And of course, providing subsidies to people on the higher end will do a good job at reducing their individual cost. But unfortunately, with such a broad base assessment on our fully insured, self-insured, and individual marketplaces, it's going to be the insured individuals and groups at large picking up those costs. So I think a better way to go about it is what you folks on the Republican side of the aisle and what Governor Lamont has signaled support for, along with Speaker Ritter wanted to study it further, was the concept of a reinsurance program, right? So with a reinsurance program, once again, we're going after a root cause of a lot of the problems with health insurance right now. And that's high cost catastrophic claims, right? So if we could get the money together in the state budget to at least start up the fund, looking at the Wakely study that was commissioned last year, 57% of the money that we put up has the potential to be reimbursed through pass-through funding through a 1332 waiver. That's a big deal. And states like Alaska, who were on the edge of a death spiral in their own markets, instituted similar reinsurance programs, and it saved them. And I think it would provide broad-based relief to a lot of the people who are hurting right now. That being said too, Senator, getting control on the mandates we pass, the assessments we pass, you have a bill today that nobody spoke in favor of. I submitted testimony on it. House Bill 5013, which would reform our mandate review process by allowing this committee, or I should say the insurance department, to contract with private actuarial firms to do that analysis and lower the cost for that. I think that's a good step into reviewing future mandates, because mandates add over $2,000 a year on average to premiums. So between getting a fix on what's driving the cost of healthcare through a robust benchmarking program, by providing broad-based premium relief, by a robust, well-funded reinsurance program, and holding the line on any future assessment and mandates, I think we can do a good job at least getting a start on fixing this problem.
Well, I appreciate that. And you talk about Massachusetts, and there are things we could learn from Massachusetts, and there are things that I believe we could do better than Massachusetts. Massachusetts does not have a public option program, does it?
No.
The answer is, I'm sorry?
No.
It does not. Thank you. If I may, I want to refer back to, in doing my homework, a issues and policies report that CBIA did in April of 2019. And I found it interesting where you talked about Connecticut state-run health insurance ideas, and for us to take a lesson from Kentucky's lesson of racing to have a public health insurance state-run program. Do you remember that plan, or do you recollect it?
You're talking about the Kentucky plan or our internal report?
No, you had a policy report that the title Kentucky's Lesson for Connecticut on state-run healthcare plans.
No, Senator, I apologize. I'm fairly new on the job here. I haven't had the opportunity to look at that report yet.
Well, I am eager to talk more about it, but I'm sure we'll have more opportunities. I really appreciate the insight that you provided and the leadership that you have in representing businesses. But it's also important that you don't just represent businesses. You represent businesses that employ people, that have a viewpoint of people that all clamor for cost-effective health insurance. And I'm appreciative that as you raise some questions on this bill, you also compliment it. And that's important for us to come away with, but also providing some solutions to addressing the unified challenge that we have to contain cost and be able to give healthcare insurance to everyone. The testimonies we all heard this long day has been compelling and very emotional. And I do believe it is a common thread that we all have, Democrats and Republicans, business owners and entrepreneurs and nonprofits, that we all have a right to quality and affordable and accessible health insurance. That being said, I think I've energized some of my colleagues at 10:30 at night. So through you, Madam Chair, thank you so much. And I want to compliment you for your remarkable leadership on this public hearing today. So thank you very much, ma'am.
Thank you, Senator Wong. Representative Nuccio.
Thank you, Madam Chair. So I'm going to ask, I'm actually going to ask the comptroller the same question for the same background. Could you possibly provide your survey, the results of your survey, and if you could, the parameters of who you asked? Because I think it's important for your survey and the comptroller survey to be reviewed and looked at, because one thing that I'm always looking for is the compromise and where we get to the middle, because I believe that there are more of us in the middle than there are on either of the extremes here. And there was something that was said a few times tonight that I kind of take exception to. It was stated that the people who were asking questions or pushing back on any of these assumptions were advocating for the status quo or leaving things the way that they are, which I don't think I heard a single person say tonight. And I think it's very important that that gets called out as as not really fair or accurate. I think for us to be able to really look at this, we have all said that the cost of healthcare needs to be reviewed, and we need to find a way to bring that down because healthcare is what drives insurance. So in essence of being able to look at that on both sides, I'm asking if you would be willing to share your survey, the parameters in which you asked your survey, and the populace, and also if you have any more information on the benchmarking, because I've heard that come up quite a few times, and I know probably barely enough to maybe be dangerous in a low level conversation, but I'd like to understand a little bit more about what's going on and whether or not it's truly been successful, and if we've given it time to kind of percolate and come back to give us some good results.
Yeah, Representative, absolutely, we can get you those survey results. You know, in normal times, you know, we usually use these surveys as a way to gauge our membership and help them inform us on how we should be lobbying during this session. We don't traditionally release those results, but I think given the fact, you know, with the poll, the ALG poll that came out, another poll that was in the HBJ, you know, we felt we needed to share the results of our members and give them a voice. So I think, you know, first thing tomorrow, I'm definitely going to work on getting that together for you and the rest of the committee.
I appreciate that. And can you again just refresh my memory? How many small businesses or how many small businesses and how many employees do those small businesses employ that you represent?
Well, in our membership representative, we have over 4,000 businesses. 95% are small, so we could do the math for you if you want. And like I said, we about 500,000 employees in our total membership. So we're a large organization. We're the third largest business organization in the whole country.
And it's fair to say that you would like to review the cost of healthcare and finding better options for your members.
No doubt, and that's what the survey said. Our 98% of our membership wants to lower the cost of healthcare, and that's why we want to work with you all. We've had these other solutions that we just think are a better pathway than the public option, is why I talked about.
I appreciate that. So am I. So I look forward to getting the information on your survey, and hopefully I can get the same thing from the comptroller so we can review it. Thank you very much.
Thank you, Senator Lesser.
Thank you, Madam Chair, and good to see you, Chris and Wyatt. And I got to ask before I get into the real questions, that's 6 feet between you, right?
We made sure of it.
We measured, yes.
All right, just want to make sure people are safe. One, I did hear, I think it was Wyatt, you mentioned that the CBIA would support I forget the exact words you used, but a robust, well-funded reinsurance program. Is that right?
Correct.
Okay. You mentioned the Wakely report. Would you support a program that would achieve the kind of savings that I think Senator Kelly mentioned in the press conference yesterday, 20% savings?
Yeah, I mean, you know, we're looking, I have the table right here. You know, for a 20% reduction, I think the Wakely report cited a $77 to $85 million upfront cost, and that would trigger upwards of $115 million in federal pass-through funding. That's something I think that really dependent on what the federal government gives us in aid and our budget numbers come the new report that's coming out soon, something we should certainly look at as a way to at least maximize our reimbursement avenues.
That was what my memory of the report too, is that was what Wakely had anticipated that kind of savings would cost. How would you suggest we pay? I mean, that would just be for plans offered on the exchange for individual policy holders. That would be like $81 million, $85 million. How would we pay for that?
Well, I think if you look at a number of other states like Alaska, you know, they've been able to contain cost at the same time as run a robust reinsurance program, and the program's paying for itself through pass-through funding. I think that's what proponents of reinsurance would like to see, is to create a program that eventually, you know, has the level of reimbursement through a 1332 that would become self-sustaining eventually. But you're right, Senator. It's a tall ask for $77 million right now. But we certainly think that would be better than levying yet another assessment on all plans throughout the state. You heard the health plans say today that they're at the breaking point for assessments. People are assessed annually upwards of $600. It's a lot of money that these taxes and assessments put on payers, insured individuals and businesses. So, we can start with a 5% reduction or a 10% reduction. Obviously, we're talking, for a 5% reduction, we're talking about $20 million, 10%, $38 million. But I guess that's your job, not mine, is to find the source of the funding.
Yeah, I agree with you. I mean, paying for programs is hard. That's what we do in this building. I mean, we're not in the building, but when we are in the building, that's what we do. And it's hard. And that's what the assessment or the user fee in the bill attempts to do. I understand it's better to say, hey, we don't have a pay for than to say that we do have one, but we're trying to be responsible. We're trying to have that conversation, whether it goes towards subsidies or reinsurance. I think we can have that conversation and work with you and your members and all the stakeholders to figure out the best way to pay for it. But you got to pay for government programs. You can't just, assume that the money comes from somewhere, because that we have really tough fiscal realities, and I think that just as probably better than I do. So I appreciate that. One last thing. I don't want. I mean, I know the hour is late, and there's still other folks that testify, and there are other folks who want to ask questions. But you surveyed your members. The Hartford Business Journal, that was a scientific poll. I'm assuming your survey was not a scientific poll. Was that?
It wasn't. No, it was just raw feedback from our members. Like I said, we didn't expect polling to be done on this. So, we thought the best information we had was direct responses from 260 of our members. And we thought it was worth sharing because it was worth at least sharing their voices. But we totally understand that there's absolutely no scientific means of collecting this data. It's just raw feedback from our members, but I think nonetheless useful for you as you deliberate.
Absolutely, and I appreciate that. I just wanted to clarify that. Thank you very much. It is very, very interesting, and I, like Representative Nuccio, I'd love to see that as well.
Sure. Yeah.
Thank you very much. Thank you, Madam.
Representative Farrar.
Thanks, Madam Chair. Thanks to you both for being with us at this late hour. Just to kind of clarify some of your comments earlier, is there anything in Senate Bill 842 that you do support?
I think we support the concept of providing relief to people wanting to join the exchange. The question is, do we do that through an assessment or a general fund transfer? I think the other thing that we certainly are optimistic about is the expansion of the MedConnect program. A lot of our members employ workers with disabilities. And if we could figure out a way to make that easier for, employees, for disabled people who want to work, but maybe have over $10,000 in assets, which is the case for a lot of people, that number is too low to begin with. We certainly agree with that effort in expanding that program. A lot of our business members will benefit from that. But as far as the public option, we certainly just, I guess, principally and philosophically just disagree with you. The widespread assessment, we at least want the committee to consider the potential impact on, small, large, and individual market premiums. We don't really have a position on the Medicaid expansion or the undocumented expansion.
Okay, that's what I was wondering, because, I think for all of us, and I'm sure for many of your members, and I know particularly, for women-owned businesses and minority-owned businesses who have been particularly hard hit during all of this, we know that the majority of our uninsured, are individuals in communities of color and primarily women who have lost their jobs or have really been cut wages, at many of our businesses. And so, I think for many of us, the question of equity and how racial justice is a part of this solution is critical.
And so in the solutions you're imagining, how is that a part of the solutions that you all would imagine that we consider for really creating more affordable options?
Yeah, so, I don't have the exact number, but a sizable number of our members are owned by minorities and women, and we certainly champion that. We're an all-inclusive organization here. I think when we talk about expanding Medicaid, Connecticut has one of the best Medicaid programs in the country. It really is a model for the rest of the nation. I think that's a testament to the folks on this committee, on the Human Services Committee, to our Department of Social Services and our previous administration after expanding it. And certainly, I think we would be willing to have conversations about how we can expand Medicaid. Specifically under this bill, I think it aims to expand Medicaid Part A, as well as the MedConnect program as well. But really, I mean, we're looking at global solutions here. We're looking at reducing premiums for the widest amount of people as possible. We're looking about improving and building on the Affordable Care Act. And I think all of those things go to that issue, Representative.
Yeah, I certainly just hope, we can kind of keep kind of clear these goals for all of our businesses and those that have suffered the greatest. And also, again, who is the majority of the uninsured. So, if you have an opportunity to be open to the Medicaid expansion and serving undocumented individuals, I think that would serve our state well. So thank you both for being here.
Yeah, and that's, we're not shutting the door on that. We want to be available to work with you on whatever package that we can come together around. CBIA is not the organization to know this year. There's too many demanding issues that the economy demands of us, that this health crisis demands of us, and we're here to work with you, Representative. So I hope we can keep an open channel of communication going moving forward.
Thank you, Representative Farrar. Senator Anwar.
Thank you, Madam Chair. Thank you so much for being here. Thank you for your testimony. I wanted to ask you guys, for your board, for your CBIA, what is the percentage of the board members who are in a are of a small business background, like less than 50 employees?
Less than 50? I'd have to get you that number, Senator. I mean, it's probably more than half of our board. 95% of our members are under 100. I believe 87% of our membership is under 50. So the vast majority, you have to be a member in order to be on our board. So the vast majority of our board and our membership is under 100 and quite a few under 50.
Okay, when I looked at the list of your board, it didn't seem like that. There are smaller groups, but it did not appear like that. The other part was, how does one become a member?
They join. We're a dues association, so they would just decide to join CBIA, either paying through our mission, which is advocating for economic growth and competitiveness in Connecticut, or certainly they could want to join because they want to benefit from some of our member programs, whether it's our health insurance, property and casualty, membership discounts, energy, workers' comp. We provide a lot of programs offerings for businesses to lower their costs and remain competitive.
Okay, and do you have an understanding of how many of your member companies have employees that are Ellis employees?
I don't have that number off the top of my head.
Okay, well, this is a fast growing segment.
I'm sorry, Senator, you're breaking up a little bit.
Sorry, you know what Ellis is, right?
Yeah, you were breaking up. I couldn't hear you. I'm sorry. Yeah.
Okay, so this is the fastest growing segment in our state. And these are all employed. So statistically speaking, they are individuals employed by your members, which means that the way the employers have set up a mechanism that they have employees that are working full-time, but they're not even able to afford a single meal at a restaurant once a month. And of course, I mean, as credible and committed you are for the business industry, the businesses are only as good as the employees are. I mean, you know that that's like basic 101 on the business end. So I know that the board is very set towards the top positions, and that makes it look very nice that it's a powerful group. But the power of the executives comes from the people. And if you do not connect those things, then they are living in two alternate realities. So I would, and that's where I believe CBIA has a very big responsibility, a moral responsibility and a sustainable responsibility to make sure that your members, because your members are the executives, the people who are working are not your members, unfortunately. But if the people are left behind, the industry is going to suffer long term. And then that's where we have to have an investment in the people. And if you look at the new businesses, which are smart, and you know this, I'm just for the most part, but you know the fact that when a new industry comes, they look for the workforce before they look for anything else. And what I see is that having an effort into the workforce and the quality of life of the workforce and their health and their personal life sustainability is going to be critical as an ingredient for the business industry. And I think that's where at times I sense that the CBIA is at a different frequency and not interacting with the people on the ground. And because every single workforce related bill, you guys have officially been against. And when I talk to you, you agree with it in private at times, but then and when I look at your readings and I say, oh my God, is it the same people? And I get confused because when I interact, you guys are such kind and nice and smart people. But then I look at your documents and then the secondary conversations from the executives, and I say, I don't know what is true or what is not. So I'm just sharing because this is a good opportunity to share my concern, because every single bill that I worry about for the Ellis community, the people who are voiceless, the people who are working full-time, I see CBIA not coming in and saying, yes, we are with the workforce. And I just want you to please consider that, because your executive, if they tell you that we are only and only and only interested in our bottom line and not in the workforce, you have a responsibility to educate them that their industry is dependent on that workforce and the well-being of that workforce. And I believe this bill is a step in that right direction, even though imperfect, but it's still a step in the right direction to try and address that. So, and again, I've said quite a bit right now. And these are philosophical aspects, and I'm hoping that maybe I'll be able to get into your hearts, not necessarily the minds, but the hearts at least.
Well, if you don't mind me responding to that, Senator Anwar, I mean, we haven't met yet, and I've been here since August. I can tell you, I ran a family-owned business and grew from 40 people to 150 people over 18 years. You could call any one of my former employees. I have a great relationship with them. I have probably met more small business owners than anybody who's been before you today. Thousands in my 18 years of running business, friending companies. They treat their employees like gold. What you said is absolutely true. The business is only as good as their employees in the workforce. And I'm proud to say in Connecticut, we have some of the greatest businesses because we have the greatest workforce in the world. So I believe CBIA does bridge that gap. A lot of the benefits we offer aren't for the employer, they're for the employee. They're for the employee to spend less on property insurance, auto insurance, to have a healthier life through a wellness program. So a lot of our benefits are actually geared towards the employee because the employer wants to have happy and healthy employees. The employers in Connecticut really care about their employees. And I could say the employers in Connecticut do that more than many other states. I ran businesses in Seattle, in California, and in France. I didn't see that love, that compassion, that embracing of the employees like I see here in Connecticut. So I would be happy to talk further about that one day. I believe CBIA does bridge that gap.
Look, CBIA, when they look at my score, you guys evaluate everybody, and I don't score very well because I work for the people, and I don't work for the executives, which is fine. I take that but you're new, so maybe there's going to be a culture shift. that may happen. And the time has come for the rest of the world is waking up to it, and it's about time we do it as well. The second question I wanted to ask you was, look, I have a master's in public health. I do public research at times, and I've been involved in some of that aspect. You ask a question in a manner to get the answer that you want. If people want to do this. So when I see your study saying that 69% of I guess your businesses that are connected with you, they are opposed to a public option, I would love to know how that question was asked, because you're not in your website, it doesn't say that, but I just heard you say 98% of the people are not happy with the way the healthcare costs are, which was interesting because that's something that should have been mentioned in your website as well. Maybe I missed it. But when you say 69% of the people are opposed to public option, that tells me, how was that question as asked? It was, and that maybe give us a glimpse what answer you were going to get or you're looking for. Because when I interact with the businesses in my community, they are really worried about healthcare. They're really worried about the cost of healthcare. And then they're looking at all options, and they're really not married to any idea. They just want to make sure that their workers are taken care of. But then I look at your website and they say, oh, well, almost 70% people don't want this. And I say, wow, this is amazing, because we are completely indifferent. And then I say, okay, maybe none of the people that I'm interacting with are part of CBIA, but then you claim to be there too. So it's really confusing, but I thought I'd just put this there as well, because that is giving a wrongful perception to people that there is no healthcare problem.
Well, I did say, Senator Anwar, in my testimony, but it's also on our website, 2 paragraphs down from the 69%. It says 98% of CBIA small businesses surveyed that they were very or somewhat concerned with rising healthcare costs. It's right there on our website, just a couple of paragraphs below the 69%. And I even put it in my testimony as well. Healthcare costs are a major, major, major issue for Connecticut businesses, small businesses, medium and large. And we need to address it. And as Wyatt said, we're here. We're not just here to say no. We're here to offer alternative solutions and work with you all. And there are some really good alternative solutions. We can and we have to lower the cost of healthcare.
So, and if your board, which obviously is the one that controls the organization, has executives from the insurance industry who have been very clear where they stand, what are the chances that you are going to say, you know what, public option is a reasonable option?
95% of my membership is under 100 employees. 87 is under 150. Yeah, it's under 50 employees. Do you think I'm going to win? This is the 95% of my membership or 5% of my membership? I'm going to listen to the 95% of my membership that's under 100 employees. We are here opposing this on behalf of the small business community, not the health insurance.
No, but I thought the board governance is from the board, right? Or it's different governance?
No, our board does govern us. Yes, our board is here to govern us.
And
but as I said in my testimony,
we're executives of the insurance industry, right?
Yes, some of the insurance industry on our board, some of manufacturers on our board, some of professional services on our board, construction industries on our board. We have a very diverse and robust board.
I know. So, and that's what makes it a little tricky. Again, I understand how these big groups work, but I want you to keep that in mind, that I look at your studies with a little bit of skepticism, because no board is going to say that where their own business is going to be impacted, because it's all about protecting the business. And end of the day, that's why CBIA is about. And I respect that. I understand that it's necessary. It is and I'm interested in the balance, and that's what my interest is. And I think the balance is not there right now, because if you look at the statistics of the ALICE community, that is increasing. If you look at the number of people in the last 10 months, what has happened, the entire thing has shifted in a direction where we cannot afford to have business as usual any longer. And that's why we have to start of thinking of options and real options, and then present real solutions going forward. So again, I truly appreciate the opportunity to talk to you. I was getting like sleepy and tired, but as I heard your testimony and I'm just awake again now, I'll be up all night. So thank you so much. Thank you for your testimony. Thank you, Madam Chair, for the opportunity.
Thank you, Senator.
Wyatt, thanks for coming here tonight so late. We really appreciate you spending all this time with us. Thank you.
Thank you, everybody.
Michael Goldstein is next on the list, and I don't see that name. Nicole Bongiovanni, Elizabeth Frazier, Dan Flug. Did I say your last name right, Dan?
It's Flug. Hi, everyone. My name is Dan. I support SB 842. I want to give my quick background and then offer one suggestion for the public option bill. I'm a CPA, chartered financial analyst, and I have an associate in reinsurance designation. I work for a small business in Westport. I have a wife with a pre-existing condition and 3 young children. My Anthem Blue Cross Blue Shield fully insured annual premium is $33,800, or just over $2,800 a month. Even at that cost, the plan is a high deductible plan at $2,500 per individual. Basically, anyone at my company who can buy insurance through their spouse at like a government job or large employer does so. Every year, as you know, the premiums go up while at the same time the coverage gets worse. For example, an ER visit a few years ago was only a $250 copay, but now an ER visit, you have to meet your $2,500 deductible first. I work in finance, and I do believe free market capitalism is the best path forward for most industries. However, as we heard tonight, health insurance has gotten completely out of whack. So I do support a public option. The one suggestion I would make is for the bill to ensure that small businesses and nonprofits can obtain a disruption report from their current health insurer. A disruption report shows all of the providers being used by the policyholders. So you can then compare bids and see if the doctors would be in network under a potential new health insurance plan or this public option. We tried to shop our Anthem plan last year and requested the disruption report, and Anthem withheld it from us since they are not required to provide it to small businesses under current Connecticut general statutes. I believe this is anti-competitive and you guys should address this. Thank you very much, everyone, for your time.
Dan, thank you. And thank you for that great insight on the disruption report. I would like to pass it over to Representative Meskers.
Dan, I want to request that you personally reach out with an email. I think it's worthy of having some further conversations about the entire industry. And given your background, I think you could be a valuable resource to us, okay?
Will do.
Thank you much. Meskers, M-E-S-K-E-R-S, State Rep, and out of Greenwich, the 150th District. Okay, thank you much. Thank you, Madam Chair.
Senator Wong.
Thank you, Madam Chair. And I didn't have Dan on my list, but I believe I know Dan, right?
Hi, Dan. Yeah, hi, Tony. Yeah, I'm a big fan of yours.
Well, I am very eager to also follow up like Representative Mesker to get some more information. And these are issues that we're looking to address. And I couldn't resist, even after a long day. I was so happy to see you, and I just wanted to say hello and thank you. My best to the whole family.
Thank you, Tony. With my health insurance issues, I worked with my state rep, Adam Dunsby. I didn't want to bother you too much, but I do appreciate everything you're working for, and hope to speak to you soon.
Absolutely, my pleasure.
Dan, thank you so much for coming tonight and spending this late hour with us. We appreciate your testimony. Demeen Davis.
Representative Wood? Chairman Wood?
Yes.
You jumped over Elizabeth Frazier several times.
No, I called her.
She was here.
I'm right here.
Okay, Elizabeth, you are up. You were after Nicole, so I just didn't hear. So I apologize, and why don't you go for it?
Thanks. Not a problem at all. And good evening, Representative Wood and Senator Lesser and members of the committee. My name is Liz Fraser. I'm here today representing the Connecticut Association for Human Services. And CAUSE supports Senate Bill 842, which we believe offers a thoughtful, multi-layered solution towards greater health equity. And passage will advance family economic stability and will impact the future of many marginalized families and children throughout our state. Much of what I've had to say has already been discussed, so I've sort of changed my notes around. But for the last comments of the night, for myself, I would like to bring it back to families that really need the insurance and just can't afford it. Do I pay my rent or do I pay for health insurance? Can I finally afford insurance or should I put safe tires on my car? And these are the decisions that working parents are making every month. Pre-pandemic, 46,000 parents didn't have health insurance. This is pre-pandemic. The necessity of foregoing health insurance impacts not only their own personal health, but children's well-being is closely tied to the well-being of their parents. And it's really important to remember that the impact that the stress from not having health insurance, as we've heard tonight from so many stories, that stress goes right to the children. When parents are not healthy, they have a harder time taking care of their children. Uninsured parents are less likely to bring their own children to the doctor, even when the child is insured. Ill health can run up debt for both medical costs and lost wages from being ill, making it difficult to support their children. And the family stresses all contribute to the environment that children are living in. And this can have very long-lasting consequences. We're not just looking at one generation here, we're looking at two. As I look at Senator Lesser and his new little baby, 2 generations, right? Our family affects us. So in regard to Husky A, with 47,000 parents not having insurance, for many of the parents in that category of Husky A, there is no other affordable health insurance options for parents. Additionally, we're also very concerned that as the minimum wage is increased, we know that Husky A is at the present eligibility level, is one of the first benefit cliffs that will affect enrolled families. Raising it to 201% will help to ensure that families don't fall off this cliff without affordable options. The other thing I'd like to say about this is that many of these families are working, well, in Connecticut, 25% of children live in a family where there is no job stability, meaning that no parent in that household has full-time year-round employment, but they're working. 25%, 38% of Black and Brown children are living in those families. Those are the families that are part-time workers often that are not getting health insurance. And that is just a huge discrepancy. And so many of those families, their hours shift, they just don't know from week to week what their hours will be, or sometimes from season to season, and they never really know when they're going to fall off that cliff. So it's really important to take that into consideration. The childcare industry has been brought up as an example of benefit of those that would benefit from a public option. These folks, as you've heard, are very low wage, but they've also been working since the beginning of the pandemic in difficult situations where they've been getting sick and afraid of being ill. And many of them don't have insurance. So it's really important. They're not the only industry, but the childcare industry is hurt. And there are many others also that have these unpredictable schedules or that are low wage workers that have been working throughout the pandemic. And finally,
Elizabeth, you've hit your 3-minute mark. So if you just want to, add some closing statements.
I would be happy to. What we've found is that the pandemic has exacerbated the dire need for additional affordable insurance, and it's illuminated the systemic inequities in our healthcare system, exposing chronic injustice that has disproportionately impacted families of color. We believe this bill will provide some relief to many hardworking Connecticut families who have been able to access affordable insurance, and is a step towards rectifying some of the health inequities that have contributed to historically lower healthcare outcomes in Black and Brown populations. Thank you very, very much. I really appreciate the time.
Thank you, Elizabeth. Appreciate you coming on so late. Any questions from the committee? Thank you.
Thank you.
Okay, so I apologize if I skipped anyone else, but following Dan, I have Jameen Davis, Summer Kim, Camilla Guza Chavez. I thought I saw her name on here. Yeah, Camilla, you're on next.
Hi, yes, thank you so much. And thanks for still being here and creating the opportunity for all of us to speak. I'm Camila Guiza Chavez. I'm from New Haven, Connecticut, and I'm involved with the Samia Collective, and I support SB 842, an act concerning health insurance and healthcare in Connecticut. SB 842 will make healthcare equitable, dependable, and affordable by creating new public options for health insurance in our state. As a young woman from California building a life in New Haven, I've always considered myself lucky. I came to Connecticut to attend Yale, where I graduated in 2019. And during my time here in college, I had the privilege of meeting community organizers in the immigrant justice movement here who inspired me and motivated me to stay and continue working here and building a life for myself after graduation. I'm lucky that I've been able to keep my job during the pandemic. I work at a nonprofit cafe, a small business in downtown that seeks to support and build power with immigrant and refugee women here. We currently work with women from Arabic and Spanish-speaking backgrounds who work with us for 6 months in our cafe and attend a range of classes. And our long-term goal is to be an organizing space and cultivate our community's capacity to mobilize itself. I'm still under 26 and my parents have jobs that provide health insurance benefits in California. So if I need to, I can schedule a video call with my primary care doctor in California and can be prescribed medicine that I can pick up at a nearby pharmacy. And yet I'm, as someone living comfortably with a stable job and no dependents, I can't access a doctor in the state of Connecticut. Although I've needed to in the past year. A year ago, I needed care for a small injury, finger that I jammed, and tried going to a local health clinic, but was told it would cost me hundreds of dollars out of pocket that I couldn't pay. I went to a CVS Minute Clinic and was told similarly it would cost hundreds of dollars out of pocket, which is not an option for me. And it was a simple injury, but without proper care, it's permanently disfigured. And I would have had to fly myself to California to get care that I could afford. My income places me above the poverty line, so I don't qualify for Husky, but the monthly cost of private health insurance for me is nearly half of what I pay in rent. So I'm sharing my experience with you all today to just add my drop in the ocean of stories you've heard. But a key part of my experience that I have to share is that I have friends and mentors who can't access any healthcare at all because they don't have a social security number. And this makes no sense to me and is why Husky expansion needs to pass. It's nothing less than a crime by the state to categorically exclude any group of people from healthcare and to allow private health insurance companies to do the same. And the pandemic should show us, if nothing else did, that our health and well-being is interconnected, as someone shared before me very wisely. Protecting the well-being of a community means ensuring that every individual is cared for and has access to care. So I support the bill for Husky expansion and the public option because I believe healthcare is a human right. Every single one of us deserves to know that if we have an accident, if we catch the virus, or if our human bodies ail, as we do, that we will be supported. So I urge the committee and Connecticut lawmakers to support the bill. Thank you so much for your time.
Thank you, Camilla. I appreciate you coming out so late. Any questions for Camilla from the committee? Thank you. Robbie Goodrich is next, followed by Sophia Ditkiff. Robbie, just unmute yourself and you're ready to go.
Yes, good evening, members of the Insurance and Real Estate Committee, Madam Chairwoman and Chairman Lesser. First, I want to hold up this idea that this process that we go through every session here in Connecticut, especially this year, is very unhealthy. And it's so inaccessible. This has been exhausting. And I'm hoping that we work together to reform this process so it becomes more healthy and accessible for all those involved, including the elected officials. Now, most of the opposition tonight has been fighting for the health and welfare of corporations and profits. And it's been so distinctive in their claims that SB 842 is not healthy for the state of Connecticut. And most of the folks like myself supporting it are fighting for our friends, our families, the people in our community. That's not missed on me tonight. It shouldn't be missed on the members of the committee as well. So I live and work in Waterbury, Connecticut. I'm the executive director of a small grassroots organization called RACE. We fight for racial justice in our schools. I'm a father and I'm a son, and for years I've had premiums for health insurance that have ranged from $300 per month to $800 per month. The coverage has changed drastically, and so has my options for primary care physicians, cost of copays, and out-of-network costs for the care I need. The access to high-quality and affordable health care on a consistent basis has wreaked havoc in my life, both financially and emotionally. Now, as the leader of a nonprofit organization, I've spent days, weeks, months trying to raise enough funds and win enough grants so that folks we work with can at least have the option of having health care. We simply don't have the financial flexibility to pay folks a living wage and offer them health care coverage without bankrupting our organization. This means we work long hours doing the dangerous work of anti-racist education activists and advocates without knowing how our colleagues will be able to support their emotional welfare or get treatment for physical maladies after they become ill, despite their efforts to fight for the lives of folks in our communities. This is one of the ways that systems of oppression can kill us with impunity or bankrupt us. This is not fair and it's not just. Now, healthcare is a racial justice issue, especially here in Connecticut, and access to affordable, high-quality care is a fundamental human right. And despite that, tens of thousands of Connecticut residents struggle daily with decisions to either pay rent, pay for groceries, pay for transportation to and from work, or getting the proper medical treatment for depression, diabetes, heart disease, or getting their teeth cleaned, or having the proper exams done to prevent diseases such as cancer. Again, this is not fair, and this is not just. Now, I must acknowledge that the public health crisis caused by COVID-19 is a primary reason why a public option is just not good politics. It's the moral as well as ethical decision to make. Now, these are only some of the reasons why you must support SB 842. This legislation saves lives. This legislation supports an expansion of economic stability. And finally, this legislation protects and preserves families here in Connecticut. So I urge you to support SB 842, get it out of committee, and get it approved and voted for as soon as possible. Thank you again.
Robbie, thank you very much for your testimony. I apologize if I have all these dings going on back here. Any questions for Robbie from the committee? Robbie, thank you for waiting so long. I'm sorry that it was such a tough situation for you. We had hoped that on Zoom we could make it more accessible for people, but would love to hear your thoughts on how we can improve it. Next up, we have, I don't see Sophia on here, but I do see Evelyn. Evelyn, you're up next.
Ok, buenas noches a todos.
And Madam Chair, I'll be interpreting for Evelyn.
Estimados miembros del Comité de Seguro y Bienes Raíces de la Asamblea General de Connecticut, mi nombre es Evelyn Majano Montiel. Vivo en Bridgeport, Connecticut. Soy miembro del colectivo Semilla y Apoyo a SB 842. Tengo 45 años.
Dear members of the Insurance and Real Estate Committee of the Connecticut General Assembly, my name is Evelyn Majano Montiel. I live in Bridgeport, Connecticut, and I am a member of the Semilla Collective, and I support SB 842. I am 45 years old.
Vivo en Bridgeport y soy propietaria de una casa. Trabajo como proveedora de cuidado infantil y gano alrededor de $1,200 por mes. Hace 4 años a Hace 4 años a mi esposo le diagnosticaron gota. Una mañana, después de tomar su medicamento para la gota, se despertó con un dolor extremo en su espalda y cuello completamente torcidos.
So I live in Bridgeport and I am a homeowner. I work as a childcare provider and I make around $1,200 per month. 4 years ago, my husband was diagnosed with gout. One morning after taking his gout medication, he woke up with extreme pain and his back was completely crooked.
Pasó de centro de salud comunitario a centro de salud comunitario. Durante todo esto no pudo pararse y tuvo que caminar con muletas. Vio a muchos médicos especialistas. Como no tenía seguro médico, mi familia pagó de su bolsillo. Ellos iban desde neurocirujanos, urólogos, especialistas en espalda, acupuntura y fisioterapia.
So he went from community health center to community health center. During all this time, he was not able to stand and had to walk with crutches. He saw many specialist doctors, and since he had no insurance, my family paid out of pocket. They ranged from neurosurgeon to urologist, back specialist, and acupuncture and physical therapist.
Tuve que pagar $3,000 por una tomografía computarizada, alrededor de $1,000 por análisis de sangre. Cada visita a los especialistas oscilaba entre 200 a 500 por visita.
I had to pay $3,000 for a CT scan, about $1,000 for blood work. Each visit to the specialists ranged from $200 to $500 per visit.
Finalmente, un neurocirujano diagnosticó a mi esposo con una hernia de disco y ordenó una cirugía. Como no teníamos dinero, el hospital nos dijo que teníamos que pagar alrededor de $50,000 de nuestro bolsillo para la cirugía. Fuimos al banco para obtener un préstamo contra nuestra casa, pero fue rechazado.
Finally, a neurosurgeon diagnosed my husband with a herniated disc and ordered a surgery. Since we had no money, the hospital told us that we had to pay $50,000 out of pocket for the surgery. We went to the bank to get a loan against our house, but it was declined.
Finalmente, el hospital de Bridgeport, con ayuda de un trabajador social, accedió a realizar la cirugía, pero nuestra familia pagaría $40,000 de nuestro bolsillo en un plan de pagos.
Eventually, Bridgeport Hospital, with the help of a social worker, agreed to do the surgery, but that our family would have to pay $40,000 out of pocket and in a payment plan.
En total, mi esposo no trabajó durante 1 año y medio. Mi familia pagó el hospital tanto como pudimos, sabiendo que debido a esta gran deuda podríamos perder nuestra casa.
Altogether, my husband did not work for a year and a half. My family paid the hospital as much as we could, knowing that because of this large debt, we could lose our house.
Tuve mucha ayuda de familiares y amigos que nos ayudaron con comida y préstamos para pagar el cuidado de mi esposo. Todavía le debo a un amigo alrededor de $3,000.
I had a lot of help from family and friends, which helped us with food and loans to pay for my husband's care. I owe my friend $3,000.
Durante la pandemia seguí trabajando en la guardería de mi casa, cuidando a los niños desde temprano en la mañana hasta horas tardes de la noche. Continué trabajando durante toda la pandemia.
During the pandemic, I kept working in my home daycare, taking care of kids from early morning until late at night. I continued to work throughout the pandemic.
No soy la única persona indocumentada que está pasando por esto. No es justo que no podamos acceder a la atención médica. No es justo que mi esposo haya tenido que sufrir durante meses y que le debamos miles de dólares. Insto a este comité a que apoye este proyecto de ley. Gracias por su tiempo. Evelyn Majano Montiel.
I am not the only
Evelyn, can I just interject for a sec? I have let you guys go far beyond the 3 limit because I know there's 2 of you speaking, but could you get to a point where you can start to wrap it up? We do want to hear your story, but I can't let you go on, more than everybody else.
Sure. Yeah, and this is in closing. So the last thing that Evelyn said is that I am not the only undocumented person that is going through this. It is not fair that we cannot access healthcare. It is not fair that my husband had to suffer for months and that we owe thousands of dollars. I urge this committee to support this bill. Thank you for your time. Evelyn Majano Montiel.
Evelyn, thank you for sharing your story and staying up so late to share that with us. We really appreciate you being here tonight. And Luis, thank you for interpreting for us. Do we have any questions from the committee? Thanks to you both.
Thank you.
So I see that Summer has come on, but I'm going to go to Constanza Segovia, since she has been on longer, and then Summer Kim will be next.
Hello. Thank you for being on this for this long. I know everybody's tired. I sent in my written testimony, so I will keep my remarks short. Members of the Insurance and Real Estate Committee, I'm just here to urge you to not leave the undocumented community of Connecticut out of this bill. We know that there's a lot of details that will continue to be negotiated, and you will go back and forth on a lot of things. And I just want you to please prioritize creating a structure so that undocumented people in Connecticut who are residents like everybody else have access to at least something that can be a way to get coverage for their healthcare needs. Like Evelyn just mentioned, her story is something that we experience in our community constantly. I am part of the Hartford Deportation Defense Collective in Hartford, and this is, hundreds of people in our community around the state that have very similar stories, thousands of dollars in debt, life-changing care that is not, that they don't seek because of the financial constraints of what that might imply. This is working people. This is the parents of kids in our schools. This is human beings that need to be taken care of like everybody else. So please, I know there is, a part of this bill that would create a subsidiary that would make it so that undocumented people have access to some coverage. I know it is not a perfect solution, but it is an important first step to get relief for our community. We hope that it is a first step and that we can continue to work together. And we are here to, support you in that work and to work with you as a community so that we can get to a point where everybody in Connecticut and the United States has access to equitable, affordable, dependable healthcare without any discrimination based on any variables, including the many identities that people hold and their immigration status. So thank you very much. And yes, in support of Bill SB 842, and please keep the undocumented community of Connecticut in mind.
Constanza, thank you very much for your testimony tonight and doing so late in the evening. Really appreciate it. Any questions from the committee? Last but not least, Summer Kim, thank you for being here. You're up.
Hi, everyone. My name is Summer, and I've been living in New Haven for about 7 years now. I'm a fundraiser at a local nonprofit called All Our Kin, which focuses on early education and family childcare. And I am in support of SB 842. I truly believe that every one of us deserves affordable and quality healthcare just because we are alive and for no other reason. As someone who struggles with mental health, I have often experienced bouts of depression and anxiety that have made showing up to work every day almost impossible. But because the healthcare that I rely on to treat my illnesses was tied to my employment, I was facing this kind of catch-22 every day of either attending work at the expense of my health or not attending work and losing my access to healthcare. A public option, I think, would provide so much stability and peace of mind for me and many others like me, knowing that no matter my employment status, I will be able to depend on my healthcare. And particularly in the context of COVID, when so many of us have lost our jobs, and while so many others have risked their lives at their jobs every day. Connecticut residents need and deserve access to high quality and dependable mental and physical health care now and moving forward. As a matter of equity, evidence shows that Black, Latinx, and other people of color are disproportionately affected by the pandemic. And I believe we have a moral responsibility to support every member of our communities, particularly those who have been most devastated by COVID. Ultimately, the implementation of a public option will improve our workforce by enabling a vast number of underprivileged Connecticut residents to obtain and maintain a level of health that will better support us in stable employment. So I urge the committee to support SB 842. Thank you for your time.
Summer, thank you. And thanks for hanging out so long to give your testimony. We really appreciate it. Any questions for Summer? Well, I want to thank the committee for hanging out so long. This was a long hearing, and there are so many of you spent the whole day with us. Sam spent the whole day with us too, which was great. He was an active member of the committee today. I think he looked like he was having a blast learning government.